morning, everybody. Welcome to Kolkata. We'll start the scientific deliberations straight away. The first session is heart failure cardiology, and we would want to invite the chairpersons on the dais, Dr. Mrinalindu Das, Dr. Bishwajit Majumdar, and Dr. Dilip Kumar, please. Dr. Saroj Mandal, sir, if you're here, please. We would request the chairpersons to invite the speakers. The first speaker is Dr. Ayan Kaur. There is a change of schedule because of availability of speakers, and we'll start straight away. Thank you.
So, good morning, everyone, and welcome again to this 9th annual conference of Society of Heart Failure and Transplantation. So to begin with, this is a conference where we are going to discuss heart failure and transplant, but it's a better idea to begin with the over to you.
Thanks, sir. So, as you truly said, sir, this was a conference on transplant and heart failure, but I think we were also asked to look at some preventive strategies to prevent transplant, I guess. This is about LDL-C, and one of the cornerstones of therapy for preventing ischemic heart disease is managing your LDLs well. So given the aggressive nature of LDL reduction we are looking at, and with 2 societies in India encouraging really extensive reductions in LDL as primary focus, is something that we really need to look into. So we will establish the need for effective LDL-C reduction. We look at some patient profiles to understand how we use drugs that are available with us in current clinical scenarios. We look at quick guideline recommendations, and we'll also look at why we are looking at silencing RNAs as an upfront therapy in certain patients, and of course then some take-home messages. So we understand that ASCVD is one of the leading causes of cardiovascular morbidity and mortality. If we look at the numbers are very stark. It is about 1 in 10 report a secondary MI or a stroke or a CV death within the first 100 days after experiencing an MI. So this is something that we keep telling our patients, that the first 3 months is something that we are very concerned about. Of the modifiable CVD risk factors that we have in our hand, LDL-C is one of the top modifiable risk factors, and it's easily done. That's what's more important. Now, when we look at the actual idea of reducing LDL and you look at the real world evidence of actually doing it in clinical settings, you would see that parts of the world which are considered to be more developed than ours, even there with the standard of care available, the failure to achieve LDL-C goals is extremely high, and we are looking at not 40-50%, we are looking at 70-80% rates of failure to come to LDL-C targets. So which is why the role of earlier combination therapy in high-risk ASCVD patients, which is why you would see that the Cardiological Society of India currently recommends that in patients with ACS, we are giving almost upfront full dose statins along with an ezetimibe of 10 milligrams to ensure that we bring them down to the lowest LDL possible. So starting combination lipid lowering therapy at diagnosis in high-risk patients, we are typically looking at ACS patients, that is acute coronary syndrome. It reduces treatment delays, number 1, and ensures faster LDL-C reduction with dual benefits. So initially we were treating to targets. Now there's an urgency to treat to target. It's not just about treating to targets, there's an urgency to the whole thing. So let's look at some case scenarios. So we'll look at, this is Abhay, 39 years, male. You see he's borderline overweight, 26 kg per meter square is what his BMI looks like. He was diagnosed with diabetes 5 years ago. So at 34, a diabetic. So remember, as per most lipid guidelines, moment you become a diabetic, you are high risk. He presents with an NSTEMI and undergoes a drug-eluting stent to the RC at the current hospital admission. What is important to note that despite being on an atorvastatin of 40 milligrams, his baseline LDL, that is on treatment LDL as we call it, is 154 milligrams per deciliter. Very high. So even if you look at the population average LDL, I won't name the society, but we are looking targets of 70 to 100 for normal people who do not have any comorbids. So here 154 of LDL-C is something that's very high. So we need a robust lipid-lowering therapy, and it needs to be a convenient treatment to fit his busy schedule. So remember, young patients are the most non-compliant patients. They forget their therapies very often. They do not take their medicines because of the kind of work they do. So which is why if you look, one of the alternatives as therapy that can be given is Inclisiran, which is basically a silencing RNA, and it significantly reduces LDL-C. What you can see, it does it very quickly within the first 3 months, and it maintains all the way provided you take your doses well. So there is an Inclisiran provides significant and sustained LDL-C lowering across glycemic data. Now, and that's irrespective of your diabetic status. And what you see, Inclisiran is a first strategy. So remember, this patient was already on an atorvastatin of 40. So we have generally seen that incremental benefit of making 40 to 80 is not very high. So you don't have a lot of reduction with making 40 to 80. Rather, adding other lipid lowering therapies that could either be ezetimibe or bempedoic acid is what we would have done. Otherwise, of course, you can always increase that to 80 milligrams, and beyond that, it would be Inclisiran. But given the fact that this is a young patient and we are trying to prevent future events, we would like to bring his LDL down to as low as possible and as early as possible. So which is why you see we would generally Inclisiran as a first strategy, which is implementing Inclisiran earlier in the treatment pathway, significantly reduced LDL-C. Also, please remember that most of our events after an MI happens within the first 3 months or the first year. So that is the time when you really need to aggressively treat these patients. So which is why if you look, so if you had to take a statin, that would be once daily dose for the rest of your life. If you look at injections like evolocumab, etc., which were available with us before, that's about 26 injections. Whereas with silencing RNAs, it's just 2 injections in a year, once every 6 months. Now, if you look at majority of patients in the Orion 8 trials, they achieved their LDL goals. So you looked at real world data, which was about 80%, where they failed. Whereas here we are showing you data where we were able to bring down to the target LDL level of 55 and close to 66% of patients, which is significantly improved. So your ACVD patients with diabetes who fail to reach their LDL-C goals can benefit from Inclisiran as an upfront strategy. Of course, you have to understand the risk factors and then give these patients. So we have a 52% LDL reduction, which is quite massive. And majority of these patients achieved guideline recommended LDL-C goals with Inclisiran. So it's important the goal as well as the time within which you achieve it. Case scenario 2, this is a trained dancer, quite obese, chronic kidney disease, multi-vessel disease, underwent CABG. So whatever I said, these are all high risk factors for lipid control. More so, her eGFR is hanging around 35, LDL-C on treatment with 2 lipid-lowering therapies, atorvastatin 20 and ezetimibe of 10 is 120 milligrams. So it tells you she's still not at target. So given the fact that Inclisiran currently can be given till the eGFR 15 mils per minute, I think this patient again becomes one of the categories. So remember, even in these patients, according to KDIGO guidelines, giving higher doses of statins comes with its own share of problems. So which is why upfront siRNA treatment comes with some benefits. Now, Inclisiran provides effective LDL-C reduction. This is the post-hoc pooled analysis of 2 phase 3 trials. And what you see are the sustained reductions. They are early reductions and they stay there. But it translates into reductions in recent MI, remote MIs, and that's irrespective of what your baseline current status is. Now, Inclisiran also provides effective and sustained LDL-C reductions from pooled analysis of Orion 9, 10, and 11. And what you see is the ballpark figure of 50% reduction, which we are really trying to achieve in our patients. Inclisiran provides effective LDL-C reductions in even patients with severe or moderate or mild or normal renal function. So irrespective of what your renal function looks like, Inclisiran works well, but remember the current guidelines is that you can give it till the eGFR of 15. So which is why this patient benefits because there's a 50% LDL-C reduction. There's a 49.2% LDL-C reduction in patients with severe renal impairment and 53.1% reduction with moderate renal impairment. Now this is case scenario 3. This is a retired banker, hypertension, has undergone 2 PCI. Remember, again, very high risk. So remember, here we are looking at LDL-Cs of less than 30. So the target becomes much more aggressive now. So this patient is on a moderate dose of rosuvastatin 20 and ezetimibe of, that should be 10. I think that's a mistake on the slide. So it's rosuvastatin of 20 and ezetimibe of 10. and he's on standard antihypertensive therapies. And what you see that he again needs a robust lipid lowering therapy, and that would be Inclisiran in this case. And of course, this patient, remember, there's no drug-drug interaction with Inclisiran at the moment. There is no injection site adverse infection. So there's a standard long-term safety data of about 9,982 patient years, and which tells you that the chances of side effects on this is quite low. As far as Inclisiran's long-term safety, we have about data for 6 years, which tells you that the injection site is very low, and any other adverse effects is very infrequent. Now, so that tells you that these three categories of patients is what really benefits from these kind of injection. And if you look at the CSI 2023 risk assessment, something that you should always run at the back of your mind before administering lipid-lowering therapies, we need to titrate our patient therapies to the kind of risks they are on. So remember, extremely high risk is ones with recurrent episodes of ASCVD, like the one which I showed you last, with 2 PCIs, or with some evidence of elevated lipoprotein A. These patients, your targets are less than 40. Remember, whatever is your non-HDL is going to be LDL plus 30. So in very high risk is again the ones with more than 50% lesions, diabetes of more than 20 years, and CKD, so very high risk. Whereas in the here your target is about 55. In high risk patients with, remember, so moment you have diabetes with 1 or more risk factors, you become high risk patients. So remember, these patients with a CKD EGFR of 30 to 59, or with some element of hypertension or hypertension mediated organ damage, these kind of patients are again considered to be high risk. Your target is about 70. Whereas low risk, no risk factors, currently the population average is going to be LDLC of less than 100. Now, irrespective of what the guideline is, we do understand at present it is going to be standard lipid lowering therapy. That could be in most cases moderate dose statin plus an ezetimibe, beyond which you would offer these patients Inclisiran to ensure that they are being treated to targets. So in your very high risk and extremely high risk ASCVD patients, they can benefit from Inclisiran, and that is something we do see. It is probably about 10 to 20% of your standard ACS population, but this is some place where I think we should treat them upfront rather than waiting for months and months. So remember, the monitoring is about 2 weeks between change of therapy. So we are looking at very aggressive way of reducing LDLs. So key messages would be the LDLC reduction is a cornerstone of CV reduction, with evidence showing greatest benefit from early significant decreases. So we are looking at the term early, and that is what we are really emphasizing on. Starting combination in lipid lowering therapies at diagnosis in high risk patients, it reduces treatment delays. It enables large LDLC reductions within the first 4 to 5 weeks. Now, 2 maintenance doses of Inclisiran per year, it achieves effective and sustained LDLC reductions with a generally very well tolerated safety profile as a complement to maximally tolerated statins or monotherapy for statin intolerant patients. So that brings us to the end of our talk. We'd be happy to take any questions, sir.
Thank you, Dr. Royankar, for your nice talk covering almost all aspects of Inclisiran. So with the availability of this molecule now, the management of dyslipidemia has becoming easier, but the only factor is the high cost. The majority of our patients cannot afford this molecule. So you have mentioned everything. So what is your approach when we are not able to control the dyslipidemia LDL in the target level? You will add statin, ezetimibe, then bempedoic acid, then you will consider this, or you will consider statin, ezetimibe, then straight away Inclisiran or PCSK?
So if you look
What
at the
is
current
your
guideline,
practice approach?
so our current guideline from the CSI is it's very simple. It says that it is maximal tolerated dose of statin plus a lipid lowering and other analog, which is non-statin analog. In most cases is ezetimibe. Bempedoic acid is not mentioned in the guidelines, but beyond that also, if your LDL is not at target, you give them Inclisiran. But in our current practice, we generally give the maximum dose of statin, ezetimibe, bempedoic acid, and then go to Inclisiran.
Yes, Major, I think many will follow that. And regarding the next question, with the availability of this molecule, what is the role of PCSK9 inhibitor? If cost and taking frequent injection is also not an issue, which molecule you will choose as a third molecule or fourth molecule?
So if you look at the cost,
Inclisiran or PCSK9?
so if you look at the cost of PCSK9 is also not really cheap, given the fact that you have to take it fortnightly. Technically, in most of our patients, once a month injections generally suffice. But of course, that is off-label. But if you had to look at fortnightly injections, I think the cost adds about to the same thing. And given the fact that now Inclisiran is available at a little bit of truncated dose in India, at least there's an offer at present where you get 1 + 1 free. So I think it is ideal possibly to give it at the moment, but long-term therapy, given the fact that this is going to be long-term in the sense it has to be continued forever, is the problem.
So frequency of injection is also matter. This
Yes,
is less
sir.
frequent. That is the most important
Yes.
advantage.
Apart from that, LDL is not common, the only factor that causes that increased risk of atherosclerotic cardiovascular disease. Other factors are there that you have mentioned, LPA, and the ApoA, ApoB, also that fasting insulin level. So any pleiotropic effect of these Inclisiran on that factors?
So lipoprotein A, from the studies that we know, it reduces with Inclisiran to the tune of about 21%. That is what the data is. But I think we have a dedicated LPA molecule coming into the market maybe by next year. That would be pelacarsen. That is obviously going to change the way we look at lipids.
How much patient, do you think that all patient, 100% patient achieves your target goal?
On Inclisiran, sir?
Yes?
Yes, sir. On Inclisiran, unless and until you are treating homozygous FH is something that does not respond to Inclisiran also. So if it is heterozygous FH and standard run-of-the-mill lipid-lowering therapy, is mostly in 100% of patients we are able to get to the target of less than 55.
Below the standard level, suppose the 100 or 70 LDL, does the same, if you start with the 70 milligram percentage LDL level, does it decrease again 50%?
Yes, sir. Yes, sir. Of course.
Not like that.
Of course. No, in most cases it does.
Any question from the audience?
Yes, sir.
Since we are in a heart failure conflict, what is your take on aggressive lipid-lowering therapy in ischemic heart failure based on the outcome of ODC data? ODC outcome said there is 17% adverse event with PCSK9 vis-a-vis statin therapy.
So you open the Pandora's box, as I call it. So what we do find is that ischemic heart failure and this is standard ischemic heart disease, they are two very different animals to treat, sir. So when you're looking at heart failure therapy, I think we cannot afford to have very high dose aggressive statin therapy. It does not really, I mean, the pathology is very different, so hence it does not work. Like you said, from the ODC data, it generally would have adverse effects because the whole intention of treatment is very different. So the targets of treatment are different, it works very differently. So when you have heart failure and the treatment is most likely going to be heart failure primarily, it is not about treating ischemia then. So ischemia obviously has gone to a certain extent beyond which you have heart failure.
Thank you, and for the fantastic
sir.
presentation. Sure. So time to move on to heart failure. May I invite Dr. Ravin Chakravarti to brief us on medical management of advanced heart failure. And by the time he's setting up, the guidelines for LDL has now been reduced to 15 in those patients who are having recurrent myocardial infarctions. So it's 15 in guidelines. Yeah.
Thank you, Dilip and other chairpersons, Sharoj and Mr. And my talk is on medical management of advanced heart failure. So this is the universal definition of heart failure, as you know, that heart failure with reduced ejection fraction, less than 40%, heart failure with mildly reduced ejection fraction, between 41 to 49%, heart failure with preserved ejection fraction, more than 50%, and sometimes heart failure with improved ejection fraction, which means that it was less than 40%, but there is 10-point increase by medication or whatever, so that is called impaired ejection fraction. That is a journey of a patient with heart failure with reduced ejection fraction. No heart failure substrate, then baseline heart failure at risk, then residual heart risk, worsening of heart failure, and advanced heart failure. This morning, we're going to concentrate on this particular area called advanced heart failure. And the heart failure with reduced ejection fraction treatment, there are challenges and there are fears. Challenges are multiple guidelines and clinical practice updates. There is associated morbidity and mortality, and it is very high in this subgroup of patients. There is a large percentage of these patients are not actually receiving guideline-directed medical treatment. And if you find that these heart failure patients, there is a higher incidence of rehospitalization, hospitalization in 1 to 3 months' time. and 30 days rehospitalization about 18%, and 90 days hospitalization is about 30%. And 1 in 4 patients with heart failure are readmitted within 30 days of discharge. 50% of these patients are readmitted within 6 months' time. And it is important for us to understand that hospitalization and rehospitalization they are directly related to mortality. So the treatment goal should be to minimize hospitalization and to minimize rehospitalization, and thereby preventing the mortality. And that is the whole outlook of treatment. So unpredictable course of heart failure is a challenge, because this highly unpredictable clinical course of heart failure can challenge even the most experienced clinician to correctly identify the optimum timing of referral to a heart failure specialist. Although some heart failure cases may be abrupt and obvious, but most of these heart failure patients are related to progressive diseases that evolve subtly over time. The addition of objective measures of exercise performance, quality of life, cardiac structures and function biomarkers, and laboratory assessments and arrhythmias burden are useful in ongoing evaluation of these patients and may serve as an important adjunct or adjuvant to plan a suitable therapeutic regime for achievement of stability. One particularly helpful mnemonic that may be helpful to identify patient in need of referral to heart failure specialist is called I need help, which integrates clinical history, hospitalization, medication intolerance, and in addition to symptoms and end organ dysfunction. Consensus supports is the correct concept of early referral to avoid the debilitation and end organ dysfunction that accompanies prolonged advanced heart failure and may preclude candidacy for advanced therapies. And that is what is important. So then what is the definition of advanced heart failure? What is it? Multiple classification is there to define advanced heart failure. New York Heart Association Functional Class 4 defined their symptoms at rest. In 2001, American College of Cardiology and American Heart Association came out with another definition. The Interplay Registry of Mechanical Assisted Circulation classification called Intermax classification was developed to risk stratify patients with advanced heart failure to better define prognosis and urgency of intervention like heart transplant. These 3 classification systems may be used in parallel in order to more precisely define where an individual patient lies on the spectrum of the progressive disease. So if you look at it, what is advanced heart failure? So advanced heart failure definition, something like frequent the systolic blood pressure less than 90 or persistent dyspnea with significant reduction of activity of daily life. NOH class 3 or 4, intolerance, inability to tolerate GDMT, end organ dysfunction, persistent hyponatremia, severe symptoms. So European Society of Cardiology, Heart Failure Society of USA, and they have JAC or American College of Cardiology, they define advanced heart failure different ways. And if you look at it now, that if you take all of them together, this particular group, this Intermax profile is extremely important. It starts from profile 7, advanced NOH class 3 to profile 6, to profile 5, to profile 4, to profile 3, profile 2, and progressive decline leading into critical cardiogenic shock. So you have to focus on this intermax profile to understand the heart failure. Because the clinical course of heart failure, as I've shown, it starts from there and progressively goes down. Probably at some stage you need to have mechanical assisted device and then eventually leading into heart failure or palliation. Accordingly, the therapy also changes with time. So this is very important for us to understand the medical management of advanced heart failure. But the problem is, based on this heart failure, last from 1986 till 20, which is something like 34 years, there are a huge number of trials went on to understand that what could be the most effective treatment, medical treatment of heart failure. And if you look at it, basically the advanced heart failure management, there are 3 important steps. 1, proactive multidisciplinary approach to advanced heart failure, early guideline-directed medical therapy, initiation, and lifestyle modification. Utilization of mechanical support when appropriate. We should not disregard it. And today, we also talk about leveraging of artificial intelligence technologies to enhance diagnostic and prognostic capability. Dr. Rohan Goswami of Mayo Clinic of Florida is doing wonderful work on this group of patients of advanced heart failure and following these 3 steps of basic management of heart failure. But the problem is that 80% of chronic heart failure patients are either not on target dose of RAS inhibition therapy or has been down titrated or discontinued, which is very unfortunate. There are pillars of heart failure therapy. We know there are 4 pillars, 5 pillars, maybe now 6 pillars or 7 pillars are coming up, like ARNI, beta blocker, MRA, SGLT2 inhibitor, loop diuretic. We should not forget loop diuretic, particularly in terms of advanced heart failure. And guidelines, however, need implementation. That is a problem. Guideline remains as guideline, but the implementation is certainly less than what it should be. And that is what has been proved in CHAMP heart failure registry. If you look at the benefits of initiation of ARNI, beta blocker, MRA, and SGLT2 inhibitor as first line of heart failure treatment with advanced heart failure treatment, has found that if you really treat it properly, it has been shown that it improves the health status, it improves the ejection fraction, it reduces heart failure hospitalization, it reduces rehospitalization, it reduces mortality, and it improves the adherence to the dose, it improves the functional activity or ADLA status. It has been shown that strong HF trial, where basically the ACE, RB or RNA beta blocker or MRA was evaluated, again it has shown that in addition to these drugs, SGLT2 inhibitor like dapagliflozin, empagliflozin has a clear role in improving the cardiovascular outcome as well as the mortality. And this is the data to prove that in European Society guideline, they have shown that DAPA and EMPA recommended in patients of heart failure with diabetes and CKD to reduce the risk of hospitalization as well as mortality. Even the American Heart Association came up with the same kind of thing, that SGLT2 inhibitor is extremely useful. So what is needed, that earlier there was a conventional sequence of the medication like step 1, step 2, step 3, it has changed. Now we go up to rapid sequencing of medication, like start with beta blocker, SGLT2 inhibitor, then immediately go up to ARNI, and then progressively going up to and add MRA. This is kind of a basic step on the medical management by rapid sequencing. And this has been proved by the data. So we have to look at the science in a different angle. This is the data which has been published by John McNair, Milton Packard, and Dr. Shine, their team in clinical research paper. And this has been shown in roughly about 4 to 6 weeks time, sometimes 1 week time. These are the drugs like RAS, beta blocker, MRA, ARNI, and SGLT2 inhibitor to be up-titrated from sequence 1 to sequence 2 like this. This should be the sequence of up-titrating the dose for what? To reduce the hospitalization, to improve the rehospitalization, and prevent the cardiovascular death. That is what is very important. So that is the basic principle of medical treatment. And then SGLT2 inhibitor again has shown in the whole left ventricular ejection fraction spectrum, even in diabetes and non-diabetic groups, a wonderful drug approved by DAPA HF and DELIVER, Emperor preserved, Emperor reduced, Impulse trial, even the soloist HF trial has been proven again and again very useful drug, because DAPA HF has shown clear improvement of the mortality. Emperor reduced has shown exactly the same figure. If you look at the SGLT2 inhibitor, are now recommended heart failure right across the entire left ventricular ejection fraction spectrum. Because Emperor has shown there's a 20% decrease in heart failure, and there is a 9% decrease of cardiovascular death. The total decrease is 27%. Even the kidney function has shown to improve. And early initiation, therefore, of SGLT2 inhibitor is important and irrespective of whatever may be the ejection fraction. Pioneer HF trial again has shown that changes in NT-proBNP concentration is of extreme importance in terms of hospitalization, rehospitalization, and mortality. Paraglide HF trial again has shown that NT-proBNP is extremely useful parameter to indicate the prognosis of heart failure patient. Soloist AW heart failure trial, again, the sotagliflozin again has shown to be extremely helpful to prevent cardiovascular death, hospitalization for heart failure, and urgent heart failure visit to the clinician. Now, in addition to heart failure, many of these patients may have iron deficiency, functional iron deficiency, that may actually help prevent the proper improvement with the conventional medication. So, intravenous iron supplementation is recommended in symptomatic patients of heart failure treatment with ejection fraction. We should not forget it. Iron is an important component. It has been shown that ferric carboxymaltose or ferric isomaltose has been extremely useful in symptomatic patients of heart failure with reduced ejection fraction because it prevents hospitalization and hospitalization. And same is true for kidney disease. Remember, advanced heart failure and kidney disease, they coexist, the same pathology, because in advanced heart failure there is significant fibrosis. And the same is true in glomerular injury, there is glomerular fibrosis. So they coexist. And because of that, there is MR, mineralocortical overactivation, sodium and fluid retention, inflammation, dysglycemia, adiposity, hemodynamic factors, cardiac and vascular hypertrophy. So this is a pathophysiological heart and kidney interplay that we should always remember that in advanced heart failure, there is a kidney element and we should not ignore it. Therefore, the drug like MRA, like spironolactone and eplerenone, which is steroidal, and non-steroidal like finerenone have been found to be extremely useful in this group of patients. This is the data on finerenone. Fine Arts HF trial again has shown there is an improvement in terms of mortality as well as heart failure hospitalization over a median follow-up of 32 months. It has also shown that cardiovascular death has significantly reduced. It is a safe drug. It has been useful, very useful in those group of patients where the heart failure is advanced. Combination of SGLT2 inhibitor, MRA, this is a disease-modifying strategy is extremely important. And then we got a lot of trials of MRA, RALS, Emphasis, ARTS, and so many of them trials have been proved. Finally, we should not and must not forget intravenous diuretic, inotropic, and digoxin. We should not forget. It has not gone. It is not out of the textbook. It is still there. For advanced heart failure, management of congestion can sometimes be difficult. Therefore, you should think of giving loop diuretic, intravenous loop diuretic, up titration of oral diuretic like torsemide, be very helpful, sometimes in combination with metolazone, sometimes in ambulatory IV loop diuretic helpful. Inotrope, think of calcitropes, which modulates calcium signaling, myotropes, which includes sarcomere through calcium-independent mechanism, and metotrope, which exerts their action on mitochondrial function, like dobutamine, milrinone, enoxaparin. These are calcitropes. Their omecamtiv or omecamtiv mecarbil, or even danicamtiv, they are myotropes, and metotrope. These are the drugs to be remembered. And there are data to prove that omecamtiv, we got data, is a direct myosin activator, and vericiguat, a soluble guanylyl cyclase stimulator, again an oral drug, has been shown to be extremely useful for, like in vericiguat MOA, endothelial dysfunction improves. This is the data we have. Mecarbil or omecamtiv mecarbil data we have. Galactic HF trial has shown omecamtiv mecarbil in heart failure reduced ejection fraction is a good drug. So the new drug like Victoria Galactic HF primary endpoint has shown to be very useful. So to summarize, the management of heart failure with advanced heart failure, first you start them with GDMT, properly guideline directed medical treatment. If patient improves, fine. If they do not improve, then think of using newer drugs like vericiguat, omecamtiv mecarbil, and similar drugs, other drugs. And then you think of using inotropic agent like oral loop diuretic, or intravenous loop diuretic with metolazone, even digoxin in some group of patients, and find because they reduce hospitalization, may not affect the mortality. And finally, you also think of intermittent mechanical support, maybe short-term mechanical support with something like Impala, or long-term with stable LVAD or something like this. So this is the kind of thing. So finally, we have to remember, when you manage heart failure, you think of old age, obesity, CKD, infection, genital infection, dehydration, ketoacidosis, these things to be remembered. Remember anemia, remember associated COPD, ischemic heart disease to be remembered. This is a very common thing, atrial fibrillation, arrhythmia, obesity, hypertension, and diabetes mellitus. Compass HF trial is again, and they have newer modality and home monitored. Medtronic has come up with a device called Chronicle system, supposed to be useful, but we do not have enough data. So artificial intelligence again has got some role in advanced heart failure, which I already told. This is the data which has been published from Yale University and Illinois University, and the Indian group of patients from South Asia, from India, from Pakistan, and also from USA. This is the data on advanced intelligence and heart failure. But we know we can make the diagnosis, but we cannot plan the treatment. So to conclude, importance of guideline recommendation for the management of heart failure, patients of heart failure, use of guideline-directed medicine, important, awareness of more complex management of heart failure, patient comorbidities and safety issues. Future prospect, the syndrome of advanced heart failure remains an epidemiological, clinical and financial challenge for patients, physicians and policymakers. Recent improvement in advanced therapies have helped more patients to live longer, but have substantially increased clinical complexity and cost of the care. Although temporary mechanical support has revolutionized the management of cardiogenic shock, the ongoing lack of prospective randomized controlled trial data limits our understanding of the risks and benefits of this technology for a given patient. Ongoing research focusing on myocardial recovery is desperately needed because of biochemical pathways capable of reversing, if not preventing, heart failure would radically change our approach to care. Lastly, we must continue to integrate patient-centered, symptom-based palliative care into our advanced heart failure paradigm in an effort to help patients with advanced heart failure not only to live longer, but to live better. Thank you very much.
Thank you, sir. It was a fantastic presentation. And management of advanced heart failure has got many aspects, like to get a patient with atrial fibrillation, maybe paroxysmal atrial fibrillation with LV dysfunction, post-bypass surgery, with mitral leak. Someone does mitral clip, and electrophysiologists, they scratch their head. Oh, the patient would have come to us, would have done a AF ablation, patient could have gone in sinus rhythm, and patient would have gotten better. Patient is having a very bad heart. There was also a consideration of LVAD. The patient could also be impaneled in listed in transplant. So there are so many aspects which needs to be done fast. Still not very clear, and these things will be discussed in today's meeting. Just a quick one to you, sir. The penetration of GDMT, even in patients who are having recurrent heart failure, is only around 18 to 20% in India.
Yes.
Just your suggestion how to improve upon that.
Awareness, you have to talk more about it, and then I think sometimes back it used to be a cost issue, but I think that is progressively getting better. So, but more and more awareness, and physician in particular, they should not discontinue the drug. I mean, sometimes they feel that our patient is better, rejection fraction has improved from 35% to 50%. Let us reduce the dose. That is not the right approach. Continue all 4 drugs to be given at the beginning, because if you do not do that, patient will progressively go downhill. Then you have to add more drugs.
Thank you, sir, for your nice talk. Just 2 comments. One is, in this advanced heart failure, often there is diuretic resistance, and that part sometimes we can tackle by low dose metolazone, not in every day, even in the 2 days in the week may improve substantially urine output and volume congestion. And another aspect not very much highlighted, we are very much concerned that iron deficiency, that is established and guideline directed, but other micronutrient deficiency like calcium, phosphorus is often not measured. And in the elderly frail patient, there may be some hypocalcemia, hypophosphatemia, even subclinical hypothyroidism. These are often missed. These are often simple things that can improve. Replacement can improve to some extent the precipitating factor. So I think some micronutrient deficiency and heart failure part should need more research, especially in an elderly patient. Thank you, sir, for your nice talk.
Thank you.
May I invite Arindam to take us through GDMT post-revascularization.
Good morning, respected chairpersons and dear audience. My job is now a little easy because after the fantastic talk by Professor Rubin Chakraborty, we now know how we should treat our heart failure patient, what is the importance of 4 pillars or 4+1 diuretic. Many times we forget, but this is also having a class on indication whenever your heart failure patient, be it reduced ejection fraction or preserved ejection fraction, has volume overload or congestion. Now the issue, in the algorithm, which was very nicely shown by Professor Chakraborty, how we should approach to treat heart failure patient, you will not find something known as revascularization. So most of us who are sitting over here are either interventional cardiologists who do angioplasty. There are, cardiac surgeons who are doing bypass surgery. There are cardiac anesthesiologists, cardiac critical care specialists, but as of now in 2025, we are not very sure doing bypass surgery or doing angioplasty will improve the ejection fraction of the heart or not. Why? Because even in 2025, we are lacking something known as the diagnostic tool to assess the viability of the myocardium. So be it cardiac MRI, be it SPECT, whatever you name, those are not 100% sure to get you, information regarding the viability of the myocardium. And that is why majority of the trial, even the large randomized trial, has failed to show improvement. Recently, 2 years back, Revive BCS trial, a very large trial from United Kingdom, which failed to show improvement of ejection fraction post-angioplasty in ischemic cardiomyopathy patient. Similarly, if we see the available evidence with bypass surgery, whether your patient will come up with improved ejection fraction, you are not very sure. So that is why the GDMT post-revascularization becomes very important, and I'll briefly try to, analyze the available evidence, what we are having. So impact of coronary artery disease and heart failure. So it's a marker of worse long-term outcome in heart failure patient. We all know heart failure with ischemia and heart failure without ischemia, they are not same entity. They are different animals, and the prognosis of heart failure with ischemia, that means some significant ischemia, actually is bad. So it will increase the rehospitalization rate, it will increase the mortality of the patient, and so on and so forth. So is coronary revascularization alone sufficient to manage the reduced ejection fraction heart failure with coronary artery disease? Let us see, let us dig into the available evidence. This is the data from Excel trial. You can see the mortality, mitral infarction, repeat mitral infarction and stroke, post-revascularization, either if you do angioplasty or bypass surgery. Initially, this is the data with the PCI, the mortality and this thing are showing little low, but with follow-up within a span of 3 years, you can see it will catch up. And this data is about patient whose ejection fraction is less than 40%. That means heart failure with reduced ejection fraction. This is the mildly reduced, this is the preserved ejection fraction data, which suggests it's not a big problem. But whenever you are intervening in reduced ejection fraction patient, be it bypass surgery, be it angioplasty, it is not ensured how good you are doing in terms of repeat, hospitalization, recurrence of MI, and mortality. Because until 3 years, there is, very lack of different. I'll show you another data. This is the, retrospective cohort study where you can see post-PCI, this is the data post-PCI, this is the data post, bypass surgery. You can see the mortality is still significant. The heart failure hospitalization is still significant. So if you do a very fantastic job in terms of revascularization, be it bypass surgery or angioplasty, you are not very sure whether your patient is not going to come back with hospitalization, whether he is not going to die. So what is the next step to manage such category of heart failure and reduce ejection fraction patient post-revascularization? Let us try to evaluate what we are again and again discussing. The GDMT, guideline-directed medical therapy, should be considered for all patients with complex coronary artery disease treated either with bypass surgery or PCI. Even post-revascularization, when your patient is getting discharged, it is mandatory to give the 4 pillars of therapy until contraindicated. Why? I'll show you the data. So this is, there is misconception. There is misconception that continuing GDMT may be of less value once coronary artery disease have been mechanically revascularized. This is a misconception. Why? I'll show you the available evidence. You can see the compliance with GDMT. It remains low. And this is the data which clearly suggests if your patient are not taking the GDMT, the important 4 pillars or other therapy, which is actually indicated, even in post-bypass surgery or angioplasty, the mortality goes up. And importance of post-GDMT, you can see the dig out the data from the STITCH trial. We all know about STITCH trial. There is 35% reduction in the risk of mortality when you are using GDMT. So this is clearly beneficial, and benefit actually persists even after 10 years because STITCH has a long-term follow-up data. So GDMT post-CABG reduces risk of all-cause mortality in reduced ejection fraction heart failure patient. There is 16% reduction. This is the data from the registry Stitch trial. There is 16% reduction, the primary outcome, all-cause mortality with GDMT post-CABG versus patient of CABG where the GDMT is not offered. So very clear-cut data. And this is another analysis which suggests 21% reduction of the mortality, cardiovascular mortality. If you give GDMT or not give GDMT, that makes important decision because they are going to live longer. Survival is improved. And this is the recurrent hospitalization. That also you can see clearly there is 28% reduction of cardiovascular hospitalization and cardiovascular mortality if you give GDMT. Now this is the data from syntax study. You can see the syntax study. Patient receiving GDMT post-revascularization showed 36% reduction in the mortality, 27% reduction in the risk of composite endpoint, that is mortality, recurrence of myocardial infarction, recurrence of stroke, cerebrovascular accident. So it is extremely, extremely important to prescribe GDMT whoever is getting discharged post-revascularization, be it angioplasty, be it bypass surgery. I see in practice the penetration still is there to some extent for the interventional cardiologist, but for the surgeon, I don't see that is happening. Many of the patients are getting discharged with ejection fraction clearly mentioned on the discharge certificate, less than 40%, but they are not on GDMT. Why? Because of inertia. We need to deal with this inertia, otherwise we are doing harm to our patient. So which GDMT should be followed to manage this kind of patient who are extreme high risk for recurrence of hospitalization? This is the European Association of Cardiothoracic Surgeon guideline. They have clearly mentioned, all the 4 GDMTs are important, 4 pillars of heart failure therapy, but out of them probably we have strongest data in favor of sacubitril valsartan. This is having a class 1B recommendation. So all patients who are undergoing bypass surgery should be having this if the ejection fraction is less than 40%. There is no denial of the fact. And if you see the European Society of Cardiology guideline, if you see the American College of Cardiology guideline, everybody is actually unanimous. You need to prescribe proper medicine. 4 pillars until contraindicated, and out of these 4 pillars, probably we have strongest evidence in favor of sacubitril valsartan, and this is the data for sacubitril valsartan to reduce the risk of cardiovascular mortality and heart failure hospitalization in reduced ejection fraction patient post-revascularization. There will be 26% reduction only by prescribing this single molecule. There will be 26% reduction in the risk of mortality from cardiovascular causes and heart failure hospitalization, which is a very significant number. 19% reduction in the risk of cardiovascular mortality if you just simply prescribe this molecule to your post-bypass surgery or post-angioplasty patient who have actually less than 40% ejection fraction. There will be 20% significant reduction of cardiovascular mortality compared to enalapril. So this is a very significant data. We should not ignore this data. There is 17% reduction of the coronary composite outcome, composite of cardiovascular mortality, non-fatal MI, angina hospitalization, coronary revascularization, everything is going to come down to. So summarize, implementing GDMT post-revascularization improves the clinical outcome in heart failure with reduced ejection fraction. So all your patients who are getting discharged post-bypass surgery, post-angioplasty should have 4 pillars of therapy until contraindicated, and we have strongest evidence in favor of ARNI. Thank you very much.
Suppose I have a patient of post-revascularization LVF 38%. One patient has symptoms of heart failure, one patient is totally asymptomatic. Would you consider GDMT in both the groups, or you will want to give GDMT only in the symptomatic group?
Very relevant question. In fact, we should clearly understand both the group will benefit out of it. Why? The patient who are symptomatic, their symptoms are going to improve, their quality of life is going to improve. But even in patients who are not symptomatic, you can have clear-cut data. There will be 20% reduction of sudden cardiac death. Less symptomatic patients, they die higher. The number of death with sudden cardiac death and unexplained death actually is higher in less symptomatic patient. So we have very clear data that even if your patient is asymptomatic, if you replace ACE inhibitor, or if you can start de novo ARNI or other pillars, other important three medicines, group of medicines in heart failure, that will have additional benefit in terms of reduction of sudden cardiac death, and that will also have improvement of survival because there is clear-cut mortality benefit.
Thank you, Dr. Arindam. One question that one patient presented to you with that heart failure with reduced ejection fraction. Now, undiagnosed CAD, when you subject that patient to CAG?
So unexplained LV dysfunction, as of now, if you see the coronary angiography, guideline, so unexplained LV dysfunction is a class 1 indication to go for angiography. We discussed this in different forum as well. So at least we need to do angiography because we are not sure doing revascularization will improve the outcome or survival or not, but there are subgroup of patients because some group of this patient will have left main disease, will have proximal LED involvement. So there is data which suggests if we revascularize them, then there is survival benefit as well.
Now you will do that viability test or directly you go for the revascularization?
There is no viability test in 2025 you can rely on. So I don't personally believe on viability test. They are of no use. So you should use your clinical judgment. If your patient is having chest pain, which you think is anginal, probably that is the best viability test. All other viability tests need to come a long way because none of them are actually gold standard now.
Thank you,
Just
Dr. Pandya.
one question.
Lot of questions now. Yeah,
Dr.
sir.
Pandya.
Please,
Yeah,
please.
that is thing.
Dr.
Thank you
Pandey.
to nice presentation. Yes. But question of that in cases of the post-CABG and post-PCI complete revascular, in spite of that, low rejection of patient getting the pain, 40% cases. Because of intermural small vessels, 40% cases, inoka is there, microvascular disease. So that cases definitely should be proved that ischemic burden, how much it is. Because SPECT, PATS, MRI, and trace echocardiogram duodenum tests available now determine the ischemic burden of that. If the ischemic burden is very high, that case revascularization either CABG or PCI, depending on the coronary anatomy, must be very helpful addition to the guideline directed therapy.
Thank you, sir.
Thank
The
you.
debate will continue. Dr. Das, just a quick word. Yeah.
Yes, sir.
Any role in low ejection fraction in patients with aortic valvular disease, for example, severe aortic regurgitation with low ejection fraction operated for aortic valve disease? So do you have any role on RNA in this case?
Yes, sir. So all these trials, they did not look into the etiology of heart failure. They look into the heart failure overall. So be it ischemic, non-ischemic, valvular, if you have low ejection fraction, you have clear data. Definitely this particular patient will not improve until you change the aortic valve. But at the same time, GDMT is also extremely important. It is mandatory to give all guideline-directed GDMT until contraindicated.
Thank you. Arindam. Time to move on. Sir, but I think may I invite Dr. Aftab Khan to take us through newer drugs, and Dr. Ravin can give the comment.
No, I think regarding viability test, what Saroj said, I think the cardiac MRI, functional MRI, is coming up as a new role to assess not only the viability, also the functionality of a dysfunctional myocardium and prognostication on a long-term basis. MRI is coming up.
Thank you. So I think we've had a lot of discussion, and I was fortunate enough to follow up Professor Robin Chakraborty and Arindam. So my talk becomes that much simpler. So I really don't know how many slides to keep, and probably will skip through a lot of slides. So my talk is newer drugs and heart failure. Now what is new is difficult to decide. I mean, new can change based on which area you are in. Now in 2025, if you look at new drugs, we probably be talking something different. I think this is a slide that we all show when we speak to our colleagues, and I think this is just to explain to you that the most stable patient of heart failure has more risk than the worst patient with an atherosclerotic cardiovascular disease. We all understand about coronary artery disease, but we don't really put our thoughts into stable heart failure or unstable heart disease. And that's where I think we need to understand that we are on the tip of an iceberg, looking at the tip of an iceberg when we see our patients with so-called stable heart failure. This is again a slide that we all have seen. It's always a downward trajectory once you diagnose your patient as having heart failure. And we have these hospitalizations with acute decompensated heart failure. And we have Indian data too, besides the one that Professor Chakraborty showed. the Trivandrum Heart Failure Registry also reflects the same thing that has been noted globally. We have almost a 30% rehospitalization rate within 1 year. So 1 of every 3 patients will come back to you within the first year itself. And each hospitalization is a killer. It is life-threatening. So once you have a patient who comes into the hospital, there is a 3-fold more chance that he will probably not leave the hospital. So each hospitalization adds to mortality. Again, there's a concept that I would like to bring on, and that's the concept of home time. And this is now emerging as one of the criteria to understand how your patient is doing. Hospitalization is an event, definitely, but how much of the time that the patient is spending out of an hospital institute or of any other heart care institute, and how much time he is spending alive and well at home is now becoming an important criteria. A hospitalization maybe for 1 day, it can be for 4 days, and that may not reflect the accurate criticality of a patient. And a home time is now being looked at as a more patient-centric outcome parameter to decide which patient is doing better. This is again a slide that Professor Chakraborty has shown. We've moved on from 1980s to where we are right now. And the future, again, as he's already talked, is about AI and phenotype-specific treatment of heart failure. 1980s, we had basically the ACE inhibitors, beta blockers, and the MRAs. 2000s was the year where device therapies really took the center stage. And then we had the other guideline-directed medical therapy that has really changed the outcomes of how we seek our patients. This slide has also been shown, and we already know about these 4 and the others, the iron and the bericiguat, which can be possibly added on, and of course, ivabradine also, which can be added on as essential drugs when you're treating our patients. Why it is important to know that we put all these patients on medications is that you add life to patients' years. So there has been data to say that you can add on an additional 8.3 years in a 55-year-old man when you add him on guideline-directed medical therapy as compared to conventional medical therapy, and 8.3 years is huge. And there's almost a 73% absolute risk reduction in terms of mortality when we put a patient on heart failure therapy. So we need to understand that we are not just improving patient's symptoms, but we are also allowing him to live longer with the therapy, and therefore it really is essential that we target guideline-directed medical therapy for all our patients. When it comes to mildly reduced or preserved ejection fraction, well, this is 2022, but ESC 2023 has now put SGLT1 in a class 1 indication. So SGLT1 is across all heart failure, irrespective of where you stand in terms of medications. We have other therapies also which are intermediate, and once a patient is not doing well, you have to look at these other novel options besides, of course, CRTs and your other therapies. And we have therapies known as CCM, or cardiac contractility modulation therapies, and baroreceptor therapies, which have been really looked at to benefit those patients who are not responding to patients with not responding to devices or with medical therapy, or those who have not really qualified in terms of a QRS duration to really be eligible for a CRT. But again, these are something which are still experimental and not really available with us in India to be really looking at them. Dilip has also talked about MitraClip or transcatheter edge-to-edge repair of mitral valves to help us in those patients who have been tried guideline-directed medical therapy and are still not doing well. Now we look at newer therapies, and we know that we have tried these medications, and we've looked at all these, and they work at different mechanisms. They help by vasodilatation, they work on reducing fibrosis, they work on nephron protection, and we all understand that heart failure is now looked at something that is known as a CKM, or a cardiorenal metabolic disease, rather than just the heart alone. And I mean, this is a busy slide, but this is where they work. And this is just to help us to understand it's not one target, it's multiple targets. And therefore, we would want patients to be started, even if they're on the smallest dose of these medications, all 4 should be started, or they should be started even in the smallest dosages, rather than trying to go up on one dose alone and not doing the others, because they work at different sites on the cycle. Some of these slides, I'm sorry, they would be pretty busy, but I'll run through them. And this is RNEs. We've already gone through this. Professor Chakraborty has talked about the Paradigm HF trial, a trial which showed mortality benefits in patients with heart failure, reduced ejection fraction, and that got it its class 1 indication. We have data in patients with mildly reduced or in preserved ejection fraction, where it's a class 2B indication. And this has come on with the Paragon HF trial, the Paragon HF trial, which said that probably you could use it, the benefit if you did a subgroup analysis was in patients who had an ejection fraction up to 57% and females. So those were two groups of patients where we probably could use RNAs, and that gets a class 2B recommendation. Patients who are we've started off with using RNA in the OPD and started using them into patients who are hospitalized, and we start using them early. The Pioneer HF and the transition trials also give data that we should initiate them early whilst the patient is in the hospital or pre-discharge so that you get the benefit of RNA early. We've also talked about the heart failure, reduced ejection fraction, and SGLT2 inhibitors, DAPHF, Emperor reduced, the Soleast WHF trial. So these were all patients who have reduced ejection fraction, and now we know that this has got it a class 1 recommendation in patients with heart failure with reduced ejection fraction. And as I said, this is not a class 2A recommendation anymore. ESC 2023 has put it a class 1 recommendation now, and you'd use RNA across, you used SGLT across the board, irrespective of the ejection fraction. So that's one of the drugs that you don't need to escalate. You give it just across the board, even without waiting for an echo to get the heart function. We've also had the same thing as we are done with RNA, started on OPD stable patients, and now we've started using it in patients who are hospitalized also, and that comes from the Impulse trial, a small trial, 530 patients, but we started it early whilst the patient is in the hospital. Once the patient is stable, as compared to placebo, we had a benefit in terms of endpoints of first hospitalization and in all-cause mortality. So this is across all ejection fractions. So irrespective of the ejection fraction, starting SGLT2 in the hospital is something that one should do. Vasodilators, again, the Victoria trial, which looked at vericiguat, and that's a soluble guanide cyclase stimulator. The Victoria trial, again, was used only when patients had worsening heart failure. So when they were really sick, and then this still showed that though there was no mortality benefit, there was a heart failure hospitalization, and combined the endpoints were a bit better. And since we thought that this was in patients who are very sick, the logic was that in the Victor trial, using them little early rather than waiting, then they become so sick and they have worsening heart failure, might as well start them early. And the Victor trial has been looking at patients where we initiate vericiguat before they have heart failure hospitalization. So it did not require heart failure hospitalization in the last 6 months like the Victoria trial did. Neither did you have to have IV diuretics in the last 3 months. So you want to start them early to see whether we benefit them early. Digoxin, again, I think this was also mentioned by my previous speaker. Interest is now coming back, but we don't have enough data, and this DIGIT-HF and the Decision trial will help us to understand, whereas now presently we use digoxin mostly in patients who have atrial fibrillation along with heart failure. We are also looking to find out whether you can use it in patients who are in sinus rhythm, and we have heart failure, all-cause mortality benefits or hospitalization benefits. So I think we are looking at mortality benefits with digoxin to see whether that's a drug that should come in. Again, as I said, newer drugs, again, a busy slide, but it just shows you that there are so many other targets that one can use, and this is where science is now looking at to decide where you could put your money in. Non-steroidal MRAs, I think this again has been mentioned by my previous speakers. We are now looking at patients with, especially in patients with heart failure with preserved ejection fraction. So we have data more in heart failure preserved ejection fraction with your finerenone. We are also looking at data to say whether combination of finerenone with empagliflozin, as we said, you want to start EMPA early in patients with heart failure, whether the combination would give you a better outcome. That is what is also being looked at in patients with in the confirmation HF trial. Again, one more drug that we often use is tolvaptan. So this is a vasopressin receptor antagonist. We often use it for maintaining the potassium, and though it has a drug which has an aquaurisis, so it causes more of water loss rather than sodium loss. And this was again tried in a group of patients in TACTIS HF trial and the Secret of CHF trial, where they tried to see whether using this drug would help outcome benefits. Well, it did produce more diuresis, so your patients were decongested earlier, but it did not translate into major outcome benefits in terms of hard endpoints. We also have data from GLP-1 agonists. So again, heart failure and obesity is something that's coming back, and we have the STEP heart failure preserved ejection fraction data. Again, these data is more in patients who have heart failure with preserved ejection fraction. In reduced ejection fraction, we are still not there. to say whether we really have a benefit, and that's what the trial would really be looking at. Especially the data is more strong in patients, for example, if they have diabetes or if they have associated kidney disease. But again, in preserved ejection fraction, we really don't have the data. In reduced ejection fraction, we really don't have the data. And especially this trial, which was known as the FIGHT trial with the liraglutide in patients with heart failure with reduced ejection fraction, was a negative trial, so we did not get the benefit. So we still would use it in patients who have obesity with a preserved heart failure. Other mitotropes, coenzyme Q, this is something that has also been tried, and yes, it has had some benefit. This was a 2014 data, small numbers, 420 patients only, and it showed that yes, you could use it in patients who are very sick, and you could get a low cardiovascular mortality. Trimetazidine is another drug, 2016 data, again, a very small number, 55 patients alone, and they said that there's a trend towards an improvement in the ejection fraction. Again, I think this has again been talked about. Omecamtiv, again, has been talked about by Professor Chakraborty. Again, we have others, mavacamten in patients with hypertrophic obstructive cardiomyopathy. We know that these are patients who often can present with heart failure with preserved ejection fraction. Anti-inflammatory drugs, heart failure with a CRP that is elevated and ejection fraction that is more than 40%. We have these drugs that we're looking at, ziltivekimab, and we have the anakinra, which is used for rheumatoid arthritis. We are going to be looking to see whether these patients do benefit, especially those who have an inflammation or a CRP that is elevated. Phenomapping is something that is now going to be looked at. And again, we know that not all heart failure is equal. And again, the best example is heart failure with a preserved ejection fraction. And what we all understand is that we can have 3 different phenotypes. You can have an older vascular aging phenotype, the elderly patients who have atrial fibrillation, who have hypertension, who have heart failure with preserved ejection fraction. We have the metabolic obese phenotype, the obese patients, obstructive sleep apnea, heart failure, and the relatively younger low BNP phenotypes. And these patients would all be treated differently. Even though they fall into what we call as heart failure with preserved ejection fraction, they would all be treated differently based on their phenotype. So to summarize, we know that there's been remarkable advancement that has been made in the field of heart failure. We still have residual risks despite using the guideline-directed medical therapy. The DAPA-HF trial showed that we have a 16% residual risk despite our use of GDMT, and therefore we still are targeting there. We are still not there. Survival has improved in patients with heart failure with reduced ejection fraction. Preserved ejection fraction is still a ball game that we have still not understood. We are looking at treatment of amyloidosis, hypertrophic cardiomyopathy, where diagnosis and early treatment may change the outcome in this group of patients. And ongoing trials, advancement in phenotypic segmentations, and use of AI may help us to understand how we treat our patients differently. Thank you.
Myocyte usually uses that fatty acid as oxidation to produce ATP. Then but it increases more than 20% of the normal oxygen for oxidation of the glucose or other pyruvate or that ketone body. So we shift during heart failure, basically shift from that fatty acid oxidation to other metabolism. So baseline of that the drug of these all depends on this metabolism. Whatever, or say CTP inhibitor, that the trimetazidine or omecamtiv, stuff like that. And coming to the Dr. Das's question, that what Arindam was talking, that whether it is useful in the post-aortic stenosis, the hypertrophy, or that in the hypertrophic cardiomyopathy, omecamtiv will be useful. So all the drugs depend on the decreased fatty acid oxidation or increased fatty acid utilized, or increase the glucose utilized, or increase ketone body utilized. The basic concept for improving drugs or adding on drug or depends on these factors. I believe it.
Thank you. We have some hands coming up. Yeah.
Ruling out reduced ejection fraction, no bias. SELECT trial clinically showed improved outcomes in heart failure, both heart failures. HFrEF hazard ratio was 0.65, and HFpEF was 0.69. So, I mean, events were a little bit here and there, but we cannot completely rule out reduced ejection fraction from semaglutide. I mean, this comes from a very personal note of, my clinical practice.
So we are going to hijack GLP analogs from endocrinology, same way as we have hijacked SGLT
Absolutely,
inhibitors.
the way you did SGLT2, yes.
Thank you. I think it was fantastic first session. It generated a lot of discussion and comments. So we conclude this session here. Thank you so much. Thanks to all the speakers and my co-chairs.
Thank you for a very enlightening first session and the beginning of the day. Moving on, extending a very...
We move on to the academic sessions. Thank you all. Thanks.
Thank you all. Moving forward, to sail us through the next session, which is on advanced management and device therapies for heart failure, I would like to call on stage to chair the session Dr. Lalit Kapoor, Dr. Plabhan Mukherjee, Dr. Dipankar Ghosh Dostidar, and Dr. Arijit Datta. The chairpersons will be introducing the following speakers. I would also request Dr. Mrinalendu Das sir to grace the chair.
We'll change the order a bit. Good morning, everyone. Dr. Bala would like to speak first. I've been told that on the Indian devices for heart failure from concept to implementation. He needs no introduction.
Sir, I'll call you back a little later. Good morning. This is an unusual topic in a heart failure and transplant meeting. As I said, thanks to Dr. Kunal, who asked me to speak on a relatively new area of our endeavor. So how did I start this very unlikely journey into very unfamiliar territory? As you all know, we've been very busy with transplants, and over the course of the last decade, in spite of having done over 100 odd VADs, there are clearly patients, despite organ availability, who are not good candidates for a transplant and need a VAD. And I looked at the challenges in increasing the number of implants despite good outcomes. The longest surviving VAD in India is this man. I think he's now 12 years post HeartMate 2. This young boy, 3 years after VAD, is able to physically climb the Raigad fort on foot. As you can look at the steep steps, it's not easy for normal people to do that. This man next to Anna Hazare, 3 months after VAD, is playing volleyball in the forecourt, and in the morning he's milking his cow and dealing with cow dung. And the currently available VADs only one support the left side. A lot of our patients have biventricular dysfunction with poor renal function. It's not easy to carry 2 HeartMate 3 bags and controllers. And most importantly, from our perspective, we generate a lot of electronic waste. Every time you do a VAD, you have to buy 2 controllers, 2 sets of batteries, and if that patient gets transplanted, dies or recovers ventricular function. So this is just from 5 years of VAD work in our own hospital. What do you do with this? You can't get a refund. Patients in this country often ask for saying that we paid for so much, can you do something with it? And the biggest elephant in the room is the cost. So we started a company to build VADs. It started in Sydney. I was one of the founders. We raised $5 million and actually held up. The idea was to build a VAD. And this is a slide from the ASIA meeting in New Orleans last month. Even in the United States, only 15% of patients who need a VAD receive it, and amongst other things, one is the cost. And we thought if the cost could be more manageable, we can include it in the state insurance schemes and Ayushman Bharat increase in numbers. So we built a VAD, which is small in size, which is slightly smaller than the Medtronic HVAD, with open-throated impeller, with the diamond-coated DLC coating for reducing thrombus. And it was hydrodynamic to begin with. One of the key features was to make it an affordable pump, which can support both the right and left ventricle by VAD with a single controller and single battery. And we were able to achieve a very flat SQ curve with fairly pulsatile flow with 10 millimeter outflow graft. In the month of January last year, by a force of circumstances, we ended up doing almost 7 transplants on patients with functioning VADs, out of which 3 were HeartMate 3 and the rest were HVAD. And this is, you can see, these patients actually did not have a stroke, but all of them had a big thrombus, the junction between the sintered and non-sintered part of the ventricle. As you can see, is a big thrombus. This is an HVAD 9 years after the VAD implantation. You can see the healing around is still flimsy. And this is a 9-month-old, I think this was done in Singapore, right? Dr. Sivadas' patient, we came to us for a transplant. 9 months after VAD insertion, you can see the solid healing of the inflow cannula and the beautiful endothelialization around the inflow cannula. So I think Medtronic's HVAD, apart from other issues, one of the reasons for the stroke was the inflow cannula design. So we created entirely sintered inflow. We took out several patents on this. And the animal studies, we implanted over 20 animals across 3 cities, Adelaide, Melbourne, and Palomar Institute in Hyderabad. And then after a $5 million investment, we faced headwinds, we had a fund crunch, and we have now shifted the entire company to Chennai City to complete GLP certification and get CDSCO approval for first-in-man, that work in progress. So that every crisis is an opportunity. When we're trying to raise more funds for this, everyone said if you actually have a catheter pump, which has a greater market amongst cardiologists, we might be willing to fund it. Anyway, we ended up, me and the business partner I had, we funded this. We started a new company called FlowAid in the IIT Research Park to build a microaxial catheter pump for acute heart failure. This was started as a startup in the month of June last year, 2024. And the indications for a catheter pump, of course, are well known, including high-risk angioplasties, cardiogenic shock, and in pediatric age groups, I think a failing right ventricle and a failing fontan might perhaps be. So one of the PhD students under me, I'm also a faculty in the IIT Madras. He did his MS thesis under me in catheter pumps. So I called him back. He was working as in a semiconductor design company in Taiwan. I called him back, and we started this company as him as the chief technical lead. So we designed impeller in-house, totally from ground up, built our own mock circulation loop, optimized the design, and created the impeller, the inflow and outflow connector, and the entire assembly was done in-house. We had two different cannula lengths, 5 and 7.5 centimeters, to account for different body sizes. One of the challenges was to get a motor. The only company which makes a motor of that size is from Germany, and they are contracted to impel our company, and they won't supply it. And the other one actually asked for 2 years lead time and more than $2 million in optimization. So we thought we would use an external motor with a flexible shaft. Thereby, we can actually reuse the motor and reduce the cost. It also actually surprisingly gave us bigger advantages in terms of greater maneuverability across the aortic arch, better torque, and actually we got better flows. So we have designed a patient monitoring system which can support both right and left ventricles with a single controller. And we actually put in an ultrasound sensor, 200 microns, in the connecting cannula between the inflow and outflow connector so that we can actually have a measured flow instead of estimated flow. This pump initially was designed to deliver 3 liters flow at 60 millimeter mercury pressure head for an overall diameter of 14 French, which can be increased to 4 liters. We compared head-to-head with our pump with the impeller pump, and actually we got much flatter HQ curves and higher flows for the same RPM. And I think one of the reasons was since we were using an external motor, our torque was higher, and we could actually ramp up the motor as much as we wanted to get good flows. So that turned out to be an advantage. So by the time we started all this, there's a very nice animal facility in Hyderabad called Palamur Institute, which is GLP certified. Now there's one more lab in Chennai, about half an hour's drive from our research facility on the highway to Bangalore, which is a very beautiful modern lab with a Getting operating room and a Philips gas lab. So there are at least now 2 GLP certified labs in India, which are much less expensive than going overseas. So we chose the pig as the size of the femoral artery in the pig is actually bigger than the sheep. And because of the design, actually the device insertion is very, very easy. Within 3 minutes from the puncture, you're into the ventricle and pumping. And I think we have done 5 pig implants so far. We initially tried without a PERT system, and for that duration, actually, it works without a PERT system. But we have incorporated a PERT system in case it's needed. And the entire patient monitoring system was designed in flow. So we got a pressure sensor which can actually measure pressure. And we also have a thermistor probe in the catheter so that we can have the actual cardiac output. So compared to the existing impeller pump, a few features which are actually more advanced than what is. So one of the things we found was at very high flow rates of 3.5 liters, actually after 9 hours you get hemolysis. And sometimes the sheath around the flexible cable actually has this thing. So one of our PhD students started a project Raktamantra to optimize hemolysis. And now the hemolysis is down to actually levels comparable to the impeller. The holy grail is to give you 5 liters at a 10 French size. So we had a design engineer from IIIT who's a PhD, a young guy, 30 years old, we hired him. So he came up with a nice design, and we just got a beautiful impeller design, which is an expandable impeller, which can shrink into a sheath, which is 10 French in size, and then goes out and expands into a 5.5 millimeter impeller, which can deliver 10 liters at 5 liters. And that's undergoing trials. We also designed, as a part of this, a reverse impeller, which can support the right ventricle, or in children, through the left ventricular apex into the aorta. So this guy who's doing this has a wide, vivid imagination. He calls it Matsya because it looks like a fish, I think. So the big challenges are you can either have a duration of support which is high and a maximal flow, or a entry size profile, but it's not easy to have all 3 in one device. We also felt the big need for mechanical circulatory support through a percutaneous device in children because we see a lot of heart failure, acute myocarditis in children, and to initiate ECMO actually takes longer time through because children, central ECMO is what is possible. It's not easy. So the youngest we have done is this 12-year-old girl through a transaxillary impeller as a bridge to transplant. So we also use a lot of mechanical pumps in Alcapa children, especially with profound ventricular dysfunction. We electively put in a LVAD and support it for 3-4 days before extubation. So we looked at the feasibility of adapting our pump to pediatric application. So we looked at the size of the femoral artery in pediatric population across and the second constraint was the size of the aortic annulus, because the aortic annulus has to be big enough to accommodate the profile of the catheter. And then the third biggest challenge was the distance between the midpoint of the left ventricle and the top of the sinotrabecular junction. One size cannula can be too long in a child. So we looked at 50 DCMs in our series of CT scans, and compared the distance between those less than 10 kilograms and those and more than 10 kilograms. And on that basis, they designed 2 different sizes of cannula. And if transaortic access is not possible, we thought a transventricular access should be possible in children if the peripheral artery is so small. So we have designed an apical access device made of nitinol, which can be introduced percutaneously into the left ventricle, through which you can push in a catheter through the aortic valve into the ascending aorta. This is accepted as one of the first best projects for pediatric mechanical circulatory support in a SIO meeting in New Orleans 2 months ago. So where are we now? The design is frozen and components and sources are sourced from facilities in Hyderabad, Mysore, and Chennai. We have a manufacturing license and are partnering with a local facility for contract manufacture. We have completed a 12 French catheter pump delivering 3 liters at 46,000 RPM. We have an 18 French catheter pump delivering 5 liters at 30,000 RPM. And we have an 18 French RV support pump. And we are developing an expandable impeller 10 French cable of 5 liters at 30,000 RPM. We expect to finish the GLP certified animal trials before December 2025. And the work's already started, and hopefully first in man in the first quarter of 2025. What lessons have I learned in this journey? There's a tremendous talent in this country at a fraction of the cost of what it costs in the West. The salaries we were paying in Australia per month is what I can hire somebody per year in this country. All young kids, 25 to 30 to 35, extremely eager. There's a booming private sector in contract manufacturing, though it takes time and effort to find them. There's a surprisingly active space for fundraising, both venture capital and private HNIs. There are plenty of interns available who cherish industry experience, are surprisingly good, sincere, and very motivated soon after graduation. This is actually surprisingly in contrast with medical graduates who are always preparing for the next NEET exam and post-graduation have no interest in research. So understanding the challenges in design and manufacture has been a life-changing experience. One thing to put in a VAD clinically, another thing to know how it's designed, manufactured, what are the pitfalls, what are the challenges, what we need to do, and I think we have to traverse that space. Bench tests and CFD results are exactly like operative pictures in an operative surgery textbook. They don't bleed, so the actual experience into manufacturing is a totally different animal. Animal implants and survival are not easy. Actually, it requires even more skill than getting human survival to extubate a sheep after putting in a VAD on bypass and getting it to extubate and stand up and breathe. There's no intensive care at night. These animals have to survive for 3 months. It's actually a huge challenge. You need to build a team. So you have to fail early and start again. Don't fail late after you spend a lot of money. And you have to build a smart, loyal design and manufacturing team and be liberal with equity and compensation. So the chief technical officer in our company, he's got 20% equity. I pay him 6 lakhs a month, but the guy works 36 hours in a day. It's brilliant. We have technical talent to build world-class products in this country. We need more animal facilities, that's for sure. What are the challenges we faced? Again, those of you who might wish to embark on this journey. Government funding exists in principle in large amounts, but it's very slow, erratic, and bureaucratic, and I could not navigate the space, and maybe it's okay for some others. So depending on government funding, you'll never get anywhere. Barring a few exceptions, government facilities were not very useful. They don't stick to timelines, equipment often don't work, technicians are on leave, they have no skin in the game. Whereas private players, since they put money in it, they are more than eager and actually eager to help. Again, this is a very frank statement. Chinese companies respond 24/7 with quotes and deliver before them at a much lower cost for samples, even in lower numbers for components. It's the reality we need to confront and learn from. I found them, you send an email at 1 o'clock at night, at 1:30 you have a reply. In India, it takes much slower to respond and often more expensive. I think it's something we have to be ready to accept and perhaps improve. The other challenges are importing components. Every device which is made anywhere in the world, not all the components are made in-house. Importing components, we have to pay, as a startup in the revenue, 18% GST and 20% customs duty. That is actually cruel. That is not easy. So automatically the cost of any component goes up 100%. That has to be. I've spoken to several people in the ministry. No one seems to be able to do anything. Manufacturing license takes time. Documentation for CDSCO approval is complicated. Even getting animal blood for hemolysis testing is a challenge. There's no clarity on number of animals in duration of support or the number of patients in duration of support. This is our team of 20 engineers. And we started this with a seed capital of $300,000, a fraction of what we spent overseas. And hopefully we'll be able to make an impact. Thank you very much.
Great presentation, Bala. So this is basically our Indian-made VAD, which we are trying to make it. And the difference is this the cost or any other difference is there compared to what existing VADs?
The cost?
Yes.
Oh, yeah, we plan to costing is not in our hands. Cost of manufacture is in our hands. The cost at which we sell is a complicated business. But nevertheless, I think it would be substantially lower. And we are planning to I think a catheter pump at 5 lakhs would be actually a game changer compared to 27, 28 lakhs we spend now.
The other important thing is the main problem with the VAD is the drive line. So have you worked on that?
Our driveline, again, we found a company in Bangalore run by a young guy. They are not even IIT graduates. Brilliant chaps. So we've taken this hydrodynamic marrying. So we flattened the top of our impeller, and actually we're making a hybrid hydrodynamic / maglev. And he's been able to put all the electronics inside the pump. So the driveline actually is 4.2 millimeters in size. And as I said, we have a patent for iliac bone-based coupling system, where like a hybrid Toyota car, even if you don't have a total transcutaneous energy, you can have a tether-free or untethered life of few hours a day, where you can take a shower or swim and come back. That's a start before going totally driveline-less.
Thank you. Any questions from the audience?
Thank you, Dr. Bala. I'm here, Laban. Daughter's heart transplant. Now you teach us all this. I marvel at the scientist and the innovator. I hope you can inculcate this into all of us. That's right.
Thank you.
Thank you so much for coming.
May I call Dr. B.P. Pandey for his talk, Optimizing the Patient Care, Translating Evidence into a Clinical Practice. Dr. B.P. Pandey.
Good morning, respected chairpersons. My job is to tell you regarding the evidences of using Verisuat in heart failure. So this slide you have seen that no heart failure is really stable heart failure. So we have got an analogy like oncology, either it's active disease or is in remission. So most of the so-called stable heart failure is actually in remission, and we need to continue all the GDMTs which we have started. The problem is with the foundational therapies, usually because of the hypertension or renal issues or potassium issues, we are not able to up-titrate doses in many cases. Indian studies like Trivandrum heart failure, the GDMT rate is poor, less than 20%, all the 4 drugs. So at least the discontinuation rate is also important. It's maximum with MRI is around 42%. And across the board, all the 3 drugs are discontinued around 1/4 of the time, 23, 26, 25%. So starting is a problem, and continuation of the drug is a problem. And once you discontinue, it's usually not restarted. That is another problem. It's a problem with the clinicians. So we know all the blockers, like all the 4 GDMTs are actually blockers. So when the chips are down in a really failing heart, we need some activators. And one of the activator is cyclic GMP activator. And another you heard in the previous talk was omecamtiv, which is myosin stimulator. So if you work on other pathway like cyclic GMP, probably it paves the way for restarting other GDMTs which were withdrawn either because of the side effect or which was not initiated either because of the hypertension or low EGFR. So this acts on different pathways. And looking at the residual risk in all the mega trials, look at the response rate. The Even the primary endpoint in the paradigm heart failure in the comparator arm, look at the DAPA or Emperor, it was around 14 to 15% in the active arm. So there is a lot of residual risk even with all the 4 GDMTs. So we really need to add something else. And with the vericiguat, you can see the absolute risk reduction was around 4.2 with the pretty low number needed to treat. Heart failure is slightly different than atherosclerotic. You have seen this slide. 1 year mortality could be as high as 40% compared to the worst case scenario on ASCVD, which has got 7 to 8% 1 year poor outcome. So how we can tackle this, and I'll discuss 3 case scenarios. One is those patients who have got a decompensation, and if you look at the background therapy, they are already on 4 pillars of the therapy. What else you can do? This is the perfect case of adding vericiguat, as was shown in the Victoria trial. Just a reminder that Victoria did not include SGLT2 because it was not on board when it was tested. So this is the simple way to add vericiguat. If your patient is still symptomatic, not coming up with the 4 foundational, start using vericiguat. It's 2.5, 5, and 10 milligram doses with not much of side effect. And the lowest eGFR you can start if it is even more than 15. So in fact, the 2 drugs which can be started in stage 4 CKD is SGLT2 inhibitor and vericiguat. All other, you need at least eGFR more than 30 bearing beta blocker. So this is the 58-year-old gentleman who had a PCI for STEMI, low EF. He was in outpatient, class 3 symptomatic. After stabilization, he was started with ARNI, SGLT2 inhibitor, spironolactone and beta blocker on top of antiplatelet and statin therapies, and he was not improving. So this is the case scenario 1, where you can add vericiguat 2.5 milligram once daily, and you can up titrate every 2 weeks up to 10 milligram. And it doesn't cause much of hypotension, not more than 2 millimeter drop in blood pressure, not hyperkalemia, no drop in eGFR. So it's a pretty safe drug to start with. Regarding the doses of 2.5, there is also trial going on known as velocity trial. You can probably start even with 5 milligram, so you can cut down another 2 weeks to reach to the optimal doses. So this is the one way to tackle. So all the data set has shown that if you add on top of foundational therapies, you have 10% reduction in endpoints, and that includes mortality reduction or heart failure hospitalization. So it's a very easy drug which does not cause much of the side effect. Coming back to the scenario 2, where you have got incomplete background therapy, mostly because of the hypotension or because of the low eGFR. And these are the patients who are only on a minuscule dose of beta blockade and probably some SGLT2 inhibitor, not on RAS blockade, not on MRAs. So this is the drug vericiguat. If you add, it will pave the way for future. There has been data from, although retrospective from Germany, known as the PAVR trial. Those patients who are started on vericiguat and SGLT2 inhibitor, down the line 2 years, a good number of patients could be reinstituted on ARNI and MRAs. So it paves the way for future GDMT therapies. So this is one way to start. So the similar case, 66-year-old lady who had NSTEMI, EF is pretty low. She's only on beta blockade, carvedilol, and SGLT2 inhibitor, apart from diuretics and anti-diabetic therapy, EF around 30%. So this is the case scenario 2, where you can start vericiguat, cyclic ZMP activator modulator, which will help in optimizing the drug therapy in due course of time. So what is the impact of vericiguat on renal function? As I said, doesn't cause drop in eGFR, doesn't lead to rise in potassium, and you can prescribe up to eGFR of 15. Even when the eGFR drops below 15, there is no impending reason to stop this drug, just like SGLT2 inhibitors, whereas you have to down titrate your MRAs and RAS blockade. Coming to the case number scenario 3, there could be a situation where you have got incomplete doses. It was because of the clinician's inertia, and patient has landed with a worsening heart failure. Of course, you will act in two ways. One is to up-titrate the therapy, which is guideline mandated based on the checklist of contraindications. At the same time, we'll initiate a vericiguat in 2.5, 5 and 10 milligram. So just to simplify the things that if you get a patient like this who are on suboptimal doses of GDMTs, you will increase the doses based on strong heart failure data, that if you are on an optimal dose, say beyond 80%, probably you'll get the maximum benefit, and at the same time you add vericiguat. So you have got a 3 broad case scenarios of using the cyclic ZMP, but the most important scenario is the number 2 scenario, when we could not use because of the EGFR potassium issues or BP issues. Then it paves the way for adding other drugs in subsequent period of time. So it can be started even in hospitalized patients once they are off inotrope, off vasodilators and off intravenous diuretics. The same is the indication for most of the GDMTs, barring probably beta blocker, and it does not come with much of the side effects. So no hypotension, no hyperkalemia. So at the end of my presentation, my take is that you always ask the question, if I'm not going to start GDMT, who is going to start? So that is the most important. And second question should be asked, if not how, then when. So I'll end my presentation here so that we can take few of the questions. Thank you.
Thank you, Dr. Pandey. So as I assume that those 4 pillars of GDMT, once if you can establish, is there any role of vericiguat in that? Or if you cannot give one of those, for example, for low blood pressure or kidney function, then only this is the alternative. Is
so
that
as I said, the Victoria trial was done on top of 3 optimal therapies, because SGLT2 use was only 2%, it was not on board. So the evidence-based is only that. And the other 2 scenario is the usual clinical practice, because you have seen, based on the retrospective data, as the said PAVR data from Germany, 2 years data, more than 2,000 patients, it always paves the way. So you can start, because it acts on a different axis. You give more ATPs, more bioenergetics to optimize the heart failure patient, then you can always add on other therapies. So priming of the drug is important, like priming with SGLT2, which brings down the potassium to a lower level. It acts on the bioenergetic level, and then this cyclic GMP stimulator. Then your blockers will act.
Thank you.
I mean,
Any
we don't
questions from
use
the
this drug that often now. We are still with ARNI. So like, what are the drugs we should be careful about for that interaction? Stop anything like,
No,
as
no,
we have to
for,
stop?
for starting vericiguat, you need not withdraw any of the drugs, because this is a very neutral. No hypotension, no hyperkalemia, no drop in GFR. In Victoria trial, a little bit of anemia was reported. We really don't know the reason why there was anemia with the use of vericiguat. The only caution is that you have to stop nitric oxide donors like sorbitrate or sildenafil if he's on board, because 2 nitric oxide donor is of no use.
Any questions from the audience? Dr. Dilip Kumar? Okay, thank you. We'll move on to the next topic.
Choosing the right patient for TAVR in a failing heart. Dr. Dilip Kumar.
Should I get my laptop? Just a minute. So, good morning, and thanks again for having me. Yeah. So, these are my disclosures, and I'm going to talk on who should receive TAVR in a failing heart. So let's begin with who requires an aortic valve replacement. And there is some subtle discrepancies and differences when it comes to recommendations from American ACC and European College of Cardiology and Society of Cardiology. So patients who are symptomatic and having severe aortic stenosis with good ejection fraction, more than 50%, they are recommended. And even those patients who are having ejection fraction of less than 50% and with no flow reserve, suppose we give them dobutamine challenge and still the heart function doesn't go up, these patients also, they do require aortic valve replacement. And then we'll discuss the options which would be better. And also for those patients who are not overtly symptomatic, but still they get symptoms on exercise test, or they have got a threefold increase in BNP, and which is and the patient is perfectly feeling all right. These patients, they are recommended for aortic valve replacement. The level of evidence differs from ACC to ESC. And look at the the criteria where a TAVR and SAVRs are recommended as per the ACC guidelines and the European Society of Cardiology guidelines. The cutoff which is given in ESC guideline is 75 years for choosing your patient for TAVR. And for ACC, they have given a cutoff of 65 years. And then obviously we need to look at the life expectancy of these patients. If the patient is going to live more than 20 years, obviously a surgical aortic valve replacement is favored. And if the patient lies between 65 to 75 years, this has to be shared decision making, which therapeutic modality needs to be chosen. And more than 80 years and less than 10 years of life expectancy, TAVR is the number one choice. And it also depends on how much is the surgical risk. If someone has more than 4%, we have to lean more towards TAVR. And these are the guidelines, these are the studies which paved the way for the guidelines. So these are pivotal studies, and we all know these landmark studies. This is a partner trial, partner 1, 2, 3, and then CERT-AV and Evolute Pro studies. And recently we have another addition in form of dedicate registry, and where a low-risk patients, SAVR versus TAVR, proved to be a little beneficial. So I will take you all through some of the cases, which where it will show us which patient and how TAVR is required and gives benefit to the patients. This was a 59-year-old gentleman who was having a CKD, and he was on maintenance hemodialysis with severe calcific AS of 112 by 67 peak by mean pressure gradients. Patient was in fact waiting for surgical aortic valve replacement, and in between he developed acute coronary syndrome, chest pain, his ejection fraction dropped to 55 to 30%, tropi was 22. He also developed moderate MR. And then he was in hospital on medical management for 1 or 2 weeks, and he was not getting better. Then finally a heart team was set up. It was decided that the patient requires, the only way to treat these patients, these failing hearts with a new acute coronary syndrome, with the dialysis patients with severe aortic stenosis, even if the patient is having 59 years of age, his life expectancy is not more than 10 years, it seemed to be, and then we went ahead with the TAVR. And look at the angiogram. The patient has severe distal left main coronary stenosis. And in the same sitting, we had to stent the left main to LAD, and we also had to do a transcatheter aortic valve replacement. So this is the first case of a left main intervention and a TAVR, which we did in 2021 in India. So a severely symptomatic failing heart patients with poor LV, with acute coronary syndrome on dialysis, there is a genuine reason to go for a TAVR, even if the patient is having a less than 65 years of age. So we need to know the life expectancy. Look at this patient. This patient had a porcelain aorta. So you don't have a place to clamp, and then again, TAVR becomes a choice by default. And this patient also went well. a patient who is in his 80s with 2 episodes of CVA, 2 infarcts in last 6 months. So this patient had 2 spider filters put in the carotids. At that time, there was no sentinel device, and we did TAVR, and this patient also did well. And finally, one last prototype case, patient with a mitral valve prosthesis, a tissue prosthesis, which got degenerated in 6 years' time, and also his aortic stenosis, which was mild, progressed to severe. And finally, the patient landed up with a TMVR as well as TAVR in the same sitting. So these are some cases where we need to take into account the life expectancy, the risk of the patient, the surgical risk of the patient, and finally the patient's clinical situation, and we decide for TAVR. Now looking at those patients who have a good life expectancy, as well as both the options are there, more than 65 years of age, and then from 65 to 75, you have to take a shared decision making. What all the factors which can give some difference in the opinion. So patients with bicuspid aortic valve, we still don't have much of evidence. We have a Notion 2 trial which give us an idea that bicuspid also has the same kind of result. We have a valvular registry from US which also says the same, but we are lacking in randomized control trial data in bicuspids. Unfortunately, Indian patients, we get 30 to 40% of bicuspid patients, and there lies some controversy, some kind of decision making, and it has to be discussed in heart team. This gentleman had a severe bicuspid aortic stenosis with bicuspid aortic valve, with a LVOT calcium, and look at how we had to struggle. One valve deployed, valve got little pushed up, then we had to put the second valve, and finally the patient was doing well. But these are the problems which we encounter while dealing with bicuspid aortic valve. So this is an area where we still need more and more RCTs. Patients where there is a lot of LVOT calcium, there you can't predict the paravalvular leak, how much is going to be left there with TAVR valves, but still we have got some improvements in skirt sealing, and then leaks are coming, but still this is a matter of concern. And requirement of pacemakers, which is around 20-24% in some series, as high as 30 to 40% in some bicuspid aortic valve series. But thankfully, we have got conduction system pacing to deal with this scenario, because this is acquired LBB, which we are going to get the patient, or a CHB, and these patients, they do get this kind of normal ECGs with conduction system pacing, but it's still a matter of concern. If someone has a very long membranous septum, then we need to take a call whether we should be going with TAVR or not. And finally, one of the most important is your coronary access. If you feel that the coronary is going to get a problem and the future access will be a problem, then we need to take a call. This patient, we had a 2 protection from right and left as well, and then this is the balloon occlusion to see exactly our coronaries are going to affect it or not. Finally, we got away without putting coronary stents. It was a good result, but coronary again is an issue. So I started with a kind of a talk, where should we do TAVR in a failing heart? But I would like to end my talk by showing you cases, showing you circumstances where we should not be going into TAVR. And these are the cases: very bad peripherals, you don't have an access. So we only have data with transfemoral TAVI, which is as good or maybe superior to surgical aortic valve replacement in selected and chosen patients, not from alternate access. Patients with severe LVOT calcium, annular calcium, they should also be touched only when this is surgically turned down. And patients whose coronaries are threatened, we don't want to venture with TAVR. So with this, I end my talk here. There will be more studies, RCTs lined up in these challenging scenarios, but as of this moment, you should be concerned more on in which patients we should not choose for TAVR rather than going for TAVR in which patients. Thank you so much for the patient hearing.
Sir, just 2 questions, sir. Sir, you spoke about the failing heart. Is there any role for TAVR in patient with aortic regurgitation and failing heart?
So we have got some trials in pure AR, that is Align AR trial, which was done with Zena valves. So in pure AR, we can't do a TAVR because we don't have any mechanism to fix the valve. In severe aortic stenosis, we have calcium around the valve, which takes the valve, stabilizes the valve. In pure AR, annulus is dilated, there is no calcium, and then your valve can embolize. But a Zena valve has got an anchoring mechanism, and I think the trial has come with more or less non-inferiority showing with Zena valve, but still it has a long way to go. There are some case studies where normal, balloon expandable valves or normal self-expanding valves have also been utilized in severe AR patients, but there we have to go with 30% or more oversize, which carries a risk of annular rupture. So this is still evolving science, but having said, the afterload mismatch, which we see in aortic stenosis patients, we see the kind of LV coming up right in the cath lab. We put the valve, rejection fraction which is 30%. Now we can see here in cath lab only it has gone to 50%, 60% next day. It doesn't happen in AR patients, and there is nothing like flow reserve or kind of afterload mismatch. In AR, you have to be critical about taking those patients who had a very severe, LV dysfunction. Less than 25%, better not to choose these patients. 35 to 40% severely symptomatic patients, bad surgical risk patients, still we can choose, provided we plan the device, oversize the device. We don't have access of Zena valve yet in this country.
Thanks, sir. Sir, and just one more. Sir, there's a feeling among us surgeons, at least with me, sir, that the incidence of strokes following TAVR has been understated. Evidence is showing that the incidence of stroke is actually much higher if you see them over a longer time.
So this is all the RCTs, they have shown incidence of stroke higher in surgical arm, lesser in transcatheter aortic valve arm. So these are 30 days to 90 days stroke rate. I'm not aware about the data where surgical, the stroke is higher, but especially in those patients where we are dealing with valve-in-valve, there is a degenerated graft, we are putting a valve, going multiple times, repositioning, then there is a chance of, or patient with a bicuspid aortic valve with severe calcium, there can be some embolus going from there, not thrombotic, but calcium emboli which can go up. So these are scenarios where we get more strokes, but in all studies till now, in normal tricuspid valves, the stroke risk is more in surgical arms, sir.
Can I just make a comment about stroke rate? I think we have to look a little bit deeper into the stroke data. You are correct. It depends upon what period of time you are studying the strokes. Okay. So if you are looking at the stroke rate post-TAVR till your index hospitalization, that stroke rate is less. But one funny thing with TAVR is the strokes goes on happening over a period of time. So if you translated it as a stroke rate over 3 to 6 months, that is one thing. In heart failure, the other data that we must look at is, if you look at the recent Californian data which has come out, why is it significant? Because according to the ACC, the AHA guidelines, they have given an advisory, not a guideline, about 65 years. Now, a whole lot of TAVRs are happening even in US because it is an advisory below 65 years. But the important thing is, the survival is not showing up to be equivalent. So as TAVR goes on, it's very good, clever technology, definitely gives a better EOA compared to surgical valve, because what is TAVR? TAVR is a stentless valve. You do not have a stent which is eating up your EOA. So all that is in favor of TAVR. As surgeons, we have to accept that the stroke rates were not as catastrophic that we were thinking before, that all the calcium will fly away, etc. It did not. But there is a important piece of the puzzle to be solved, as now we have a significant number of patients with TAVR who are sub 65, who had, by conservative estimate, another 10 years to live. Now, that survival data is not flattering. Now, why is it happening? So that is an important consideration, and you have other couple of things to look at. One is, if you have to explant a TAVR, It's almost like putting somebody in an electric chair. It's got 25% mortality. Secondly is underestimation of paravalve leaks. Is it persistent paravalve leaks which is causing some of your influence in survival? But really we have to look at CD. But the advantages of TAVR are there. They can very easily get into a 15% heart, give you a better EOA and do it. Regarding strokes happen over a period of time. Why? That is a question. They have to sort it out. But as you handle more and more people sub 65, because you see, one important thing is, I forget the name of the trial, there are that many trials, the one about survival.
Notion was, yeah.
Now, Notion trial is very clever. You know why? Because you have a registry which goes into tens and thousands of patients. How many patients did Notion trial look at? If memory serves me right, it is less than 500. So how are we? Because now your results has to be extrapolated on registry data, not on that cherry-picked data where your registry is tens and thousands of patients and you are coming to survival conclusions based on 500 patients. That is scientifically very suspect. Thank you.
I just wanted to have your opinion. In a sub-60 patient who is a renal failure patient or a liver failure patient waiting for a liver transplant or kidney transplant, who is below 60 years of age,
yes,
what is your choice? Would you refer that patient for a TAVR or a surgical valve?
So that's very, very, very important point. We have to look for the life expectancy of this patient. How many valves he is going to get. So when it comes to 60, 65, 75, threshold 75 in Europe, 65 in US, these kind of patients where survival is little doubtful, patients waiting for transplant. And if the transplant surgeon, renal transplant or liver transplant patients, they say that, the surgeon says that no, we are the patient looking fine, and we look at a survival of maybe 10 years or 20 years, 80% probability in this patient, you can choose either of the valves. But if the surgeon, the transplanting surgeon says, like liver transplant surgeon or renal transplant surgeon, he says that no, we are still doubtful, the chance of survival in this patient is 10 years, around 25%, 30%, then definitely TAVR gets the kind of, we should lean towards TAVR. And also, there is one more comment from my side, 65 cutoff. For India, it can be, it can be well understood. But for US, where the life expectancy is more than 80 years, still these patients can get, okay.
And after Trump, it is getting worse.
So it depends. So if life expectancy, so we have around 72 years. So the longest survival we see in Japanese patients, and there the cutoff has kept to be 80 years. Only those patients receive TAVR who are more than 80 years. In Europe, more than 75. In US, 65. And India, I think 65 is a good cutoff. We look at maximum 2 valves, 1 plus 1 more valves, so 20 years of survival after putting aortic valve, whether we are going surgery or transcatheter valves.
Just to add to the point of the stroke, it is very surprising that when you are doing a surgical AVR, you are in fact removing the whole calcium, cleaning it, clearing the whole annulus. I practically feel there is no chance of any stroke because of the valvular calcium. In fact, in TAVR, everything is there. The chances of strokes are high.
Yeah.
I don't know how that data came up.
Yeah. So,
accept it.
Yeah.
Because what we think garbage, calcium in the aortic annulus is very useful for the cardiologists.
For them, yeah.
So they are actually using that junk to anchor the valve. So what you and I think to be calcified junk to be cleaned is actually very essential for them. And where there is no junk, like in AR, they cannot have TAVR so far.
So we are not removing the calcium, we are pushing the calcium back.
They need the calcium.
I totally agree. But the point is regarding the stroke. So the calcium embolization, I practically feel it is
Yeah, so
not
yes, yes, sir.
possible
So
in
this is
surgical.
bicuspid aortic valve. They say there are some data which shows severely calcified bicuspid aortic valve, the surgical, the stroke risks more, and the valve in valve cases it's more. In rest of the cases, all the cases it is lesser than the surgical aortic valve.
I think we should
Yes.
call that off, but just one line, last comment. A patient with failure, this is what we were discussing, failure patients getting a TAVR. They have a higher incidence of pacemaker, higher incidence of paravalvular leaks with a TAVR. So if a patient with failure gets either of them, you're actually making him worse.
So these are the concerns which will be there, but they're getting addressed with conduction system pacing and extra sealing skirts. All the new valves are coming with extra sealing skirts. We have brought down to paravalvular leak less than 5% now, almost zero with some of the valves. Yeah.
Dilip, just one question regarding failure. Is there any way out to assess the myocardial function in AR preoperatively? Just like dobutamine
Sir,
stress.
for aortic stenosis,
but there is no documentation that dobutamine stress works in...
For AR, I think MRI can be done. Otherwise, for AS, what we do, dobutamine stress and all, these are not recommended here.
Not recommended in AR?
Not recommended here, sir. Yeah.
So
for AR,
there is
we
no
don't
way
recommend
to assess whether this myocardium is going to improve after replacing the valve or not?
It's MRI which can give you some hints, sir. Yeah. The amount of fibrosis which the patient has. If you get a scar burden which is more than 15-20%, then chances of recovery will be lesser. If it is lesser, then it can be higher.
Okay.
So can I just add one point to that? This is regarding AR, sir. MRI related studies are there. There's one study been published from Oxford and Barts Hospital. They have shown that MRI quantification can help with regards to improvement in the myocardium as well. And in most of the subsets, they have seen even with a very dilated LV, the LV usually recovers in AR. And with regards to AS and heart failure, I think heart failure, AS TAVR, we've got enough data now. And there are two recent publications, one in European Heart Journal and another will be coming up in JACC. And both where it has been shown that TAVI has got very low mortality and very good outcomes in acute decompensated aortic stenosis. It is called as acute decompensated aortic stenosis ADAS, where ADAS TAVR is being published. It's a registry data. With regards to very less, it's less than 2% of paravalvular leak significant. Pacemaker incidence is around 6%, and the in-hospital mortality is almost very, very low. It's negligible. I think they have quoted around less than 2%. So I know this because I was a part of it around 2 years back. So it has been running since 2020, and there's enough data. The most recent will be published in JACC.
Thank you. Thank you so much. We'll just call that next speaker, please. Thank you very much. Mitral interventions in end-stage heart failure. How about that? Dr. Sumanto.
Thank you. First of all, I'd like to thank the organizers and the Society for Heart Failure and Transplantation to invite me to talk on this topic. Good morning, everyone. I will be talking on mitral intervention in end-stage heart failure. Though rather than end-stage heart failure, we would want to do a mitral intervention in heart failure. So probably I'll discuss first the options, and then we see what we can till what level of heart failure, to what level of end stage can we go for mitral interventions. So basically for mitral interventions in heart failure, the options we have will be a MTR, that is transcatheter edge-to-edge therapy or repair, commonly known as MitraClip. Then we have TMVR, transcatheter mitral valve replacement. We can do transcatheter annuloplasty. And in patients who have previous mitral valve interventions, for them we can give paravalvular leak closures or again do a valve-in-valve. So now the most important and the most talked about at the present time, MTR. So what was the idea behind MTR? Well, it comes from a surgical concept known as Alfieri stitch, whereby the central leaflets are being approximated. So how does this help? So there are some similarities between MTR and Alfieri stitch. Basically, both of the procedures help in effective leaflet coaptation. They create a tissue bridge and hence limit annular dilatation. and have a good durability. They exert a rain effect on the LV, helping in LV remodeling. The slight differences with MTR is that it is always done under beating heart, and it avoids valve distortion because it's all in the beating heart, and the patient is mainly under mild anesthesia or sometimes under conscious sedation. It grabs the leaflets from below and ensures smooth coaptation, and there is a continuous real-time evaluation of the MR and the mitral valve anatomy with the 3D TEE. So what do we have the guidelines saying about for MTR? So I'll mainly focus on secondary mitral regurgitation of patients with heart failure. Primary, we know if it's not amenable for or it's a high risk for surgical repair, then you can go for MTR. Otherwise, it's mostly secondary, which is important. Secondary, what we see is if the patient has got a heart failure with a severe MR, and if they need a CABG, then they should go for concomitant mitral valve surgery. According to ACCHA, this has got a class 2A recommendation. Now, if they do not require a concomitant CABG, then this is why transcatheter H2H repair is important, because this is a class 2A indication, particularly if LVEF is less than 50 and LV end systolic dimension is less than 70 and with a high PA pressures. Whereas mitral valve surgery in this subset has got a class 2B indication. Now, when we look at functional or secondary MR, the various types of MR that we can have is an atrial MR, whereby the atria is dilated, flattens out the anterior leaflet, and the posterior annulus is displaced, causing tethering of the mitral leaflet and causing a mitral regurgitation jet. And a ventricular MR could be due to dilatation of the ventricle, causing annular dilatation, reduced zone of coaptation. It could be tethered chordae, displaced papillary muscle in cases of ischemic subsets or even dilated cardiomyopathies, and then restricted leaflet mobility because of tethering can occur, causing an MR. Now, the MR of this MR, some MR could be proportionate, that is, the MR is due to the dilatation of the LV only. And sometimes it can be disproportionate, that LV is dilated, but the amount of MR is disproportionately higher than the LV dilatation. Why this concept came or is important is because of these two trials. The two of the important trials, one was MITRA-FR and the other was COAPT, to evaluate MitraClip in patients of, or MTR in patients of heart failure. MITRA-FR showed no difference in GDMT alone versus MitraClip, whereas COAPT showed a gross difference, and there was significant reduction in 12 months heart failure, hospitalization, and death when MitraClip was added on top of GDMT. So why the difference? If you look at MITRA-FR patients, the inclusion criteria had a higher LVEDV, that is, their LV was more dilated as compared to COAPT patients, and their EROA, that is, the effective regurgitant orifice area, was smaller, mean of 31 millimeter square, whereas COAPT had an EROA of 41, so they had a severe MR, less severe LV dilatation, though their EF was equivalent. So these patients who have got a more severe MR as compared to their LV disease, they really do well when we give them MTR. And if you see, when LV end diastolic volume and EROA is plotted and a line is drawn, this is called a proportionately severe MR. If you have proportionately severe MR, your chances that the patient will have improvement in the hard outcomes is less. Whereas if they have a more severe MR, which is like the COAPT patients, they do really well. So this is just to show a case. Here you can see there is a bad LV, but there's an eccentric jet significant due to tethering of the posterior mitral leaflet, and the anterior leaflet, there is a pseudoprolapse causing severe MR. This is an 81-year female who had severe functional MR. So we do a MitraClip. This is the clip that is put right at the site of the jet, and the leaflets are approximated. There was another clip got, and there is a trivial residual MR, if at all. With a mean gradient of 5, this patient is doing very well after 1.5 years of the procedure. Now, coming to the recent 2 more trials that was published, that is, one is Matterhorn, where transcatheter repair versus mitral valve surgery for secondary MR was compared. Small trial, but what it was that these patients were good candidates for surgery, and what it was done was to see whether MTR was non-inferior to mitral valve surgery, up till 1 year. So it shows no major, it's that it is non-inferior. If you look at numerically, the data was slightly in favor of MTR versus surgery with regards to the composite, but recurrence of MR was higher in the MitraClip group. But all-cause death was again higher in surgical group. So overall, they concluded by saying that MTR is non-inferior to surgery in patients who are actually candidates for surgical mitral valve repair in patients with heart failure. And Reshape HF2 actually is done and focuses on that we should not wait till the end-stage heart failure or till the LV is too dilated for going ahead with an MTR, because MTR along with medical therapy can reduce hospitalization rates in patients with symptomatic heart failure and even in moderate to severe MR. So in functional MR, even a moderate plus MR in patients who have symptoms or have got LV stress, probably it is better to treat them early after optimizing GDMT as compared to waiting till end stage. So just to summarize, which patients anatomically can be considered for MTR therapy is the patients who have mostly central jet, some localized jet rather than along the whole coaptation line. Their leaflet should be pliable, non-thickened, at least a 6 millimeters of a posterior leaflet length. And if they have apical tethering or focal prolapse or fail, these are actually ideal candidates for MTR therapy in patients who have got heart failure symptoms. Now to the other options. What other options apart from MTR we have? One was an annuloplasty, and that is with Cardioband. So this is again a 70-year-old gentleman with multiple comorbidities, low LVEF of 22%, CRT, atrial fibrillation, recurrent hospital admissions. So this, if you look at, that's the LV, pretty bad LV. You can appreciate that it's non-coaptation. You can see the huge jet of MR. So this is the 3D. This is actually the catheter used for delivering the Cardioband. And what we do here is we put in pledgets. So this is not available in India. This is one of the cases that I'm showing from where I was in parts. But what we do is we basically put pledgets and put a band and then tighten that band. And this is what we get. So this was the MR to start with. After tightening up, causing that annuloplasty, you can see those bands there. You barely have reduced it to mild MR or trivial MR. And this is another way that we can do for annuloplasty and reducing MR in patients with heart failure. Then if the patient already has a previous mitral valve intervention and CRT and ICDs all, and they have now developed a severe MR, this is a very straightforward thing. Nowadays, we do a straightforward mitral valve and valve. Another option, non-surgical, quick with very good results. Again, sorry. This is not available here at present, but hopefully we should have this by next year. What's happening? Sorry, this is not playing. So basically, if you can look at here, this is a transcatheter valve that gets implanted transapically called the Tendyne mitral valve implant. This can be done in a native annulus for patients who are not suitable for MTR but have got a severe regurgitation and symptoms of heart failure. So hopefully by next year we should have in India as well. This is a transcatheter transfemoral mitral valve implant. Again, for patients not suitable for MitraClip but severe MR, we put a docking ring under the mitral valve and then Edwards valve is implanted within that. Again, can be done for native valves and is very good for heart failure. And this is actually now CE and both FDA approved. CE approved, FDA is going to be getting approved. So other option is if a patient has a huge mitral annular calcification and there is a severe mitral regurgitation or even stenosis with regurgitation where you can't do a MitraClip or an MTR. This is a patient with severe MR. You can see heavy bloats of calcification. Elderly lady with multiple comorbidities, previous surgical AVR. What we can do is we lacerate out the anterior leaflet called lampoon procedure. This is the laceration going on. That's why you're seeing all the bubbles. And we create a little bit more MR, but this is to take this leaflet away so that we don't have a LVOT obstruction. And this will show the final bit of the laceration. All this is done under 3D TE. So this is now the leaflet being cut, and you can appreciate the cut there. That is the anterior mitral leaflet being split. There's a lot of calcification there, and following that, we actually go ahead and implant the valve. Again, the echo guidance, that is the balloon and the valve getting implanted. And this is what, we had a mild bit of paravalve there with the MAC because it's very difficult. It's a very irregular surface, and but did not cause any significant hemolysis, which we always watch for. And after later on, you can see that was taken care of, and there was virtually no MR and no significant gradients. TMVR gradient of 3.5. Again, patient is 1 year post and is doing really well. The other option is if there is a paravalvular leak in patients who have, this can often cause a hemolysis as well as heart failure, which is intractable. So in these patients, a careful transesophageal echocardiogram to evaluate is very important. And then this can be again closed with a small plug, straightforward procedure, but does help in stabilizing heart failure symptoms and hemolysis. So these are the arena that we can use transcatheter for mitral valve interventions in patients having heart failure in different circumstances. So I would say the success of mitral valve intervention in heart failure actually depends on selecting the right patient and the right clinical indication, and before it's too late. Like, we don't want to do a mitral valve implantation or a MitraClip procedure in a patient having an EF of 10%. Selecting the suitable valve anatomy and then tailoring the intervention, like whether it is clip versus TMVR versus surgery. And then it is very important to do the job properly and get a proper optimal MR reduction so that the patient actually benefits. Thank you.
Okay, we'll have the questions after we do the surgical thing.
Thank you.
Dr. Chandrasekhar, please. Dr. Chandrasekhar will tell us about the surgical mitral valve repair and replacements in failing hearts.
Can I have the slides, please? Thanks. I thank the society, Dr. Kunal, Debashish, and Pradeep for giving me this opportunity. So I'm going to talk to you about the surgical journey in patients with mitral valve disease and heart failure. We all know 2 lesions can be there. Stenosis, when heart failure occurs, it's very end stage, and most of them, they need a replacement. So most of the focus of this talk will be on mitral regurgitation with a lower ejection fraction. Can be acute or chronic, and acute is an acute heart failure situation, mostly complicated by a caudal rupture, acute myocardial infarction, and endocarditis, and all these are surgical emergencies. Acute MI can result in an acute MR, which is usually in the first week, and most common with inferior wall myocardial infarcts. And these are acute emergencies. Patients usually crash in the ICU. Most common with the posteromedial papillary muscle because of the single supply. And 2/3 are partial and 1/3 are complete. So if you look at the natural history, by 8 weeks, most of them are dead, otherwise operated. It needs medical stabilization and expeditious surgery. Revascularization is required, and sometimes mechanical support. Now, whether to replace or repair techniques have been described, but most often these patients need a quick operation, a quick replacement, preferably with a caudal sparing. Now, they are life-threatening, but operative mortalities range from 15 to 40%, but once they go through the surgery, their survival is not very bad. It's about 60% at 5 years. Now, if you look at chronic MR, which will be the most of the focus, it's nothing much has changed over the years in both the understanding the concept and the results. Now, there are 2 types. One can be a primary MR where it's long-standing leading to heart failure, or it could be a heart failure that is causing the MR, which is called the secondary MR, which could be ischemic or non-ischemic. So if you look at the primary MR indications, mitral valve surgery is class 1 indication if the patient is symptomatic or has an LV dysfunction, and also favors mitral valve repair as to replacement. This is for degenerative MR. Similarly, the European Association guidelines also carry the same. If you look at secondary MR or the functional MR, it could be symmetrical or asymmetrical. Most often the ischemic MRs are asymmetrical, and it's a surrogate marker for poor outcome. Most of these patients do not have a good survival. Now, not only MR affects survival, the degree of MR is directly proportional to the 5-year survival as given by the literature. Now, we know that ischemic MR is a ventricular disease, and most often we give an annular solution for this, and that is why most of the time
annuloplasty alone fails. There are different anatomical components in the mechanism, and the entire mitral apparatus and the subvalvular apparatus are involved to a larger extent, more of the ventricle, like the papillary muscles and the leaflet tethering. The primary problem here due to the infarct, what happens is there is a papillary muscle displacement and leaflet tethering leading to unequal forces leading to a central mitral regurgitation. We also know there is an atrial functional mitral regurgitation, which is usually amenable to a reduction annuloplasty. Now, a part of the evaluation, it is important to have a good echocardiogram, and you know IMR is a dynamic condition, and vena contracta probably is the most predictive. There were changes in the degree of MR grading, but now it is back to similar to the primary MR grading. So, and it's also important that in ischemic MR, one can underestimate the severity because of the eccentric jet and the crescentic shape of the regurgitant orifice. So, this is the formula: 40, 50, 60. ERO more than 40, regurgitant fraction more than 50, regurgitant volume more than 60. The same as primary MR signifies severe mitral regurgitation. This slide you see in the previous paper, the guideline directed medical therapy is the class 1 indication for ischemic MRs. Now, if you look at the summary of what it says, it's a 2A indication if there is a CABG or revascularization is the primary strategy. If you have only MR where you're not going to revascularize, it's only a 2B indication. And also it says that preferably a caudal sparing mitral valve replacement may be preferable. If you look at the European guidelines, which came later in 2022, they have upgraded the surgical to a class 1 indication. So if somebody undergoes CABG, if there is a severe MR, it's a class 1 indication to address it. And if the patient has refractory to guideline directed medical therapy, without revascularization, it's a class 1 indication for intervention of the mitral valve if they are symptomatic. Now we have different options, just revascularization or add a mitral procedure in the form of a repair or a replacement. One has to have a proper understanding of the mechanisms. Now the cornerstone remains restrictive annuloplasty, maybe an edge-to-edge repair, but of course one has to be familiar with neocords as well as leaflet techniques to plicate or resect. Now, the golden relationship described by Carpentier has to be maintained between the transverse and the septolateral diameters. And we have to address all components because the mechanisms can be very complex in ischemic MRs. Now, undersized annuloplasty, as I said, forms the cornerstone, and it is most important to place the sutures properly. Most of the repairs fail because improper anchoring of the ring, especially in the trigone and the annulus. Now, coaptation height is very crucial because this determines the long-term durability. A minimum of 6 millimeter is needed, and one can determine what ring he is going to put and what is the coaptation height he is going to get based on measurements in the transesophageal echo. Now, there are different types of rings: partial rings, flexible, rigid, semi-rigid, planar, saddle, so many makes by different companies, as we know that. This just shows that we still don't have a proper understanding, and that's why there is no single solution. There are different solutions, and sometimes rings alone may not work. We may have to add certain procedures on the leaflet to address the MR, which could still be there after the annuloplasty is done. That's why one has to be familiar with all the techniques. Now, caudal cutting, also described because of the tethering, can also help improve coaptation. There are other techniques described that like papillary muscle relocation, papillary muscle plication, and all those techniques which are very, very complex. Now, basically what ring to use, the current consensus is probably a complete rigid ring, but do we have evidence to show? There are many types of rings we have in the market today, and we have this Physio 2 ring, which is double saddle type, supposed to maintain the dynamics of the anteroposterior as versus the transverse, where it is rigid transversely and flexible anteroposterior. Now, whatever wing we use, we had a structural person addressing it, we have to consider a valve in the ring in the future. So, a complete semi-rigid ring probably is a good option for these patients. Now, are there any RCTs comparing rings? None. We have 3 small studies which compared the, rigid was the flexible or the complete was the incomplete. There is no clear answer that this one is superior to the other. So what you are familiar, you're good in your hands, you please use it. Edge-to-edge repair, the Alfieri stitch on which the tear is based on, is a very good adjunct to repair.
And majority of the times we have to, by planimetry, measure the two orifices, otherwise it could be reported as stenotic. Now, what are the predictors of failure? There are certain criteria. We have a larger annular diameter. We have tenting area and tenting heights, severity of the jet, complex jets, and leaflet tethering. These all determine poor outcome. So we should have a good adequate AML length of at least 26. The short lengths are bad. We should have a tenting height less than 1.5 centimeters and a tenting area. These are echo parameters which are very important to determine whether the repair is going to work, and also the severity of the tenting, that is also matters. And as I told you, a coaptation height less than 5 millimeters, it's definitely going to, the MR is going to recur in a very short time. And also some parameters like the C-sep distance. Now, when we know that the repair is not going to do well or the parameters are not good, it's better to go with the caudal sparing mitral valve replacement, which is a 2B recommendation today. We all know that the bioprosthetic valves in the mitral position do not do well as good as the aortic position, but so we have to face the challenges that are attributed to this. The mitris resilia, which is being promoted as one to reduce the turbulence in the LV outflow, and also has the saddle shape to promote better hemodynamics and maintain the native annular diameter, is probably but we do not know what's going to happen. But the tissue technology and mitris is supposed to be durable and supposed to be more longevity. So this was a paper published in the JCTVS in 2023 by Bowling and colleagues. Should mitral valve replacement guidelines be lowered with better bioprosthetic mitral valve durability? This is a question of debate, and I think that's left alone. Now, should moderate MR be addressed during CABG? Several studies have shown that it is of no benefit. Now, this is a Stitch trial in which it was not powered for this, but they made a sweeping statement that avoiding surgical intervention mitral valve during CABG to decrease perioperative mortality might be unjustified. So they said you have to address if there is a moderate MR. Now, what does the science say? There are 4 RCTs and 1 meta-analysis. All are very small sample size. None of them have showed a survival difference, but they all showed a better functional class. The CTSN network trial published in the NEJM is probably the largest of the 300 patients, 150 in each arm. And the primary endpoint was LV end systolic volume index. And definitely the degree of MR at the end of the study was less when the mitral valve repair was added. But there was no difference in the LV reverse remodeling. And freedom from persistent MR at 2 years are more related to the lateral wall revascularization as compared to adding whether a mitral procedure to the CABG. Now, there was no difference in mortality as May's admissions, and also improvement in the posterior lateral wall, as I told you, was the only marker that improved the freedom from mitral regurgitation. So they did not find any significant difference. Whether to replace or repair, we all know that mitral valve replacement along with CABG carries a higher mortality, almost double that when you do a mitral valve repair. So again, the CTSN network is the randomized trial which compared replacement and repair, 250 patients. Again, what we found was in repair, the recurrence of MR was higher, but no difference in survival. But mitral valve replacement give good results in terms of freedom from MR, but the perioperative or the procedural mortality was higher. This meta-analysis done by the core group from Australia took the CTSN network RCT as well, and they found similar. Mitral valve repair, periprocedural mortality was less, but recurrence of MR was higher as compared to mitral valve replacement, but no survival difference. Now, so this formed the basis of a 2B recommendation in the AHA that adding, when there is a caudal sparing mitral valve replacement, may be reasonable to choose over downsized annuloplasty. So a good repair is better than a replacement, of course, which is better than a bad repair. So one has to see the echo for themselves. Intra-op TE is mandatory. Moderate MR to be addressed if you are not revascularizing the lateral wall. I use a semi-rigid ring incomplete. An edge-to-edge repair, the low threshold to get a good result is important, particularly in ischemic complex. And when the lesions or the jet is complex, a mitral valve replacement caudal preserving is probably the best option. We have 274 cases so far with decent results. Now, I want to add a small note about base device. This is one of the device that we, part of the trial, which is not in the market now. This is a very good functional MR. It also reduces and also acts as a containment device. This is based on the Acon device that was tried. Unfortunately, there was no takers for this technology. In fact, Merrill wanted to take this, but they have not shown any interest. And it's a very promising concept. And we have 7 cases. We lost 1 case not related to the device. 5 are on follow-up and with good results. And a note about transapical off-chord neochord implantation. Again, this technology has not taken up very well. The person behind this idea was working with me at the Mayo. This has not also taken off well. So to conclude, I would say that functional MR is more complex than simple as we think. Guideline-directed medical therapy is very critical. Revascularization has a prognostic benefit. There was no survival advantage, but better functional results with adding a mitral valve procedure. Recurrence of MR is common after a repair. Benefit of repair in moderate MR is questionable based on literature. Caudal preserving MVR replacement is better than a bad repair. Of course, transcatheter techniques are coming in a big way, and we may see a huge change in this in future. Thank you for your attention.
I think that's exhaustive. We've had lots of discussion on mitral, and I think we should.
I believe, let's open it to the floor. I
would
believe
like to
there'll be a lot of questions.
Yeah,
At least I have one which I have to ask Shumanto. Anyone, please, from the floor, yeah.
Can I ask a question?
Yeah.
Hi. Great talk. Thank you, sir. Great talk by Dr. Chandrasekhar and Dr. Sumanto. My question is quite simple. Right off the bat, secondary MR patient with severe LV dysfunction, let's say EF 20%, what are some of the hard points that you look at? Again, for both Dr. Chandrasekhar and Dr. Sumanto, what are the hard points that you look at which would tell you probably refer them for a VAD or a transplant?
It's a tough call, actually. But if you feel that the patient has good targets, revascularizable targets, and your FDG PET or viability, even though with inverted commas, they have not scientifically shown to be of any great value. But if the viability is good, if you have an MRI where the myocardial fibrosis is less than 25% of the total myocardial load, and the patient is relatively young, I think a revascularization strategy will be good, and a mitral repair. If it is feasible, adding a mitral repair. If it is severe, a caudal preserving replacement or a repair, whatever works in your hand. But I tend to use a repair more in favor than a caudal replacement, mitral valve replacement. Again, because of the peri-procedural mortality is high if we replace these valves. Vis-a-vis transplant, yes, if you don't have revascularizable targets, and if the myocardial fibrosis is more than 25% of the myocardial load, I think a transplant or going on the transplant line will be a better option, remembering that what is the chances that he is going to get a transplant in the near future.
Chandrasekhar, what is the reason? Can I just make a point, Chandrasekhar? Chandrasekhar, I think to put things, brilliant talk, both you and Shumantos. I think as surgeons, we have to be humble to the fact that we did not do very well. The concepts about restrictive annuloplasty and repairing of ischemic MR, the entity that basically we did not do very well with it because we are still struggling with 2 parameters. One is the symptomatic and the recurrence of MR, and the second was survival. So much so, I think it was around 2014 or 2015 that the echocardiographic definitions of ischemic MR were changed. And they were simply changed to lift the bar higher so that surgeons will not jump the gun and go on doing more and more, a higher threshold for surgical intervention. So from that point of view, my question to Sumanto is that are the mitral devices doing any better? I mean, how do you read your tarot cards right now? Because surgeons are faced with the dilemma, either we make them symptomatically better, even if we do, the survival is not very clever, the MR seems to come back, so on and so forth. So I know perhaps do you think it's still early days for your devices, or do you think you can do any better with that?
Thank you, sir. So with regards to the device, I think we have got 5-year data for our H2H repair, and it seems to be durable, and there is pretty good, with less than moderate MR is around 82%, so which is not bad in the kind of subset, because initially the COAP data and the extended expand registry trial, they took patients expand registry which were even worse. So the LV was bad, they were more dilated, they were a complex kind of a MR, both due to papillary muscle displacement as well as tetherings, and there was a significant wall motion as well. So yeah, it seems promising, but yet again, as we all would agree that it's still in its infancy, like 5 years in valves for these subset of patients, and particularly when we are thinking that whether to move into moderate MR or not, we need more data, and that's why the moderate MR2 trials are on the way. Surgery versus mitral valve H2H repair. There will be Matterhorn has got an extended arm. There are 2 more trials that are coming up. So there will be a lot of more data with regards to what is the durability and with regards to which patients ideally should be taken for an H2H repair versus which should not be taken. Now, just to come back to the previous question, I think what we follow in terms of mitral clip is that if a patient has got a bad LV and there's a severe MR, first and foremost, as I discussed, that is it a severe MR? That needs to be established, because if it's only a bad LV and the MR is probably just a byproduct of that LV, then just treating that MR, particularly when the patient is way down the line, is not going to change much. So that is one thing. Second is, obviously we need to take into consideration the age, the comorbidities, and the coronary artery status. Because if the coronary artery status is worse, then probably it has to go to surgeons. If it is not, then if it's well revascularized, or there is no coronary artery disease, and you've got a disproportionate MR even at a 20% EF, I have quite a lot of cases which I can show that they have got really very good results. But it is to distinguish, like if you are in doubt, probably you have to kind of, do all the other tests like 6-minute walk test, sometimes an exercise echo and a cardiac MRI, just to see the LV is not totally gone, that there's no reversibility left in that. So that is one part. And the other part would be in a young patient, and supposedly you have a lot of LV that is diseased, then we never give mitral clip as an option. We ask that should be considered for a transplant. We've done some mitral clips as a bridge to transplant. Supposedly they are on the transplant list, and we know it's going to take a time. For that time to keep them out of hospital and give them some quality of life, we have done some mitral clips. But mitral clip will not be a destination therapy in those kind of patients. Thank you.
Pradeep, just before you say something, may I tell the surgeons or even you to classify MR as, don't use the term secondary MR. Because secondary MR includes ischemic MR, it includes a dilated cardiomyopathy MR, where the pathology is totally different. And we confuse ourselves by saying this. Let's just restrict it to ischemic MR or MR. Use the Carpenter's classification, And after you, I'll have a question for you.
So I'm just going to keep it very simple. So there are very few things we know for sure in cardiac surgery. For example, we know that Lima to LAD works. We also know that ischemic MR, the problem is not with the leaflet, it is with the myocardium. So if that be the case, then that is the reason why Alfieri was stopped 30 years ago. And surgeons moved on from repairing the leaflet to addressing the problem with the ventricle. So why do we think now that MTR is going to be a good operation, something that was abandoned by surgeons 30 years ago? That's point number one. And second thing is, as Sumanto himself has shown, that there is a very, very select group of people who may benefit from MTR, and all those results are very short term. So those are the two issues. Even this Matterhorn trial that you talked about, it's a very nice study. But it took 16 centers, 7 years to recruit 250 patients. They screened all the patients and 50% of them were not eligible. The point I'm trying to make is most of the patients with ischemic MR are not eligible for a device right now. And unless you come up with something that addresses the ventricle, we can keep on doing MTRs, but it's not going to work. Thank you.
So, rightly said, sir. Matter on, there was a slow recruitment, but if you look at the inclusion criteria, it is not only about the feasibility of MTR, they also had to be low-risk candidates for surgery. So, MitraClip, as till now, is accepted for patients who are at least moderate to high risk for surgery. So, finding a low-risk surgical candidate who would also be equipped to have an MTR was also a difficult part. So, that was one of the other parts, that if we took a high-risk surgical population and then show that MTR is better, that is not fair. Similarly, if we take a non-ideal MTR candidate and show that MTR is worse, that is not. So it was more of a trial which was to see that a patient could be eligible both for MTR and both for surgery in a low risk, and then compare the outcomes to make it a very well balanced.
No, I think the thing is, in ischemic MR is a surrogate marker, whatever you do. The current literature shows that correction of MR only improves the functional symptom status. It doesn't affect survival. And the survival, if at all, some benefit is only in patients in whom revascularization has worked, improving the regional wall motion on the lateral and infralateral wall. So correction of MR is purely a functional. It may be sometimes cosmetic. And I think so one has to be very careful in choosing these patients where to intervene, because there is a procedural mortality, which is higher with replacement as compared to regurgitation. And many patients after a mitral valve replacement, when you completely abolish, the ventricle takes a hit. The EF drops and the post-operative period can be really stormy for these patients. I think so, like Pradeep said, it's a ventricular problem, so unless we address that, we are giving annular solutions, leaflet solutions. These are not going to work. This is only temporary. It may be giving a better functional status, and I think none of the literature shows any survival advantage, because basically we are dealing with a poor subgroup of patients, a cohort of patients.
Thank you. I think we need to stop, Chandrasekhar. Let's go to the next talk. May I invite our invited guest, Dr. S.P. Khoshbin, for recent updates on VADs. Thank you. He has been adequately introduced, I think, by Dr. Kunal.
Yes. Thank you very much. Ladies and gentlemen, Mr. Chairman, thank you for inviting me to give this talk about updates in ventricular assist devices. As Dr. Kunal introduced me already, I'm a surgeon from Harefield Hospital. So without further ado, let's get on. I have no conflict of interest to declare. So this device, the HeartMate 3, is now the dominating device in the market. It's a very easy to use device. It's miniaturized and one that can be picked off the shelf and used as will. So, as I said, these are ready to use. You can, the process of putting these are very simple. It has got worldwide applications, and it's an emerging technology which is improving every time. If you compare that to the heart transplant, for a heart transplant to happen, you have to have somebody who gives his life. It's a complex process. It requires nationwide organization, but still is the gold standard. If I give you a comparison here, on one side you can see a meal that was prepared for by my wife. One of those occasions that you get food that has been prepared. You can see there's a turkey there. The turkey had to give his life to end up on that table. A lot of preparation has gone to make that meal for me. And on the other side, you can see a tin of soup. The tin of soup can be picked up off the shelf. It's quite convenient. It would fill me up maybe for a few hours until I get myself to a nice meal. So this is a bit of a comparison between the transplantation and the LVAD. But the LVAD has improved significantly, and it's evolved to a much better meal, such as something you get on the aircraft, lasts you a bit longer. So I'm going to be talking about the recent modifications to the LVADs, the newer devices, the future of the device, and what's in there for us. Some of you may remember this device, the Jarvik 2000. It was a pulsatile device. It was a axial flow pump, Many other devices try to imitate the same mechanism, but there were axial flow devices, and we know that the axial flow devices had their problems. The HeartMate 2 was the most widely used one, especially in US, and I know that this was used in India quite extensively. And they formed a part of the rematch trial, which showed the advantage of using mechanical circulatory support over medical therapy, but they had their problem. At the same time, we had the centrifugal pumps, which were introduced. They were very bulky, not much advantage from them really at that stage. A lot of them did not make a market until this device, the hardware, was introduced. And the important thing about this device was that it was miniaturized. It could be fitting inside the pericardium, and we used it very extensively until 2015, where the HeartMate 3 came along. We implanted our first one in 2015, and since then we have not looked back. One of the advantage on this is that it's a magnetically levitated device, it's centrifugal, and it has got the pump head has got quite a good cavity where it reduces the frictional and stasis in the pump and improves the compatibility. And then it came the Momentum 3 trial. HeartMate 3 is one of HeartMate 3. It is one of the most investigated pumps there is. We have got results of the randomized control trial to both 2 years and 5 years from this, which has shown improved outcomes. You can see the randomization. It was a trial that compared HeartMate 2 to HeartMate 3 devices. The 2-year outcome showed an improvement in survival, overall survival, and also reduction in complications. And then there was a 5-year survival data which continued to show advantage for both all comers and also for destination therapy. As I mentioned, there was a significant improvement in the hemocompatibility in terms of reduction in strokes, reduction in bleeding, and thrombosis. And that was to the extent that with the coming of the ARIES trial, we saw a disappearance of use of aspirin. So the pumps sometimes can completely run even without heparin. So it is a very hemocompatible device. So now that they're dominating the market, they're going to focus on advancements through device modification. Many of the surgeons who use the device have seen this recent letter from Abbott giving warning about some of the complications. The first complications I'm going to talk about is the leakage of blood and suction of air. I've had 2 of these cases where I had bleeding issues with the pump, and I had, in one occasion, I had to change the pump. But quite frequently, I actually see air being sucked in after putting these devices in, because my anesthetist will tell me that there is air getting into the system. We can't get rid of the air. Luckily, I use CO2, but then I found that as soon as I fill up the pericardium with blood or with fluid, the air disappears. So this is one of the things that Abbott is trying to make some implementations and changes, and you can see that there's what I think the issue is between the pump head and the ring, which allows the air to suck in and the blood to come out. And there's been modifications, and hopefully we will soon see the new ring that will improve that. The other problem has been with the external outflow graft obstruction. Personally, I haven't seen any of those. We know that there's several points along the outflow graft that obstruction can happen. This specific problem is underneath the bend relief, here shown in E. This problem looks something like this with accumulation. I have my own thoughts of what this is caused from. I haven't seen it, but the company has made some changes to the bend flow in order to prevent this from happening. And this is a temporary fix by making some holes in the bent relief to prevent that. So what about new devices? So there has been some advances in manufacturing technology with the 3D printing and so on. These initially made it easier for us to make this miniaturized. As you can see, they can fit in the palm of your hand, and that's advantageous because you can use it on the smaller patients. It makes the implantation less traumatic, and it's basically fits in the pericardium. You don't have to get into other areas of the body to put one of these in. And this is the most recent one, CHVAD from Japan, from China, sorry, that again, it fits in the palm of your arm. It has got modification. It looks extremely similar, as the name implies, to the HVAD, and it has shown from retrospective studies, both short and medium term, to have improved outcomes. What are the other things? So the advances in design made it magnetically levitated, which means that there's less friction, better hemocompatibility. There's some improvement in flow dynamics in terms of strengthening the straighteners that will make the flow more streamlined, and also diffusers that reduces the amount of blood stagnation and formation of clot. There are other changes into the design is that the heparin coating or polymer coating that is there. Also, there is, as you saw previously in some of the lovely pictures that were shown, the titanium macrospheres, which increases the, accelerates formation of epithelium on the surface of these devices and improves hemocompatibility. As you can see in this picture, the microspheres are located on these surfaces, which improves epithelialization. There's some advances in accessories, the coring tool. This device, I think it's a good device, but I would personally use this more in an off-pump situation. I still use the normal coring device for the on-pump cases. So there are some needs for improvement. We need to prevent driveline infection. There's been quite a lot of work done, and we're doing a lot of work on trying to prevent that. One of the most recent things that we've done is trying to fixate the driveline to the skin using some special dressings, and that improves or reduces the rate of infection. There are other things such as reducing the size of it and different materials, antibiotic coated and so on and so forth, that has been tried. But what we are aiming to do in the future devices is to make these VAD technology to be fully implantable to eliminate the risk of driveline infections completely. And every single company and every single device is trying to do this on their own. And this is one of the next generation pumps, still not in circulation, but as you can see here, the device is fully implanted with and can't be charged from outside. So this is what the future hopefully will have. Nobody's excluded on that. The second Achilles heels, in my opinion, of VAD surgery is the need for preventing RV failure. There's a lot of work that we actually been doing at Harefield in terms of reducing this problem by using hemodynamic and echo findings perioperatively to predict risk of RV failure. This is a picture of my team of researchers at Imperial College, and I have to tell you about this device. It's an exciting device, the Bivacor, which has recently received the emergency FDA approval for clinical use in, I believe, 12 patients in the USA. This is a very good device. Gives you biventricular support, so you don't need to worry so much about your RV, and you can implant one of these. It's made of a titanium case, and it is the same magnetically levitated device with the centrifugal that supports both sides and eliminates the need for using multiple devices. But we need more intelligent devices. This is one of them, TORVAD, that works with pistons that go around. They are extremely hemocompatible, but again, they are quite bulky, and they're still in stage of being investigated and not used. In fact, this has been around for about 20 years. They are intelligent. They can increase the flow up and down with the heart rate and your blood pressure. Excuse me. So in conclusion, ladies and gentlemen, VADs are readily available and have got worldwide applications. We have adequately minimized these devices so that they can be used in smaller patients and in the pericardium. The continuous flow devices have revolutionized the use of this, and we are looking forward to the transcutaneous energy transfer, which would actually improve the outcome for the patients. The goal ultimately is to be able to use these devices as a destination therapy. And there are some very exciting new technology there that hopefully we would be able to see come to surface. With that, I thank you.
Thank you. That's a great talk, Dr. Pushpin. I have one small question. So what actually prevents the miniaturing, making the VAD smaller? Is it that we cannot put all the electronics inside that small VAD? Because we have so many small pumps.
Yes.
So is that the electronics doesn't fit in small pump or anything else?
Yes. So the miniaturizing has got its advantages and disadvantages. So in terms of advantages is that if it fits inside the pericardium, it avoids having to go and put the, different parts of the pump in different cavities. It has got ability to be put into smaller patients. So these are the advantages of making it smaller. However, the disadvantage has been that you've had the pump has had the smaller chambers. The chambers have been making it more susceptible for clot formation. So there's a balance. So we have reached, I think, with the HeartMate 3, those balance where we have got a smaller pump that can be put into the pericardium easily, but it is not too small, and the chamber is of a good size so that it can actually prevent forming. And the design of it is such that, as I said, how the blood flows within the chamber reduces stagnation and reduces the clot formation and thrombosis of the device.
Can I ask?
Can I ask? Sure. Can I ask a question?
Yeah, sure.
Dr. Pershin, thank you for the presentation. Other than destination therapy, how long has been the survival of these patients, the longest one? And is the graft occlusion is a problem, and what is the anticoagulation that's required for these? And would miniaturization be an answer probably in the future so that the anticoagulation, etc., can come down?
Right. So the survival has been good. So the Momentum 3 trial has shown that the median survival for LVADs now is around 6 years, 5 to 6 years. And I think that is probably a slight underestimation. With the improvement in the medical therapy after these, I think we probably will see higher than that, and improvement in the risk of infections and so on and so forth. I think we were going to see that destination therapy will be a bit longer than that. I think that's your first question. The second question was, could you repeat your second question?
Was the occlusion, graft occlusion, etc.?
Oh, the graft occlusion. So the graft occlusion, the way, I think, personally, I haven't seen any of them. I've seen a picture of it, but in my practice, I haven't seen. I think that there is a little bit of link between that and maybe some torsion of the outflow tract. So the ones that I've seen on the pictures, to me, it implies that there's a space there between your bend relief and your graft, and that space accumulates. So the machine is not designed to have any space in that area. And the only way that can have is if there is a slight torsion within it. So this is why it is so important that when you actually, during the technical placement of this, making sure that there is no tension, there's no torsion when you put in that graft. So I think that is the important thing. There are, however, I know that the new bend relief is coming with Abbott, so I'm looking forward to seeing that. We are supposed to getting that soon, which would prevent having to make those holes. But having said that, I've never put any holes, and I haven't seen that. What I have seen is a leakage.
Thank you.
Thank you. Yeah, I didn't follow it. How do you actually make holes in the graft?
So the way they make the holes, I haven't made any holes, so I'm just telling you the way people have made the holes, is that you make some cuts on either side and then use the aortic punch to make holes in the bend relief. So that way you get some...
And then how do you close the holes?
How do you do what?
How do you close the hole?
The hole is in bend relief, not in the graft.
Oh, right.
In the bend relief, not the graft.
Bend relief.
Okay.
Yeah. So the bend relief is the bed that will protect the
I see.
outflow graft from getting injured when you re-enter. So, but that has been problematic. Of course, in the previous ones, and the bend relief is the same one that they had in the HeartMate 2, so and it had a problem there as well. So the fact is that actually you cannot see, because it's a solid, you can't see inside it. So you can't see if there's a slight bend or within it. My money is on a little bit of torsion causing some space within the bend relief which you can't see. And maybe the holes that you're making, it's making it more obvious and more visible. And then you would not be...
I spit two quick questions to ask, Roughly, what percentage of patients, say in the NHS in the UK, who are actually prescribed a VAD end up getting it? And the second question is, do you really subscribe to this view that with 3,000 plus transplants happening in the US, a little bit of energy has gone out of the VAD scene? Has that affected? Because I believe the enthusiasm in the VAD scene is less, because this year I believe the transplants in US will exceed 3,000 the way they are going right now. Is that affecting?
I hope I hear that.
Is one affecting the other?
So you mean, does the VAD affect the transplant?
Does the increasing transplant numbers, particularly in the US, is that affecting?
I think, Kunal, there is a change in the strategy, because previously patients who were on VAD would get preference for the transplant. But now if somebody is stable on VAD, they do not get preference to get transplant.
No,
That's what
it's not just that. If you see the VAT numbers in North America, they're coming down.
That is why previously patients were putting more on VAD to get into a transplant list,
Absolutely.
actually.
So-
It is, and if you look at I think it is UNOS, isn't it? Their
UNOS,
latest-
yes.
Huh?
So what with our...
If you look at the recent allocation criteria, 2018 allocation criteria, I think by that allocation criteria, less and less people will be. Yeah. So it is more like ECMOs and transplants now.
Yeah. Previously, people on VAD would get a transplant chance, so that is why they were putting VAD and getting into a transplant list, but that has been abolished.
They actually
that
have
is why
more-
VADs are less now.
They
People are
actually
putting
have
in
more hearts they can use.
more on
They have
more
more
on
hearts
ECMOs rather than VAD.
Yeah, so I hope I understood your question. I will tell you what the way it works with us is that we assess the patients for both transplant and for VAD. So nobody goes onto a VAD list and gets a VAD in the UK unless they're on a transplant list. So everybody who's got a VAD has to be. However, about 60% of our patients who have been put on the list after VAD, they do not go on to become a transplant candidate. So about 60% are basically destination therapy, even though we don't offer destination therapy. So it's a large proportion of patients who are living with VAD and for a very long time, and we've got very long survivors of VAD still going around. So I don't know if this is the questions you were asking. So there is two groups, because we don't offer destination on NHS. We don't put patients there for that reason, but about 60% of our patients won't receive a transplant after LVAD.
Yeah, I'm Sivadasan from Singapore. In Singapore, problem is to get donor hearts because the population is too small. So we rely on VADs, and our VAD experience goes back to years. So most of our patients stay on VADs for a long, long time. And for heart mitral, we have been using for now coming to 9 years. We have survivors going up to 9 years. Now, we have seen a couple of graft obstruction. The cause of the graft obstruction is the proteinous material that seeks or diffuses through the graft, which is similar to any vascular graft used for aneurysms and all. And that accumulates between the vein relief and the graft. The vein relief is made up of PTFE material, so it's not porous. So gradually this fibrous material accumulates and compresses the outflow graft. That's how it happens. Whereas we don't see it in the graft that is not covered by the PTFE, because like for aneurysm surgery, when you replace with the graft, that doesn't happen because the inflammatory cells around the mediastinum, they causes fibrosis, infiltrate, and the graft gets incorporated into the fibrous tissue. So the presence of the PTFE vein relief prevents that happening. So we started making holes. We were the early users of making holes. So what we do is we take a lever knife, stab holes right on the graft, and then punch holes with the puncher we use for coronary bypass graft. So the purpose is to, whatever protein is, in fact, we have analyzed the proteinous material. There are no cellular debris there. It's pure proteinous, fibrins, collagen material. So the purpose is these holes will allow the protein sort of diffuse out, one theory. Other theory is it allows the inflammatory cells, like the macrophages, fibroblasts, to creep into the graft and seal the graft. Yes. So, and other things we have done is, in initial stages we do make a subxiphoid incision, open the graft and suck it out. But now what we do is put in a stentless, put a stent into it, covered stent, And we have done that for about 4 patients now. Because our patients are staying long on the LVAD, we see these complications.
So basically, this is a long-term complications.
Earliest we have seen is at 18 months after. We have seen it also in HeartMate 2, but we are seeing more in HeartMate 3 than in HeartMate.
So for the vent relief, one end of the vent relief is fixed with the outflow. The other end of the vent relief is free, isn't it?
It's free, that's right.
So then how does it accumulate? Why don't it come out?
Well, it's the length of the outflow graft and the vent relief. Vent relief itself is about probably about 8 centimeters.
Yes.
Right? So it's pretty long. So it really doesn't diffuse out. And the accumulated fibrin itself would block the outlet too. So it gets trapped between the outlet and the body of the graft itself.
Yeah, that's good.
Can I just ask,
Yeah.
thank you very much for sharing your experience. What proportion of the patients that you see this problem with? Because as I said, we haven't seen it in our population. And I'm just wondering what is the difference in practices where you will produce this. What proportion of your...
Well, I think one reason is our patients stay long, for years, 4 years, 5 years before they get a chance to.
4 or 5 years before they see
So
it.
we probably see more.
Yes. And then
But otherwise, it's the same process. Now, earlier, we used to wrap the outflow graft beyond the vent relief so that when easier for re-entry. Dr. Botapapa has used PTFE graft and he has also encountered the same problem of graft getting obstructed between the outer coating of the PTFE and this.
Yes.
So what we do now is we still cover it, but we split the covering so that when we re-enter for transplant,
yes. I guess one of the reasons that we don't see these very often in our institute is that we do bridge a lot of these patients to transplant. So the ones that are under continuous surveillance and come to transplant, then we will not see that problem with them and they go on and have a transplant.
Yes, probably that's the reason why
that may be the reason.
Don't see it because most of them don't wait long enough.
But I always wondered if there was that susceptibility, other than, as you were explaining about porosity, there was a susceptibility because when you have got an area empty space, then you could imagine that filling up with material oozing out of the graft, PTFE graft.
Yes.
So I do wonder that if there is a susceptibility, because not every patient gets it.
Yeah.
Some
For example,
gets
hardware, we don't see, or we never seen it.
Sorry?
When we're using hardware.
Hardware?
You're using hardware?
When we used it, we never saw it.
No.
Because the vent relief is sort of articulated structure rather than a complete structure.
Yes.
Thank you, sir. It's a very interesting discussion.
I just have a very quick question. You mentioned about a VAD which is totally implantable, which is still not in the market. Would you like to know what's the energy source? Because that was the caveat, the whole thing.
So it's a magnetic.
But it should be high energy source which charges because it's a lot of load, right?
Yes. So it's the same idea as your mobile phone when you put it onto the disc.
But it's
so it's a magnetic.
But the wattage is very high, right? For a VAD,
it would cause a bit of heat. I'm not quite sure. This is not being completed, and this is the problems that they're probably facing at the moment. But there are hybrid devices where you can do both magnetic and electrical charge for those. And at the moment, those are the ones that are being trialed.
So same lithium sources, or
sorry?
the source of energy, the battery is a lithium battery, or?
Yeah, it is, but it actually, they have been estimated that it will run for 12 hours.
Okay,
so
one charge.
With one charge, it runs for 12 hours. It's a bit like having an electric car. You have to charge it, and then it will go for so many hours.
Thank you.
I think, Dr. Balakrishnan, would you like to make any comment? I'd like to listen to you.
Talk, like Dr. Shiva said, We have seen a couple of instances of this collection between the graft and the bend relief. The first one we saw was in a HeartMate 2, 11 years after the implant. He didn't want a transplant, and his previous CT scan 6 months back didn't show it. So why would that seepage happen after is a question. The other one I saw day before yesterday, that was 6 years after HeartMate 3. We've never seen that in an HVAD. And one of the solutions actually could be, I saw that with a new Berlin heart companies coming with an implantable VAD. So one end is slit right open. So the bend relief is not, it's like a C, so you can actually turn it around. So that could be a solution. And the VAD we are developing, we don't have a complete coverage, but the multiple fenestrations like the HeartMate bend relief was not an issue. It had other issues, but bend relief was very cheap to make, 3D printed plastic. So that's one. The other question, if there's questions about maglev versus axial versus, a pump's final performance is a composite of all these components. So suddenly the mood has shifted when HeartMate 2 had better outcomes than HVAD in the endurance trial. Everyone was jumping that axial is better than centrifugal. Now suddenly centrifugal is the flavor of the month and maglev is the flavor of the month. We actually, right now we have a product in evolution. It's a pediatric axial maglev. So I think you have to distinguish between method of levitation, method of pumping, method of electrification, method of bend relief. They're all different components which make to a successful pump.
Yes, absolutely. And I think the basis for saying that these centrifugal pumps are better was the Momentum 3 trial, which showed that. But the issue is that with the ventricular assist devices, the goalpost is always changing. And this is one of the reasons why there has not been a steady sort of improvement in going forward to the new generation of transcutaneous devices, because it's always changing from one to this is one better, this is the better. So they're all trying to find the best pump, and then when you got the first pump, then you will move on to say, right, okay, this is the one we're going to use. Then we're going to concentrate on getting this transcutaneous done for this particular device. And I think we're still not, even though HeartMate 3 is such a good device, I think we're still, this is not the final chapter. We will see maybe better improved devices coming, which will have, as I was mentioning, will have transcutaneous, fully implantable systems, as well as them being intelligent devices, which can vary with your heart rate, with your blood pressure, and can change things. A little bit like Bivacor, but even more advanced than Bivacor, that can understand the hemodynamics of the patient.
Thank you very much. Would like to call Dr. Sivathasan for your talk. Heart transplantation, hope for the best, but prepare for the worst.
Yeah, good afternoon. Yes, good afternoon, everybody. I wish to thank the organizing committee and Dr. Junius for the kind invitation and the privilege to make this presentation here. So the topic given to me is heart transplant, hope for the best, but prepare for the worst. Well, we have all seen this progress of advanced heart failure. And when it comes to stage D or advanced heart failure or class 4 New York heart failure, options are limited. We have discussed this by the previous speakers. So at the end of it, we are left with either transplantation, or if that's not available, bridge to transplant, or destination therapy. And those who are not suitable for these modalities well, the only hope is to refer them for hospice and supportive therapy. Okay. Now, heart transplant is an accepted treatment option for selected advanced heart failure patient, and with the hope of years of improved quality of life. Unfortunately, heart transplant is not a definitive cure. We give a new set of problems to these patients, and they need to face different complications that can occur at different times in their life follow-up. So with increasing incidence as we progress down the transplant line. And we all know the quality of life by these patients coming to end of advanced heart failure. And as we know, the transplant itself alleviates and improves quality of heart failure. Recipients return to a more active, fulfilling life. But they need to, although they get symptom relief, especially in debilitating heart failure, such as shortness of breath and exhaustion and edema, but they need to face survival which will be less than but if they're not had a heart failure at all. So with time, the survival with transplant has improved, and currently we're experiencing a median survival of about 12.5 years, and this hope to improve with better management techniques and with more experience. So I'm going to refer to all the sets of slides from the ISHLT data because they have the largest data with over 70,000 of data in the registry. So that'll be useful to look into it. So if you look at the quality of life after transplant, if you look at the coronary score, the red bar reflects those patients with no complaints, no evidence of disease. The yellow bar able to carry on normal activity, minor symptoms of disease. So all in all, you'll see more than 75% of the patients enjoy a quality of life at 5 years. And also 50% of the patients, nearly 50% of the patients would return back to their normal life at 5 years, and about 45 to 50% would return back to the job they were doing before. And if you look at the hospital admission after transplant, at 5 years, 80% of patients would be nearly, were not due to transplant-related admissions. The yellow bar reflects to those patients who get readmitted, but that's not transplant-related, but of other causes, either not rejection or not infection. So overall, transplant gives a greater survival benefit as well as quality of life. Having said that, we need to prepare for the worst. The preventive and preemptive management is very important, and it starts with the earliest complication that can happen is the primary graft failure. Then another common complication is the cardiac allograft vasculopathy. I'll talk more about it. Then, of course, rejection and progressive heart failure as time goes on. So if you look at the complications that occur, they are due to either due to the rejection, or due to adverse effects of immunosuppressive drugs, which includes chronic kidney disease, infection, dyslipidemia, malignancy, osteoporosis, and so forth. And virtually all heart transplant recipients will suffer at least one complication, and consequently, patients' quality of life and survival may be impaired. So if you look at these graphs, again from the ISHLT data, infection usually in the first 2-3 months after transplant. After that, the incidence plateaus off. Then if you look at the rejection, again, is mostly during the early period, and generally it plateaus off again. So the early complications are mostly from infection and rejection. But as time goes on, coronary artery vasculopathy catches on, and other thing is malignancy, which again catches on down the line. And talking about early graft dysfunction, in the literature you'll find that it's about incidence is about 3 to 20% where primary graft dysfunction occurs, which is defined by hypertension, poor cardiac output, needing inotropes or balloon pump, or ending up in a mechanical cardiac support. And so this would prolong hospital admission, hospital stay, and also initial early mortality. And if you look at the mortality figures, if you look at those patients who had primary graft dysfunction, extreme, with VET support, their mortality is about 30%, 17% compared to patients who doesn't have any primary graft dysfunction. And again, if you look at the 1-year mortality, those patients who suffer from primary graft dysfunction requiring a VET support, their survival is 28% compared to, mortality is about 28% at 1 year. Then other issue that occurs is the rejection, which all are aware of it. And the rejections are mainly two types, acute cellular rejection and antibody-mediated rejection. And the mortality from these 12%, and mortality from antibody-mediated rejection is higher, 21.2%. You may sometimes get mixed rejection when the mortality goes up to 18%. Now, traditionally, we have been relying on surveillance cardiac biopsy periodically to detect rejection. And initially, most centers would do once a week for the first month and gradually increase the interval in between biopsy, and most centers would stop doing biopsies after 1 year to detect rejection. But now we have donor-derived cell-free DNA and gene-expressing GEP profile come into the picture, and these, as a result, probably in time to come, we will rely mostly on, not on biopsy, but more on sort of a liquid biopsy from blood analysis. So currently, the factors we are looking for are the donor-derived cell-free DNA and the gene-expressing profile. And even in the US, the practice is that most centers are relying more on the donor-derived cell-free DNA and gene expression profile. And if you look at the predictability, there's 98% specificity if you combine both donor-derived cell-free DNA as well as the gene expression profile. And again, if both are positive, there's a 10% chance that the patient is undergoing or having antibody-mediated rejection. So this has become useful tool to monitor rejection. Then again, if you look at those current immunosuppressive protocol, what we are using is initially when we started off the transplant programs, relying on cyclosporine, but now tacrolimus has found to be superior, and most units, nearly 80% of the units use tacrolimus. Very few centers are using sirolimus and everolimus as de novo therapy, and instead of azathioprine, which were initially used, nowadays most of us would rely on mycophenolate mofetil. Prednisolone, yes, most centers would use, almost 80 to 90% would use, and again, the practice seems to be that at 6 months, by the time you're 6 months, you try to wean off the steroids and keep the patients on MMF and tacrolimus. And with the better understanding of immunosuppression, the survival, freedom from hospitalization has also significantly improved. Right. Now, induction therapy. Would induction therapy make any difference? Again, from ISHLT registry data, about 50% of the patients, 50% of centers would use some form of induction therapy, which would either interleukin R2R antagonist or polyclonal ATG. Yeah, and so if you look at the survival on the type of induction therapy used, either with the IL-2 antagonist or OKT3 or polyclonal antibody or no induction, the survival doesn't seem to depend on the type of induction you used. But in practice, if the see, in Singapore, what we do is most of our patients are on, almost all the patients who come for transplant have been breached with the LVAD. And these patients tend to have more problems in the sense that they bleed a lot, longer operations, and also there's a risk of these patients having vasoplegia post-transplant. So as a result, we see more of acute kidney injury. So therefore, what we do is we use IL-2 antagonist, and we don't initiate CNI or tacrolimus till the kidney function recovers. So Similac or IL-2 antagonist has helped us to tide over that risk of inducing kidney failure with tacrolimus in the early perioperative period. Now, the cause of death, again, coronary artery vascular disease, about 5% of patients getting a coronary artery vascular is about 5% per year, but the mortality is about 10% on that. Then if you look at the red bar, this bar, which is a graft failure, again, is initially from rejections, sepsis, and so forth, and gradually that also settles down as years goes by. Now, this is a patient during our policy is to do routine angiography 1 year after transplant to have a baseline. So this patient, in March 2002, when he had the annual surveillance, there were evidence of vasculopathy. You can see the OM branch getting narrow. And this patient presented with recurrent heart failure. We thought initially due to rejection, we checked the repeated biopsy, treated for acute AMR and so forth, but he progressed to perish, decline, and then finally perished. And the photo at autopsy, you can see the LV muscles are thinned out, and he has a fresh infarct. And we looked at the coronary arteries. The proximal arteries are all patent, but the distal segments all narrowed down. So this is a typical picture of coronary artery vasculopathy associated with transplant. And on sectioning, you see the intimal, it's not atherosclerosis, but intimal hyperplasia. So this is a problem that, one of the problems, I think the transplant community is unable to solve it yet. And this has to be watched for. So the risk factors for developing that are probably immunological factors, and second factor would be the non-immunological factors. And so the immunological factors are those patients who have had acute rejections, either AMR or cellular rejection, those patients who develop donor-specific antibodies, and those who have had a HLA mismatch. And the non-immunological factors are hyperlipidemia, hypertension, diabetes, obesity, CMV infection, and so forth. And in the initial everolimus trial, those patients on everolimus, the incidence of progression of intimal thickness at 1 year was less compared to azathioprine group. And in the chance of getting vasculopathy, again was less compared to azathioprine. So our policy is if the patient shows any evidence of vasculopathy, we try to switch them onto reduce the tacrolimus and put them on
to everolimus or mTOR inhibitors. But the problem is not all patients would tolerate. And this Mandela trial, where the patients, after 3 months, were put on, either they go on to CNI-free therapy or those with combination of everolimus and CNI. And those patients who were on free of CNI, the transplant nephropathy was much less. So if you detect the patients getting nephropathy post-transplant, we would try to switch them to everolimus. Malignancy is the problem. And again, if you look at the incidence here, all types, 27.3% at 10 years. But of these, commonest is skin-related tumors, which is 18%, whereas others are much less. So again, in this part of the world, all of us are protected by pigments, unlike the Western world. The skin cancer is very, very less, much less. So significantly, patients suffering from malignancy long after transplant is much significantly less than what you see, what is reported in the Western world. So surveillance for malignancy is important, such as screening, looking for EBV virus progression, and also the left graft dysfunction is another problem that occurs. It can be related to the previous rejections, vasculopathy, antibody-mediated rejection, and so forth. And just to give an idea of how it influences progression after transplant, if we looked at our first 60 transplants whom we did and followed up for over a period of 25 years, and see the infections are common in the early period, and coagulopathy, infection get less as time goes on. And if you look at the Cardiovascular, this indicates the number of patients diagnosed with coronary artery disease. So at 1 year, by 2 years, new cases of coronary vasculopathy. And so that, as you see, as time goes on, more and more patients do suffer from coronary artery vasculopathy. In our series, you see the cancer is very much less. So we have a protocol of infection prophylaxis, which all patients has to follow that protocol. And in conclusion, a heart transplant offers a lifetime for individuals with end-stage heart failure, but it is crucial to understand both potential benefits and the inherent risks involved. A proactive approach to care, including meticulous monitoring, medication management, and strong support system is vital for maximizing the chances of successful outcome. Thank you.
Thank you very much, sir. Anybody got any questions? Any questions from the house? I think we have already exceeded time. We must call it a day.
Yes,
right?
Thank you.
Thank you so much for the session. Thank you so much.
Thank the chairpersons for the last session. I think the next is the much-awaited presidential address session, and for this, may I now have the privilege of inviting the chairpersons, Dr. Anvay Mule, Dr. James Thomas, Dr. Jose Chakoperiapuram, and Dr. Rajan, please, to the dais. And while we call upon our incumbent president, Dr. Julius, Dr. Jose Chako will give a brief introduction of our president. Dr. Julius needs no introduction to this audience. He is the group lead for the thoracic organ transplant for the Narayana group of institutions, and Dr. Jose Chako will introduce him formally, and then he'll come to the dais. Thank you.
So on behalf of the chairpersons, I cordially invite Dr. Julius Punnan to deliver his presidential address on this auspicious occasion. We all know Dr. Julius Punnan quite well. He has been part of the society since its inception itself. and gradually he has helped the organization to grow up in its activities and has been the president of this association for the last couple of years. And he is the director of Advanced Cardiopulmonary Therapies and senior consultant cardiac surgeon, group lead, heart and lung transplant and mechanical circulatory support at Narayana Health, Bangalore. And he has been training a lot of junior surgeons over the last many years, and he has been a mentor to many centers in the country. He has been a part of developing transplant program as well as a VAD program in West Bengal, as far as I know, and in many other states of the country. And I am very happy to introduce and welcome our beloved President, Dr. Julius Punnan, to deliver his presidential address. Thank you.
Thank you, Dr. Jose, for that nice introduction. Honorable chairpersons, past presidents, and office bearers of the association from earlier, honorable secretary, treasurer, executive members, fellow members, students, and friends. The opportunity to serve as the president of the Society of Heart Failure and Transplantation represents the highest academic honor of my career. I am truly thankful and honored for this opportunity. When the society was founded, lung transplantation was not being performed in the country, and therefore the name did not include lungs. It is my honor and privilege to specially welcome the lung transplant community members to this meeting who are present here, and want to assure them that the society includes lung in equal measure as the heart. It is indeed a great time to be a thoracic transplant specialist, physician or surgeon. This is a relatively young specialty. Good number of the senior people in this room were born before the first heart transplantation was done, and would have been in medical school or in surgical training by the time the first successful lung transplantation was done. Most of us were already in cardiac surgery by the time the first heart transplant was done in the country by Professor Venugopal. And surely many of us were already doing transplants by the time the first lung transplant was done by Dr. Madhu Shankar and Dr. Govini. After lifting the moratorium on transplantation, it is only in the 80s where the number of transplants really increased to a significant number. And in India, heart transplantation became commonplace maybe only in the 2000s or later. To a large extent, it is thanks to Dr. Balakrishnan, who went around the country educating everybody on the importance of having adequate didactic knowledge and coached people to do the transplants. So at that point of time, there was a major increase in the number of transplants done across the country. And gradually, states which were not doing have picked up and started doing again. Mechanical support, ECMO, and effective treatment for pulmonary hypertension all were developed during our practice lifetime. So it is fair to say most of us have seen the birth and growth of this specialty, and we have been around and contributed. And many have pioneered in, at least in their region, in some aspect of the specialty. For those young people who are entering the specialty or are mid-career, the future is full of excitement, and there is going to be a tipping point which comes up, and the transplant numbers will exponentially increase. Although I am from Kerala, all my medical education and most of my medical practice have been in the state of Karnataka. I came to Bangalore for medical education and sort of never left there. The first solid organ transplant in Bangalore was when I was an intern in MS Ramaya Medical College. I was fortunate to be a small part of the care team at that time. The transplant nephrologist from then still says that that is what inspired me to take up transplant as a career. I was fortunate to have done the first heart transplant in that same college later on as I became a surgeon. The first time I scrubbed in for a heart transplant was something which Dr. Rajan here had retrieved for Dr. K.M. Cherian, and I did the cutaneous anastomosis in that one, which is otherwise called skin sutures. my after a year in Chennai in Global, where I did some lung transplants, I moved back to Narayana Hrudayalaya, and then we were able to get the program up and running much better. My initial experience with this whole area was when I first set up a homographed heart valve bank. We applied for a license initially. As soon as we got a license, I went around trying to harvest it from the government hospitals, which did not work out. And then after a lot of negotiations, we started getting initially from MS Ramaya, then other hospitals also started helping us. And subsequently, we were able to set up a cryopreservation unit with the help of the Department of Biotechnology. At that time, the Department of Biotechnology was kind of new and they were flush with funds. So we did get a sizable grant from them to get that going. The importance of young surgeons doing homographs or the preparation of homographs is that when you are training towards being a transplant surgeon, in our minds we are always seeing the heart from a sternotomy perspective. Of course, now things have changed a bit and so many other perspectives have developed. But once you take the heart out and put it in a bowl, your orientation becomes quite difficult. And it's spinning around and you really won't know what is what. But if you have a base of dissecting homographs, you'll be very clear about the structures, whichever way you keep the heart. So even now when I help people for the first time, I see a hint of little disorientation when you see the heart in a bowl for the first time. The first heart transplant in Karnataka happened in 1999, and Dr. Shetty did the donor and the recipient operation. I was not there, I was in Chennai at that time, so I could only do the coordination from there on phone. See, those days we did not have transplant coordinators. We had to do all their roles as well. Fortunately, Dr. Joe Darani, who subsequently became the STS president, was visiting and he helped out with the operation at that time. In 2000, I went to Australia to join the new Children's Hospital, and by the time I left there, they changed their name to Children's Hospital at Westmead. And then I was fortunate to get a job in St. Vincent's Hospital at that time, where I was able to get formal training in transplantation and heart failure and VADS, etc. The current head of the department in St. Vincent's was a trainee registrar at that point of time. After 1999, the first transplant that took place in Karnataka was only in 2007, after a long gap. And even then, it was few and far in between. We probably did one every 2 years or something like that. And Dr. P.V. Rao was the one who did all of those transplants, and I used to do the retrievals at that time. And later on, I took over the transplant program, and coincidentally, there was a growth in the overall transplant program at the same time around the country. From there, I went on to work in Global Chennai for a little while, where I did, along with Dr. Govini, some lung transplants, though I did not get to do any hearts at that time. Then I returned to Narayana Hrudayalaya, where that is the time I got my first break when no other senior surgeon was around. Actually, one was around, but he just said that he's not available because there is a puja at home. Having known him for so many years, he's never taken a day off. So he just didn't show up because he wanted me to do it. So sometimes you find mentors in very varied circumstances which you may not even recognize that they're helping you. We also developed a transplant program in MS Ramaya Medical College later on, and Dr. Ravi Shetty was the surgeon at that time. Nagamallesh was the cardiologist for then. I did the first transplant and then stood on the left side for several more, and I eventually did the 50th one there. Nagamallesh had wanted me to do more of the initial ones, but then Ravi Shetty took it up and he did a very good job. Today, he is head of Karnataka, Soto, and he's bringing up a lot of changes in the transplant administration. I was also involved in one of the earlier transplant in this city, and the only thing I remember from that is that the ambulance which we carried the heart in broke down, and I picked up the box and got into the police escort car, and there was a picture of me sitting behind the police jeep like a criminal in the newspaper the following day. So, fortunately, it didn't come anywhere else. The atmosphere of transplant in the country changed for the better around that time, and the number increased considerably. One of the reasons I think happened is because the liver transplant took off in a big way. So more and more hospitals started generating donors and bringing up more donors. And at that earlier times, there were very few takers for heart. But now that has also changed. There are plenty of hospitals which are doing heart transplant as well. When we started retrieving along with liver teams, we used to mobilize the heart, then go away for 2 hours, take a nap, then come back and they would still be mobilizing. But today, they hardly take 15 minutes more than us. They've all become very, I don't know if the technique changed or not. Sometimes you would find the liver surgeon ready to give heparin by the time you're doing sternotomy. There has been a major change in the way they conduct that. I also had the privilege of doing the first heart and lung transplant in our city. He is doing well at 75 years of age now. He was 69 when we operated him. These actually 69 or above 65 is a good age to do lung or heart lung, because realistically speaking, you're only increasing their life by an average of 5 or 6 years. If you do that to a 20-year-old, you're really not doing much of a service. But in a 65-year-old, 5 years makes a lot of difference in his lifetime. There was a time when transplants were always done by the senior most person in the department. Now that has changed. A lot of young surgeons have come back from training from various places, and many people have trained here itself. And again, when we started doing VADs, we always had to get proctors from other countries. Today, you don't have to even look beyond your city to find a proctor. Things have improved so much in the last 5 to 10 years. When you're looking at transplant, as Dr. Bala has always emphasized, it takes hours of pouring down books and journals in order to get a good theoretical understanding. Again, when most of us started, we did not have specially trained cardiologists helping us. Today, that is no longer a problem. We have very competent cardiologists and other subspecialists in infectious disease, in ICU, in so many other areas of transplant where we don't have to know everything anymore. You can still manage to get help from all the others and get good outcomes. Again, the more risky cases generally gets done by the senior people so that the relatively junior surgeons are not burdened by poor outcomes. When a young trainee shows some interest in transplant, it is common for the senior people to tell them, no, transplant is not the thing for you now. You wait for some more time. But I really feel we should encourage them to take this up, and they'll have much longer time to get all the learning which they need. There are a few changes that is happening around the allocation criteria and other things. Now, dual organ transplant is quite a struggle in our state. I do not know how well it is organized in other states. The listing and allocation criteria are not clear when an organ on either side of the diaphragm are included together. Ideally, the heart should pull the other organ, but that just does not happen. If you need somebody with a heart liver, they may not fit the liver transplant criteria, but without that, they may not be suitable for a heart transplant either. With the synthetic function failing, it is difficult to measure it, and they tend to have severe bleeding consequences when you do the operation. Same goes with kidney, because the kidney wait list is so long, they are not going to prioritize a kidney allocation like that. But then at least sometimes you can have a living donor available. Many changes are happening in the transplant law at the center, and hope these issues get looked into that. Currently, each SOTO decides on the donor allocation within their jurisdiction, and I understand it is an attempt to make it uniform across the country. But I hope it incorporates all the best practices, and one must remember that changes in allocation can have profound downstream consequences. We have seen an example and discussed it before in the US, that the current allocation policy in 2018 made so much changes that VAD has become much lower in numbers, and use of ECMO has gone up because it is prioritized. So whenever you make a change in the allocation policy, the indications for using this device changes to get a higher priority. Everybody wants their patient to be prioritized, so everyone would do what it takes to get that done. There are several other aspects also of donation that needs to be addressed and uniform management practices developed. It is often very difficult to get a CT or a conventional angiogram in a donor. Many times you may have to accept a heart without having a proper assessment with an angiogram. It again depends on the urgency you have. If you have a patient who is dying otherwise, you may have to take it without an angiogram also. Again, the amount of vasopressors that can be very high in spite of having low filling pressures and a high blood pressure. And if if a PA catheter is mandated like they have in the UK, you might be able to manage a donor much better with all the organs well preserved, rather than looking at the organ of interest for the institution which is donating. The recent advances in organ preservation, I think we'll be hearing more about them soon, which has surely improved the quality of organs and has extended preservation times to a large extent, making transplant a more elective procedure. Unfortunately, all these nice techniques increase the cost of an already expensive procedure. So I do not know how much we will be able to benefit from that. The past few years have been kind of difficult for the society. The available resources to conduct academic activities are decreasing significantly due to the new policies by the government. And also there are several societies which are addressing the same topic and share the limited resource, and it is becoming increasingly difficult to make ends meet when you are conducting a scientific activity. Our attempts at collaborating have not yet worked out well, and hopefully in the coming years it will have a better collaborative atmosphere. When I eventually retire, which I hope won't be soon, I would like to think that I have trained more transplant surgeons than the number of transplants I have done. As I lay down the office, I hope the new leadership of the society will take the society forward in a much more rapid pace. Thanks once again for the opportunity to serve as your president.
moving forward into the next session, which is on organ donation. I would call on stage to chair the session Dr. Tapash Roy Chaudhary sir and Dr. V. Nandakumar.
I'll make a very short introduction to this session, and Nandakumar can do the final summary. We have got about 6 or 7 speakers. I request them to, keep it short and finish it on time. Now, in introduction, only thing I can say that there are never enough donors. The reason there are not enough donors because most of the donor generates from the hospital just already doing transplant. So they are actually in the middle of metropolis. But there are nearly 50 ICU with maybe 100 donors a month available. If we go around and tell them or teach them how to detect a brain death patient and a potential disease donor. So that's a hard work. But if one can do that, then I think there will be more or less solution about availability of donors. Now, I will go back and ask the first speaker, Dr. Dibanjan Chatterjee.
Thank you, Chairperson, sirs, and the esteemed delegates. Sir, you have made my work very simple with that eloquent description of the problem. Where we are lacking, why we are lacking, and how we can improve. Those are the things that we will be discussing in the next 15 odd minutes. Where we are in the scenario of transplant worldwide. US does almost 47,000 transplants, organ transplants, of which 40,000 are from the deceased donors. China doing 24,000 transplants, 19 or 20,000 organs are from the deceased donors. In contrast, where is India? Just check, we are doing 18,000 transplants and the deceased donors are only 3,000 approximately, disease organ that we are harvesting. Almost 15,000 are from the living donor transplant. So it is very odd that of the large number of the transplants doing countries, we are very much lacking in the disease donor organ procurement. When we compare the number of disease donor donors, India is way down, only in 1,099 in 2023. This is the trend from NOTO 2023-24 report. The number of transplants has gone up to 18,000, whereas still the number of diseased organ donors is only 1,100 odd. So what is the requirement? How much is the requirement in the country? So for the kidney, we need 2 lakh donors, but we are transplanting only 13,000. For the heart, 30,000 is needed. We are doing only 21. For lungs, 20,000 is needed. We are doing 197. This is the 2023 data that I am going. So almost 3 lakh organs are needed, and we are doing only 18,000. Only 6% of the needy population is being treated. So we are lacking significantly. So for that, the government amended the THOA Act of 1994. The THOA Act of 1994 was the first act which came up, which regularized what is brain death. defined brain death and how we should do it. And there were some discrepancies which were corrected in the revision in 2011 and then in the rules of 2014. And through this act, the government introduced the concept of a single organization, central organization, which is coordinating the donation and organ transplantation in India. There is a single central organization, that is NOTO. There are 5 regional organ transplant organizations and 31 state organizations. So that eased the availability and the delivery of these organs. Who is going to get that organ? Everything is now much more easier through this NOTO, SOTO and ROTO involvement. How many transplants are we doing? The south and the west of the country is definitely wide ahead compared to the rest of the country. In the West Bengal, we have just maybe initiated, you can say. And far east, we are still waiting for these diseased organ donor transplants. So for brain death, what is the cause of brain death? The most common, mostly 50% of the population is having a traumatic brain injury. The rest may be a cerebrovascular accident or severe SAH. So if a patient of severe traumatic brain injury comes, the patient can either recover or can succumb. If the patient is succumbing, either the patient can have a brain death or a circulatory death. So the concept of organ donation, as we all know, is that if the patient has a brain death, that is a brain stem death, the heart continues to circulate the blood and the organs can be preserved so that can be taken. So brain death is an irreversible condition, and it is in that window that we have to be very proactive to take those organs. So who can certify brain death in any hospital? So there are a group of 4 doctors need to certify brain death. Either a medical administrator in charge of the hospital, an intensivist or an anesthesiologist, a neurologist, if not present a physician, a neurosurgeon, if not present a surgeon, and the medical officer who is treating the patient. So these 4 group of doctors, they can certify brain death. And every hospital should be having a team of doctors who are approved with NOTO to notify the brain death. There are very easy steps of diagnosing a brain death. First and foremost, you have to be sure what is the cause, and that is irreversible, and see that the patient is unresponsive. Check the brainstem reflexes, then do the apnea testing, and then you can declare. There are some ancillary tests that you can do, but that is not absolutely necessary. Before you go into these tests, always exclude that there is no confounding variables, such as the patient is having a intoxicant, or the patient is hypothermic, or the patient is under the influence of muscle relaxants. So at least 5 T-halves should be given, the time given till from the last dosage of the muscle relaxant till you start the first apnea test or checking these brainstem reflexes. Patient should not be hypothermic, there should not be shock, the blood pressure should be maintained, and there should not be any electrolyte imbalances, significant imbalances. And then you can go for these brainstem reflexes checking and then for the apnea testing. And these set of tests have to be repeated after 6 hours for adults. For pediatric population, the duration, the gap between the first and the second test needs to be higher. If it is an infant, 24 hours. If it is the patient is more than 1 year of age, then up to 18 years of age, it is 12 hours. So the gap needs to be higher in the pediatric population. So what is the process? First set of tests is done. Counseling of the family has to be done after the first set of tests come positive, and then the second set of tests have to be done. If the relatives do not agree for donation, do not go for the second set of tests. You abandon and continue the usual treatment. And after the second set of tests, you say that the patient is brain dead, sign the Form 10, and notify the regional organ transplant or organization for the organ retrieval. But what are the issues that we are facing in declaration of brain death in India? We are delaying the early diagnosis, whereas there is a hesitancy in the critical care doctors or the doctors taking care of such kind of patients to declare or go for the apnea testing. So there is delay in the starting of the donor maintenance protocol, very important, because once the patient is brain dead, they can rapidly deteriorate, and the organs after some time will not be available for the transplant, will not be in a perfect condition for transplant. So we have to start the donor maintenance protocol quite early. There is a lack of training in breaking bad news, and there is lack of awareness at all levels, not only physicians, the relatives, the general population, even the hospital administration. There is a lack of awareness that needs to be addressed. And this leads to lot of problems. That is, we have lack of number of organ donors just because we are not very proactive. So who defines brain death and how we can progress? So any patient who has a devastating brain injury comes to the hospital is a possible donor. And then you check whether the patient is a potential donor or not. Once you have checked the patient is a potential donor by 2 sets of tests, you take the family consent, and then the patient is a eligible donor. And when the patient has donated the organs, he is the actual donor. So early identification of brain death is very, very important. And for that, we need to have a system in each and every hospital. Whenever the GCS of any patient is less than 5, you have to have a system that notifies at least the head of the administration, the critical care in charge, the nursing in charge, that this patient may be a potential donor, and then that can be followed up. And the hospitals where there is a electronic medical record systems, where GCS is being recorded, there can be auto-generated SMSs to all these 3 people so that they can initiate the process of identification of these donors early. So if we subclassify the potential donors, so if when there is an alert from GCS less than 5, this potential donor is identified and checked whether their pupillary reflexes are there, the corneal reflexes are there, all those things are checked, and they are reported to the organ donation committee of the hospital. And the organ donation committee checks whether the patient is a suitable donor or not, whether the organ functions are okay or not. And then he does the optimization process is initiated. Before we are diagnosing brain death, we start the process of optimization of these patients, and then we do these 2 sets of tests to declare the patient as brain dead and declare him as an eligible donor. But there is a problem. We say that the patient is brain dead, but our Registration of Births and Deaths Act, they take as death as only a permanent disappearance of all evidence of life. So there is no uniform definition of death in legal matters. So what we find that the patient is dead enough to donate the organs, but not actually dead. Or even now, we are filling the death certificate as cardiorespiratory failure or the cessation of cardiac death beats. And even when the Form 10 has been filled up long time back, and there is hesitancy in declaring the brain death by the doctors, why should I take so much of pain of doing everything? Because this is something you have to have a passion for it. Otherwise, there is a lot of effort involved by the treating physicians, by the hospitals involved to get the organ donors. And To address these things, the government came up with an order in 2020 which eased a lot of our woes. Every hospital needs to advertise about the organ donation in proper public places so that the people are aware of these problems and these availability of the organ donation process in the hospital. And they can think about life after death of their own relatives. There are a lot of challenges for disease organ donation in the Indian hospitals, and the most common is the counseling of the families. Whenever we find that this patient is having a brain death and we approach the relatives, there is a denial. First and foremost, there is a denial that I just leave the patient alone, I don't want to do anything more. So repeated sessions of counseling is needed to convince them. We can have some incentives, but in our country that is not allowed legally. Other countries, they have these incentives. And certain countries, they have a option for opt-out. That is, if they are brain dead declared, that they will be the potential donors unless they have given an order before their death that they are not willing for organ donation. So that increases the pool. But in our country, we are still in an opt-in state. That is, either we, before our death, we have given a consent for organ retrieval, or our close relatives, they are giving a consent for organ retrieval. So opt-in reduces the number of organ donors significantly. But we can at least start with opt-out situation for the corneal transplants, cornea donations. So what is the utilization per patient? How many organs are we taking? US does approximately 2.86 organs per donor. India does 3 times, that is 3.05. So the ratio that is well maintained, but the number of disease donors are significantly low. Whereas the heart-lung, what happens? The heart is only 22% of the donors give the heart, and the lungs is only 20%. Compared it to liver and kidney, it is more than 80% of the donors are giving away their liver and kidneys. There is an issue of sensitizing the organ donation process and having a proper quality assessment of this process. And there is a significant role of the government, the role of the hospitals, as well as increasing the awareness of the general public so that the organ donation becomes a much more smoother process, less of legal hassles, less of thoughts by the doctors themselves that what will happen if they are not agreeing. The main problem that occurs is that relatives come and say, you are trying to kill my patient to have the organs for something of your personal gain. So those things can be avoided. And managing the brain dead organ donor is one of the most important things. Not only the consent, the donor has to be managed well so that we have a proper organ for transplant. Thank you very much. And before I end, I should acknowledge this was the talk was to be given by Dr. Avnish Shet. He is the country head of Manipal Organ Sharing and Transplant. And he is very much motivating all of the doctors throughout the country to go for organ donation and diseased organ donations. Thank you, Avnish sir. And many of these slides are taken from him. Thank you.
Thank you for the excellent talk on a very common problem. Very common problem. See, the donor shortage is a major problem in our situation. I think, as he said, if the law can be changed like in Europe where you'll have to have an opt-out, it will be very good. But the government has to support this program, and probably the associations, various associations also will have to come forward for popularizing the donation and the advantages of the second life for the donor. That sort of thing has to come up. And people have to be aware of the situation and the advantage of
giving their donation, and some sort of incentive for the family after the donation, some sort of, and honoring them also is actually equally important. And we do that. We call the donor's family also at the time of discharge of the recipient. But from the government point of view also, I think they have to support the family and honor the family at least once in a group of call them in as a group and then have some sort of honoring them. That also will improve the situation. That's what I personally feel. Any question from the audience? So we'll go on to the next one. I think the next topic is not organ preservation system, recent advances. Stephen Clark. Recorded.
And play a recorded talk by Dr. Stephen Clark because he hasn't been able to come here physically because of some visa-related issues at the last moment.
One issue here, can you keep it now? This is not displayed, only the dice is displayed.
Okay. Reflect the same screen. Yeah, they'll fix it, sir.
Well, hello,
Please
everyone.
play it and make sure
Thank you
this
sincerely
reflects
for the
on that.
invitation to talk to you today about organ preservation systems and, in particular, the recent advances that have taken place in this area. Firstly, I start with an apology for not being able to be with you in person. As you probably know, I ran into some very significant issues in obtaining a visa before my flight was able to depart, and so was not able to join you. But I'm very grateful for the invitation to talk to you, at least remotely. So clearly, organ preservation systems are an area of significant technical innovation and expansion at the moment, and provide us with a tool to revolutionise our field. It can increase the number of organs that are available through longer transit times, utilising DCD donors and improving the quality of extended criteria donors, with the consequent effect on our waiting list and the time it takes to get our patients transplanted. It has huge potential in reducing the incidence of primary graft dysfunction and converting a procedure often done at night into an elective daytime procedure. The technology also affords us opportunities to further assess the quality of organs and to intervene with therapeutics to improve the quality of the organs that we transplant. So I want to cover with you an update on 6 potential state-of-the-art devices, 3 for the heart and 3 for the lungs. Now, before we move on to the devices themselves, I guess it's important for us just to talk quickly about. So traditional cold storage is where we are now. It's the historic standard of care, utilising cardioplegia and pulmoplegia with organs stored in sterile bags within an icebox. It is, of course, very inexpensive. It doesn't require any additional trained staff, and for ischemic times of 3 to 4 hours for hearts, it's a perfectly acceptable method of organ preservation, particularly for good quality organs. However, there are multiple limitations in this technique because the cold storage attempts to induce hypothermic arrest of the metabolism, but we know that this continues at around 10% of in vivo levels, leading to gradual lactic acid accumulation and time-dependent ischemic injury compounded on reperfusion, leading to primary graft dysfunction and its significant increase in mortality. We know that this can lead to excessive cooling below 2 degrees C with cold-induced graft injury. We know that hearts stored on ice can reach a ventricular temperature of 1 degree within an hour, and that temperature distribution is not uniform, with the thinner right ventricle often reaching below freezing temperatures. In multi-centre studies of hearts stored on ice, the average temperature was less than 2 degrees and could get down to freezing over prolonged periods of ischemic time, with an increase in graft injury and more primary graft dysfunction. Similarly, it can be the case that there is excessive warmth of the organ above 10 degrees, which would be associated with impaired coronary microvascular function compared to cooling at 4 degrees, and vascular endothelium-dependent relaxation is best between 4 and 8 degrees, certainly in rat models. Also, there have been no real major advances in preservation solutions in recent years to improve upon these traditional methods. So what advances have there been, particularly in temperature control alone? And this would be typified by the Paragonix Sherpa Pack system. This is a simple system maintaining the donor organ between 4 and 8 degrees, utilising phase change materials which can store and release large amounts of energy and keeps the temperature range for up to 40 hours, giving uniform cooling and protecting against freeze-induced injury. The container has a monitor that continuously monitors the temperature, and it's a relatively cheap device, around £5,000 per unit, much cheaper than other devices that we will talk about shortly. It's simple and it's passive, it needs no specialised staff, but there have been no randomised trials of the device, but there is a very good registry, the Guardian Registry, which is an international multi-centre registry looking at heart transplant outcomes and comparing the Sherpa Pack with traditional cold storage. The results from this have been exceptionally good, with increased 2-year survival and significant reductions in primary graft dysfunction and improved right ventricular function in hearts stored with the Sherpa Pack. There have been recent publications looking at improved post-transplant outcomes in recipients of donor hearts which have been preserved in this way, which significantly exceed outcomes with conventional ice storage. Given the modest costs of the device and certainly increased outcomes for patients and therefore reduced intensive care unit costs, the post-operative cost-benefit analysis is very significantly in favour of this device, with very significant savings per patient of the order of $25,000 per case. Looking at more complex systems, the TransMedics organ care system is probably the most well-known and most studied perfusion system. The OCS, of course, permits the heart to be conventionally retrieved with cardioplegia, but requires 1,200 mL of donor venous blood for priming the machine. It's a Langendorf model, allowing normothermic oxygenated perfusion with the heart beating after restoration of coronary perfusion with a nutrient-enriched perfusate delivered into the aortic root. Blood is ejected through the pulmonary artery via a cannula into a reservoir and then to the gas exchanger and back into the aorta. It has the advantage of being able to display real-time aortic pressures and coronary flow, temperature, oxygen saturation and hematocrit, and allows for pharmacological manipulation of hemodynamics through adenosine and epinephrine infusions. The OCS system has the advantage of being able to control a number of perfusion parameters within certain criteria, and hemodynamically allows us to control the flow through the force of each linear pump stroke, synchronized to the ECG, and pressures can be measured in the aortic root and in the pulmonary artery cannula. However, pulmonary edema can develop quite quickly when flow is excessive, and the lowest possible aortic flow should be used to keep lactate levels low, minimize edema and reduce primary graft dysfunction. It has the advantage of being able to visualize a beating heart to allow some assessment of contractility, but remember that the heart is not held in the same anatomical position as during procurement, as it rests on the right ventricle and is suspended from the ascending aorta, which limits direct visualization and can make interpretation more difficult. It is also not a function assessment because it's not a loaded heart model, as it's a Langendorf system. Colleagues at Papworth Hospital in Cambridge have developed some pressure loop measurement systems, but that has not been widely used clinically yet. In terms of further assessment, the lactate level whilst on an OCS system has been a criterion for heart acceptance in a number of trials, but similarly there have been multiple cases of successful transplantation despite terminal lactates of over 5 millimoles per litre, and no one factor has actually been highly predictive of primary graft dysfunction. Hearts that exhibit rising lactate, but with visibly increasing edema and high aortic root pressures, may be at high risk of primary graft dysfunction. But lactate in itself does not predict the requirement for postoperative support, and further research is needed to identify other metabolites or other compounds that may predict post-transplant function in hearts preserved on the OCS system. There has, of course, been a lot of evidence surrounding the TransMedics OCS system demonstrating its safety and non-inferiority, but perhaps the EXPAND trial was the most interesting study looking at extended criteria hearts, demonstrating that these could be safely utilised using the OCS system. However, some caution needs to be exercised in extrapolating the effectiveness of the OCS system to lesser represented subgroups within the analysis, as the vast majority were those where an expected cross-clamp time of more than 4 hours or a long downtime or impaired left ventricular function had been observed. Perhaps the greatest application, though, of the OCS system is in the retrieval of DCD hearts, where many studies in the UK and elsewhere have demonstrated the efficacy of this system in producing outcomes from DCD heart transplantation which rival those from conventional brain-dead donors. However, this all comes at a cost. Increasing acquisition costs up to $40,000 are very significant and may prohibit a number of lesser funded transplant centres from utilising this technology. However, the costs may be recouped through reductions in primary graft dysfunction and reduced intensive care stay, and will allow us to expand the donor pool and reduce our waiting list time, which may minimise pre-transplant care costs and need to be taken into consideration. A newer system to be considered is the ex vivo heart transport system. This device utilises hypothermic perfusion of an arrested heart with continuous oxygenation. It has the advantage of being an extremely compact design, able to fit onto a standard aircraft seat or easily into a car. It is contained within an insulated system, maintaining a constant 8-degree temperature, and so is very safe in device failure compared to warm perfusion devices. It's extremely user-friendly because once perfusion is commenced, there's no need to adjust any pressures or flows or temperatures. It's a device that I've had personal experience with, utilising it in the first case performed in the United Kingdom with great success. The device was recently evaluated in a study that we published in the Lancet, showing significant improvements over conventional cold storage with dramatic reductions in primary graft dysfunction and excellent survival. This survival benefit extends out to 1 year, and we've just submitted this paper for publication of the longer-term follow-up of hearts preserved in the ex vivo device, showing a significantly increased 1-year survival in patients whose heart was preserved by this method. So for heart preservation systems, the roles and utility of these devices are predominantly around extending ischemic time, utilising extended donors, and for situations where prolonged ischemic time may be an issue, like congenital cardiac cases or explants of durable VADs, these devices could be of great utility, but there have been no randomised trials of OCS against Sherpa Pack, but a sub-analysis of the EXPAND trial against the Guardian registry showed very similar reductions in primary graft dysfunction rate and in 30-day survival. There have been some small single-centre analyses in using OCS for LVAD, bridge to transplant recipients, which improves 30-day survival compared to cold storage, and certainly a sub-analysis of the Guardian registry has suggested in a similar population that reduced primary graft dysfunction occurs despite increasing total ischemic time. All of the evidence on heart preservation with devices is encompassed in this European Society of Organ Transplantation consensus statement, which concludes that machine perfusion is safe and non-inferior and is a valuable tool in both DBD and DCD heart transplantation, but that currently there's no consensus on recipient criteria that might indicate the need to perform machine perfusion. With this technology, though, there is huge potential for further interventions through direct administration of pharmacological agents, gene therapy and stem cell therapy that could be of great significance. But a durable working mode perfusion platform is currently elusive. Moving on to lung preservation, this is perhaps not so critical given the significant resistance to ischemia which the lung has compared to the heart. A simple method is refrigeration at 10 degrees for lungs. We know that lungs, when they are preserved, can very rapidly be excessively cooled with significant ice damage occurring within 6 hours on ice, with the lung reaching freezing temperatures. By keeping the lung at a controlled temperature of 10 degrees, it leads us to have very effective long preservation times of over 18 hours without any impact on survival. Ex vivo lung perfusion remains commonly used in a number of. So ex vivo perfusion circuits are well described. It allows us to perfuse the lung with a perfusion fluid through the pulmonary artery with effluent escaping from the left atrium into a reservoir before being oxygenated and returned to the pulmonary artery. Also allows ventilation and bronchoscopy.
Is that it? So, Mr. Clark is not available for, is not available, okay. So just go to this next presentation. Dr. Sivathasan.
There are a number of potential.
You're supposed to speak on international perspective in organ donation.
Yeah, good afternoon again. So the title of my presentation is International Perspectives in Organ Donation. Oops. Okay, so it was on the 3rd of December 1967 that Dr. Christian Barnard made history by doing the first heart transplant 58 years ago. Since then, more than 70,000 transplants have been reported to the registry of ISHLT. And also, the first transplant that was done, the donor was not from brain death, but from cardiac donation. Because at that time, in South Africa, there were no law defining brain death. So he has to wait till the heart stops in the adjoining theater before he could procure the heart and do the transplant. And he was lucky that he was able to successfully start the new heart to work. So over the years, as you see, the number of transplants has more or less remained stagnant until about 10 years ago, when more and more transplants are being reported, mostly from North America. And whereas in Germany, it remains the plateau over the years. And the red bars are those transplants that are down outside North America and Europe. And the recent increase in numbers are from more centers from outside North America and Canada reporting their data to the ISHLT registry. And if you look at the world population, which is over 7 billion, Asia, the blue, the segment, Asia hosts 62.5% of the world population, but only 5.7 transplants was done from Asia in 2012. Whereas North America, the green bar with about 7.5% of the population, reported 55.8% of transplants were done. So as you see, Asia has the large population, but we are not doing good at all. And but it's also that it is estimated that 33% of heart transplant activity is not reported to the global registry. For example, in 2016, only one center from India reported. So there are a number of cases that have been done in this part of the world being not recorded in the ISHLT registry. And even if you take India, as the previous speaker has highlighted, you need about 50,000 heart transplants per year at least. So what are the main problems in Asia, as the talk is on international arena? So mainly is the lack of heart transplant centers and technology that's available in many parts of the world. Cost remains prohibitive because the basic healthcare cost takes a priority in developing countries, and lack of health infrastructure to develop thoracic transplant programs, lack of cadaver donor organs. The reasons are many: multicultural, racial, and religious beliefs and diverse traditions of many centuries has resulted in reluctance in organ donation. For example, Japan, belief in intact body for resurrection. Some communities consider organ procurement as an act of mutilation. Misconception that organ donation is not permitted by Islamic law. And also important in our region is that we don't have an organ sharing network as you would see in Europe. Many reasons are for this: funding, lack of infrastructure, diversity in political and social cultural issues. And also, there's, in the registry data, if you look at it, there is also underreporting. For example, Korea, the number of hearts that are available is in 2016 from 573 donors, but only 156 were utilized. And family refusal is not a peculiarity in our part of the world, but also if you look at the European world too, for example, in Latvia, 45% of the family refuses. Australia, surprisingly, 41% of patients of the family would refuse organ donation. UK, it's about 35%, and so forth. But the East European countries, such as Poland, Spain, Hungary, they are pretty doing well in that family refusal is only less than 15%. Now, this has been addressed. There are two kinds of laws that operate internationally. One is the opt-in donation system. Other one is the opt-out donation system. Opt-out is presumed consent, that if you don't declare that you don't want to be a donor, then it is presumed that you are given the consent. So examples of opt-in countries are USA, Germany, Canada, India. In fact, most of the countries do have that opt-in. Other opt-in countries which require registration, but it appears that the donation rates are low when you have an opt-in system. Opt-out countries, Spain, Australia, even Singapore, we have the opt-out countries. The expectations are to have higher donations, and also it's assumed that the patient has, or the donor has agreed to donate organs unless he has opted out. But it needs a lot of organization, counselors to speak to the family at the time of distress. Spain is a world leader in organ donation. They have success because of the opt-out system, and also they have a well-organized hospital transplant coordinators, and more important is that they have won the public trust and the awareness in the community. So in Spain, they have a national transplant organization which was established in 1989, and every hospital has a transplant donor coordinators, and are essential part of the component of the organ donation in Spain. And majority of these are physicians working in intensive care unit, but now that's being gradually replaced by nursing coordinators, and so there are 3 levels of coordination: national level, regional, and hospital. And especially at the hospital level, the role of transplant donor coordinators are very well established, and they are obliged to report any patients who are potential donors. Now, if you look at the opt-out data from various countries, it has not really increased the organ donation in rates. Same in Singapore too. The solid bars, the orange bars, for example, Argentina, that's a statistical expectation of donors in the community. And the circled lines are those after the opt-out law was implemented. And you see the numbers have really not increased in time, except in year 2000, that's because of the COVID pandemic. Similarly, if you look at Sweden, the green bar, that's the statistically expected rise in increment in organ donation, but with the introduction of outlaw, the line with the green circles, it has not increased. So in many countries, although the outlaw has been implemented, the real increase in numbers are not seen. In USA, they have a well-organized system, a complex network overseen by the United Network Organ Sharing, known as UNOS. It's a private non-profit organization contracted by the federal government. So it has organ procurement organizations in various states, and they facilitate donation process, including consent, counseling the family, and all that. But more important is that hospitals are required by the Center of Medicare and Medicaid Services to identify and refer potential organ donors imminent death to the local organ procurement organization. Probably this is in the interest of the insurance and Medicare services, because if these patients' lives are prolonged, they have to pay more in terms of insurance. So now other new trend happening in US is organization of commercial professional organ procurement services. It's a network of private organizations. So their services are now gradually being established, where you have when you have an organ donor available to a hospital, currently they need to organize a team to go and retrieve the organs. They have to fly out, cost involved, timing involved, and sometimes when they go and inspect the donors, they are not suitable. So therefore, these agencies have come into place where the hospital would contract these procurement services. They would do all the necessary procurement and then transport the organ back to the recipient hospital. So that's getting more popular and being carried out. Now, if you look at the Islamic countries, most of them, for example, Indonesia, Malaysia, they're having a great problem in establishing transplant programs. But in Saudi Arabia, Malaysia, Indonesia, although Indonesia has approved that they do not have a transplant program at all, and although several Muslim majority countries have declared fatwas or religious decrees that permit organ donation, the organ donation in the Muslim countries are still very poor. Now, apart from that, implementation of policies in heart transplants in countries have also helped in increasing the numbers. The top graph is from Korea. After they established the organizations and also the necessary regulations, the red bar reflects the number of heart transplants being done. But at the same time, their waiting list also getting prolonged. So this was addressed by the previous speakers. Currently, most countries would donations after brain death, but the concept of donation after circulatory death is coming in many countries, and either one is wait till the heart stops and then procure the heart, put it in a perfusion machine, resuscitate the heart and then use it, or normothermic regional perfusion. In other words, when the cardiac death is declared, patients is put on an ECMO system and the whole organs are resuscitated. But question is, critics, however, argue that the method of declaring after cessation of circulation, lack of clarity, and various raising concerns about the potential for premature organ retrieval. And in fact, in Germany, DCD procurement is not allowed. So DCD is mainly spearheaded by two organizations. One is from Australia, from Sydney, and also from Perth. And in the Australian study, there's no difference between the DCD hearts and DBD hearts in survival. So in USA, about 820 DCD heart transplants were done in 2024, and Australia too, about 30% of the transplants are from DCD donation. The DCD organ donors as such, not only heart, is gradually increasing in numbers in UK. The UK have a well-established program, and this chart gives you the red bars reflects those transplants done with DCD hearts compared to the blue bars, which is the traditional death after declaration of brain death. So you see the increasing numbers of red bars suggesting that more and more countries are embarking on DCD. Other important topic we need to address is the organ traffic and ethics. It was initially World Health Assembly brought it out in 2004 against illegal organ trade concerns and transplant tourism. And then Istanbul Declaration, the summit convened by Transplant Society and the International Society of Nephrology together, and they brought in the Istanbul Declaration endorsed by more than 100 countries. The aim of the declaration is that non-exploitation and ensuring that organ donation is voluntary and not influenced by financial, social, other forms of coercion, protection of vulnerable populations, safeguarding individuals from becoming targets for illegal organ trades, international collaboration, promoting global efforts in restricting organ trafficking, and being transparent in terms of selection of donors as well as recipients. So WHO offers a framework that's being used by many countries. So key takeaways, diverse global models are there, legal, cultural, and ethical differences exist globally. DCD is making inroads rapidly, and importance of education, establishment of infrastructure, and the winning public trust is the most important thing of all these factors. Thank you.
Take the questions, other questions later on. One question to you, in Singapore, it's an opt-out system. But can the relatives refuse harvesting?
Yes, we do have problems at times, but we have trained social workers and coordinators who spend time with the family, explain the need. And we rarely, after counseling, it may take 1 or 2 days, and the majority would finally agree, yes. It's an emotional state where families are not prepared, so we have to prepare them.
1 or 2 days is quite a long time, maintaining the donor in a proper state. But anyway, I just wanted to know what happens in Singapore.
It's interesting to remember that the first transplant in the world done by Christian Bernard was a DCD.
Yeah, DCD, yes, that is.
The one problem with, I always wonder, see, unless you have the system available in the same hospital, or the team available in the hospital, that will not work out, no?
No, so now, well, in that time, the donor has to be transferred to the recipient hospital. If you're...
Recipient. But the other thing is, I mean, you're watching for the circulatory death, no? Before that, you can't transfer to...
Yes, so there are two options, as I pointed out. One is to wait till the heart stops and take out the heart and perfuse through TransMedics or organ perfusion system, resuscitate the heart, assess and viability. other system that's being adopted is straight away, you take the patient to the theater, wait for the heart to stop. You stop ventilating and all that. And the moment the heart stops, femoral cannulation, and put the patient on ECMO, open the chest, and they clamp the carotids to make sure that the brain does not get reperfused.
So unlike the present situation where you can, the organ, the surgeons can go there and take time and we have plan and train there.
Yeah,
that's not possible. No, so it's possible only in centers where there's a cardiac surgeon available, or there should be, as we said, a team which is available locally and the machine for transporting, no?
Yes. How the PAPWARTH is doing is, so the patients, the family are counseled in a case of cardiac procurement after cardiac death, and the family is counseled, they agree, and then the patient is either taken to the theater or even the ICU itself. They'll stop all the support systems and wait for the heart to stop, and then they rush the patient to the theater and straight away open the chest, take out the heart, put it on the perfusion machine. Yeah.
Thank you so much for an excellent talk. And any comments or questions from the audience? We'll take on to the...
He's getting restless. You are getting restless, right?
Next is the taking solid organ transplant outside metropolitan limits, a leap of faith. I invite Dr. Satish Bose to deliver the lecture.
Good afternoon. Taking solid organ transplantation outside metropolitan limits in India, I'm for someone who's gone out of the metropolitan cities and, living a solid position as the chief cardiac surgeon in one of the major hospitals in Calcutta, and then going on to explore in a city which has only 5 lakh population. So that was way back in 2008, and myself along with Dr. Srirup Chatterjee. And from there we went on to, that was about 18 or 19 years ago, and for the last 10 years we've been doing more than 2,000 cases, cardiac surgery cases every year. But one area where we have not done well is to do cardiac transplants, or maybe solid organ transplants. August is definitely a good month to do Indian for organ donation conferences like this, because the 3rd August was the Indian Organ Donation Day, and then we have the August 13th as the Organ Donation Day internationally. But in India, we may be having maybe 7 or 8 or 9 or 10 cardiac surgeons who do only cardiac transplant, like Dr. K.R. Balakrishnan here, or maybe Sandeep somewhere in South India, but maybe handful of 30 surgeons who may be doing cardiac surgeons and as part of the entire spectrum of cases that they do, but we have 2 associations. So I think before I start my lecture today, my deliberation here today, I think we should gather together and make these 2 associations as one association. Why this topic matters is solid organ transplantation is a life-saving intervention, and there is a rising demand of organ transplant in India. And there is a huge gap between metro and non-metro regions, and there is equity, justice, and universal health coverage implications. And obviously there is a demand and supply variation across various regions of India. So therefore, as I will deliberate more, that we need to decentralize these services. Why move beyond metropolitan cities? Because we need to take a risk in logistics, training, and governance. There is a geographical inequality to reduce the healthcare centralization, and accessibility is very important. Like congenital heart surgery, where when we started in Durgapur in so many years ago, accessibility was a major reason, and then we had so many patients coming from rural areas for congenital heart. Similarly, for heart transplants, for our solid organ transplants, people from the suburban towns would have to travel long distances and also lose salary to stay in these metropolitan cities. And obviously, if the center is in a smaller city, there are lower indirect cost of treatment, like staying in a hotel or lodge or whatever. And we need to use this regional hospital infrastructure. Say in West Bengal, we have, before we went to Durgapur, there was nothing in the Tier 2 or Tier 3 cities beyond Calcutta. But now we have hospitals we can use the regional infrastructure in Siliguri, in Durgapur, and maybe in some other places where cardiac surgery is being done. So every 10 minutes, one patient is added to the wait list for an organ transplant in India. And every day, 20 patients die waiting for an organ transplantation. In India, about 17 to 18,000 transplants are performed every year, but the demand versus supply gap is widening. More than 3 lakh patients are waiting for transplant, and only a few thousands there are organ donations. So organ donations is increasing, but very, very slowly over the years. So this is the organ donation and transplant map of India. On the left side, you have the status of decreased donor organ transplantation in India, and we can see that southern India is a clear winner in this. And solid organ transplants in India from both deceased and non-deceased, live patients. Tamil Nadu is the obvious champion, and there are certain areas where it is not as yet done as yet, like Bihar, like I can see Jharkhand, and so many other northeastern states. What is the status of heart transplant in India? There is a huge red area which does not do transplant. That is the entire region that is colored red. Among those huge red, there is Delhi and Chandigarh, who does cardiac transplants. There are, obviously, Tamil Nadu again is the winner and the champion of all things, and Maharashtra, Karnataka, Telangana, West Bengal, Madhya Pradesh, Rajasthan does, and the new kid on the block is Gujarat. So what are the challenges outside metro cities? You need to have good operating theaters, laminar airflow, positive prayer ventilation, must have good ICU capacity for transplants, and very good CSSD and sterilization departments. And the various cold chain and transport logistics which my previous speakers have been talking about, and obviously perfusion devices, imaging and lab. These are very important things for these are the challenges that people would be having. I'm not talking about maybe Durgapur, but other places where we can think of starting transplant programs. Another challenge is having properly trained surgeons, transplant physicians, ICU staff, coordinators, and mentorship. And again, another challenge is licensing and the NOTO and the ROTO approvals. Organ retrieval is another challenge, and ground and air transportation, because I think 1 hour of flight time is the most important, the maximum that we can allow for all this. Another biggest challenge is lack of community awareness. Awareness, allocation is one of the two main things, that is education and acceptance of organ donation and transplantation. And there are so many myths and cultural concerns about organ donation. Sometimes I've even found that when we were starting transplants in our area, there were villages in said that, don't go there, they'll cut your kidney away, they'll take your liver away. So that was so many concerns that people have raised in those areas, especially in the rural areas. So there are so many opportunities that we need to take. That is the standardized donor-recipient workup and matching protocols. We need a hub-and-spoke model also, where metro centers can work as mentors. We can have telemedicine for pre- and post-operative consults and guidance, multidisciplinary teams and defined roles, and very important is the finance, governmental support. I'll come to this in a moment about various state-sponsored insurance schemes and also PMVJ. The public partnership, where many NGOs can come in and for awareness and donor registration, and also for the financial bit. So there is a huge volume. So this volume gap can be addressed by involvement of Tier 2 and Tier 3 cities. And Obviously, the economics, the cost in metro versus tier 2 cities is a win-win for both patients and hospitals. And if the patient is from the rural area, if the donor is from the rural area, going to an urban area, and that can ease the green channel creation and transplant logistics. In the Indian Transplant newsletter, in the year 2016, the new kid on the block is the tier 2 cities. Frequent donations have happened from cities such as Puducherry, Trichy, Madurai, Thanjavur, Pune, Aurangabad, Nashik, and so on, Indore, Calicut, Jaipur, Surat, and Vijayawada. So therefore, at this pace, we should soon reach an ODR of 1 per million population. Gujarat is, as I said, records 1/3 of the kidney swab transplants in India. And another news item that came out in 2025, August of 7th, was a Delhi child receiving a life-saving liver transplant in Kochi. So the expansion of organ donation footprint, the tier 2 cities joining organ donation bandwagon, that is Pune, Coimbatore, and Indore. And that shows that it is the transplants of liver and, more importantly, heart that has changed the face of cadaver organ donation and propelled the movement in the true sense. Now, this is the Indian Journal of Heart Transplantation. This paper came out of cost-benefit analysis of introducing organ transplant in the Ayushman Bharat Pradhan Mantri Jana Yog. This is the paper I went through in great detail, and I found there is nothing much in it. There is no extra finance for heart transplant or any other transplants. They've just included heart transplants into the Ayushman Bharat scheme. Now, there are various health scheme packages in India. In West Bengal, the max that they can give is 4.75 lakhs for any transplants. In the CGHS, there are 15 lakhs for heart, for lung 25 lakhs, and for heart and lung 35. This is a very good package the CGHS scheme gives, which I found in the internet. I was not aware of this before I started making this presentation. But in the Ayushman Bharat, which is the major inroad that scheme makes into various packages all over India, max you can get is 5 lakhs. And Telangana is 10.5 lakhs. But please, the surgeons from Tamil Nadu can tell me there is a Chief Minister Comprehensive Health Scheme that pays 14 lakhs. Is it true? 14 lakhs and 1 lakh rupees per year for medications. So this also proves why Tamil Nadu is ahead of other states. Apart from your initiative, but this financing model also helps. And I've done a bit of research and found that the average estimated cost to the hospital for a heart transplant is about 14 to 15 lakhs. So there are many cost components: donor workup, surgery, ICU, immunosuppression, transport, as well as the number of man days which are lost for a patient to go to urban regions and then go for a transplant. The American Journal of Transplantation, bold policy changes are needed to meet the need for an organ transplantation in India. And they said that the legal framework for donor consent, allocation, and reporting is an important thing. And there must be registries and uniform and streamlined approval processes. And there must be some incentives for rural and tier 2 or tier 3 city centers. And there must be subsidies for equipment and skill development. Regarding community engagement and public awareness systems, I think Indian Association of Cardiac Surgery must take up this outreach program, which we keep on discussing amongst ourselves, to increase the organ donation. And all doctors, transplant physicians, transplant surgeons must participate in this outreach program, in the television, in the social media, to increase the public awareness. And partnership, there are many hindrances that come from various local communities, religious groups, and NGOs. So we can partner with all kinds of people to increase the awareness in various groups. Now, the strategy map. Where are we? So initially, we have to identify in the roadmap thing is identify the capable regional hospitals, upgradation of the infrastructure and workforce training, approval of regulatory authorities and integration of network, and then awareness and campaigns and awareness campaigns and donor drives. And lately, after we start doing the transplants, we must monitor the outcomes and improvement quality. Now, the theme for Organ Donation 2025 is answering the call, the tribute to professionals in the field, and a call for increased collaboration. So in Mission Hospital, we have started doing kidney transplants, and this is the transplant team that we have. But we were successful. A couple of years back, during the COVID times, there was this little child who had had a road traffic accident, and we transferred this patient in a green corridor to Kolkata for various organ. We could do that. Before that time, we did not have a organ transplant permission. So conclude, the decentralization is the leap of faith that needs to be taken to save more lives. Success requires collaboration between hospitals, government, NGO, and commitment. And we must invest in the infrastructure, training and awareness, better organ utilization, better outcomes of transplant organs. And it is not, transplant should not be a privilege reserved for metropolitan areas. It is indeed a national responsibility. So organ transplant India, we have to think beyond the metros to get a better perspective. And thank you very much. This is my little granddaughter. Thank you very much.
We have got one more presentation. After that, we shall take questions.
Dr. Mondar to come for his lecture, Optimizing Challenges to Drug Therapy in Heart Failure in RF.
Good afternoon, everyone, respected chairpersons and all the dignitaries. And my topic is optimizing challenges. What are the challenges we face with the established therapies, that is GDMT, guideline-directed medical therapy. That means these four pillars, four assets of chronic heart failure with reduced ejection fraction. These are already established by different trials. And in last 20 years, there are so many optimistic positive trials that shows that these four groups of drugs, that is your ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors, these four pillars are really a disease-modifying agents like rheumatology, which can save life, which can prevent sudden death also, and limited the use of devices, rehospitalization, and quality of life. If you ask me how many CRT-P or CRT-D implanted by me between 2007 and 2014, the number was actually 376. But since 2014 till today, total number is 154 only. That means these drugs has changed the scenario too much. And there are some upliftment of therapy beyond these four pillars. These are, particularly specifically, these African American patients with advanced heart failure. And we are also in that group, black groups. We are also get benefited with hydrogen isosorbide dinitrate combination. This is an augmentation of therapy beyond these four pillars. Another augmentation of therapy is ivabradine. If the patient is still tachycardic, we can introduce, along with these four pillars, ivabradine as an addition. That will reduce the sinoatrial node activity, and they will reduces heart rate, increasing the myocardial performance by reducing their stress and strain, and this is substantiated by findings of SIP trial. The CHAMP registry data revealed that a significant proportion of outpatients are not prescribed with these drugs, and this utilization of this guideline-directed medical therapy, there is utilization rate in different registries. These are international registries, and I have taken all the continents. And this Swedish heart failure, Czech from Netherlands, CHAM from PSA, Asian, there is 11 countries from Asia are included. And also, ESC has taken data from their whole Europe. But highest utilization rate in India, Asian countries, if you see, there's particularly mineralocorticoid receptor antagonist use is not more than 60%. This is really a challenging thing. And this, why this utilization is so low? It can be due to physicians' inertia, that is therapeutic inertia, complex treatment strategies, varying interpretation of the guidelines by the non-cardiologist. Some of the drugs are really need some monitoring. Because if you are going to combine an ARNI and MRA, physician will think 3 times whether should I prescribe these 2 at a time at the upfront. Immediately, 2 at a time. They will be hesitant. That's why, and also some patient factor is also important, some social factors, some structural organization also. And there is also some discontinuation. There is a data from Evolution Heart Failure. This is a very aggressive trial performed in 2020 and 2022, which enrolled around 266,589 patients, initiating GDMT within 12 months of hospitalization for heart failure in Sweden, Japan, and US. And this initiation was in hospital, simultaneous or near simultaneous. These 2 words to be cleared. What is simultaneous? That means out of these 4, try to introduce all 4 at a time, just after stabilization. Near simultaneous means initiate SGLT2 inhibitors and mineralocorticoid antagonist. Both are bit antagonistic. Your SGLT2 inhibitor has got an effect of auto-titrate blood pressure. What is that? They will shift fluid from interstitium to your intravascular compartment. So your internal milieu will be in a balanced state that can combat hypotension more. That means hypotension may be auto-corrected with SGLT2 inhibitor, and it has got some diuretic effect also. And if you give mineralocorticoid antagonist, they will try to conserve potassium. SGLT2 inhibitor has got some diuretic effect, they will wash out potassium. Contradictory. So system will learn how to combat hyperkalemia, how to maintain volume. Orthostatic hypotension will be much less. So initiation of these 2 at first, and then you will go to introduce ARNI and beta blocker. That will be very helpful. And you can augment that therapy after a few weeks with isosorbide mononitrate and ivabradine if required. And if resistant, then you can think of some devices. This will be the protocol that was followed with Evolution Heart Failure study. But there was also discontinuation. At 1 year, 23% of dapagliflozin was discontinued, 26% of ARNI was discontinued, and 25% beta blocker and 2% of mineralocorticoid antagonist was discontinued. And this discontinuation was because of some minor problem only. So there are some, beyond medical barrier, there are some barrier which is hindering the use of this. That can be a social or socio-economic factor. Drugs are very costly. And it is mostly old, frail patients. They are not tolerating. They have some comorbidities that I will discuss one by one also. Subgroup of patients who are hypotensive. What to do? What I have told you. ARNI and beta blocker are the major culprit for hypotension. ARNI and beta blocker. But SGLT2 inhibitor and MRA has got blood pressure effect is minimal. So introduce, if the blood pressure is borderline, introduce just too fast, then go for the others. Negative inotropic of beta blocker is a significant obstacle to their use in patients with heart failure. But the Copernicus trial revealed that the beta blocker did not further reduce blood pressure in patients whose systolic blood pressure is below 90. because the body has got some rectifying effect on sympathetic nervous system. If you give beta blocker, blood pressure is 90, it will not go down too much. But the blood pressure is 160, if you give beta blocker, blood pressure will come down. Because the body's system is already in a tune where they tolerate beta blocker more. Chance of hypertension is not so much. And antihypertensive effects of MRA and SGLT2 is very minimal, require less discontinuation. That I have already discussed, that therapies can enable tolerance to other drugs. And patients with heart failure and renal dysfunction, that is an area where use of MRA, beta blocker, and your ARNI may be difficult. It is clear-cut that if the eGFR is less than 20, you have to restrict your use of your SGLT2 inhibitor. If it is less than 30, eGFR is less than 30, you have to restrict your use or discontinue your ARNI and MRA. But where should be the cutoff point? Suppose today's creatinine is 1.3, it has jumped up to 1.8. Should we discontinue or wait? That's the question. There may be a temporary decline with introduction of SGLT2 inhibitor and ARNI. The renal clearance may go down, but that will autocorrect. That decline may be temporary. You should wait and go on checking the parameters. These 4 drugs requires 4 particular evaluation. One is pulse rate, one is blood pressure, one is creatinine and creatinine clearance, and serum potassium. 4 assess, 4 bindings. That to be assessed initially every 4 days. If you go with this evolution heart failure protocol, every 4 days for 4 times, then you can exchange your timing, expand your timing. These 4 drugs needs these 4 parameters to be checked very diligently. And if there is a jump up of creatinine, at least if there is decline in eGFR more than 30%, then you have to hold your drug, otherwise no, wait. And this I have given here, if serum creatinine level increases to less than 30% of baseline value, ARNI can be continued. If the serum creatinine level exceeds more than 30% of the baseline level, the dose of ARNI should be promptly reduced or discontinued, and the cause should be identified, because there may be some renal vascular disease that to be evaluated either in the form of renal artery stenosis or some peripheral vascular disease impeding renal flow. If the serum creatinine level exceeds more than 50% of the baseline level, ARNI may not be reintroduced. That means this should be in mind. Patients with heart failure and electrolyte imbalance, a secondary analysis of IMPARA reduced revealed that the combination of MRA and SGLT2 improves patient symptoms and health status, and significantly reduce the cardiovascular mortality also. And their introduction will reduce the risk of hyperkalemia and slow the progression of kidney disease and reduce the probability of MRA discontinuation. And if there is an emergency, particularly if you have already given MRA and SGLT2 inhibitor and the patient landed up with an acute hyperkalemia, your conventional drugs may not work. That to be kept in mind in this era. I have written this slide because this drug is coming up in the market. In some pharmacy, especially in some hospital, they are keeping this sodium zirconium cyclosilicate, SZC. A novel selective cation exchanger immediately decreases potassium level by approximately 1 milliequivalent per liter in patients with heart failure and hyperkalemia. Because most of the time, the combination of MRA and ARNI can create a hyperkalemia which may not be there 48 hours before. It can be very acute. and response to your sodium calcium gluconate or dextrose insulin to reduce the potassium level acutely may not work. And patients with heart failure and atrial fibrillation, here, the last line, all these three trials, CASTLE-AF, CABANA and AATSC-AF study, all shows if the patient goes into atrial fibrillation with heart failure, try and evaluate and try to do a 3D ablation of to isolate the pulmonary vein. Because the prognosis of this combination of these two, heart failure plus atrial fibrillation, is a trajectory and invite death. Residual congestion, you are waiting to decongest the patient. Don't wait too much. If the symptomatically patient is on class 2, after hospitalization or ambulatory class 3, try to introduce the SGLT2 inhibitors, MRA, followed by your beta blocker and ARNI. Because residual congestion will be taken care of by these drugs only. Because this heart failure patient without significant fluid overload, optimizing GDMT could lead to additional decongestion without requiring higher doses of diuretics. Because if you go on giving higher doses of diuretics, that will jumble up the situation and introduction will be very late. Another area is the COPD. There is a dubious data that beta blocker is absolutely not indicated in COPD patients. This block COPD trial was the culprit to give that notion that there is too much of discourage of use of beta blocker. But the cardioselective beta blockers like bisoprolol, nebivolol, and in some cases metoprolol also can be initiated with this. And beta blocker titration can be given with this. And another thing is the physician's understanding of this drug, what I have told you, that is very important. And post this discharge, and particularly old age patients where the use of these drugs need particular cautions, because there are so many cofactors like frail patients. There may be cardiac and skeletal myopathy because there may be sarcopenic. Their body mass is much, cardiac muscle mass and skeletal muscle mass is much low. And they have sarcopenic obesity may be there. That will jumble up the situation more. And this post-hospital syndrome in old age, they goes into depression, a denial state, and drug adherence is very poor. So they need a social care and social help to have this. So heart failure clinic, to combat the combination of in-house treatment to transit those treatment to an outpatient's home-based treatment, it needs some careful area that can be solved by this heart failure clinic in a hospital, where a specific dietitian, a nursing staff, and a doctor can combine their therapies and counsel the patients and about the disease, about the lifestyle. Regarding remote monitoring, that is in the infant stage, I will say, and this is the compact slide, where is the problem and how we can tackle that. And socio-economic factor, particularly economy to be judged. Economy to be judged before prescribing these costly drugs. And devices, what we are using regarding this digital telehealth. Telehealth has got three components. One is your remote monitoring with devices. That can be a CRTP, ICD, or you have implanted sub-devices. Or it can be telemedicines, just on phone call you are advising some medicines. Or it could be a teleconsultation. Out of these three, for heart failure patient till now, teleconsultation is the best. Patient is at home, some physician is attending him, and you are at this end as a specialist, there should be a teleconsultation. Not only your device, patient, device, and local treating doctor with a referral doctor. This teleconsultation out of these three telehealth component, this is most valuable, because there is a dubious data. TIMI heart failure trial shows, yes, it is a good. But beat heart failure and OSICAT trial shows no benefit of this telemonitoring or telehealth. So potential strategies to implementation of diverse and include patient-tailored medication management, including economy, better structured follow-up. We should not see those patients who are old with heart failure like a young patients of post-PDCA patient, we are giving 2 minutes time, but this patients needs a better structured follow-up, and their transitional care protocol should be addressed in a generous way, and physician and patient awareness, including our general physician, home physician, family physician should be trained to look after these patients. Thank you.
Thank you very much for the lecture. Wonderful. Now, for want of time, we will go on to the next topic.
Okay. Thank you, sir.
We'll invite Rituparna Barua to talk on the patient-centric measure of heart failure management.
At the outset, I am very grateful to this Heart Failure and the Organ Transplantation Society, and also the Novartis for allowing me for this talk. And the previous speaker actually made my lecture very easy because he highlighted all the fundamental therapies and the potential collateral issues that could be highlighted while treating a heart failure patients. And it is very prudent to explain that all the clinical trials that actually highlighting the statistical parameters in the terms of the primary events rates are mostly dependent on the heart failure hospitalization and the mortality. And these two parameters are actually easy to define, and various devices have been investigated and various tools has been found out that how to calculate the hazard ratios and the clinical benefit in the context of the net clinical outcomes in any randomized control trial or any registry data. But the most important focus that being diverted, looking into this hard evidence in the clinical trials, at what is the outcome, what is the clinical presentation of the patient, how the patient feels while treating the heart failure patient, what is the socioeconomic status and the socioeconomic differences or the alteration in the clinical practice of this patient. And while treating this patient, sometimes it's very difficult, and sometimes we actually ignore the symptoms of the patient and what is the cognitive impairment this patient having in the clinical practices. That's why it's very important that a different sort of metric can be used in the clinical trials, like the home time. So the home time actually analyzes the time the patient remains alive, and also in the out of the hospital or out of this any clinical or any hospitalized situations where the patient remains stable, where the patient is clinically stable, and functionally the patient is capable to do the usual routine activities in day-to-day life. So these are actually the mortality and the hospital admission are basically the most important parameters we use while treating patient and particularly while conducting different trials. While mortality and the readmission rates have been widely studied in the context of the heart failure outcome, these clinical endpoints may not be fully account for the overall patient experience. So that is very important that certain parameters should be used to know the functional capacity of the patient, and the home time actually better reflects the patient experience. It accounts for the total number of hospitalization as well as also duration of its hospitalization, because we know once the duration of every hospitalization increases, the time span of hospitalization increases, the mortality and the next event rate also increases. So several factors make this patient-centered outcome measure highly relevant, and it also incorporates mortality and the morbidity that related to the treating patient. The success of the heart failure treatment is basically measured by the length of the home time. So once the home time of a particular individual under the treatment of the heart failure fundamental therapies increases, so it means that the functional capacity of the patient is improving and the patient remains alive in a functionally active condition is quite meaningful, and that might actually have a very good impact in the clinical arm or clinical situation while treating patients. So every physician must know about this metric, and is very useful. Actually, it is the surrogate for the functional capacity of the patient. So this interpretation of these different trials actually based on majority of the hard points like the mortality data or morbidity data or the rate of rehospitalization particularly. So I think that these different trials should include this, the home time could be an important metric to be included in this randomized control trial. But it is seen that the home time is underutilized in the clinical practice despite being very important measure or very important metric in the clinical practices. It is also needed to prioritize the home time in heart failure care, because we have seen that in the post-discharge period, 10% of the patient actually had no home time, and the 29% of the patient actually spent less than 50% of their time at home. And that means that there is a substantial portion of the patient still experiencing lower quality of the functional capacity, and that should be improved. And as we know that we have at least basic 4 fundamental therapies in the chronic heart failure patients that could be adequately utilized in each and every individuals, and finally to get a very good outcome. So impact of each hospitalization. Once the patient is going through the heart failure treatment, each hospitalization following a worsening phase of the heart failure increases the requirement of the another hospitalization, and that actually add to the mortality in every individual suffering from chronic heart failure treatment. So in our clinical practice, can you step ahead and then can you think and that what is your clinical experience? How many heart failure reduced ejection fraction HFrEF patients are actually readmitted in a year in your practices? So I have seen quite a big number of patients, substantial portion of the patient actually experiencing worsening of heart failure within 1 year. And the clinical impact of this heart failure hospitalization, particularly the readmission, is significantly bad and worse in terms of the mortality. So once the number of rehospitalization increases in an individual patient suffering from chronic heart failure, particularly the HFrEF patients, so there is a significant proportion of the patient may suffer from mortality in the next few years. And this repeated hospitalization definitely had a very bad impact in terms of the quality of the life. So this is very concerning figure that 32.4% of the heart failure patient experience more than 5-point worsening of the KCCQ. So what is KCCQ? This is basically a very important tool to analyze the functional capacity of the patient. It includes socio-economic differences. It also includes the workload that particular individual can take up during the routine daily activities, and also it includes the most important functional capacity in day-to-day life, and also the cognitive impairment that patient can suffer during the heart failure treatment or worsening heart failure phases. Also included in this is conscious CT, conscious cardiomyopathy, this score system. And there are actually two different versions of KCCQ score. One is the 23, that means 23 questions were asked to the patient and to find out the functional capacity of the patient. And there is a shortened version that is KCCQ 12. Both are similarly useful in the clinical practice while treating the heart failure patient. And this actually could be assessed at 1 month, 6 months, and 12 months period at least to find out the functional capacity, the socio-economic condition of the patient, and also the cognitive function of the patient, and also the amount of workload that particular individual can take up in the daily activities, whether he'll be able to do at least some basic physical activities in the form of bathing or talking or discussing with the other peer group, or whether he's able to do some gardening activities. So it actually could be interpreted in the form of the metabolic equivalence. So do we know that the metabolic equivalents are actually for to understand the workload that particular individual can take up. So if this metabolic equivalence is less than 4, that this functional capacity of that particular individual is extremely poor. And if it is between 4 to 6, so it is the intermediate range. And if it is at least able to do or take up at least more than 6 metabolic equivalence workload, that particular individual is considered to be functionally active, despite this patient is having chronic heart failure symptoms. So the composite outcome of the mortality or heart failure hospitalization was inversely related to this particular score. And if actually it is based on 0 to 100 score, maximum score may be more than 100, and the minimum or score could be 0. And if there is more than 5 numbers increase from the baseline, so it means that this patient is improving at least to a mild form. And if some minimal improvement of the clinical scoring system could be seen if the patient KCCQ score increased more than 5, and if the difference from the baseline following the medical therapy or the fundamental therapies of the heart failure, if it is increases by more than 25 to 49, so it is considered to be at least intermediate improvement of that particular score. And if it is more than 50, so it is significant improvement. If it is more than 75, so definitely this patient having very good clinical outcome in terms of improving the clinical status or functional capacity if the score is more than 75 increase from the baseline. So it definitely impact on the survival, this particular home time. So it could be a new metric, it could be a new thing for us or for the clinicians to measure, and it is mostly related to the improvement in the conscious cardiomyopathy scoring system, and that is how we can interpret the usefulness of this home time monitoring in each and every patient we are treating with fundamental heart failure therapies. So this actually drives us, every individual, to find out a particular easy scoring system or easy metric to know that how actually the physician is following up that individuals under treatment for heart failure. That could be easier for us to analyze the symptoms of the patient. And finally, I want to speak in this particular slide because most of these fundamental therapies that the previous speaker explained, that these 4 fundamental therapies, so the robust clinical benefit is actually shown by the sacubitril valsartan combinations. And it actually improves the quality of the life that is interpreted by increase in the difference of the baseline and the baseline value of KCCQ, and after the treatment, how it changes, and different domestic activities, and the peak oxygen consumption also improve, and the 6-minute walking test. This could be a very simple clinical metrics that we can use in our daily day-to-day life while treating the heart failure patients. So this is one important trial I want to highlight, why this trial being conducted. So the Prove Heart Failure trial being conducted to find out some of the unanswered questions that was not highlighted in Paradigm Heart Failure trial. So you know the Paradigm Heart Failure trial is the most important landmark randomized control trial showing the robust benefit of the sacubitril valsartan in the clinical practice, how it actually changes our clinical practice. That is why it is a paradigm shift of heart failure management while using this sacubitril valsartan molecule. There is a significant, more than 35 to 40% difference in the mortality, and more importantly, there is a significant and substantial reduction of the heart failure readmission rate. So, but this trial actually telling us that each and every patient, I mean the paradigm heart failure, how actually this particular trial guiding us to treat RAF patients, heart failure with reduced ejection fraction patient. So basically this trial telling us that each and every patient, we should try to build up the dose, maximum tolerable dose of this sacubitril valsartan to 200 mg twice daily. But in how many of you in your clinical practice observe that what is the percentage of the people actually can achieve this target dose of 200 in paradigm heart failure, very less. Maybe it is 15% of the patient in my practice. But research show whether the lower dose of the sacubitril valsartan, like 50 mg, if we can twice daily dose, and the gradually build up dose, having some benefit in terms of reversal of the remodeling that happens in the chronic heart failure patient, whether it actually improves the ejection fraction, or whether it actually changes the functional capacity scoring, Kansas City cardiomyopathy scoring system to a significant numbers, like more than 50 from the baseline, or actually it changes in the different remodeling index of the heart, like the left ventricular end-diastolic or end-systolic volume, or left atrial volume index. So these patients were categorized according to the average doses received over the duration of the trial. And it was found that the patient who received the highest dose were actually younger, because in your clinical practice you can observe that only the younger people, previously having hypertensions, less of comorbidities, and with better kidney function, can tolerate the higher dose of sacubitril valsartan compared to those frail patient or elderly patient, previous blood pressure was in the lower range. They actually do not tolerate, and they develop much of the adverse effect of this molecule. That's why it was difficult to escalate the dose of these molecules in these elderly, frail people with multiple comorbidities. And this is the time when the patient develop heart failure with reduced ejection fraction. More than 60%, majority of the patient in our clinical practice who presenting with HFrEF will have of this type of clinical scenarios like frail and the elderly. And we also assessed association between the different sacubitril valsartan dose in different tertiles and the mechanistic measures, and determined that regardless of dose category, relative improvement is observed in terms of biomarkers like N-terminal pro-BNP, and it was seen across all. It means that even if we this particular patient only achieving smaller dose like 50 mg twice daily dose, still they get the benefit. They do have the clinical benefit. They do have the changes in the echocardiographic parameter in a better way, and there's a reverse remodeling happens even if the smaller dose of these molecules. So that is why it is very important to start this molecule early, following the heart failure diagnosis, or any phase following the worsening function of the heart failure, like worsening heart failure. So it is observed that the ejection fraction, the N-terminal pro-BNP, and the different volume index of this patient, HFrEF patient, improve even in lower dose like 50 mg twice daily dose of this patient. So to conclude my lecture, this home time is defined as time spent by the patient alive and out of any healthcare institutions, and it represents a novel trial endpoint that should be used in our clinical practice, and it can help us to find out the heart failure management, the outcome particularly, and the heart failure therapy that reduces hospitalization, it lowers mortality, that is well established by sacubitril valsartan, also with other fundamental therapies. And the sacubitril valsartan has proven benefit, and also it improved the ejection fraction, particularly in the HFrEF patients. Thank you for your attention.
Thank you very much. I think this concept of home time is excellent parameter, but unfortunately we cannot quantify that patients to patient. So in clinical practice and research, that's going to be a shortfall for this home time. It's a very abstract concept, excellent concept, very, very useful in our outpatient clinic.
Actually, if the home time is connected to the Kansas City scoring system, it could be a more implicable in the clinical practice.
I mean, it needs a very objective assessment.
Yes.
This is one thing.
Actually,
second, no, I just do not interfere the chair. Okay, the chair is speaking. So I think one of these, this brings to our very basic questions. Like we are talking about very advanced medicine, advanced surgery, cutting edge technology. But we know that whether in all our hospitals and our outpatients, all the blood pressure equipments, measuring equipments works universally, equally, we do not. we always take a reference from guideline from American Heart Association or every European Heart Association. Are Europeans and Americans and average Indians the same?
Is there definitely difference
Yeah, we
in
are
certain
different.
aspects? Yeah.
So I think when we come to this scientific conferences and present our paper and our ideas, there has to be a very gray area, because from the sources we are deriving our data is faulty. All the guidelines are, because we have not got an Indian guidelines. So that is what all the speakers, all the scientists, all the researchers, all the clinicians, all the professors, I would urge that please get a guidelines from India.
Yes, our diversity.
Epidemiological or clinical or research outcome. It has to be an Indian guidelines.
Yeah, our diversity sometimes could be limitations
So
in terms of language and
there you
social
are.
culture.
Well, now the whole, I think it's opening to a couple of questions of the whole session. Anybody can ask questions from the first paper?
I think PC Mondal sir, please,
Okay.
What sir was telling, that this your home time is an abstract thinking. It is not an abstract thinking, sir. It is after telehealth introduction this concept has came. Whether the patient is alive and what is his functional status, that will be measured in this home time. And that home time can be measured, not that that patient should come to the hospital. It can be judged by your telemedicine. That's why after telehealth introduction, this concept has came. It is not an abstract thinking. It is fully real, sir.
Only thing is this problem is in implementation. That is what I am trying to
Actually,
say.
There may be shortcomings, but telemedicine in this 2025 is not an abstract.
Actually, it is
different thing altogether.
Actually, it is home.
Connect to our remote districts also in Purulia, Minnapur, Jharkhand. We can connect there. So
telemedicine is not future anymore. It's current. Currently, in my hospital, most of the doctors are using it.
That's why this home time is also coming after that concept. Home time can be judged by this telehealth.
Any other questions on the whole session? If not, we're just going to move into the next one.
Thank you. Thank you.
Yeah. Yes, my co-chair are requesting me to close the session. So thank you, gentlemen, for your presentation and for your cooperation.
Thank you everyone for the previous session. Now we are going to start the session on heart transplant. I would like to request the chairpersons to please come up on stage. Dr. Anvay Mule, Dr. Chandan Mondal, Dr. Shubroto De, Dr. Shondip Sardar, and Dr. Shuja Chatterjee.
We will start the session. I request Dr. K.R. Balakrishnan for global current status of the heart transplant.
Thank you. I think Dr. Shivadasan covered the global status in extensive detail. So I shall speak about the current status in this country because it's got its own peculiar challenges, and I think we need to be aware of that, and despite which, what kind of results are possible. We've had a lot of discussion. There's been a steady increasing the organ donation rate, and I think close to 200 plus transplants are done every year. One of the biggest challenges is to manage, not only to get patients for a transplant, to manage them, keep them alive till you find a donor organ. And that's a challenge despite, at least in our setup, the average waiting time is not more than 2 months. We were the first to start using ECMO. I think this is the first patient bridged to transplant with an ECMO in this country way back in 2012. She had a cardiac arrest, was bridged with ECMO and survived. 5 years later, she was skiing in Gulmarg. We've used ECMO extensively even in pediatric patients. This man had 2 runs of ECMO, once with femoral cannulation, which got avulse and central cannulation. We got a donor heart which looked like that, which is refused by 9 units, and eventually we transplanted him, and he did well. He came back after 5 years because he had skipped tacrolimus due to not taking even water during Ramadan and had rejection, and fortunately got treated with that. There's been a lot of discussion on DCD donation and suboptimal donors. This man, this young boy, was an ECMO after a cardiac arrest. The echo on the left is his basic ventricular function. He was decerebrating for 2 days and woke up. We got a donor heart which had significant ventricular dysfunction. And so despite which we accepted it. And he did well for 2 weeks and was shifted to the room, and then he developed new onset RV dysfunction with a free TR. He took him to the cath lab thinking it could be rejection. It turned out to be a donor-derived triple vessel disease. I think one of the previous speakers in a session spoke about, Julius, I think, about the impossibility of getting angiograms. This is a young donor of 32 had triple vessel disease, so this boy had 2 stents. His RV function completely recovered, and he came back after 1 year and required a restenting. He's alive and well 7 years later. The youngest VAD we have used as a bridge to transplant is 4-year-old child. Suboptimal donor is very common because we don't have affordable VADs. And so the reasons for suboptimal donors are well known. This child actually was flown into us from Bulgaria last year for a possible Berlin heart. She had a cardiac arrest twice, once over Karachi airspace and had to be landed and massaged, and then once as she reached the hospital. She was put on ECMO, and then we got a donor heart from Wadia Children's Hospital in Bombay. The heart was not usable for regular patients, so we accepted it. This child had an open chest ECMO for 10 days and completely recovered and is doing well. We also used ECMO for significant PVR because this patient can't afford a VAD. This patient was in support for the right ventricle for 22 days, following which he completely recovered. So the big challenge we had to overcome was transportation, and this is the number of centers in Tamil Nadu where donor organs are available. Now virtually every district hospital has an organ donation, and every government medical college. It's one thing to have an organ, it's another thing altogether to transport these organs, because there's no airline available, we don't have often time. Most of these places don't have a commercial aircraft flying. And to drive from close to Trivandrum to Chennai is actually 12 hours with bad roads and bad monsoon. So Chennai, we were the first to start this concept of green corridor. And we have done the maximum number of airlifts for commercial heart transplant in the whole world, close to 400 using commercial airlines. As you can see, progressively the ischemic time has increased, the average ischemic time from the time we started. It's also a testimony to our increasing confidence in accepting younger hearts with good ventricular function. And the highest maximum ischemic times have been in excess of 8 hours. And we actually compared the outcomes of transport by road, by commercial flight and chartered flight. And there's a process of how you take an organ with a chartered flight. The longest, we often get an organ from PGI Chandigarh. Very often we have to change the aircraft from Delhi from T1 to T3. And quite often the ischemic times are in excess of 8 hours for these kind of patients, but they are young donors. When we compare the outcomes in terms of ischemic time, age and donor age and hospital mortality, there's no difference in survival. This was actually presented and published in the recent ISHLT in Boston. We are now developing an organ care system with the Indian Institute of Science in Bangalore. This is a pig heart. It's been supported for almost 10 hours with intermittent cold perfusion. And after 10 hours of ischemic support, the heart is beating vigorously. This is undergoing animal trials in PSG Institute in Coimbatore. Hopefully we should have it commercially available next year. So as of last year, we had done over 500 transplants. This is more now. So we analyzed the last 490 of them. The youngest was 4 months old. The oldest was 81. 1/3 of the patients were Intermax category 1 or 2. And the 90-day survival is around 85%. It might be higher as compared to the United States data, but as I said, a lot of these patients are very sick and we don't have a VAD as a bridge out, so they all got transplanted. The factors affecting 90-day mortality when you put a forest plot, the most important are poor renal function and low Intermax category. So when you compare Intermax 1 and 2 versus the higher Intermax category, the difference is mortality is striking 3 times more. And even in Intermax 1, these are patients who had a pre-op cardiac arrest, they had massage and put on ECMO. Out of the 51 patients in this series, roughly half survived. So I would not look at it as 50% mortality, I would look at it as 50% salvage rate. Effect of poor renal function is very considerable. I think Julia spoke about lack of consensus on combined organ allocation in this country. So creatinine more than 1.5 carries a 3 times higher mortality as compared to normal. What are the 10-year survival? When we first started, we had no data even from the kidney or the liver guys as to what is the realistic survival in this country with unclean water, unclean air. Who knows who survives for 10 years. But fortunately, by the time this program started, thanks to Reliance and Jio, we had widespread net availability at a very, very cheap rate. Everyone had a smartphone. So our follow-up of transplants is much better than CABG. So we really know what is happening, and no matter when they die, they actually contact you to tell you what's happened. So our 12-year survival now is close to 60 plus, which compares very favorably with ISHL, and this was actually quite surprising to us as well. Patients younger than the age of 18 have a survival which is better at 74%, and conditional on 1 year survival for the whole group is 77%. And if it's more than 18, it's 73, but if it's less than 18, it's better. If they survive 1 year, 90% of them actually are expected to be alive beyond 10 years. And if they're young, less than 40, it's significantly better. If you have creatinine less than 1.5 and you're more than Intermax 1 and have not arrested, more than 3/4 are alive at 10 years. And even between Intermax 1 and 2, the difference is substantial. So it'll be nice if these patients are referred to before they are in ECMO or cardiac arrest. Even on patients who are on ECMO after a cardiac arrest, 10-year survival actually is 50%. So I look at it as half of them can be salvaged. So when you look at the hazard ratio or Cox regression for 10-year survival, what is striking is poor renal function and low arterial elastance or very high right atrial pressures. This was published in the Journal of Heart Transplant. The low mean perfusion pressure index to body surface area as a determinant of poor function. We've had several publications in this, and here you can see the difference in survival between preserved renal function and a deranged renal function. All these patients were accepted on the basis of an ultrasound which showed a normal kidney size and not shrunken. The eGFR was less than 70 ml in them, with a median value of 37. The difference in survival is striking, and if you subcategorize them, why would some patients survive despite such low? So if your BSA is more than 1.8 and your age is more than 50, you don't survive very well. So this could be actually the starting point of a discussion with NOTO and our state groups, and at least for this category of patients, if the association such as ours puts in strong recommendation, maybe we can have better allocation for combined heart and kidney in this country, which is crucial in my opinion. This is published in the Journal of Heart Lung Transplant. We also looked at what makes the RV function worse in patients with LV dysfunction. We analyzed the effect of pulmonary vascular resistance, pulmonary arterial elastance, and LA pressure. The most important was pulmonary arterial elastance, which captures both resistive and pulsatile load, which is calculated as pulmonary arterial systolic pressure by stroke volume. And on this basis, we hypothesized if that pulmonary arterial elastance being high leads to poor RV function and high RA pressure. And low arterial elastance has an effect on, so the ratio between PEA and SCA should have an effect. And when we charted mean perfusion pressure was pulmonary to systemic elastance ratio, the inverse relationship is striking. And the outcomes of patients with PASCA more than 0.5 is actually very worse. And this was published in the Journal of Heart Lung Transplant last year. We also have had some experience in long-term use of IABP, especially during COVID times when there's no organ available. So we had a series of 11 patients. The longest supported on an intra-aortic balloon pump was 9 months or 10 months, which is very long for an IABP supported in heart failure. And we looked at the reason why some patients, despite being maximal inotropes, respond to a balloon pump, and we did a mathematical modeling of, we found that in the presence of intra-aortic balloon pump, in select patients, the renal artery perfusion pressure, renal artery flow, and the gastric flow and the cerebral flow increases, and this was presented in the American Association of Artificial Organs meeting in Chicago last year. Rejection, we have 15% as the rejection. We do a biopsy in every patient before discharge, roughly 2 weeks after the transplant. Around 15% of them have some histological evidence of rejection, though mortality is not common. But late follow-up rejections are increasingly seen. The most fatal or most dangerous is antibody-mediated rejection. This girl, 9 years after transplant, presented to Holy Family Hospital in Bombay, cardiac arrest, resuscitated on ECMO, was airlifted to our hospital with barely contractile ventricle. We had to decide whether to retransplant. Biopsy showed antibody-mediated rejection. She was treated on rituximab and plasmapheresis and made a dramatic recovery, full recovery of ventricular function. She's doing well 2 years later. The functional outcomes have been excellent. This man shifted from Lilavati Hospital in Bombay in acute renal failure on BiAPP. He's the CEO of a 2,000 crore company 5 years later. This young man from Calcutta actually finished first in a half marathon 5 years post-transplant. This girl to my left is actually 1 year after being on ECMO and transplant, is in mountains of Munnar looking for mountain goat. He can be back to playing tennis, and this young boy was playing tennis for his state team, soccer. And this 78-year-old man, 1 year after transplant, is playing tennis in the Bisnagar club. So in conclusion, preserved renal function is crucial for excellent long-term results. And even in a resource-constrained environment like our country, good long-term results comparable to ISHH standards are possible. Thank you.
Any questions to the floor? I think at the end we will see if there is any question.
Next speaker is Dr. Minal. This topic is optimization of marginal donors. Dr. Das, please.
Good evening. At the outset, I thank the Society for giving me the opportunity to speak over here. My topic is optimization of marginal donor, and you have just recently seen by a lot of videos shown by Dr. Balakrishnan how marginal donors can be utilized. So I'll just go a little bit into depth of it. So normally about 50,000 patients are listed for cardiac transplantation, and out of which probably 5,000 make it. And the main reason is the shortage of the organ. And two reasons for shortage of the organ is either the donors are not counseled properly and the organs are wasted, or there may be a donor defect where the donors are found to be not suitable for transplantation and they are rejected. So these are the marginal donors, some of them marginal donor, and some of them can be rescued by optimal managements. The main reason abroad for rejecting donors is, one of the main reasons is Medicare assisted hospitals, where if the result falls below the established values, probably Medicare will not sanction them. So they are scared to use marginal donors, as well as some centers, particularly low volume centers, has a current state of excessive risk aversion, and that is why marginal donors are not used. These are the few reasons. So choosing a gift for your near and dear one is difficult from this overproduction of world.
but choosing a perfect heart for your patient whom you have been caring for quite some time is even more difficult in the midst of donor-recipient mismatch, and at the same time there are time constraints, there are expectations, hope, frustrations, and at the end we have to make a lot of compromise and concessions, and finally we have to take something which is left behind is the marginal heart. The question is whether the marginal heart is good or not. So let us take a deep dive into that. So in general, age is important factor, less than 45 and above we call it as marginal donor. Reduced ejection fractions, 45% or less. Left ventricular hypertrophy, posterior wall thickness more than 14 millimeter. Coronary artery lesions and significant valvular heart disease are the areas where we try to avoid these hearts. But if we look more carefully, there are a lot of other reasons where we exclude the heart and where we can work more to salvage those hearts, like virology status of the patient. Sometimes intracranial hemorrhage and penetrating head injuries are rejected. Sometimes donors are not properly managed and when they are initially informed to the centers, and sometimes non-beating heart, that is DCD donations, are normally considered as marginal donors. So if we look at the timeline criteria, till 1985 we have been using the regular donations, and then 1990 onwards we started extending the criteria. First the age criteria was relaxed, and subsequently size mismatched. Some of the valvular regurgitations were started accepting. In between there was a preparation for an alternate list where the recipients who were not suitable, they were put into the alternate list and given marginal donor, and 2000 onwards we have relaxed the donations and started accepting all these kinds of marginal donors. So this is how the donor pool is getting extended. So as we get into the optimization of standard donor, first we need to optimize the standard donor in terms of optimizing the CVP, the pH, and hematocrit, and then see that exclude all structural abnormality and see whether the ejection fraction is good or not. If the ejection fraction is not good, then hormonal management, and subsequently if required PA catheter has to be put and cardiac index has to be measured, and if those are not suitable, then probably these are the group of heart probably could be rejected. So left ventricular function optimization, most of the time severe after severe brain damage, there is catecholamine storm and there is reduction of the left ventricular ejection fraction, but however, they recover. Cardiomyopathy and coronary artery disease has to be ruled out, and recent UNOS data has showed that even if the ejection fraction is low and all the structural abnormality has been excluded, these hearts do better over the period of time, and results at 3 years are not bad. Another way to rescue this heart is to do a pharmacological test and do a low dose of dobutamine or dipyridinol test. In this, we can differentiate whether these hearts are reversible or not. There are 3 types of responses. Either it is reversible, or necrotic segments do not show improvement, or sometimes new onset wall motion abnormality appear where we suspect the coronary artery disease. Donor's age has a very important relevance in marginal donor. As the age increases, the mortality also increases in general. ACC guideline shows less than 45 years is the optimum donor. Beyond that, we consider as marginal donor. But normally about 18 to 34 years age of group of donors are nowadays accepted. If we look into evolution of older hearts, we have seen already that beyond 40 years and beyond 50 years, there are equivalent surveillance, and there are many reports of that. and particularly if somebody is waiting in the waiting list for a long time, their older donor mortality risk outweighs by the wait list mortality. And particularly in a bad cases where there is emergency, the patients are sitting on VADs or ECMO, there you probably relax it. And as Dr. Balakrishnan has shown so many videos where the heart recovers later on. The current advisory is that older donors are better selected for critically ill patients, and patients who are stable, probably it is better not to use older donor for them. Optimum use of older donor, we should be having a CMB negative probably, and they should have normal echocardiogram, short ischemic time, and at the same time, lesser transpulmonary gradient in the recipient. So these are the areas where we need to look into before using the older donors. Donor size mismatch is very important. Current obesity is an important factor for the recipients. So previously we used to take the weight as a criteria, but now it predicted heart mass measurements, donor recipient ratio is very important because it takes four things into measurements like age, sex, body weight and height. So that gives a better measurements. And it has been shown that in 2007 to 2016 UNOS data that 32% of the donor which has been declined as calling as a small heart could have been used if we would have used this predicted heart mass study. Left ventricular hypertrophy, probably up to 13 millimeter of posterior thickness can be used if the donor is young and ischemic time is less. Coming to repairable heart, some of the valvular lesions can be repaired. CABG, particularly those who are single vessel disease, can be repaired either before or after surgery. And presence of LSVC is important. If the right SVC is big enough, then we can always close the left SVC. But if the right SVC is small, then we have to do a biatrial technique. And if LSVC is running into coronary sinus, we have to make sure that there is no unroofing of coronary sinus because that can cause significant right to left shunt. Donor with coronary artery disease can be used with minor irregularities or myocardial breach can be used. However, the donor with single vessel disease, 2B classifications. Recommendation regarding cardiopulmonary arrest, up to 30 minutes we can accept, but beyond 30 minutes also can be accepted, particularly if the echocardiographic function and hemodynamics are favorable. Opioid overdose is a very large section of people get into the hospital and dies because of opioid overdose, and this group of patients can be included in the donor list. They have a major problem of hypertension, infective endocarditis and coronary artery disease and coronary dissections. So if these things are excluded, they can be included. HCV positive patients were initially not included in the not been transplanted, but nowadays the treatment for HCV is quite good, and with the latest drugs available, within 12 weeks of transplantation they can be made negative, and nowadays more and more HCV positive donors are being used to increase the donor pool. Bacteremia and donor in certain cases, in desperate cases can be used. Proper antibiotic has to be given. Unusual death in younger patients. Sometimes we get this one and they are brain dead. But here, the more important thing that coronary artery disease, abnormal coronary artery pattern, particularly right coronary arising from left sinuses and interarterial courses, that is the commonest cause of the sudden death in young. So these things has to be excluded before they have been taken as a donor. Various neurological tumor, these are the neurological tumor which can be included, and these are the neurological tumors where donor cannot be taken, donation cannot be taken. Pediatric heart transplant shortage is more an issue here. They tolerate marginal donor better. Smaller heart is a risk factor, female donor, and ischemic time more than 6 hours is tolerable. ABO incompatibility is permitted in pediatric heart transplant. However, they do badly compared to ABO compatible donor. Impact of ischemia is very important. Important part in the donations. As the age increases, the odd ratio for mortality also increases. So we do so many things to reduce the ischemic times. We try to harvest local hearts. Green corridors are made. Private jets are used, reducing warm ischemia time, particularly releasing the cross clamp after doing LA and aortic anastomosis. This is how we do it. But currently we are using cold static preservations where directly heart is put inside the saline, inside the preservative, and then ice around it. But there are modern mechanism which has already been discussed quite a lot, that is cold static technology, hypothermic machine perfusion and normothermic machine perfusions can increase the ischemic time, and therefore some of the donors which are more than 4 hours after harvesting can be used, and that's how we can optimize the marginal donor. Sherpa pack has already been discussed. Here we can keep the heart at 4 to 8 degrees centigrade, better preservations, and this is how the temperature is maintained. And this is Guardian registry where a lot of patients has been included, and they have shown compared to cold static preservation that 51% reduction in PGD and good results, and 1 year mortality is same or rather better, and less use of ECMO and VAD. So at 3 hours, if there is a 10% chance of PGD in Sherpa pack, that the same thing, 10% chance of PGD at 6 hours. So this is how the ischemic time can be extended, and the transport also is possible. There is a report where donor heart has been transported from Alaska to Boston, and there was no evidence of PGD after 447 minutes of ischemic time. This is hypothermic machine perfusions, the latest one which has been discussed by Dr. Clark in his presentations. So here preservation can be done up to 8 hours, and then organ care system which has also been extensively discussed. So in organ care system we can reduce the cold ischemic time and shortens the long distance transport is possible, and organ can be inspected well. So there are 2 trials actually. PROCEED trial is non-inferior trial where it shows it is non-inferior, and then they jumped into EXPAND trial, and where a lot of marginal donors has been included in this trial. If you look at the right side of the study, all the marginal donors are used in the EXPAND trial and compare with the cold static trial, and the results were no worse than the usual cold static preservation. So that is how the EXPAND trial and more cases are being excluded in the EXPAND trial. If you see out of 173 marginal donors, 150 donors were used in this trial. So there is good utilization of marginal donors, and those who had less lactate level, increased lactate level were rejected. That's only about 13%. So DCD transplantation has already been discussed. I am not going into much details about it. So challenges of DCD, there are two ways of doing it, either direct recovery or through normothermic perfusions. And normothermic perfusion preserves the other organs as well, but it is more cumbersome and has got a lot of legal implications, where direct procurement is easier, and here we can put the patient organ on a organ care system where cardiac function could be assessed and transplanted. So more and more DCD hearts are being used, and more marginal donors are being utilized. So coming to the outcome of marginal donors. This study has shown that 43% of the donors are used and results are equivalent to a normal donor, and therefore the marginal donor, if they are optimized properly, can give a very good results as compared to normal donor. Here again from St. Vincent's Hospital, Australia, they have used marginal donor, and they have categorically says that hypothermic perfusion is going to prolong the ischemic time, and probably more and more marginal donor can be used. If the patient is waiting on the list, there is a comparison of using marginal donor for the patient and putting the patient on LVAD, and they have equivalent results. So this result shows that donor risk increases when there is marginal donor is used, the risk increases. So therefore, that needs lot of resources to resuscitate those hearts, and therefore, if these marginal donors are used in a centers where smaller number of heart transplants are being done, probably results are not good. So that brings us to the fact that should orthotopic heart transplantation being used in a marginal donor should be limited to higher volume centers. And whether should marginal donor be used for a heterotopic transplant, that's another area to be explored. So to conclude that, first of all, we need to optimize the existing donor, where if we do not optimize, they can go into a stage of marginal donor. Secondly, these are the areas which I've alluded to, is that older donor, size mismatch, and prolonged ischemic time. All these areas we need to work, and normally those who becomes a marginal donor, there we can optimize these donors and put them into the donor pool. Novel transport system has made lot of changes currently, particularly temperature controlled transport and ex vivo perfusion and organ care system. And direct procurement and normothermic perfusion in DCD heart is very important, because all the DCD hearts are marginal donor, and they can be, as I have shown you, that 87% of the marginal donor DCD heart through organ care system can be utilized. And this is how we can increase our donor pool. So thank you very much.
Thank you, Dr. Das. I request Dr. Devasis Das for heart transplant challenges and way forward in this time.
Good afternoon. Thank you for moving me up in the order, because I had something to do, and I do apologize for that. It's a humbling experience to speak after Dr. Balakrishna's spectacular data, but we thought it was important to, this is collated data from the entire Eastern India heart transplant activity, and this is just a very honest assessment of what we have been able to do. As Dr. Sarkar mentioned in the morning, we started in 2018. So we actually collated data from all the participating centers and then did this. So starting from 2018, there are certain systems now in place. So this is one of the busiest So this is in the donor body, and this is just a couple of hours later in the recipient's organ. So it is still, in spite of having been involved with this activity for some years now, it is still a very gratifying experience. I'll run through this quickly, but we all know that the heart transplant activity started way early in India. In 1968, when Dr. P.K. Sen transplanted a heart in KEM hospital, this was probably the 5th heart transplant in the world. It was probably also a DCD donor, although the terminology was probably not in place. But and for some hours the heart did beat, and but the first official heart transplant which was successful was in All India Institute by Dr. Venugopal and his team. If we see the thoracic organ activity, if we concentrate on South Asian, Dr. Sivathashan gave us quite a good amount of data from the region. And 50% of the transplant activity still happens in North America, but however, if we concentrate on South and Southeast Asia, I think a significant amount of activity happens in India. So this is a slightly older picture from 2021, and this is how the heart transplant activity would look like if we map them onto the world map. And this is as gradually the numbers in India are increasing, and both in heart as well as heart and lung. So some amount of data collection initiatives have been successful. So this is the INTRAN, which is the Indian Heart and Lung Transplant Registry. The last report was published in 2023, and which enumerated all the centers in India. Since we talked about to mainly elaborate on what has been happening in Eastern India, these are the 7 centers which have started the heart and heart-lung transplant activity in the city of Calcutta. There are a couple of centers outside Calcutta now which have got the license, and the transplant activity hasn't started in thoracic organs yet, but I'm sure it will start. Dr. Satyajit Bose was here, and he was talking about plans for taking it outside the metropolitan limits. So this is, if we see this map, this color coding thing, Gujarat, by now Dr. Dhiren Shah is here, is probably deep green because this map is again an older map. And we know that at least we are not in red. But we are in a unique position where we are surrounded by states where there is a lack of transplant activity, and that is what is important, because we region-wise probably have at least started this activity, but it is now imperative upon us to take it further. This is the overall INTRAN data till 2023. These were the number of transplants, LVAD, lung transplants, heart lungs done in India so far. To come to the main part of what we have done in Eastern India since this thing, 2018 to 2023, I am glad most of the co-authors of this paper, we managed to publish this in Indian Journal of Transplantation, are there in this hall. Dr. Dey is here as a chairperson. He is also one of the co-authors. So we collected data, and I'm very grateful to all the co-authors who actually shared this data with us, to see as to what exactly was the in-hospital and a very small follow-up of these patients who were operated in the state of West Bengal for heart transplant. So year-wise, if we see till 2023, there were 38 transplants done in the state. After that, 2024 was a low activity area because there was only 1 heart transplant. 2025 has seen 4 so far. So the total number is 43 here done in the state of West Bengal. If we compare it to what has been the organ donation rate, now organ donation rate vis-a-vis the number of people that live in this state is still very low. However, I want you to concentrate on the number of transplants that we could do locally. So there is a paradoxical situation of low local organ utilization rates. We do have organs in the city, but none of the centers would actually have a ready recipient. And we face it not very uncommonly. And I think it is an experience which is not unique to us. It is an experience which has been shared in other programs as well in the starting phase. So I think we just have to get on to that stage where collectively at least we have every blood group, every center would have sort of one ready recipient so that the organ is be able to use locally, because again the ischemic times will be lesser, the outcomes are probably better if we are able to do it locally. The organ retrieval, so 5 out of these 38 patients which were analyzed in the paper, which is 13%, were out of state retrievals. Whichever hospital used a more than 1 hour flight, it was a non-commercial private flight. Most of the organs were transported out of the state by commercial flights. Again, Dr. Balakrishnan has just left for something, but he published a paper where it is a unique phenomena of using commercial flights successfully for organ transplantation, and was published. And so we have had very little experience, but we do have transported organs from nearby states, and they have been successfully transplanted here. These 38 patients, again, predominantly males, again, around a relatively young population of mean age of around 38 plus minus 17.4. 3 of them were pediatric patients. 1 of them was a post-Fontan patient, which these 3 were done in the center where I work. And the in-hospital mortality rate of collective all this center was 5 out of 38, which is 13, and on a rather higher side. These were the etiologies that we dealt with. So half of them were dilated cardiomyopathy, idiopathic in origin. Second would be of ischemic origin. And then we had other rare anomalies like sarcoid, congenital being two of them, giant cell myocarditis, post-viral dilated cardiomyopathy, and even postpartum dilated cardiomyopathy. The 13 patients with I have actually not labeled them as PGD and rather labeled them at low cardiac output state because there is no evidence, because these were data collected from multiple centers. We could not classify it as classic PGD, but these 6 were early deaths. One patient was a late rejection death, and 6 patients actually succumbed to infection, which again shows as to what are the current challenges that we face. Most of the centers have collaborated well in terms of sharing their immunosuppression protocol. All the centers, when we contacted, have used induction as their immunosuppression protocol with the standard drugs of methylpred, basiliximab, and mycophenolate. Endomyocardial biopsy protocols were also more or less uniform with most of them would actually do a pre-discharge EMB, then 1 month, 3 months, 6 months, and 1 year. Some of the centers have done more frequently than this, mostly based on the clinical performance of the patient. And in this, we documented 2 cases of acute cellular rejection, R1, which was successfully treated, another one ACR R2, and 1 case of documented cardiac allograft vasculopathy, in which immunomodulation was done and the patient subsequently did well. When we followed up these patients till 2023 December, the data is only till then, 86%, that is around 33% were discharged home. 28 out of 38 had completed 1 year. 3 out of 38 had actually completed 5-year follow-up. 4 patients, we don't know what they were lost to follow-up, and they're not part of this data. So this is how they performed in the follow-up period, with 33 of them going home, and we know that till at least some of them have actually gone beyond the 5-year follow-up level now. Coming to one of the main challenges that we faced was infection. Some of the centers, including ours, we started our transplant program in the midst of COVID pandemic. And 2 of the patients actually had COVID infections, not in our center, but in another, and succumbed to it. One was pneumocystis carinii. Bloodstream infection of bacterial origin was in 4 patients out of 38. 6 patients actually succumbed to various forms of infection when we combine them together. So other infections were cryptosporidium leading to diarrhea, aspergillosis, and pneumocystis carinii in the lungs. As I said, there were a couple of rejections which happened, ACR R1 in 2 patients, ACR R2 in 2 patients. 1 patient had documented cardiac allograft vasculopathy. 1 patient succumbed to a rejection episode. So the common complications that we faced was early low cardiac output in 5 of these patients, COVID infections during the time when COVID was raging, bloodstream infections, mainly sepsis related to bacterial infections in the postoperative period, cryptosporidium diarrhea, and pulmonary complications like aspergillosis, MDR, COX, and pneumocystis carinii. Heart-lung transplants and lung transplants also has started in a little bit, in a very small way here. 2 centers have currently performed this. There have been 4 lung transplants, 1 heart-lung transplant. This is a patient, I'm grateful to Dr. Mahapatra who actually shared this picture. This is the IPGMR patient one year after transplant on a follow-up visit cutting a cake at the hospital where he was transplanted. So if we have to just concentrate on the conclusions from this study, I think we do admit that there was a relatively high early mortality rate. There are a lot of infections in the follow-up period, and some of them leading to fatality, not successfully treated with appropriate whatever anti-infection measures. We do face a hurdle of low organ donation rate. I think at least, although being a high population metropolitan city, we started late in 2018, but at least we have now 7 centers where systems are in place to take it further. We just have to see as to with awareness, with more organ donation, as well as more organ utilization locally, how do we take it further? So compared to the total population, the transplant numbers, even if just like if we compare the entire Indian data, I think our numbers of transplants are very small. Again, I will harping on just one thing, that organ donation rates are lower. We keep saying this, but I think as a transplant surgical community, at least here in this city, we need to improve our organ utilization rate. We also have to have some interface with NOTO and ROTO to have a dynamic waiting list, because currently there is no method of organ allocation that we follow in this particular state. If you have a patient on mechanical circulatory support, you really have to argue your case with ROTO to give you a priority. It does not happen naturally currently. So our challenges, our funding, we saw as to what are the variables. So this activity being capital intensive, fund is always an issue. Post-operative infections are still one of the major challenges. There are logistics of organ transplants, organ transport, which we face as a challenge. Post-op transplant surveillance and loss of follow-up is another issue that we face. Pediatric organ donations are almost non-existent. There are late referrals of patients with very advanced heart failure who actually have multiple organ dysfunction and are not suitable for a low-risk transplant. That is another thing that we face. Organ utilization, as I said, and lack of organized heart failure clinics. We do get a lot of lay press coverage in this part because of this activity happening sporadically. We don't mind it. I think it does help to spread the awareness. So it is funny to see organ transplant being covered in this manner in a lay press, but I think at least it spreads the awareness that this activity happens here. So there are certain questions as a community which we need to answer. Where exactly do we stand? I think we have just made very little inroad into it. We just have to take it further collectively. There are important bottlenecks which I have elaborated upon. Every institution has been very enthusiastic in starting it. All corporate hospitals, public hospitals together. If you ask the surgical team involved, do you get enough institutional support? It's a very silent answer that you will get, because it is, so far whatever activity has happened is because of individual efforts. I think we need to have more methods into place to take it further. We need to collaborate more. We need to analyze our data objectively. And the key message is we have only made very initial inroad. If you compare it to Dr. Balakrishnan's spectacular data that we saw, I think we have a long way to go. But I'm sure if we collaborate more, we can take it further. Thank you for your attention.
Great. Congratulations, Devasis. I think we'll talk about the...
Thank you, sir.
Thank you for finishing in time. I request now Dr. Aditi. Sorry for... Aditi, for pre-transplant cath data and its importance.
Good afternoon, everyone, and thank you so much to the Society for inviting me to give this talk. So we'll be shifting gears a little bit from the status and scenario of heart transplant to management of heart transplant candidates. So the topic given to me is pre-transplant cath data and its importance. So in this talk, I'll be going over the role of right heart catheterization in heart transplant candidate evaluation, the various hemodynamic parameters and their clinical significance, what the guidelines say, then vasoreactivity testing protocols and how to interpret them, and some management strategies for elevated PVR. So we're all familiar with the pathophysiology of pulmonary hypertension in heart failure, and the key role for doing right heart catheterization is to evaluate for pulmonary hypertension. So as we know, in heart failure, there typically tends to be elevated left-sided filling pressures, and over time, this elevated left-sided filling pressures will lead to passive venous congestion, which over time leads to remodeling in the pulmonary arterioles as well, and eventually that passive congestion remodeling becomes fixed over time. So that is what we are essentially concerned about. And this is just showing in the timeline the natural history of heart failure. When we start with venous congestion, passive venous congestion initially, the cardiac output and PVR are low, but as this progresses and there is arterial remodeling, the PVR starts increasing, and then eventually there is RVPA uncoupling and further drop in cardiac output with continued increase in PVR. So this is the stage that we really want to see where we are at in this spectrum and what is actually harmful for heart transplantation. Pulmonary hypertension definition we're aware of, it was changed in the recent guidelines to a mean PA pressure of 20 millimeter mercury, and this is also reflected in the heart transplantation guidelines now. And isolated post-capillary pH is when you have an elevated wedge pressure with a low PVR, which is acceptable for transplantation. However, if you have combined pre- and post-capillary pulmonary hypertension, this is the situation that is challenging in the setting of heart transplantation. So why does right heart catheterization matter? The right heart failure is one of the leading causes of early mortality. Up to 20 or even 30-40% of early post-heart transplant deaths are because of right heart failure, depending on the data that you look at. So accurate hemodynamic assessment is essential for risk stratification. Elevated PVR is predictive of donor RV failure and poor outcomes as well. There is some data on transpulmonary gradient, PAPI, diastolic pulmonary gradient as well, but that data is not as consistent. The best prognostic data exists for PVR. So this is essential for candidate selection and planning the transplant, and it is a class 1 recommendation for all transplant candidates. This is data from the 90s that first showed how important PVR is in terms of outcomes. So good outcomes are seen if you have a PVR of 2.5 at baseline, or if your PVR can be reduced to less than 2.5 without a low blood pressure when you use vasodilator testing. If your PVR can be reduced, but with a low blood pressure, we can see 3-month mortality is as high as 30%. And if your PVR could not be reduced at all, your mortality is even higher. So this data is extremely convincing about the importance of PVR. And this is shown even in the contemporary era, where if your PVR is less than 300, the all-cause mortality at 30 days, even out to 1 year and 2 years, is much lower compared to if the PVR is greater than 300. We can see almost 4 times increase in mortality with a high PVR. And even the UNOS registry, which has long-term survival data, up to 5 years, shows that pre-transplant pH, that is an elevated PVR, is a significant predictor for mortality. But interestingly, at least from this data, the severity of pre-transplant pH did not affect survival. So the guidelines say that right heart catheterization should be performed on all adult candidates in preparation for listing for cardiac transplantation, and then periodically until transplantation as well. And the key parameters that we want to look at are PVR, transpulmonary gradient, and the blood pressure in these settings. Now, what are the contraindications to transplant? Absolute contraindication is a PVR greater than 5 Woods units that is irreversible on testing. And these are the relative contraindications. So transpulmonary gradient, that is between 15 to 20, we need to consider vasoreactivity testing and then consider these patients on a case-to-case basis. Similarly, systolic PA pressure that is greater than 60, and PVR that is between 3 to 5 Woods units, that is non-reactive on testing. And in these cases, we need to see what options there are if this can be reversed over time. So this brings us to vasoreactivity testing. What is this and why is this needed? The indications for doing vasoreactivity testing are an elevated PVR greater than 3 Woods units, transpulmonary gradient 15 millimeter mercury or more, and a systolic PA pressure of 50 millimeter mercury or more. And in order to do acute vasoreactivity testing, we need to have a blood pressure of greater than 85. Ideally, this should be performed once the patient is stable in a euvolemic state and no active ischemia. There are various testing agents, various protocols. The prognostic data is with using nitroprusside for vasoreactivity testing, though other agents like milrinone, sildenafil can be used as well. Nitric oxide, prostaglandin for vasoreactivity testing has also been reported, but they can lead to pulmonary edema if you have an elevated wedge pressure. And a positive response is defined as a PVR that reduces to less than 2.5 to 3 Woods units. This is the primary endpoint, along with the transpulmonary gradient less than 12 to 15, and systolic blood pressure of greater than 85 millimeter mercury should be maintained throughout the testing, and the cardiac output should be preserved with the response. So this is a clinical decision-making tree for patients. So all patients should have an initial right heart cath at baseline in euvolemic state. If the PVR is less than 2.5, you can go ahead with listing them. If it is between 2.5 to 3, you should monitor them closely, look at your other variables also, the overall condition of the patient. If the PVR is greater than 3, you should perform an acute vasodilator challenge. If the response is positive, you can go ahead with listing them. If the response is negative, then we need to further see if they can become candidates or not. So you can reassess them with continuous hemodynamic monitoring, with further optimizing their volume status using inotropes and vasodilators. And often these patients, after 24-48 hours, we can see reductions in their PVR. If you still don't see a change with this, temporary mechanical circulatory support can be used. And with temporary MCS or with any of these pharmacological methods, if you have a response, then you could list them. But if you still do not have a response and their PVR remains elevated and fixed and irreversible, then these patients should be considered for durable LVAD. Heart transplant alone should not be performed, or you could consider heart-lung transplantation in these patients. Mechanical circulatory support, that is durable LVAD, has been used in India. It's not so much as an option for us in most patients because of financial considerations, but in the West, LVAD is used frequently for patients who have fixed pulmonary hypertension, and it has been shown that after unloading with an LVAD for 3 to 6 months, up to 60-70% of those patients who had fixed pH, that actually resolves, and then those patients can become transplant candidates. Now, the other important use for right heart catheterization in Western countries is that their patients on MCS are prioritized, and hemodynamic criteria are needed to use MCS in the United States particularly. In India, in some states, use of MCS is prioritized, but we currently do not have hemodynamic criteria to guide the status urgency. The next important use in heart transplant candidates is to assess hemodynamic stability during the waitlist period. This is also extremely important. During the waitlist period, again, patients can decompensate. So right heart catheterization can help you to guide diuresis. There is some data that shows that elevated RA pressure can lead to graft failure, can lead to higher incidence of graft failure post-transplant, and also affects your organ perfusion, liver function, renal function, and the worse those are, the worse your outcomes will be post-transplant. So we should try to keep patients as euvolemic as possible during the waitlist period. It can help identify deterioration also. We know the SCAI classification heavily emphasizes the use of hemodynamics in classifying shock. And so right heart catheterization in these patients will be helpful to identify shock, classify it, classify the severity, identify if your patient needs temporary MCS while waiting, and guide the type of MCS that the patient needs as well. Importantly, it can also help you de-escalate therapy. If your patient's hemodynamics are good, then you can reduce their inotropes or mechanical support that they're on. Serial evaluation while waitlisted is also recommended. The assessment should be within 6 months of listing, and serial monitoring within every 3 to 6 months, is recommended for adults. And again, this is important because it will help optimize your medical therapy, can define the urgency of the candidate, assess end organ injury, and guide MCS placement. Routine surveillance is not generally advocated in children, but again, if there is clinical worsening, you should reassess their hemodynamics. And it has been shown that right heart catheterization prompted by clinical instability and routine surveillance as well has helped improve waitlist survival and improves their access to transplantation as well. Special consideration for pediatric candidates is that PVRs, the same PVR cutoff has not shown to have the same outcome effect as it has in adults. So an indexed PVRI, that is indexed to their body surface area, of up to 9 Woods unit is acceptable in patients. This can be either on initial assessment or after treatment with medications or MCS. And the same has been seen for both congenital heart disease population as well as cardiomyopathy population. I won't go too much into the details because Dr. Shashiraj will be talking more on pediatric transplants, but the etiology for pulmonary hypertension is different, particularly in congenital heart disease, where they can have anomalies in the pulmonary anatomy, they can have differential blood flow, aortopulmonary collaterals, and single ventricular function, AV valve regurgitation. All of this will have an effect on pulmonary hypertension and assessment in these patients. Fontan population is another special population where we cannot assume what the PVR is, and we cannot accurately calculate it as well. And in that patient population, inhaled nitric oxide, pulmonary vasodilators may also be beneficial, and embolizing aortopulmonary collaterals may be beneficial as well. Donor-recipient matching is another important aspect, particularly if you have a candidate with pulmonary hypertension. We should try to oversize the donor, use a predicted heart mass ratio of closer above 1 at least in these patients, and particularly female donor to male recipient should be avoided. There is some data from the UNOS registry showing that using an RV mass ratio that is greater can mitigate some of the risk of having pre-transplant pulmonary hypertension. Another important aspect of heart catheterization that we don't commonly do is assessing for portal hypertension. We know that congestive hepatopathy over time can lead to irreversible liver fibrosis, and those patients are high-risk candidates or not a candidate for heart transplantation alone. And using a right heart catheterization, we can assess the hepatic vein venous wedge pressure gradient. A gradient of less than 5 is normal. If you have a gradient of more than 5, it suggests that there is portal hypertension. And that suggests that you have advanced liver disease, and those patients will be high-risk candidates for heart transplantation alone. What are the complications of right heart catheterization? Overall, it is a very low-risk procedure. The most common complication, in fact, is really data misinterpretation. So factors such as ensuring that there is proper zeroing is very important, making sure the transducer is leveled, because errors in this can really affect your numbers. Over-damping or under-damping of the system, so ensure that there is no open connections, no bubbles. All of that is extremely important. Inaccurate wedge pressure is something we see very commonly, so you should always try to obtain a wedge saturation to ensure that you are in the accurate wedge position. Sometimes significant respiratory variation can be present, particularly in obese people, and this can really affect the PA pressure and the wedge pressure and affect what value to take. So in those patients, we should try to take an overall mean across the respiratory cycle. If you have tall V waves in the wedge pressure, this can also affect your PA mean. Typically, we take the end diastolic pressure at end expiration because that is what closely reflects the LV EDP. But what the pulmonary vasculature is actually seeing is the whole wedge pressure, including the V waves. So if you have big V waves, you should take a mean that includes the V waves as well. And then inaccurate cardiac output calculation. Thermodilution is a derived value. This can be inaccurate if you have significant TR or shunts. And direct FIC method is very difficult to actually get because most cath labs don't actually have the ability to measure directly what the oxygen consumption is. So using an indirect FIC can give erroneous results as well. So I'll just conclude quickly with a case. This is a 39-year-old male with familial non-ischemic cardiomyopathy who had advanced heart failure and was being evaluated for transplant. These are his pressures at baseline. RA pressure was 12. His PA pressure was 82/35 with a mean of 51. Wedge pressure was 35 with V waves of 60. And his PVR came out to be 6.6. So we did vasoreactivity testing with nitroprusside for him, and we saw a very good result with PA pressure reducing to 35/10 with a mean of 18, mean of 8, and PVR that came down to 1. So we accepted him as a high-risk transplant candidate. So it really shows the importance of good cath data and ensuring that you do all the testing to be able to provide the right treatment to your patient. With that, I'll end. So to conclude, right heart cath is mandatory in heart transplant candidates. Elevated PVR increases post-transplant mortality. Vasoreactivity testing should be done in the right setting. And pharmacological and mechanical interventions to assess candidacy should be used in elevated PVR settings. And serial assessment should be done while patients are waitlisted to guide management. Thank you so much for your time and attention.
Okay, thank you. Our next speaker, Dr. Somojit Ghosh. His topic is pre-transplant assessment of recipient, surgeon's view. Dr. Ghosh.
I would like to thank the organizer for inviting me for this topic. And my topic is assessment of heart transplant recipient. But thing is that it includes donor and overall transplant situation. First, for the indications, as we know, the systolic heart failure, LVEF less than 35%, cardiogenic shock, ischemic heart disease, intractable ventricular arrhythmia uncontrolled with standard anti-arrhythmic therapy, device therapy, and or ablative therapy, severe symptomatic hypertrophic or restrictive cardiomyopathy, cardiac tumors, these are cardiomyopathy of any kind, dilated hypertrophic or restrictive cardiomyopathy, anatomically uncorrectable congenital heart disease, refractory heart failure after previous cardiac surgery, significant cardiac allograft vasculopathy or chronic graft dysfunction of a previous heart transplant. Indications were according to the etiology, but this is the indications of the heart transplant according to the functional classification of Intermax. As we know, Intermax 1 that shows the crash and burn situation where there is hemodynamic instability in spite of mechanical circulatory support and high inotropes. Patient is sinking with critical hypoperfusion with target organ severe cardiogenic shock. And Intermax 2 shows, Intermax 2 classification includes that kind of patient, that's a group of patients that those is having the steep inotropic support but rapidly deteriorating kidney function and nutritional state or signs of congestion. And Intermax 3 includes those patients who are having moderate inotropic support but having rapidly deterioration in kidney function. And Intermax 4 group of patients that includes the temporary season. These patients having no inotrope, but they are having frequent symptoms with fluid overload. And Intermax 5 group of patients are housebound, but they cannot have any light physical activity. And Intermax 6 group of patients, they can do only light physical activity. And Intermax 7 group of patients, they can do their physical activity and having no recent unstable, fluid water congestion. And these are the tests we do routinely for assessment of every recipient. It includes the CVC, LFT, RFT, all other tests we can, and also HRCT, VO2 max test, and PFT. And it includes also immunological evaluation. That the purpose of immunological evaluation for the heart transplant is that to detect the pre-existing antibodies and that can cause the hyperacute or acute rejections, can determine the compatibility between the donor and recipient, and identify the immune risk that might require the desensitization or special immunosuppressive regimen. We do panel reactive antibody testing, PRA1, PRA2. If we find it positive, then we do the donor-specific antibody testing. If it is positive, then we treat the patient with immunoglobulin and or plasmapheresis. We also test the patients with IgG of other viral infections. That includes the CMV, varicella, herpes, toxoplasma, Epstein-Barr virus. And if they becomes positive, then we test them with IgM of these viruses. And if they are still positive, then we treat them with Valgan cyclophyr. And cardiopulmonary exercise testing, this is a very important test. Typically, it is done using a treadmill or bicycle ergometer. And we measure the VO2 max. And VO2 max, what is VO2 max? This is the maximal oxygen use, maximal amount of oxygen that body can utilize during the maximal exercise. And if it is more than 14 ml per kg per minute, it is, if this patient can be managed medically, and if it is less than 14, that indicates its candidacy for the transplant or LVAD. Right heart catheterization is very important. It is the very, invasive hemodynamic assessment that provides essential information about the cardiac function, pulmonary vascular status, overall candidacy for the transplant. And the key hemodynamic parameter it assesses the pulmonary vascular resistance. If it is more than 5 Woods unit, that denotes that the patient, this is the contraindication for the heart transplant. And transplant pulmonary gradient, that is calculated as mean pulmonary artery pressure minus the pulmonary capillary wedge pressure. If the value is less than 15, then we go for transplant, but if its value is more than 15, it is regarded as a contraindication to heart transplant. And this is the predicted heart mass match calculator. If we put the data of the patient's age, sex, height, and weight of the donor recipient, the ratio is between 0.8 to 1.2, it's a good match, donor recipient match, as per the predicted heart mass calculation. This is the routine assessment usually we do in every situation, but thing is that surgeon has better role to play, and they should assess the heart and recipient, and donor, and every single situation of the transplant, so that the outcome becomes bigger, because the onus is on the surgeon, because the patient is admitted on the surgeon. The surgeon should decide on the very critical part of the transplant process. For example, surgeons should go to the donor site. They can take the T machine, and they should see the T themselves, whether there is interventricular septal thickness more than 1.4 or posterior wall thickness more than 1.2, and if there is any RWMA or not, if there is any valvular lesion, if there is any PFO, they should see personally. They should not rely on the others' echo finding for choosing a donor. And they should demand that center, donor center, to have a coronary angiogram if the donor's age is more than 40. And inhaled nitric oxide should be present in the operation theater. And we know that all centers don't have this inhaled nitric oxide facility in Kolkata or West Bengal, but it should be there, because in marginal donors or high borderline PA pressure, so if there is right heart dysfunction and difficulty coming up of the bypass, or in that situation, it can be started on the OT table also. It can be started, because that will determine the outcome later on. And this inhaled nitric oxide is helpful in pulmonary hypertension, also right heart dysfunction, hypoxemia due to the pulmonary hypertension, VQ mismatch, and primary graft dysfunction, and it can be used as a bridge to weaning from the cardiopulmonary bypass if it's needed. So decision making, surgeon should be a decision maker in that case also, whether he would use the nitric oxide, inhaled nitric oxide in the OT table itself. When he sees that there is a borderline pulmonary pressure is very high, and there is right heart dysfunction in the OT table, and he can take decision to use the nitric oxide even in the OT table also. And he can continue that in ITU also. And decision of the VA ECMO. Surgeons will assess the situation in the operating table after transplant, and should have independent opinion on VA ECMO to be used or not. If it is a borderline donor, as we are discussing before, and if the patient was previously on ECMO, all the recipient is having the steep inotropic support, and it was very difficult to coming up the bypass. And in that case, surgeons should decide that he needs the VA ECMO in the OT table or not. So if surgeon feels that, he should initiate that VA ECMO and shift the patient with VA ECMO to the ITU. Other surgical issues, if there is LVAD, which was used previously as a bridge to transplant, LVAD can be taken out when we are on CPB, And in case of redo transplant, CT chest and color Doppler of the peripheral artery should be done as a prerequisite if we need the peripheral bypass or we need the VA ECMO. And this is the redo situation. The CT chest is done to assess the distance between the heart and the sternum, and also the addition of the other organs with the sternum and surrounding structures. And if needed, we can go the peripheral bypass in redo situations, and to avoid the inadvertent the graft injury or LVAD situations, we can go peripheral bypass before, and for that we should do the peripheral Doppler or CT peripheral angiogram to see the peripheral vessels, so that we can go for peripheral bypass, or we can use it as a VA ECMO later on. So take-home message is that the transplant surgeon is taking the accountability for every positive and negative outcome, and surgeons should take part in the crucial decision-making situation as much as possible. If he needs to see the echo, if he wants to use the INO, or if he wants to use the VA ECMO, he should decide independently. That is the take-home message. Thank you for your attention.
Thank you. Thank you. Any questions from the floor? I just want to know, if you mentioned about the PFO. What do you do if there is a PFO?
I'll close it on the table when we will before transplant.
Previously, but now, as you saw Aditi saying, almost 15 to 20% of the patients, they get right heart failure immediately after the transplant. So leave it open, and if it is big shunt, then you can always device closure. So, but initial period, if it is a small PFO, I'm not talking about big ASD. Big ASD you close down or whatever. But if it is a small PFO which may not be known also, then leave it alone. It helps in the immediate early post-op period. And another thing is left SVC, persistent left SVC in a donor heart. I think it should be harvested and anastomosed to the innominate.
Yeah, definitely.
Thank you.
Yeah, welcome, sir.
The next is Shashiraj, Dr. Shashiraj for pediatric heart transplant.
Good afternoon, everyone. Thanks to the organizers for the kind invitation. I will just briefly go over, pediatric heart transplant, since the topic itself is, wide and vast enough to discuss for many sessions. I have no disclosures for this topic. So I'll just go through some of the challenges in pediatric heart transplant as we see in, day-to-day practice. We'll briefly go over the survival, recognition of advanced heart failure, especially in children and adult congenital heart disease. Few cases, and then donor-recipient size mismatch, and then post-transplant morbidity. So heart transplantation remains an effective therapy with growing number of long-term survivors through infants into old age. Right. If you look at the recent Pediatric Heart Transplant Society data from US, this is across 150 centers, covering more than 10,000 transplants over 30 years. So once you have a conditional survival for more than 3 years for a child less than 10 years of age, the long-term outcome is pretty good. So if you look at the 3-year conditional survival is 82%. And at 15 years, it's about 70%. And at 20 years, it's still about 60%. So that's a median survival, what you see in children as opposed to in adults. We're still barely, beyond a decade of survival, or maybe 12 to 13 years. And if you look at conditional survival to 10 years, which means you've had a good natural history post-transplant for 10 years, so obviously you have a much longer long-term outcome. So the survival at 15 years is 85%. So someone who has lived for 10 years post-transplant at less than 10 years of age, 85% of them would live at 15 years. So I mean, this is the data what we can, briefly share with the parent when we, discuss about an option of heart transplant for survival, when we are looking at a mortality of more than 25% at 6 months when you treat a child with advanced heart failure. And even at 25 years, this is the latest data what we have, about 2/3 of them live long enough for 2.5 decades. And if you see, there is no significant difference in survival beyond 10 years based on underlying diagnosis. So you have the history difference between the congenital heart disease and cardiomyopathy in the first year after transplant, but beyond that, that survival goes away. And the best survival happens in infants or less than 1 year of age if you transplant. So they have the best overall survival outcome. Let's just look at, we see probably everyone in this room would have seen, several cases on a, regular basis. The relationship between ventricular dysfunction in congenital heart disease and cardiomyopathy. So we don't look at the diagnosis of a particular disease in its, as a unifying thing. So if you look at this relationship, there is a vast group of patients with congenital heart disease, and there is a group of patients without congenital heart disease with cardiomyopathy. We all see that on a day-to-day practice, right? Once you have cardiomyopathy as a definition, you have abnormal myocardium. It may be manifest or it may manifest later. So cardiomyopathy, by definition, it would lead to ventricular dysfunction in 100% of the cases. But if you see the left side of the diagram, 20% of the treated congenital heart disease have abnormal myocardium. They may manifest or they may not manifest in their lifetime. But once they have ventricular dysfunction onset, the incidence of heart failure is about 40% in the long term. So this is where we should be paying attention to the onset of ventricular dysfunction, whether it is systolic or diastolic, in a vast pool of treated congenital heart disease. Imagine, thousands of cardiac surgeries would have happened in the last 20 years or 25 years in India. In our center, there are about 2,500 pediatric cardiac surgeries done in a year. So if we track low EF at the time of discharge, the incidence is about 1 to 5% of all the discharges would have children with severe ventricular dysfunction at the time of discharge after undergoing a corrective or a palliative cardiac surgery. So there would be hundreds of patients who would come back to your follow-up. Many of them would recover, many of them would not. And that's based on the individual phenotype and whatnot. So let's just look at our first case, 7-year-old girl with chronic heart failure. So she's status post VSD closure in infancy, typical case, right? Normal function on follow-up. At 9 months follow-up, she has LV of 23% out of nowhere. She has severe MR, aortic regurgitation, and she's on oral heart failure therapy. The LVEF improves to 45%. This is probably one of the routine cases many of you would have seen, in your day-to-day practice. At 5 years of age, she undergoes, aortic valve repair, mitral valve replacement, and post-op 2 months, her LVEF is back to 19%. And this is not unusual, right? So at 7 years, her LVEF is hovering around 35%. She's on oral heart failure therapy. She's the phenotypic case of where there is overlap of what we see historically in her long history. She has an abnormal myocardium which we don't still understand in terms of genetic predisposition, whatnot. Probably independent of her simple CHD when she started with. So now this is her LVIDD 54 millimeter plus 5 Z-score at the latest follow-up. What is the chance of needing a heart transplant in her lifetime? I think it's very high. Whether it's 20% or 50%, we don't know. But at least we know that when she deteriorates, she'll be a less suitable candidate for a repeat sternotomy and a repeat surgery than needing a transplant. So that's a clinical judgment we will have to do on follow-ups. And probably, a cardiologist and a surgeon, frequently faces this situation. We may not have the perfect answer, but knowing the history, I would bet that 5 years from now, if she presents with severe AR, severe MR, LVEF of 30%, there is a high chance that I would not be advocating for a repeat cardiac surgery to fix the valves. Now, each individual patient might be different, but so, changing gears, let's look at a 15-year-old boy, tale of 3 lives. He had a normal birth. At 3 years of age, he has Wilms tumor, chemotherapy, nephrectomy in remission, cured. Cancer is cured, right? So at 15 years, he presents with, class 3, class 4 symptoms for 2 months, end-stage heart failure. EF is 15%, LVIDD is 62. His RA mean is 22, right heart failure. Our PA mean is 34, LV wedge of 30, cardiac index of 2 liters. So he has a, dilated heart with a restrictive physiology. So he's on, Centrimag for his advancing symptoms, and post-op day 8, on BIVAD, he gets a heart transplant and he's nearing discharge. So this is a different phenotype where we see increasing number of children cured of cancer, probably thousands, with improving cancer survival. You would imagine there is a big portion of children, especially when their cardiotoxicity drugs beyond their permissible doses are used, especially with non-availability of cardioprotective dexrozoxazone in India. There will be thousands of children and young adults who would have been treated for cancer several years ago, and now they present with early heart failure or advanced heart failure. So programs incorporating cancer survival probably should liaise and coordinate probably for the long-term care to look at the heart failure, whether early or late stage, I would say. Again, I was amazed at how that, I'm not used to seeing the heart in the OT. I'm a cardiologist by training, but you see the right atrium is like dark and trying to die. So he was just several hours away from a cardiac arrest before we took him for a elective Centrimag. So this is a review article we wrote about 15 years ago based on, how the evolution of cancer and their, cardiac phenotype changes. Once their cancer is cured, regardless of their cardiotoxicity levels, they do have subclinical changes in their myocardium. And now they may have a slightly dilated, phenotype which be stable for several years, and once they advance to, advanced heart failure, they go into a restrictive physiologic state which we saw in our recent patient. So this is again, this is not our own data, but the hemodynamic profile of children with advanced heart failure who are listed for heart transplant. So clearly, I think the data mimics what we see in adults. The PCWP more than, the ones with left heart congestion, they have, higher risk, post-transplant, but especially the ones with elevated, left heart filling pressures and low cardiac output, they do the worst in terms of, post-transplant survival. So this is just a, overview of the risk factors, what the ISHLT, slide has. It's a continuous risk factor in terms of recipient age. Younger the age, better the survival. Donor age again. We take, adults for pediatric recipients, of course, but the continuous risk factor remains for long-term survival. So a 20-year-old donor versus a 45-year-old donor probably makes a difference in terms of long-term survival. Again, ischemic time and recipient EGFR, and I'll briefly go over the donor-recipient height mismatch. So the ISHLT data of about 6,000 children, where they show that once you cross the 20% donor-recipient height mismatch, the mortality risk is increased. Again, this is an interesting topic we come across on a daily basis when we assess the suitability for a donor heart. Accurately predicting the cardiac size, it has typically has been by weight. If you look at the UNOS database of children less than 18 years, this is about 7,000 children. They looked at the donor candidate weight ratio. The median was about 200%. The range was anywhere from 150 to 240%. As we go higher, the risk of MCS will be much higher for sure once you cross 250 or almost 300%. Again, the centers which, when we put in the UNOS registry for a listing, we have to put the weight criteria. So we always put a higher weight criteria, but the actual acceptance is much lower. So most of the accepted heart transplant is much less than 200%. Although in our situation, we routinely accept much higher age donors as well. So this is an interesting concept which has been emerging with more advanced imaging, total cardiac volume either by CT or MRI. We have been, if you look at, this is still a very small number of patients what they have discussed, but we are looking at our own data to predict normal children, both young as well as adolescents, from their normal CT scan to derive their mediastinal volume and then extrapolate to the potential donor alert. So we look at their 3D derived mediastinal volume and see if once we have a donor alert, let's say a 22-year-old donor, 60 kilo, 5 feet 4 inch, is it suitable for a 6-year-old recipient? So based on normative data of their mediastinal volume of a normal population, we can probably try to extrapolate that. So this is work in progress. Hopefully by in about 12 months or so we will have our own data to look at Indian population so that we can know what is the predicted mediastinal volume when we get a donor alert, so that we don't underutilize potential donors. Again, this is one of the unique features in most of the pediatric heart transplant centers, especially in Western countries. So we started back in early 2012 to 14 in University of Iowa, where we completely avoided using steroids. No biopsy, no steroids, and no induction for low-risk transplants. So this was a single-center study of 31 patients, less invasive post-transplant approach that avoids biopsies and steroids was implemented. Both groups had similar survival. So there was no increased risk associated with steroid and biopsy avoidance in post-transplant patients with some clear benefits. Again, and this is a recent, not relatively recent study of 296 patients where low-risk patients were, which means no preformed donor-derived, donor-specific antibodies. They were managed with steroid avoidance as well as no biopsy, and they had excellent short-term outcome. Again, this is just a brief of the pediatric heart transplant and cardiovascular vasculopathy. CAV in children is reported less frequently, could be probably because of less imaging. Age at transplant is definitely a strong determinant. 75% of the children transplanted in infancy and young age, they have an 8-year freedom of CAV as compared to more than 10 years of age. And the guidelines do suggest use of statins for more than 10 years, or if you have evidence of hyperlipidemia or retransplant. So in a typical patient less than 10 years of age, especially if we have a good assessment of the donor coronaries, we don't start statin, especially when there is mixed data in terms of slightly increased risk as well. Thank you.
Thank you, Shishiraj. Now I request Dr. Pushibi. A good nap.
A little bit jet-lagged. Right.
The topic is heart transplant after VAD.
Brilliant. Thank you very much again for the invitation to come and give the presentation here. Last time I checked, heart transplantation was still the gold standard therapy for end-stage heart failure. Yesterday, I was speaking to Julius and we were talking about VAD explantation. As I understand it, most of the LVADs implanted in India are destination therapy, so you don't have the misfortune of having to take one of these out. So it is, thank you. It is quite a big job to try to take one of these LVADs out after you've put them in. But it's quite a routine in my practice to do that. Right, if I can get to the next page. So, as I mentioned earlier, I'm from Harefield Hospital, and we have a long tradition of heart transplantation. We've been pioneers in heterotopic heart transplant and dominant heart transplant, and we've done the first heart-lung transplant 40 years ago in Europe. We do a very large number of orthotopic heart transplants, and some of those are from VAD explants. So transplantation after LVAD surgery has got its benefits. It does improve the quality of life for patients, and it does actually improve the longevity in combination therapy. As you can imagine, after you had your LVAD, then you go on and live longer with your transplant, and that is a good thing. And as I mentioned, we do mainly transplantation as a bridge to LVAD as a bridge to transplantation. It does, however, increase the complexity, and the complexity really depends on the mode of VAD implantation. So if you are doing an explant on a patient who had LVAD inserted through a median sternotomy, then you have got the issue of having to do a reduced sternotomy going through the chest with structures that can be injured, such as the outflow graft, the drive line, the heart, and the aorta, and the rest. In contrast, if you do the operation through a bilateral thoracotomy, then you have different set of problems. You'll be going through a number of cavities. You have to do a bilateral thoracotomy. The visibility may not be as good if you're trying to do it minimally invasive. And then you have what I call a Gore-Tex vests, where there's so much Gore-Tex put on because you need to be separating the pump head and the rest of it from the lungs, so that you have a job taking it out. However, what it does do, if you do a bilateral thoracotomy, it makes it much easier when you come to do a transplantation to be able to open the chest in the middle of the night. You don't need to worry about injuring the structures immediately. But still very difficult to do a VAD explant if you have done it through bilateral thoracotomy with challenges. So this median sternotomy is my preferred approach, and is the one that most people use for VAD explantation before transplant. A few years ago, I published a paper in the Annals of Cardiothoracic Surgery about how to explant an LVAD. At the time, hardware was the LVAD of choice, and how I started that article was by saying that preparation for LVAD explantation starts at the time of implantation. So you need to have explantation in mind at the time of transplantation. Now, this I put as an example of what not to do if you're planning to remove the VAD at a later date. That is okay for destination therapy, but you can see in this image that you have got your drive line directly in the midline where you're going to be cutting open. So you've got your outflow tract. This is pushed up, and then you've got your outflow tract connected to the ascending aorta right at the top. So all of those can be affected when you go to do a real sternotomy. So I try to plan my operation so that I can get the drive line out of the way. This is what my LVAD implant looks like. So you can see that there's no drive line going across here. This is actually, in actual fact, is a drive line. The way I position this, it pushes the drive line down, and then I'll bring it up on the side and out from here. And then you may not appreciate, but over here, there's a shelf of tissue where I leave behind as the part of the inverted T, where that actually protects the outflow tract. So when we come to open it, this will be there. Quite a few times I have actually sewn a Gore-Tex to this so that it doesn't actually come out. But this, if you leave it as that, it doesn't actually protect the heart or the aorta. And what I do for the drive line, I would connect it to the side of the aorta. This is to prevent to have this sort of scenario where you've got your outflow tract right under the sternum at a high risk of being cut open as you go with your saw to open this. As I mentioned about the Gore-Tex, what I like to do at the end of my implantation is to put a 2-layer or sometimes 3-layer Gore-Tex where the drain will go between the 2 layers. As you can see, there's no opening of any of the other cavities, so it's just one cavity opened here, and then we'll close the chest as standard. So now just fast forward to where we're going to do the LVAD explantation at the time of transplant. Well, this is my favorite slide, so I always say that when you, as a surgeon, if you choose a good donor and choose a good recipient, do a good operation, then you will have good outcome, and this is what we should do for every patient. However, you're starting with a recipient who's very challenging, maybe a good recipient, but very challenging. You need to have a good donor, and obviously the surgery is going to be very challenging too. So you're already a lot of challenges to face. So in order to cope with all of that, my advice is to allow adequate time to explant the heart and the LVAD. Usually it's important to know what the estimated arrival time is, and when you have that, I usually allow at least 2.5 hours before arrival to start anesthetizing and start the case. Probably about 90 minutes anesthetic time, and the rest for the reduced sternotomy. This varies between DBD and DCD. So in ideal situation, you want to have a chest open with the heart out and the LVAD out, and you'll be waiting for the heart to arrive to do the implantation. But this is more and more becoming controversial because of the problems of possible airplanes crashing and the ambulances crashing to the deer in the road, and you may be not getting the heart over here. So we tend to not to do any anything that will crosses the point of no return until we have the heart in a close proximity. The point of no return would be the cross clamp of the aorta. Certainly, we do not do anything irreversible when the organ is in the air, and more we're having the heart actually in the hospital before we start doing the explantation. Most of the times we have the heart ready and cannulated and wait for the organ to arrive. It's important to be familiar with your team, know the people who are going to be helping you, because you need a lot of assistance, usually quite strong assistance required. This is a little trick that I do by putting some ethibond stitches on either side of the sternum, so that during the re-sternotomy I can pull them up to try to avoid injury to the structures below. But that also proves to be handy, because sometimes if you do the mistake, or not the mistake, but if you do get into cavities unintentionally, as I did about a year ago, where I ended up in the patient's aorta, you can very quickly approximate the sternum using those ethibond and then go on. And in this case, I did that and put the patient on bypass through femoral cannulation, circulatory arrest, and luckily the patient, the donor was a DCD heart, which could wait on the OCS machine for a time being until I managed to get a safe entry, and we did the transplant. The patient did extremely well and went home. Doesn't always happen though. Then after you've done that, important to maintain good hemostasis. I undermine the sternum on both sides so that I can get a retractor in. Then I move to the other side of the table, try to free up the structures. The structures that I immediately want to be freeing are better visualized from the left side of the table. Here you can see that I'm trying to, I hope you can see that I'm trying to go around the innominate. Then here I've got the innominate vein pulled up, and you've got the aorta. And in the next one, you can see that I have isolated the outflow graft, which I would go around and control with some sling. Then I move back onto the left side, on the right side of the table. I hope you can appreciate this. I'm trying to separate the PA from the chest wall. That's going to be very challenging because, as you know, PA is quite a fragile structure and you can easily damage it. And then when I've done that, I can put a proper retractor in and open the chest widely and do the cardiectomy at that point. So then we isolate the outflow graft, aorta, SVC, IVC, and if I can't approach the IVC because of the outflow graft, I go femorally, do a bicaval cannulation, put the patient on bypass, and at that point I would tie 2 ties around the outflow graft so that we will be able to maintain bypass. Then we would cross-clamp and excise the heart. Now, the way I do that immediately, I would decompress the left side through the atrium, through the right and then into the left atrium. But then the rest of the explantation is not conventional like a normal virgin heart. I'll start that and I would go from the top down. So starting from the aorta, PA, SVC, and work myself down through the roof of the atrium, left atrium, and down to the IVC. Now, this is a technique I described in my publication. So you can take the heart out in 2 ways. One is M blocks, which is you will free the heart up and then you would excise it out. Sometimes it can be very difficult, especially in the cases where the LVAD was put in through bilateral thoracotomy. Then the sagittal split comes into play, where I divide the heart into 2 in the ventricle, at the ventricle, and that will allow me to actually rotate the pump head so that I can get to see the pump head and try to go around it and separate it. Usually, in a lot of cases where by bilateral thoracotomy, there's a lot of Gore-Tex there, and it's a very difficult one to do, and occasionally I've had to actually try to chisel it off the chest wall because it just gets stuck. This illustrates what I've done. I'm sorry if the quality is not good, but its visibility is very poor when you're trying to do this. But this procedure actually saves a phrenic because you can do it under direct vision. And then you end up with something like this, which is blood everywhere. It is one of those procedures where you really pull and push and try to, tear things out. So at that point, you have a hemostatic pause, which during that, after that, you will have your heart arrived and be able to check it and trim it. This is the donor heart, and you can see I'm trimming it. Yesterday, we were talking about this little line that you would cut around, and you will be able to see right. So then comes to putting the heart back in, and that's a standard done the way I usually do. Nothing special about that, and that is the heart. And finally, before we all pack up and go home, we have to take the driveline out, and that's not an easy part either. It's usually very much stuck, and as you can see, we have got this little area in the middle which we open. We have to pull this driveline out. It's very difficult. Sometimes, as you can see, the driveline could actually be in the abdomen, so don't be afraid of asking for help when you're taking it out, because it could be attached to anything. It could be to the omentum, to the small bowel, to the stomach. It could be connected to anywhere. So in summary, safe explantation of LVAD starts at the point of implantation. Technically, there's little difference between sternotomy versus thoracotomy approach in terms of explantation, but both can be quite challenging. You need to use appropriate amount of Gore-Tex, not too much. The sagittal split technique can protect and can be useful in preserving your phrenic nerve, which is, as you know, is so important post-operatively. And then always prepare for the worst scenario. I always keep this in mind. Prior preparation prevents poor performance. So think of that, prepare, because you can get into trouble, as I did that one time. Hemostasis is quite a key, and as surgeons, we're responsible to align the moons. And remember, the moons have to align. You need to have a good donor, you have to have a good recipient, you perform good surgery, and then you will have good outcome. And I'll leave you with that. Thank you very much.
Why don't you prefer the destination therapy?
Why do we not?
Why don't, in England, LVAD, you do transplant even after LVAD.
Yes.
So why don't you do as a destination LVAD and not, you don't have to take this out at all?
Yeah, so we do both. We do destination and we do bridge to transplantation. But I guess you do it the way you do it with everybody. But in the NHS, we are still not doing destination therapy. It's only a group of patients who are not NHS that would do destination.
So is the approach for doing LVAD by thoracotomy versus sternotomy depends on whether it's a destination or?
No, it's not. It doesn't depend. Obviously, as I said, that when you have a destination therapy, and I guess it doesn't really matter which way you do it. If you're doing a bridge to transplantation, doing it through thoracotomy, it means that when you wake up in the middle of the night and you go back to do the transplant, you would use your reciprocating saw and you open the chest as you would do in a virgin chest. And that, yes, is good and gives you a bit of a sense of security when you go in. But as I said, the difference between that and doing it through sternotomy is very little, because although you get in very quickly, you will soon find out that as you're in, there's so much Gore-Tex, there's so many other things, like the pump would be stuck to the lung, the pump would be stuck to the chest wall, you will have parts of the Gore-Tex where it distorts the rest of the anatomy. So the anatomy is completely distorted. You know, you have the outflow tract which is pulled down. You don't know whether it's below the SVC or it's above the SVC. The phrenic, you know, some people go through the pericardium into the pleura and then put Gore-Tex there. So it makes it, in my opinion, makes it much more difficult. I'm a traditional surgeon. Cardiac surgeons used to doing sternotomies. For me, doing a redo sternotomy in the middle of the night, really not much of a big deal. And I can manage to get in. And when things go wrong, we know how to deal with it. So in my opinion, although the entry may be a little bit slower, but the rest of it, it becomes so much easier because you can use your blunt dissections, you can use your hand, and you don't have to deal with it. You try to buzz Gore-Tex off the pump. It's so difficult because you keep on buzzing and then you will end up damaging. It's like using a blunt knife when you're cutting something. You get into trouble.
And how do you manage anticoagulation before transplant?
So when we start at the time of bypass, then we will anticoagulate as normally. Before we start, they're on warfarin. We reverse it quite at the beginning because that VAD is going to go. So we reverse it. The problem is much less with the HeartMate 3 because you can't do that. So we reverse that. If they're on anything else other than warfarin, which nowadays we don't have them, then that's very easy. But then we will fully heparinize them and we'll take the whole thing out.
Okay, so
yes, so one of the special, so I showed you the incident where we went into the aorta and we had a difficult situation. And we always checked CT scans beforehand to make sure that what's the distance between aorta and the chest wall, where does the lie of your outflow tract, where is everything. And in this case we did. We looked at the CT scan and the CT scan looked very favorable. The aorta was miles away from the sternum. Everything was in a very good place. And then we had that incident where, as I opened, the aorta was so close to the back of the sternum, it just popped, the whole thing, blood everywhere. So then we went back and looked, and we realized that the CT scan that was done, and we looked at it, was within a month or two of the VAD implantation. And the operation was done a year and a half later. And in that time, the distance between the back of the sternum and the structures had reduced. So the whole geometry of the chest wall had changed. So the lungs have much better expanded. The whole, the area where the accumulation of fluid, that had disappeared. So the heart had moved up. So everything was stuck to the back of the chest. So as a consequence, we've done some studies looking at the serial CT scans of the patients to see whether or not how quickly things change following the LVAD implantation and the distance between the heart and the outflow tract and the back of the sternum. So that's an important thing. And so now, as a rule, every patient who's had an LVAD will have a CT scan within a year of that. So, and that is surgically, for me, the most important thing, because I want to know that is going in. And that is, I think, the most important examination that we do before we do the surgery.
And second question is it, do you take it as a protocol that when you're doing a post-LVAD transplantation, you go on femoral cannulation beforehand and then do the dissection, or you will always try to go for the routine antegrade cannulation on pump?
Yes.
So before opening the chest,
yes,
do you have such protocol that you need to go beforehand for the femoral cannulation?
It's not, we don't have a protocol that you should do, must do. But as I said, when we look at the CT scan, it gives us an idea of how bad things are. Because some of these, I'd be very lucky to get one of my LVAD patients coming back for a transplant. Usually somebody else, and you don't know whether they put Gore-Tex, where they put it, how they put it. So we look at the CT scan. If the patient's at risk, if it's not favorable, then yes, we will cannulate femorally to begin with. We go on bypass, just we deflate the heart. But don't forget, if you have to do that, then you have a problem of having to fully heparinize the patient. Then you go in, and I will tell you, it would bleed because everything is stuck. It really stuck. So
I think we are running short of time. Dhiren, you are the next anyway to come on stage. So you have to finish 2 minutes earlier now.
Speaker is Dr. Dhiren Shah. His topic is overview of long-term management of heart transplant.
At the outset, I would like to offer my gratitude to Dr. Kunal Sarkar, Devashish Das, and Dr. Pradeep for giving me this opportunity, and Society for Heart Failure and Heart Transplantation for giving this opportunity to deliver a talk. And my talk is long-term care after heart transplantation. And after heart transplantation, taking care of the gift of the life. You are getting a new life, and it is very important how you take care of that gift is what we are going to learn. No financial disclosure, but only one disclosure: be prepared to shed money for your patients. In majority of the patient, you will have to spend money for your patients in the post-op care, because majority of the patients will say, now I don't have money, how am I going to manage my complications? Till date, we have done 63 heart transplantation. I am sharing my learning. This is the eternal truth. The birth and death are constant. How much you live depends on how you maintain your life. And I think so heart transplantation is the biggest example that how you maintain your life between getting a heart and you die. It all depends on how much life you get, good life. So we all know that heart transplantation is the gold standard, is a miracle, but at the same time, surgery is the starting line for a marathon. It is a marathon, and you have to take care of that whole long marathon. We all know that more than 135,000 heart transplantation have been performed worldwide, and in India we have done now more than 1,700 heart transplantations. And over a period of time, the survival rates have improved significantly, and it is all because of this various innovations in the immunosuppressive drugs, understanding of the immunology, understanding of the rejections and everything. The overall survival has improved significantly. And with each decade, the survival rate is improving significantly in the heart transplantation. So after getting a heart transplantation, what is important? It is not just the survival, but the relief from the symptoms, improved functional capacity, and psychological well-being is our primary goal. And this is what we intend to give to a patient after doing a heart transplantation. So for long-term outcomes and long-term better outcomes, what is important is we need to understand what are the complications after the heart transplantation. And I'm very grateful to Dr. Siva. He has already enumerated a lot of points, and I'm not going to go into detail into that points. And Dr. Shashiraj has spoken about the pediatric, so I'm not going to go into the pediatric heart transplantation. So if you know what complication is going to occur at what period of time, then definitely you are vigilant and you will take care of that patient. The central challenge after heart transplantation is the lifelong immunosuppression. We all know it is a necessity, at the same time it is a double-edged sword also. And this is the standard immunosuppressive therapy that is given at the time of discharge, and after 1 year, this is the immunosuppressive therapy or the medical therapy that is the patient is on after 1 year. So what are the immunosuppression protocols that you need to follow? 3-drug therapy till 1 year, that is the standard protocol in majority of the centers, not in all the centers. 2-drug therapy after 1 year based on the patient condition and history of rejection during that 1 year period. Corticosteroid withdrawal can be successfully achieved in 3 to 6 months after heart transplantation in many low-risk patients. Those who are without circulating anti-HL antibodies, non-multiparous women, good HLA matching is there, or cross-match, LCM cross-match is there, and no history of rejection, and older heart transplant recipients. PSI, that is the sirolimus and everolimus, can be substituted for CNI, that is the tacrolimus, later than 6 months after heart transplantation to reduce CNI-related nephrotoxicity and CAV in low-risk patients. Lower level of CNIs in heart transplantation should be sought when CNI are used in conjunctions with MMF, because with this combination, lower levels are safe, associated with lower rejection rates and improved renal function. And substitution of everolimus or sirolimus for MMF earlier than 3 months after heart transplantation is not recommended. So tacrolimus is the key. You should know what are levels you are supposed to maintain after the heart transplantation, that is at 1 to 3 months, 4 to 6 months, 6 to 12 months and beyond 1 year. And at what interval time tacrolimus level needs to be checked after heart transplantation is also very important and kept in mind. In spite of good immunosuppressive drugs, still the patients may have rejection, and the incidence rate is almost 20% at the first year, and by end of 5 years, 45% of the patients will have rejection, and you should be able to diagnose it and you should be able to treat it. Another very important thing that we have learned over a period of time is preservation of donor sample for future DSA assessment of the patients. So in all our patients, we keep that blood sample of the donors preserved at our laboratory. So how to identify? Obviously, the EMB is the standard protocol. If you follow the standard protocol for first year, because that is the period wherein you get the maximum rejection, if you follow these protocols, then probably the chances of rejections are less. But yes, still, after 1 year also rejection is common. And nowadays we have, apart from EMB, we have this DSAs, we have this AlloSure and AlloMap available for detection of the rejection. If the patient has rejection, obviously we need to treat cellular rejection or antibody-mediated rejection. Standard form of therapy is available, and if you follow the standards, good outcomes are there. Graft rejection, obviously the early graft rejection is very high, from 2 to 28% is the incidence rate. But yes, after first year, the rejection rate goes down, and then at the end of 10 years, almost 10% rate of graft rejection is, dysfunction is there. And obviously we know what are the treatment for graft failure. Then infection, again a very important issues after heart transplantation because of the immunosuppressive therapy that we are giving. Almost by the end of 10 years, 91% of the patients will be having any major infection in their lifetime, that is in last 10 years, for which they got admitted and they got treated. So infection is the major culprit of the morbidity in the heart transplantation patient. And obviously, we should be aware at what point of time which infection is likely to happen in this particular patient is very important. If you know all this infection pattern, then it is very easy to catch hold of the infection. Cardiac vasculopathy, allograft vasculopathy, again, a major component in the later part of the heart transplantation wherein the morbidity and mortality is mainly because of CAV. So by the end of 10 years, 50% of the patients will have CAV, with 32% mortality at the end of 5 to 10 years is because of CAV. And to understand that CAV is very important, what are the reasons for CAV and how to prevent that CAV is very important. So if any patient, CAV is an entity wherein patients can be totally asymptomatic. Sometimes patient may have a decreased exercise tolerance, or there may be heart failure, or there may be arrhythmias, unknown sudden arrhythmias, diastolic dysfunction, sudden cardiac death. This all can be because of CAV. And CAV is a generalized endothelial thickening or muscle thickening of the coronaries. It is not atherosclerosis where it is eccentric, or at some part it is the generalized thickening of the wall. And it can be identified by angiography, and the better modality is IVUS. And in IVUS, what is very important is if the patient is normal, the normal baseline study at the end of 4 to 6 weeks after heart transplantation. If the thickness is 0.25 to 0.5 mm, intimal thickness, it is normal. And in normal patient after 1 year or 2 years, the same thickness will persist. But if you are doing IVUS at the end of 2 years, and if you find that the thickness has increased by more than 0.5 mm, then definitely that suggests that CAV has already started. And there are different variants of CAV, type A, type B1, type B2, and type C, based on which the outcomes are there. So how to deal with CAV? Aspirin is only indicated prophylactic antiplatelet drug which has shown the reduction of progressive CAV by almost 37%. So aspirin has to be there in each and every patient of a heart transplantation. Statins, immunomodulator effect is there. Immunosuppressive drugs, so in this, PSI or mTOR inhibitors are very important, and if you find any evidence of CAV, the early part of your heart transplantation patients, then definitely switch over from this CNIs, tacrolimus, to everolimus or sirolimus drugs after 1 year of your transplantation. Revascularization has not much benefit. If you do a CABG, high early mortality up to almost 40%. So definitely, ultimately, this patient using creatinine levels and need to reduce tacrolimus dose. Again, CAV will be this mTOR inhibitors will be very helpful. So if you are starting sirolimus or everolimus with tacrolimus, then the combined level of 4 milligram is good enough when you are checking the blood levels. So 4 to 6 combine of everolimus and tacrolimus is good enough. That is how you can reduce the CNI nephrotoxicity. Repeat rejection and particularly AMR is reduced by using mTOR inhibitors and to maintain levels between 3 to 6 nanogram per ml. Chronic disease, kidney disease, obviously, by the end of 10 years, 19% of the patients will have renal dysfunction, may require dialysis, and obviously the patients requiring dialysis, the overall mortality is high. And so for surveillance, what is important is urine analysis and spot urine albumin creatinine ratio should be obtained at least yearly for all the transplant patients. So at every annual checkup, this needs to be done in all our heart transplant patients. The incidence of malignancy, again, a dreaded complication of long-term immunosuppressive drugs. It increases significantly after 5 years, almost reaching 28% at the end of 10 years, 3 to 4-fold greater than the age-match controls. Skin cancers and lymphoproliferative disorders are the major culprit of malignancy in these patients. And 24% of the death after 5 years are directly linked to malignancy in heart transplantation. So how to deal with these malignancies? Should we reduce the immunosuppressive drugs? Yes, again, here, the CNIs have more chances of malignancies than the everolimus or PSIs. So again, substituting or using everolimus or sirolimus after first or second year of our transplantation can reduce the chances of malignancies also. Age-appropriate screening for breast, colon, prostate cancer, as well as skin cancer should be done at a regular interval. Regular screening of Epstein-Barr virus load is important. And chemotherapy or NTB, monoclonal antibody in case of post-transplant lymphoproliferative disorder is good. New-onset diabetes after heart transplantation, almost in the range of 5 to 50%, and you have to treat accordingly. Management of neurological complication after heart transplantation. Many heart transplantation patients may have seizures, which may include because of the, again, tacrolimus toxicity. Again, you have to decrease the tacrolimus level, manage the hypomagnesemia, and majority of the seizures they reduce. Another very important entity is the posterior irreversible leukoencephalopathy, that is a PRES after heart transplantation. Again, here, the culprit is CNI. If there is a CNI toxicity, obviously some patients may have this posterior reversible encephalopathy, PRES, and you need to just reduce the dose of CNIs and you can treat this encephalopathy. Hypertension, obviously, because of immunosuppressive drugs, can happen. CCBs, ARBs, and AC inhibitors are the drug of choice in heart transplantation. Beta blockers, as far as possible, should be avoided in post-heart transplantation. And obviously, when the patient is on corticosteroid for first year, the chances of calcium depletion is there. So exercise and bisphosphonate in the first year of heart transplantation is very important to maintain the calcium level and bone density issues. Other complications, these are in our experience that we have experienced, is the pulmonary embolization. Because of the repeated neck veins cannulation, sometimes the neck veins, they develop a lot of clots. And that clots, they can dislodge, go into pulmonary veins and can have pulmonary embolism. We had one such patient. Infective endocarditis post-EMB. Right now we have one patient who has an infective endocarditis in RV wall post-EMB. Aspergillus infection is quite common after heart transplantation, because if they don't take care of their residents, they don't take care of about their environment, then the chances of aspergillus is very high. Parvovirus infection is very unique. Diarrhea due to cryptosporidium is quite common as compared to what we think about. And persistent RV dysfunction due to high PVR and its management. There are few patients in whom the PVR doesn't reduce significantly, and then there are issues of managing that patients with, again, high PVR. And misdiagnosis of a transplant patient and its wrong management in the peripheral center. It is one of the biggest issue. I lost one patient because of that. Patient had rejection, RA-RV dysfunction. The peripheral physician thought it is pulmonary embolism, treated it as a pulmonary embolism without referring this patient to us, and ultimately we lost that patient. So key to longevity is surveillance and adherence. Frequency of routine test and clinic visit is very, very important. Advice to inform the patient that any small change in their symptoms, kindly inform us. And this is the book that we hand over to the patient every time when the patient is getting discharged, with the dates mentioned that on this date you have to get this test, on this date you have to get this investigations done. And patient education is of paramount importance. Support group and heart transplant groups are very important. And this is our WhatsApp group, wherein all our heart transplantation patients are there, and they talk with each other. They celebrate the occasions, they celebrate birthdays with each other, which helps them to really boost them up. And recommendation on pregnancy after heart transplantation, obviously for the first year is not recommended. After first year, yes, they can plan, but again under the surveillance of the whole team. And last 2 points, these are very important points from the society perspective. If you go deeper dive, the psychosocial journey of heart transplantation is an emotional and psychological roller coaster for a heart transplantation patient. It is not just a physical one, because they go through various anxieties and depression and survival guilt. And this can be managed only by the strong family and social network, and obviously the transplant support groups and psychologists. And this is where I would feel that as a society, SFHC society or INSHC society, can work to make the life of these heart transplant patients better by creating these groups and creating these awareness programs. Similarly, economic impact, immunosuppression, clinical visits, tests, insurance challenges, and employment, all this can lead to a great financial impact on the life of a heart transplant patient. These are the future and ultimately the take-home message. The pillars of modern long-term management are personalized immunosuppressive therapy. Standard therapy everybody knows, but obviously from patient to patient, the immunosuppressive therapy can change. Proactive surveillance and risk management is very, very important, as I have already discussed. And holistic and multidisciplinary care is the paramount important and one of the most strongest pillar for long-term better outcome of heart transplantation, which includes collaboration, holistic approach, patient care, and education is important. Thank you very much, and I appreciate it.
Thank you. Thank you very much. We call the end of this session.
Thank you everyone for this wonderful session on heart transplant. We are going to start our next session on immunology and follow-up after heart transplant. I would like to request the chairpersons to please come on stage. Dr. Rajagopal S., Dr. Jacob Abraham, Dr. Karunakar Pari, Dr. B.B. Mishra, and Dr. K.M. Mandana. Can I please request Dr. Rajagopal S., Dr. Jacob Abraham, Dr. Karunakar Pari, Dr. B.B. Mishra, and Dr. K.M. Mandana.
So I invite Dr. Jabir for the talk. He'll be speaking on remote monitoring and cardiac rehabilitation, the missing link of heart failure management.
Good evening. We have gone a long way in the treatment of heart failure. Great improvements made by medical therapy, device therapy, and surgical therapy. But still, there is a long way to go because still it carries a high mortality, heart failure. We discharge the patient, the in-hospital mortality in many of the Indian registries is close to 7 to 9%, but the one-year mortality is close to 20%. So there is a big gap at the time of discharge, and then we are losing large number of patients at the end of the 1 year. Possibly, there is a big problem because we are not able to follow up the patients well. A busy cardiologist, interventional cardiologist, a surgeon, it's extremely difficult for a frequent follow-up program, and we do not know what's going to happen or what's happening to the patient once he is discharged. The strong heart failure data, it says if it's an aggressive follow-up after discharge, that is 1 week, 2 weeks, 3 weeks, 6 weeks, with all the guideline recommended medical therapy on board by 6 weeks and possibly maximum tolerated therapy, there is a significant reduction in heart failure hospitalization at 180 days. So is there a role for a cardiac rehabilitation program which has been proven to be a very effective treatment modality and which should be an imperative component of all cardiac therapies, all cardiac diseases, but the take-up is extremely low. If you look at the cardiac rehabilitation recommendations, it's a class 1A recommendation by all the societies, the Europeans and the Americans and the heart failure societies. For patients with heart failure who are able to participate, exercise training is recommended to improve the functional status, exercise performance, and the quality of life. So it's a class 1A recommendation, but the cardiac rehabilitation program, to be honest, my hospital cardiology department do not have. We are treating large number of heart failure patients, one of the biggest heart failure clinics. So even now we don't have a structured cardiac rehabilitation program. So it's extremely poor uptake in globally as well as in India. Globally, 1 in 10 is referred for it, and India referral to cardiac rehabilitation is negligible. So if you look at the 4 pillars of therapy, I'm sure everybody knows the 4 cardiac drugs for therapy, and this may be considered, the cardiac rehabilitation, as the 5th pillar of therapy. So recent advances in the post-discharge monitoring in cardiology, axis explanation, a remote, all the concept was a little accelerated during the COVID era when we were not able to see the patients. So the remote care for the underserved areas, early detection of life-threatening issues like the arrhythmias, a change in the blood pressure, a disease decompensation. Because you catch them early, you can treat them better, you can avoid a heart failure hospitalization, you can avoid even a mortality, and you can improve the quality of life. So cost and outcome improvement by reducing hospital admission, huge savings by optimizing discharge and improve the patient's quality of life. So you can have, this is all made possible because of the introduction of the digital healthcare platform. So this has revolutionized the concept of cardiac rehabilitation program. Technological landscape, you have the non-invasive things like wearables, the smartwatches, step trackers, pulse oximeters, glucose monitors, and also a handheld ECG monitoring device, as well as the invasive one. We have plenty of data on the remote heart failure monitoring system like the CardioMEMS, pulmonary artery pressure monitoring, the continuous glucose monitoring, the implantable loop recorders, pacemakers, and we have the monitoring from the pacemakers as well as the defibrillation. But if you look at a cost-effective thing, a software plus the use of a weight measurement, a regular or daily weight measurement, looking at if there are symptoms, looking at monitoring in the electrocardiogram, pulse oximeters, heart rate, this will give an idea about what's happening to the patient. So a self-care of weight, blood pressure, heart failure symptoms, nutrition, correcting the appointment, reminding the patient about the appointment, promoting him to meet his attending physicians at the correct time of appointment, and ensuring the continuous supply and intake of medication. So this is one app. This was made by Life, is made by the Lupin Digital Health, plus their cooperation or rather understanding with the American College of Cardiology. This ecosystem comprises of a patient and a doctor-facing application supported by a 5-member multidisciplinary team. There is a care manager. This care manager will be constantly in touch with the patient through the app, and he'll discuss, inform them regarding the symptom and the medication adherence. And a cardiotherapist is a physiotherapist or cardiac physiotherapist. They can educate regarding the effort tolerance improvement, and the health coach who can tell about the nutrition and lifestyle coaching, and of course a mindfulness coach where stress and anxiety management can be also managed. So all these people will be in touch through the app, and it's basically there's a particular interval. They'll have a group activities, and during the early part, first 3 months, there will be real one-to-one interaction also. So the patient details are uploaded and reviewed by the care team, and the patient's clinical cohort identified based on the clinical inertia. What I understand is that Dr. Manoj Dureraj, I don't know whether he's here or not, he is using this thing in large numbers. Dr. Dhirensha is using, that's what I know. So it's a WhatsApp-enabled thing, AI-driven, and a call-assisted. And all these devices which is given to the patient or used by the patient, some of them the patient has to buy also. For example, the handheld ECG monitoring system, the watches, the smart watches, they will be given when they take this program, or if they are a part of the program, they'll be given a weighing machine. So weighing machine, you have the glucose monitors, the blood pressure monitorings. So all these things are Bluetooth enabled devices, and when they take the measurement, it is automatically loaded onto the system. Is there any global evidence supporting the technology-led home-based rehabilitation? We have plenty. So can see the Poland's National Health Fund in acute myocardial infarction, a reduction in the major adverse cardiac events by close to 50% and mortality by close to 40%. And there is in heart failure, the German data of 571 patients, the average length of the hospital stay, they could reduce it by 36% and an overall mortality reduction by 30%. And John Hopkins, they are in acute MI, it's 1,664 patients, significant reduction in the readmission. American Heart Association, it's 36% lower hazard of mortality. And European Society of Cardiology, they could improve the 6 minutes walk distance, which improved by 36%, and the quality of life improved by 26%. So it's almost equivalent or much better than the 4 pillars. So each trucks of the 4 pillars of therapy, the mortality benefit and the heart failure hospitalization reduction. And the remote cardiac remodeling, the remote cardiac rehabilitation is now gaining big momentum in India. The Accent's post-ACS study, small number of patients, there was a reduction in the systolic blood pressure by 8% and diastolic blood pressure by 6% after 90 days. And the Life reported a 31% improvement in the quality of life. The Restart post-ACS study, there also the blood pressure reduction, the HbA1c control, that all showed a improvement. The multi-center clinical study in heart failure, that is with a digital platform, the India's largest real-world evidence in heart failure regarding the remote cardiac in rehabilitation. So the largest one, multi-center, which has 2-arm, prospective observational study, and the second arm, there is a comparison with this thing and the standard care. So it assessed the software-driven interventions impact on the heart failure patient's quality of life, versus the standard care and measure the cardiac-related hospital admissions and unplanned visits over 6 months. And the secondary objectives of major adverse cardiac events, functional capacity, the biomarkers, and patients' compliance over 6 months. 540 patients on this live. So this is only an interim analysis data. Majority, close to 2/3 it is 63% hypertensive patients, 41% diabetic patients, CKD 13%. So you can see it's a pretty high rate of comorbidities which is expected in the heart failure patients. And the intervention-wise distribution, that's a real intent scenario, 60% on only medications, bypass grafting in 30%, PCI in 12%, and the device therapy, which the uptake is still a lower one, it's 5% when it is close to 20 to 30% in the Western population. And the blood pressure monitoring, BP goal achievement status was improved with a 29 or 1/3 or 30% of the patient, there was an improvement in the blood pressure monitoring. The blood pressure remains stable. And the weight monitoring, without a gain in the weight, on average, they record around 8 to 12 weight readings per patient for a month. The improvement or the goal achieved stabilized in close to 60% of the patient. And this cardiac therapy, the health coach and the life care manager sessions completed for all patients. Cardiac therapies for 224, health coach in 473, and life care manager in 400. It's an ongoing study. It's an interim data. So you can see the number of patients and the clinical outcomes. It's only, it's a, what do you call, data, the randomized control data is not yet available. This is the observational data. You can see the baseline blood pressure of 116 at 19 days, it's close to 116. So the blood pressure is well maintained. It's not statistically significant. And the maintain the weight, which is close to the dry weight, you can see it's 68.6 plus or minus 14.3, and then the baseline to final it is 66.8 plus or minus 4.6. The mean improvement is 1.8 kilogram. There is no significant fluctuation in the weight gain. That means the patient is not deteriorating. And the 6 minutes walk test, there is a 350 has become 370. Again, there is no statistical significance. The numbers are less. And the quality of life score, the SF36 score, there is a 6-point improvement from 48 to 54.2. Rehospitalization rate was 7%. The annualized rehospitalization rate from the major Indian registries, it's close to 20 to 25%, and the mortality is only 4.32%. So to summarize, 500 heart failure patients participated in this trial with strong engagement in the education, health coaching, and exercise therapy sessions. Education and nutrition sessions had the highest reach, and more than half of the patients achieved stable or improved weight and BP status over the program period. And they experienced clinically meaningful improvements in the 6 minutes walk test, walk distance, and the quality of life score, reflecting better physical function and well-being, though these changes were not statistically significant. The cohort had a high burden of comorbidities, which is expected. The red alert and SOS alerts indicated frequent monitoring. Acute weight gain alerts reflected timely intervention and course correction. And these insights can collectively highlight the value of a remote cardiac rehabilitation system or a monitoring system. Because there is nothing implanted, it is not like the CardioMEMS, it's simple measurements, but these simple things, by monitoring remotely, we can keep the patients under surveillance, under control, or clear or what you call proper observation by the attending physicians. Always the data can be transferred to the physician, he can interact with the care team, he can interact with the patients. I think this is going to change the scenarios, not a very costly affair also. Thank you so much.
Thank you, Sheikh. It's a very thought-provoking topic you have discussed. Any question from the house? One question.
Dr. Dhiren is using it, isn't it?
Yeah.
Excellent talk. Just wanted to add 1 or 2 points. We have been using it, and the initial resistance from the patient is always the cost factor. But when you make them understand that by using this platform where the cost is very minimal, you're reducing your rehospitalization, and the cost of that rehospitalization is going to be far more. Then majority of the patients, they get ready for this. And we have seen a significant difference in overall outcome of the heart failure patients. Along with that, what we have added, since last 10 years, we are running an H2H program, that is hospital to home program, wherein if the patient takes a package for rehabilitation, then every 15 days, our nurse or a medical officer visits their place, examines the patient, and they report to us every 15 days. So we have made a periphery of almost perimeter of 1,000 kilometers, wherein we cover all our patients in H2H program also. So again, it is a fantastic mode wherein you can reduce the rehospitalization of a heart failure patient, and the burden is huge. You have a huge burden of heart failure patient in our society, and I think so this may be a game changer.
And it's impossible for the cardiologist to follow up very frequently. It's not easy.
Not.
I just wanted to ask you one thing. What about those people who are not tech savvy? Is it a problem for them to use this device?
See, I think so majority of the patients nowadays are using mobile, and it is all through the mobile only. So they don't need much thing. And another new modality which I have started using is the biosensor. It's a life sciences from Bangalore. Immediately after the surgery or immediately after the angioplasty, if the patient is high risk, we want to monitor the ECG, blood pressure and everything from home. I can continuously 24/7 monitor the ECG. And if there is any alteration in ECG, they alert the patient immediately, they rush to the hospital immediately.
I think that is the future. Yeah. This is the future.
Yeah,
Dr. Manoj.
Definitely, I think it's a game changer. In my unit, for my center, I've recruited around 118 patients who are the surveillance wing and 80 patients who are in the non-surveillance wing. All are LV dysfunction, less than 35%. So almost 200 for my own center.
In the randomized arm or in the observation?
In the randomized and observer. Randomized is 118 and
observation is 80.
80, yeah. So almost 200. And what I've found out is that I'm quite confident to increase the, reduce the frequency of the visits. So the interval between, like, I used to call them every 2 weeks to 3 weeks, 1 month. Now I started calling them 1 month, 2 months, 3 months. So that confidence level has come because quality of life is improved, 6-minute walk test is improved, and also the repeat hospitalization for heart failure has reduced. So I think this is a game changer in the next 2 years once it's published.
Thank you, Chair. It's a very good presentation. Next speaker.
Invite Dr. Nagamillesh for the talk on management of sensitized patient in transplantation, heart transplant.
So good evening, everyone. So sensitized patient or problem for not only pre-transplant, but also for the long-term post-transplant. So what is sensitized patient? Sensitized patient is presence of anti-HLA antibodies before transplant. So it can increase waiting time for the transplant, and also the post-transplant, they can have complication like AMR, CAB, and also death. So there are many reasons for patient get sensitized before transplant. It could be pregnancy, multiple blood transfusions, previous organ transplant if you are doing retransplant, or sequential transplant if you are already done liver or kidney, ventricular assist device, vascular allograft, valve implants, and previous open heart surgeries. So all these patients can have experience hyperacute or accelerated acute antibody-mediated rejections. So how to assess these patients? The best way of assessing this patient by using panel of HLA typed cells using CDC or solid phase assay. So PRA percentage is calculated based on the percent of positive reactions from the tested panel, and CPRA or calculated PRA is calculated based on the frequency of unacceptable antigen in various ethnic donor population or from the community. So this we don't have in India because we are doing fragmented way. So this part of the country is doing something different, Bangalore is doing something different. So we are not integrated. So we don't have at present the calculated PRA that's important for assessing these type of patients. So what is this HLA antibodies? There are two types of antibodies. One is HLA-1, that is HLA-A, B, C, class 1. And this is expressed in all nucleated cells and recognized by CD8 cytotoxicity cells. And class 2, which includes HLA-DR, DQ, DP, which is expressed in B cells, monocytes, and other antigen-presenting cells, which is recognized by CD4, also called the helper T cells. So this class 1, class 2 HLA proteins are encoded in set of highly polymorphic gene with many genes on the short arm of the chromosome 6. So that is why this is so polymorphic. Each individual in the community is different because of this reason. So the sensitization can affect all part of the organ transplantation. Preoperatively, it can increase the donor waiting time and compatibility, and also the post-transplant, it can cause AMR or CAV. So UNESCO study shows that the allo-sensitization did not independently predict worst post-transplant outcome among patients who are on mechanical circulatory support. But patient without mechanical circulatory support, allo-sensitization does increases the post-op survival, reduce the post-op survival and the complications. So what is significance of the PRA? PRA more than 25% is supposed to increase the significance, reduce the survival of 5 years post-transplant. At 5 years, the survival in patient with PRA more than 25% was 65% versus 74% those who are PRA less than 25%. Means almost 10% reduction in survival people who have high PRA. So that's the reason this cutoff was postulated. So managing this sensitized patient, one is desensitization therapy may be considered to increase the chances of negative cross-match and expand the number of suitable donors for this patient and also improve the post-transplant outcome. Not that if somebody is PRA positive, you can't do transplant. It's only the number of donor available for this recipient will reduce significantly. So potential target for desensitization therapy are B cells, plasma cells, antibodies, and complement activation. So all these are the important component of human immune response, and basically these are the target for the desensitization. So what is the strategy for desensitization? We have to remove all antibodies, inactivate them by giving IVIG, or downregulate this by producing the antibody producing cells by giving rituximab and related drugs. So who is the reasonable candidate for desensitization therapy? So even though any level of detectable antibodies are considered sensitized, but the PRA more than 25% or CPRA more than 50%, and MFI of 3,000 to 5,000, some centers consider only after 5,000, is considered a clinically significant sensitization. Also, if you have a recipient or multiple cross-matches coming positive, you're not able to select donors, so these are the cases where you need desensitization. So this is the flow chart when to desensitize. You obtain the CPRA, what in our country have only PRA. The CPRA of more than the less than 20%, you don't require any treatment. The patient can straight away go for transplant. Or PRA less than 10%, what we use here. CPRA between 20 to 50% or PRA between 10 to 25%. They are high rate of post-transplant mortality, so you have to be careful it doesn't require any desensitization, but monitor this patient regularly with a DSA 3, 6, 12 months of post-transplant, and monitor closely for rejection. If PRA is more than 50% CPRA or PRA is more than 25%, which increase the wait time and the waiting list mortality, these are the group you require desensitization. So as I told you, either you remove or neutralize or reduce production. So coming to remove these antibodies, so plasmapheresis is the one. There are many ways of doing plasmapheresis. One is therapeutic plasma exchange, double filtration plasmapheresis, immunoadsorption plasmapheresis. I don't know what other centers do, but we do only therapeutic plasma exchange. I think this is the only thing available in our country, I think. So this is just to filter the plasma, remove plasma, and they replace with the albumin or fresh frozen plasma. Double filtration plasmapheresis is a apheresis technique where you selectively remove the large molecule from the plasma and return the filtered plasma back to the patient. Immunoabsorption or plasmapheresis is selectively remove the specific antibody and immune complexes from the blood. So therapeutic plasma exchange is what commonly done. So here typically we remove 1 to 2 plasma volume with fresh frozen plasma or albumin. The plasma volume of that particular recipient can be calculated with this formula. So either you remove 1 time or 2 times the plasma volume. It removes the alloantibodies from the circulation, but it does not remove alloantibodies from the extravascular compartment. That is the problem with this. Usually it is very safe procedure, but you should be careful. It can cause hypotension, infection, sepsis, and other things, bleeding. So intravenous hemoglobin should be given to neutralize whatever the antibody is present, either intravascular or extravascular. So in this, the 33% reduction can be seen in 1 week, and by 4th week, a significant amount of alloantibodies are neutralized. So, and the combination of therapeutic plasma exchange and IVIG is reported to reduce incidence of rejection and also the positive cross match. So rituximab is a monoclonal antibodies against B cell marker CD20. It depletes the B cell lymphocyte through combination of antibody dependent cell cytotoxicity, complement mediated lysis in induction of apoptosis. So this can reduce from 70 to mean of 70 to 30% of alloantibodies, and also increases the chances of negative cross-match. In combination of therapeutic plasma exchange and IVIG, rituximab is the most the common combination to desensitize patient. The bortezomib, it is a reversible 26S proteasome inhibitor, which act by disturbing the protein processing and degradation, which can act on the mature plasma cells, and it can reduce significantly more than 50% within 7 days of the protocol. So what is important is rapid antibody reduction compared to other protocol like IVIG and rituximab. The only problem with this, it can have little more incidence of infection. So these are the desensitization techniques, strategies, but what is commonly done is therapeutic plasma exchange, IVIG, and rituximab. So these are the different protocols which can use either from the inpatient or the outpatient. If you have outpatient protocol, you can give IVIG 0, 1, 30, 31, and also CD20 like rituximab can be used. That's what available today in the market. Out in the inpatient setting, you can start with the plasmapheresis. You can give bortezomib, and this can with this protocol. And if somebody is resistant, tocilizumab can be given in that. I'll show you then later the protocol. So I'll skip this because I already told about this. So those who require urgent desensitization, the patient who are already on life-saving devices and the cross-match is coming positive, you can start them on tacrolimus, mycophenolate, and prednisolone before transplantation. A recipient undergo plasmapheresis, that is double plasmapheresis around 12 hours before the surgery if time is available. So you can give rituximab around 200 mg if it's more than 40 kgs or 100 mg before less than 40 kgs. And IVIG 2 gram per kg total should be administered. If you don't have time for this method, because you have less time for the transplant, you can do a plasmapheresis on cardiopulmonary bypass. So urgent desensitization has a lot of advantage. So 1 year patient survival and graft rejection rate was analyzed. It found the sensitized recipient was sent the first year survival is 76% for the sensitized patient. There are 8% antibody-mediated rejection and 60% acute cellular rejection. But there's no significant difference in 1 year survival in either those who are sensitized or those who are not sensitized by this technique. So this is what desensitization, perioperative desensitization technique. So they tell you the overall strategy how to do it. First you assess anti-HLA antibodies. So identify the strength by MFI and determine CPRA. So if it's less than 50 to 70%, if it's more than 50 to 70%, they go for prospective cross-match. And if they are positive, they go for decide on the desensitization strategy. If CPRA is 50 to 70%, either you can adopt either inpatient or outpatient, as I told you. So you do plasmapheresis and botuximab. If they are resistant, if you still PRA is more than 50%, you can give a tocilizumab. In outpatient, you give IVIG and rituximab. And if still PRA is more than 50%, you give plasmapheresis and botuximab. If the PRA is still persistently elevated, you can give tocilizumab. So to interpret the cross-match, the flow, because it's very important in this setting, negative flow or negative CDC, they undergo transplant. Is positive flow and negative CDC considered for desensitization, and positive flow and positive CDC do not transplant. So this is what we have to adopt when we do a transplant. So post-transplant DSA monitoring is important. So when patients are transplanted in the presence of DSA, frequent post-transplant monitoring is warranted. It has been shown that patients who have DSA MFI decrease during the first 2 weeks after transplant do not develop AMR, while patients with a persistently elevated or increasing MFI DSA, they have higher incidence of AMR. So to conclude, the sensitization prolongs the pre-transplant waiting time associated with the post-operative complications. Desensitization therapy can be considered to increase the negative cross-match, expand number of suitable donors, and improve post-transplant outcome. The current strategy is to remove the alloantibodies or downregulate or neutralize these antibodies. Thank you.
Thank you, Dr. Nagamalesh. Does routinely use basiliximab and ATG is used as an induction agents? Does these drugs have any beneficial effects on patients with raised PRA or sensitized patient?
So that induction we give for all the patient, but only thing is what we see clinically. If you are doing a prospective cross match, so irrespective of the PRA, doesn't make much difference. If a cross match is negative, it doesn't mean anything. Like you can still undergo transplant. The only thing is you have to monitor these patients. So we do induction for everybody, not for only those who are PRA positive. I don't know, each center, they have a different way of doing it. Some patients don't give nowadays induction. Only if there is a high risk like PRA positive, or in those patients they give induction.
questions? Okay, thank you. Thank you, Dr.
Thank you.
Kumar. We'll move on to the next talk. That's the last talk of the section. Non-invasive monitoring in non-invasive monitoring of rejection by Dr. Jasmeet. Oh, sorry. We have the talk by Dr. Talha Meran. Dr. Talha. Immunosuppression strategies, routine, special circumstances.
Good evening, everyone. Thank you again to all the organizers for the kind invitation. The topic allotted to me is immunosuppression strategies, talking about the routine strategies, which has already been discussed, so I'll probably skip that, focus more on the special circumstances, and maybe also get a chance to answer the question that was just asked by one of our chairs about induction therapy. So I don't have any relevant disclosures related to this talk. We've all seen these slides today. There's consistent improvement in survival post-transplant over the last 30 to 40 years. Much of this improvement, the credit for it must go to the immunosuppressants post-transplants, with the initial discovery of cyclosporin in the early 1980s, followed closely by the availability of ATG around that time, and the mid-90s saw the introduction of tacrolimus. So over that period, the post-transplant outcomes have significantly improved. Now, when you talk about this topic, induction immunosuppression, I wanted to just separate this out, induction immunosuppression and maintenance immunosuppression regimen. So initially, we'll just focus on induction immunosuppression. Now, all over the world, if you look at the ISHLT transplant registry, roughly about 51-52% of the patients receive induction therapy. It's used more commonly in North America as compared to Europe, particularly the ATG molecule in North America is more commonly used. If you look at any difference in outcomes between patients who are given induction therapy, so if you look at this, the percentage of recipients experiencing rejection between the discharge from transplant and 1 year follow-up is actually slightly lower in the no induction group. However, this data can be flawed because generally in the Western population, as I said, the centers generally do not perform induction therapy in patients who have a lower risk category. So if you're lower risk category, you probably will not have as much rejection, and that's probably what the difference is showing here in the ISHLT registry. If you look at the survival curves, no significant difference. The only difference is if you focus on the green and the red curves. That's the green is for the ATG, patients who receive ATG induction, and the red curve is for the the interleukin-2 receptor antagonist, that's your basiliximab. You will see that only these two groups have shown a significant survival difference in favor of polyclonal induction. But mind you, these are unadjusted analysis, not accounting for several modifiers that can impact this outcome. So, closer look to try to come to an answer to this question, whether induction therapy affects mortality or rejection. So this is again a retrospective review of around 36,000 patients from the UNOS database, slightly older study between 2000 to 2017. And out of which around 52% received induction, and then they analyze these outcomes based on whether they received induction therapy with T-cell depleting agents. So your T-cell depleting agents are your ATG versus your IL-2 receptor antagonist. So what they found is the T-cell depleting agents did not show any effect on mortality, however, definitely reduced odds of rejection at 1 year, which was statistically significant. The IL-2 receptor antagonist arm, in fact, saw a slight increase in mortality, but again, no impact on rejection. So overall, the ATG induction group showed a slightly, a much better chance of improving rejection at 1 year. This is more contemporary data. This was presented in the ISHLT meet a few months back. This is a single center data from Innova in USA. Retrospective single center review between 2013 to 2023, smaller group, 132 patients, out of which 46% of the patients received this center used only ATG for induction. These were the primary and secondary outcomes. The primary outcomes was acute cellular or antibody-mediated rejection. And much like the previous slide, ATG recipients had a lower rejection rates, primarily driven by a reduction in the incidence of cellular rejection. There was no impact on any of the secondary outcomes, including development of de novo DSAs, donor-specific antibodies, and no impact on allograft survival as well as all-cause mortality. Now, if you look, if you think about using induction, this is a particularly high-risk subset of patients who require mechanical circulatory support prior to transplants. We believe that MCS can be a major sensitizing event in the pre-transplant period. So this study was particularly aimed at looking at these patients, whether induction therapy confers any survival advantage. So roughly around 4,000 patients from the UNOS database between 2018 to 2022 who required pre-transplant MCS. So all of their patients were either on ECMO, balloon pump, HeartMate 3, Impella. The comparison was then made between no induction versus IL-2 receptor antagonist therapy or versus T-cell depleting agent. And over here, this is the major difference between the previous slides and this study. The 1-year survival was actually worse among the patients who did not receive any induction. So that means the patients who receive induction, actually their 1-year survival was much better. And looking at rejection, the rejection was significantly lower, again, in the T-cell depleting agent group, so the ATG group. So this is similar to the previous studies. However, this is the first time we've seen a survival difference. So a little bit of mixed outcomes depending on what population you're dealing with. So if you want to apply it to an Indian context, now, this is the Western data, right? So this shows definitely induction therapy improves rejection. At 1 year, we are not too sure about the survival benefit, except maybe in patients who require pre-transplant MCS, particularly with ATG. As we all know, when we are managing rejection, the best therapy for rejection is prevention. So that is the key here. However, in the Indian setting, we are actually fortunate that we don't see so much of rejection. We see more of infection. So we need to interpret this Western data with a little bit of caution and base your decision based on your center's preference and your individual patient characteristic. Definitely, I would say that you must use induction therapy in certain higher risk settings, sensitized individuals, positive cross-match. If they have pre-transplant MCS, especially if they are younger, they have a more robust immunity, most chance of developing a positive immune response, and also in multi-organ transplants. So now changing gears, talking about maintenance immunosuppression. Now, this is again from the ISHLT thoracic transplant registry, looking at maintenance immunosuppression that is used as expected all over the world. Tacrolimus and mycophenolates are the most common, followed by corticosteroids, prednisone. Some of them are still using cyclosporin, sirolimus, and azathioprine. Does the survival differ? Not really. So much like induction therapy, your choice of maintenance immunosuppression does not really impact your patient's survival, conditional on survival to 1 year. However, there is a significant difference in the incidence of rejection favoring the tacrolimus group as compared to the cyclosporin group. So cyclosporin plus MMF, much higher chances of rejections as compared to tacrolimus plus MMF. And this is probably why we see this trend. Over the years, the use of tacrolimus going up and the use of cyclosporin going down. If you look at the use of MMF and prednisone, they have pretty much remained stable over the last 2 to 3 decades. Now, when you talk about special circumstances and especially in terms of maintenance immunosuppression, you would have to think about the complications, because that's what you are going to do. You're going to react to the complications, or maybe try to predict complications and try to modify the immunosuppressions based on the list of complications. Now, in the interest of time, we won't have time to go over everything, but we'll try to cover what's more common in our clinical practice. One of the most common things is severe renal dysfunction, with nearly 16% of our patients having renal dysfunction within 5 years, severe renal dysfunction, which is defined here as a creatinine of more than 2.5. And why do we bother about it so much? Because it can drastically impact our patient's survival. Look at the two curves separating out early and remaining separated for several years down the line. Now, what would be some of the changes that you could make in your maintenance immunosuppression regimen? One of the choices is going on a CNI-free regimen and adding a mTOR inhibitor with mycophenolate, or reducing the CNI to a lower dose and adding an mTOR inhibitor. Over here, timing of initiation of mTOR inhibitors is very important, and we'll discuss this important aspect in the next 2-3 slides. Just keeping the patient on, just reducing their goal tacrolimus level, CNI low dose. Belatacept seems to be a promising molecule, not easily available in India. Some of our renal transplant colleagues have used it. It's an IV medication, monthly or bi-monthly use, much better metabolic profile, no hypertension, no hyperglycemia, no hyperlipidemia, and with no effect on renal function. So belatacept may be something that may be useful. Now, when you discuss what you want to do in terms of changes for immunosuppression in your maintenance regimen, like most of our learnings in cardiac transplant, we have borrowed all the data initially from the kidney transplant world. This initial study actually gave a lot of negative publicity to sirolimus-based regimen. So this is from the kidney transplant literature, the Elite Symphony study, which actually showed that a CNI-free regimen had no difference in their eGFR and actually had a higher incidence of rejection. However, this really hasn't been true in the case of post-transplant. So we'll discuss that in a little bit. First, I wanted to talk about the teammate trial. Now, this is a very recent trial. This is the only randomized multi-center control trial in pediatric heart transplant recipients who were randomized in 6 months post-transplant between low-dose TAC and everolimus, or versus standard dose TAC and MMF. About 200 patients who were followed up for 5 years. There was no difference in the primary outcome, which was a composite of this special score which they made, a major adverse transplant event score, which included CAV, cellular rejection, antibody-mediated rejection, renal dysfunction, and PTLD. So both these groups had similar scores. However, if you look at the secondary outcomes, the everolimus group actually had lower CAV, lesser renal dysfunction, and lesser CMV infection rate. So good if you are in the everolimus group. Now, TAC monotherapy is something that has never been studied except for this trial. This was the famous TIC-TAC trial, old trial from 2011. Again, a single center study, open label prospective trial. I mean, this is the investigators were really brave. No induction, steroids were weaned off by 8 weeks post-transplant, and then they divided them into a monogroup. So MMF would be withdrawn between 14 to 28 days, or they would be on a combo group, so TAC plus MMF. There was no, their outcomes actually showed no difference in the composite biopsy scores with similar survival. This is some more data coming in favor of mTOR inhibitors. However, these are all smaller studies. So this is the most famous study. This is the Scandinavian schedule study, which looked at comparison between everolimus plus MMF or cyclosporin versus MMF. Now, this was a small subset, roughly around 100 patients, and all of these actually data showed the same thing, slightly higher grade of rejection at 12 months of follow-up in the mTOR inhibitor arm, but lesser degree of infection. Now, again, as I told you, smaller subgroup and short follow-up. This is what really changed the tide. So this is from the Mayo Clinic group, Dr. Kushwaha's group, where they worked extensively on long-term sirolimus use, which extensively showed how safe it was to use sirolimus or everolimus long-term in post-transplant patients, especially if you convert the sirolimus, convert from CNI regimens to a mTOR-based regimen early meaning before 2 years. They had a much better chance of reducing the progression of CAV as compared to the late converters. Not only did they show a difference in the CAV progression, they also showed a difference in all-cause death and in cardiac death. So all across the board, I'll probably just take 2 or 3 more minutes, that's all. Sirolimus also showed, this is similar, this is the same group looking at different outcomes here. Sirolimus again showed favoring trends in terms of long-term PTLD. And again, early conversion was shown to have a better survival rate as compared to late conversions. Quickly talking about leukopenias, cytopenias, we see this quite commonly, especially with MMF and azathioprine. How you could manage it is by either trying to reduce the dose of these agents, or then if that also doesn't work, switching to an mTOR inhibitors. If the patients continue to have chronic cytopenias, I would suggest ruling out these conditions. These are just based on anecdotal experience that I've had with my patients. PTLD management was discussed. Finally, so what are the subsets or what are the clinical situations where you would consider switch to an mTOR inhibitor? We talked about chronic coronary allograft vasculopathy, persistent leukopenia with MMF, GI intolerance, gastrointolerance to MMF despite dose reduction, PTLD and renal dysfunction. These are the goal levels that I would aim for if I'm depending what indication I'm using. And finally, these are the takeaway points. TAC and MMF are the most common maintenance regimens. TAC-based regimens have lower rates of rejections as compared to cyclosporin. Remember the teammate trial where everolimus was beneficial for our pediatric transplant patients. mTOR-based regimens have lower chances of renal dysfunction, lower chances of PTLD, and lower chance of CMV reactivation. TAC monotherapy may be considered in selective cases. It gets a class 2C recommendations according to the 2022 ISHLT guidelines. De novo mTOR inhibitor regimens, completely CNI free, now we know have good long-term survival data. And finally, and most importantly, selecting the most appropriate immunosuppression regimen. It's like picking a poison for your patient. So you have to pick your poison based on the individual patient and the patient characteristics. Thank you.
Thank you. It's a very good point you have made, that induction therapy is not always required. But in your practice, what type of medication you do prefer to use, if at all, the high-risk group of patients?
So we've been doing transplants since the last 10 years. Initially, we used...
polyclonal or monoclonal?
I'm coming to that, yes. So initially, we did use ATG. Rabbit ATG, but we have now completely stopped using ATG because of initial experiences with mediastinitis, XDR, TB, and severe infections. And then since then, at least for the last 7 to 8 years, we've been consistently using basiliximab. And that too, I would like to say, over the last 1 year, we are trying to cut down on use of basiliximab as well on a case-to-case basis, where we know it's a completely low-risk transplant. We've gotten away without using any induction therapy.
Another question is, if at all you are handling a case of high-risk group, and
handling a case of
high-risk transplant patient,
right,
and you are desensitizing beforehand, And how do you manage to, whether you prefer to do induction therapy or not?
Definitely. So
Yeah.
pre-sensitized patients, definitely you would want to do an induction therapy on them, definitely, without a doubt.
Thank you. Any question?
If a patient, in my case scenario, there were 2 patients where I had issues in immunosuppressive therapy. Immediate post-transplant, if the patient is having some GI issue, so one patient had mucormycosis of intestine and the other patient had paralytic ileus severe. In that case scenario, you are not able to give MMF or tacrolimus orally. Then what? This is an immediate post-transplant.
So this is while they are still in the ICU or in the hospital or just immediately post?
They are in the hospital.
Okay, so I mean, if it's a reversible cause like mucor, then treating that would help. And in general, if you have mucor, then maybe lowering the immunosuppression.
Yeah, but how will you give immunosuppression?
So
because oral.
So there's so there is no good way here. In US, at least I know we have a separate sublingual formulation for tacrolimus. We have done the Indian jugaad of breaking the capsule of tacrolimus and putting it sublingually. Yeah. But I can tell you that the levels after that, the TAC levels are very, very difficult to predict.
What you can do is, with the paralytic ileus, we frequently face that.
Yeah.
So you can give it a small water, like 10 ml, 20 ml water, nothing will happen, it will get absorbed. Basically, even paralytic ileus, nowadays gastroenterologists suggest you give 50 ml of clear fluid so that that's how you stimulate the gut. So with 20-30 ml of with the water, if you give tacrolimus, that's fine. Otherwise, how will you do it? It's very extremely difficult.
There is no injectable available.
Yeah, there's no injectable.
Yeah. Injectable is not available in India.
Yeah, so yeah, the sublingual we can break the capsule and do it, but the levels are very haywire.
Yeah, that's very difficult.
Sorry to interrupt. Because of paucity of time, can we end here only? And the next, I would like to invite for the next talk, Dr. Jasmeet Kaur. His topic would be non-invasive monitoring of rejection. Dr. Jasmeet.
Good evening. At the outset, let me thank the organizers for having me here. And the topic is non-invasive monitoring of rejection. We talk about rejection, the first thing monitoring comes as the DSA. We've had a lot of talk about the DSA in the previous few sessions. But DSA is where monitoring all started from. And we still heavily depend on DSA. But once we worked out what is DSA, we moved from the evolution to the revolution. And the revolution came when we also started doing a lot of HLA typing, finding out new HLA types that are there. And then there was this need to multiplex and detect more antibodies against the n number of antigens. And this graph just shows how the number of HLA antigens which were detected increased in number. So there were more tools that came in, more strategies that came in, and more ways of risk stratification. So we moved from the CDC way back in 1960s to ELISAs, to the flow PRAs, which are by and large out by now. We then had the Luminex, which is a solid phase assay, and the Luminex gave us a way of detecting DSA and sort of quantifying DSA with the MFI as it stands today. We now are in the era of the next generation sequencing, where we are able to look at better HLA, a more sensitive and larger number of alleles of HLA, and also use these techniques to monitor in the post-transplant with cell-free DNA and other tests. So first talking about the DSA. Now what are expectations from a solid phase assay, which is the Luminex? The red one is in the pre-transplant, which are not bother with as of now. We've discussed that, but in the post-transplant setting monitoring, we need to correlate or predict episodes of antibody-mediated rejection or graft loss. We also need to correlate desensitization success, whether it's worked or not, look at rescue therapy and the impact of treating antibodies which were detected. So that's where we stand as of this, as far as the solid phase assay is concerned. Now, the immune risk assessment is, as of today, the key to individualized immune suppression after transplantation. And this is the dynamics of how antibody-mediated rejection in a heart allograft can have. There can be a mixture of the A, B, and the C, which is a variety of lesions which affect the arteriosclerosis, mixed patterns with atherosclerosis, some amount of microinflammation. So what we have is a lot of smaller combinations that we get in our antibody-mediated rejection. So if you look at the ABMR in heart, and you look at these two graphs, there is no difference in overall survival based on DSA pre-transplant status in 3 years. This is what, when they looked at the single antigen bead with the C1q assay, which is the complement activated SAB, and SAB in 1:8, that is dilution of SAB, and the CDC cross match. But patients that develop de novo DSA, which is DSA which comes up after the transplant, had a higher incidence of ABMR and cellular rejection in these patients. So what became clear over here was post-transplant antibody monitoring is critical to apply immune suppressive therapies early enough to decrease worse impact on the graft outcome. So looking at monitoring DSA with C1q, and C1q I said was a part of the complement activation. And when you look at this in the post-transplant DSA, when there is no DSA compared to post-transplant DSA, the p-value is significant at 0.002. But if you have an IgG positive, that is DSA, and a C1q negative, as compared to an IgG positive and a C1q positive, the outcome is much worse. So it's not only the presence of the IgG antibodies, but it is also the complement activation capability of the antibodies, which is significant here. So C1q fixing antibodies, therefore, had a higher trend towards a higher incidence of ABMR. So decision-making algorithm, which is just an algorithm we can look at for DSA surveillance, new onset symptoms, signs of graft dysfunction, you could do a DSA. And when I say a DSA, I mean the single antigen bead assay. So if it's positive or it's not positive. If it's positive, go out and do a biopsy and move on, so forth. But if its symptoms are there and the DS is not positive and it's early after heart transplant, you could still look at a biopsy. Or if it's late after heart transplant, look at the C1q assay, the complement fixing ability of the antibodies detected. And if it's C1q positive, it's more of endomyocardial, or C1q negative, you would have to just then monitor more with DSA and consider any of the therapies and IVIG if the MFI is above 5,000. So we also have the non-HLA antibodies, and this is from the lung transplant because they've been looked at more in lung transplant. And there are a large number of non-HLA antibodies, but the AT1R, which is the angiotensin type 1 receptor antibodies against that, and the ETAR are the ones which are most significant as far as ABMR is concerned. As of today, where the non-HLA antibodies stand is if there is ABMR, there is no DSA, we then go out and look for the non-HLA antibodies in these patients. So the clinical decision making is now moving towards just beyond antibody detection. So it's not only detection, you need to look at the MFI, sure. You need to look at the C1q, yes. You can look at the subclass of the IgG. It could be IgG3, or is it 1 or 4, which is less important. And also in the post-transplant, these become relevant when you're looking at non-invasive tools for clinical decision-making, becoming more pathogenesis-specific therapy in this period. So if you look at the guidelines here, the post-transplant monitoring for DSA should be performed at 1, 3, 6, and 12 months post-operatively. DSA testing should be performed for any patient presenting with signs and symptoms, which I've already said in the algorithm, and DSA that remains at higher dilutions. By dilutions, I mean a 1 in 8 or 1 in 16 or a 1 in 4. So you can do DSA, perform DSA testing at various dilutions. A C1q positive DSA antibodies, DSA that persists despite immune therapy, and DSA arising late after transplants have been associated in literature with worse outcomes. The clinical significance of non-HLA antigens, such as MYC, is yet not established in the heart-lung transplants. But post-transplant care is beyond DSA and more challenging. We can't have a one-size-fits-all. We're moving towards a more specific, targeted, tailored kind of therapy, and I have this molecular window for clinical alterations. And what's important to know here is when there is rejection, which is beginning to happen, first comes up the transcriptomic window, then moves to the morphological alterations, and then the clinical alterations. The whole point is to start picking up at the transcriptomic window, because the changes that come in, even at that point, are reversible and action can be taken against these. So the current surveillance that we have is endomyocardial biopsy, expensive, serious procedural complications, and of course there's inter-observer variability, which can go up to as much as 50 to 70%. We have the gene expression assays, which have a high negative predictive value, low positive predictive value. The DSA, which has a low positive predictive value for ABMR. And of course, clinical evidence, which would be left ventricle ejection fraction. So we have the non-invasive tests. We have the less accurate ones with DSA, clinical valuation, the invasive tests, and the more accurate, which is donor-derived cell-free DNA, gene expression profiling, and endomyocardial biopsy, as well as the molecular microscope, which is the MMDX. So reshaping the paradigm in diagnosing rejection in heart transplant. We have donor-derived cell-free DNA, and in India, some centers, we do have good experience with this particular test now. There is a molecular microscope, which is the MMDX, which is invasive on the biopsy, but it is a gene expression test. There is the gene expression profiling, which is the AlloMap, which we don't have available to us in India as of now. And we also now have monitoring immune suppression, that is the toctinovirus, the TTV monitoring. So that's for those who need to understand what is donor-derived. We know that a transplant is genome transplant dynamics. There's a pre-transplant recipient type, a post-transplant, a mixture of donor and recipient DNA in circulation. And what we're actually looking at, how much of the donor DNA is coming into recipient circulation in the post-transplant period, because whatever that would be because of a certain amount of injury. So the concept is to look at the kind of injury that happens to the transplanted organ. So there are two different techniques to look at allograft health, and both non-invasive. The gene expression profiling, which looks predominantly at genes which are associated with immune signaling, and the donor-derived, which is more of injury. And jointly, the gene expression and donor-derived are powerful non-invasive tools for heart transplant surveillance. So if you look at the way they look at heart care, so there is the gene expression, which is more for ACR, the donor-derived, which is more for ABMR, and a combination of those two would be just great. And this is a study that came out from in the American Journal of Transplantation. Jointly, they have an area under curve of about 81 to 82%. And that's another study which looked at no rejection versus any kind of rejection. There was no rejection. A type of ACR and cell-free DNA did not show much variation, but ABMR, there was a distinct elevated levels as far as looking at the values was concerned. So donor-derived monitoring in heart transplant, the first graph shows how it would be, how the donor-derived result would be in a clean case without rejection. The B figure is donor adult recipient with acute cellular episode at about 15 months, so the values would definitely go up. And then another one with ACR episode at 9 months, and then required a new transplant, this patient. And the last one is very nice, where you see the cell-free DNAs, which have at no point been stable and have gone up at 4 to 12 months, and then again at 5 months. So that's how you would monitor any of these patients with just cell-free DNA. That's a single case where the cell-free DNA value was at 1.6%. The histopath showed acute cellular rejection. There are a lot of lymphocytes, a lot of blue we can see in the graph, in the picture out there. So what is this surveillance in a clinical setting? You have two groups of patients, the highly sensitized and those under routine surveillance. You could do a for-cause cell-free DNA monitoring, or you could do a proper follow-up in these patients. The testing schedule varies. We don't have a protocol for India, but if we were to look at the Western protocol, it would be monthly for the first 12 months, quarterly for the next 2-3 years, and then biannually probably. And the rationale for doing this would be, in short, one would look at any point where you're going to either change immune suppression, step it up, change to another one for whatever reasons, a toxicity. Those would be the time points where you would have to intensify and do the monitoring more closely for these patients. So that's some of our cases that we looked at. So we looked at the median cell-free DNA levels in all cases. Now, we don't have protocols in India, but the cell-free DNA median in heart we found was at 0.12%, which kind of correlates with the cutoffs of the West, which is 0.2%. And that's how the distribution was across all ages. A little higher we saw in our pediatric group, 1 to 10, which is 0.26, but the rest of it was pretty much within the normal range. But this is very early data from our own center. And that's MMDX. And why I want to talk about MMDX is that we're looking at wanting to do this for our patients. The intra-graft rejection-associated transcripts are what we look at in MMDX. That's what the graphs look like. No injury to in principal component 1, 2 injury, ABMR on top, to TCMR at the bottom. So that's how the genes are classified and grouped. And that's how the report of an MMDX would go out. When you look at the MMDX, it correlates very well with the endomyocardial biopsy. But when you look at MMDX and cell-free DNA, the correlation is great for ABMR and for any rejection, that is mixed rejection. But for TCMR, the correlation falls to about 54%. So the concordance is there, which is ABMR and mixed, but not so much for the TCMR. So there are certain rejection transcripts which are classified genes for various endothelial activations, parenchymal injury. These are the genes which are evaluated in most of these tests. And that's another one which shows some of the genes where the rejection is red and the no rejection is in the blue region. And lastly, I have just a couple of slides on the new test that we have. And this is not a test to monitor graft health, but this is a test to monitor adequacy of immune suppression and tailor immune suppressive therapy. Like I said earlier, it's not one size that fits all. We need to move away from that. So avoid rejection episodes to inadequate immune suppression and consequences of over immune suppression, which Dr. Talamiran just spoke about, infections and malignancies. We're trying to get to a point where we just give what is actually required and nothing more or less. And the current immunosuppressive monitoring is mainly pharmacokinetic based, which is TAC levels or levels of various drugs we have. So that's monitoring TTV in, this is from lung transplant, but if you look at the first one, fraction without infection, TTV levels at 9.5 log, and the duration after transplant. So that goes right down. But if you look at the others where the TTV levels are high, but that's where your cumulative fraction without clad. So the point in TTV is that it helps you monitor your immune suppressive therapy within the right range, not more, which would lead to infection, or less, which would then lead to rejection. So in summary, donor-derived cell-free DNA is a great surveillance test, and we have seen it, we have experience with us, and it is non-invasive, can be performed frequently, and also help a personalized titration of immune suppression. Its levels are elevated in both ABMR and acute cellular rejection. In addition, it also helps in monitoring patients in the post-rejection therapy, and helps decide on recovery from rejection. So the point here is that the test results may not eliminate the need for biopsy, because there are articles which say it's replacing the biopsy. As a pathologist standing here, I cannot say anything replaces the biopsy, but yes, it will decrease the need and help you titrate when to go in and do a biopsy, and may increase the probability of a positive biopsy result when the cell-free DNA does have clinical meaning over there. And yes, thank you so much, all the way from Delhi with lots of water on the roads. Thank you.
Thank you, Dr. Jasmeet. We are already delayed by 1 hour, so we close the session.
Thank you.
Thank you, everyone. We will now begin with the panel discussion.
Thank you. Ladies and gentlemen, so there is a bad news and a good news. The bad news is that we are running 1 hour 30 minutes late. And the good news is we'll try and make up as we go along, so we'll have to cut down the duration of the next two panel discussions. For the first one, if we can have the slides on, and I would like to invite the moderator, Dr. Monimay Bandyopadhyay, if he's there. Sir, if you could kindly come up on the stage. I'm not sure if he is, but Dr. Monimay Bandyopadhyay, if you're here, he's the director of ROTO. He was meant to be here, but he's probably not there. In which case, I'll invite the speakers to come onto the stage, please. Dr. M. Das, Dr. Julius Punen, Dr. Manoj Durairaj, Dr. Vikas Raidas, Dr. B.B. Mohanty, Dr. Plavan Mukherjee, Dr. Mohapatro, Dr. Dhiren Shah, Dr. Basha Khan, Dr. Aditi Singhvi, and Dr. Jasmeet Kaur. So it's a lot of people on the dais. I may or may not be able to ask everybody a question, so my apologies in advance. Please kindly come to the stage quickly. Now the slides, please. Now the good news is that most of the panel discussion that we are going to be discussing, most of the topic has already been covered during the course of the day. So we may sort of just fill in some of the things. If there are not enough chairs, we can get you some more. There are a couple of chairs here, please. Okay. So I'm assuming that everybody who was meant to be here is here. I'll go straight into the meat of the panel discussion. The slides are not moving, unfortunately. Next slide, please, if you can move. Okay. Okay. Now, you saw this paper earlier on. Dr. Debashish Das presented this paper. And this is a paper that summarizes the experience of heart transplant in West Bengal. 7 hospitals in the last 6 years in this paper had carried out 38 heart transplants. Today the number stands at 42 or 43. Now, how do we look at it? It's a great effort from what it was 6 years ago. So 0 to 42 in 6 years. Is it a glass half full or is it a glass half empty? Or should we just be thankful that we have a glass? Julius.
When you look at how transplants have grown in any state in this country, there has been a phase of very slow growth. Like you look at our place, our state itself, we were doing 1 transplant every other year when we started. Then it gained momentum. Then you reach a point where donors increase, recipients increase. A lot of times you have difficulty having people on your wait list. I think that phase is getting over. At least there are several hospitals which have got 2-digit waiting list. I don't think anybody's got a 3-digit waiting list. But there was a time when we had a donor, we are trying to find a recipient.
So what, if I get your drift right, what you're saying is we should look at it as a glass half full. I mean, it's a good start.
It is a great start.
Fantastic. So, but now I'll just go to the panelists one by one, starting with Aditi. If you could just mention one barrier do you think which may exist for increasing the numbers? I mean, one barrier that comes to your mind. I'll be asking most of you the same question, so you can think of another barrier, which Aditi may or may not cover.
So one of the things that we come across frequently is late referrals. And I would say that's a barrier because that is not the ideal patient that you want to transplant. A lot of them are so sick that they can't even be considered for transplant at that time, or they don't have the finances to facilitate the optimization and the workup that they would require pre-transplant.
So you're saying finance is an important thing?
Finances is definitely one thing, but now at least in a state like Karnataka, that is not a huge impediment because the government supports.
Sure. I'll just move on to the others and see. Manoj, I'll come to you, Plavanda, later on. Just tell me one barrier that comes to your mind, apart from finance that has already been covered.
Transplant coordinators. I think they are the crucial pillars.
Lack of transplant coordinators. Dr. Das?
Well, what I have found out that they still think that transplant is a very big operation and whether we survive or not. So we find it very difficult for them to list. And then they keep on asking us to continue medical treatment if at all possible. So listing them becomes a very difficult. So it's a very recipient, not having recipient is a problem.
I think that's a great point, actually, not having a recipient. I mean, we talk about not having donors, but not having recipients is a very important point. Dhiren, you have got a huge experience.
So apart from the recipient, I think, so that is the biggest issue. And when you are starting a program in your state, obviously that is the biggest impediment because majority of the cardiologists will feel that the outcomes are not good and that is why they don't refer the patient. And second, obviously the organ donation. The more the donation is there, the better the outcomes and better the number of transplant. And another very important thing is, if in a government setup, if the good amount of transplants are being performed, let me tell you, automatically the number will increase significantly.
That's again a good point. I'll come to the government sector later on. That is why I have avoided Dr. Plavan Mukherjee. Basha, what do you think?
Another important thing is to have a scientific data and registry. So if we start collecting data, how the patients of advanced heart or lung failure are living at 5 years, and those who had a transplant at their outcome, so that it will be more objective instead of subjective, and that's a one way to move it forward.
Great point. Dr. Kaur?
So mine would obviously be from the lab side, but one thing we need to put together state-wise, nation-wise, is to have a registry where we monitor the sensitization status. You know, when a patient gets to know his sensitization status is becoming worse, it's a motivation for him to move ahead. If they're moving up the ladder, down the ladder, and that would encourage them to understand, I need it fast, the transplant.
Sure.
And probably.
So, Dr. Mohanty, I know that you have just got the permission to carry out transplant at your place, so...
Yeah, actually this is most important part. Everywhere, it's not happening. It is happening only in a few good centers, and it is not possible to happen in all these centers because financial implications are already discussed, and number two is the donor and recipient problems, and the third thing is the infrastructures. It has to be well-established infrastructure to maintain the recipients and the donors.
I'm very happy you use the term infrastructure, so that will bring me to Shubhendu. Shubhendu, you have done quite a few transplants now. You work in a government sector, and we generally tend to believe that the infrastructure is much better in corporate hospitals compared to government hospitals. What do you think?
The human resource part is lacking. Means we don't have any dedicated team or number of staff or less. And regarding recipient, I do agree with Dr. Das because we are having less number of recipients. Last month we had 6 branded declaration, but we didn't get any recipient.
Thank you. I'll come to that again in a minute. Now, before I ask the question to Dr. Plavan Mukherjee, let me tell you that he advises the state government on different policy elements. So, what I would like to know from you is how do you see the government making sort of say immediate, mid-term, long-term plans to take this forward?
In fact, I have brought this paper with me, the plan I had given to the government. And I had, in short, I'll just tell you, I told them, let's have some immediate things which we should do immediately. Like, as he said, establishing a national registry, expanding the training program, enhancing the organ transport infrastructure, which is very important, and implement standard protocols. All the protocols are different in different places. This is immediate, which should be done in 1 to 2 years. After that, the midterm things that they had to look into, 3 to 5 years, develop centers of excellence. I absolutely think, doing 2 transplants here, 2 transplants there is not the way to go about it, both financially.
So can I just stop you there and ask you a question? Because Dr. Satyajit Bose earlier today, he gave a talk where he talked about decentralization.
Absolutely important. I think it's very important. How can a patient from Durgapur come to Calcutta? Let's have a few centers there.
But then if you're saying that you can't have 2 transplants here and 2 transplants there, that's contradictory.
Like the thing I told them, let not every we have 5, 6 medical colleges in Kolkata. Let not everyone do it. Let 1 or 2 centers do it, and those who are interested, let them go and do it there. So center of excellence may be useful in infrastructure development where the cost can be sort of, put together in one place.
So before you come to your long-term plan, I just want to bring Julius again. Julius, what do you think a corporate attitude is? Obviously there are different corporate hospitals. Would they be inclined to accept this idea that only say there are 10 corporate hospitals, only 2 or 3 of them should do it? I mean, do you have a...
I have thought about it various times, but how can you make a choice? Like, I want me to do it and you not to do it. That is just not possible. So you can only show by producing better results and being competitive financially and get the patient to choose your hospital over another one. There is no way one can have an overarching body which will say that you cannot do it.
Yeah, you can't stop anybody, but in a corporate world at least. Yeah. In a government world you can.
Yeah, we were talking about the government, It's a different scenario
Yeah,
altogether.
so please continue with your long-term plan, sir.
So that was the midterm plan that we were thinking about. And the long term would be in 5 to 10 years, where we can develop indigenous research capability, making these things as Dr. Balakrishnan was doing. Make our own things so that we don't have to really depend on outside world for the things to come. And then achieve international standards. I think that's very important, As I think Mrinal said, often patients come to you and say, shall I live after this operation? It should be like kidney transplant where people go and do it. So if we achieve these standards, automatically, the numbers of patients will increase and transplants.
So one question for Manoj. Manoj, do you think, we have talked about some of the barriers. Now, what about donor pool expansion? We obviously want more donors, correct? Now, do you think in India, we still have DBD? Do you think DCD is an option that can help?
I think it'll take some time because there are a lot of medical legal issues and interpretation issues on DCD at the moment. So it'll take a time. I personally feel if you're asking for a donor pool expansion, it'd be better to increase the donor retrieval teams. That makes a lot of sense because if you are somebody in Karnataka where the organs are getting wasted and the recipients are less, and up north you have shortage of donors, you can have teams sending across the organs. This is what I call a positive organ donation program. And retrievals anybody can do. It's up to us to train the retrieval team. Any of the cardiac surgeons can do it.
Sure.
But I feel that's the way to go about rather than having a DCD kind of, a problematic issue.
Okay. So, yeah, Basha, you wanted to say something?
I think before we move from disease DBD to DCD, our goal should be to recognize DBD earlier, and if we can bring the duration of utilization of the disease organs less than 5 days, then we can utilize much more organs. What happens? Most of the time it's already 5 days, 6 days already, that catechol storm is there, infection has set in, so you're not going to utilize those organs.
That's absolutely great point. Again, I think we don't want to get into the legal wrangles. Now, Dhiren, earlier on today, Dr. Sivasasan mentioned opt-out policy. Now, in India, we follow opt-in. Do you think opt-out is a good policy that India should consider to increase the organ donation?
I think so. It's a very long way to go for opt-out policy in India. First, we need to accept that organ donation is right. There has to be transparency in the systems across India. Government and the, I think so, non-government side, everybody is accepting organ donation. Because if you look at all India level, northern part, there is hardly any donation. Whatever is happening is only in the southern part or below the MP part. So once the organ donation is widespread across India, that is the stage when we can think of opt-out policy.
Yeah. So I think you again touched upon, the donation being restricted to certain places, regions, and I can tell you in our state, there are 7 hospitals which utilize the heart, but there are only 2 where donations happen on a regular basis, one of which is a government hospital, the other one is a corporate hospital. But on the subject of...
One point. Another point which I think so to increase the donor pool expansion is need to involve all the medical colleges compulsorily, having KPIs for that medical colleges, how many brain deaths have they have
Why not
identified.
Corporate hospitals as well?
No, obviously corporate also, but see, the huge chunk of the patient will always come from the government hospitals. Always.
But why should they?
Huh?
Why should the huge chunk come from the government hospitals?
See, because all the road traffic accident patient, majority, they land up ultimately in the government hospitals.
Okay.
That is what I have observed, because in private setup, they don't land up.
But don't you think that the unit that is using hearts should also have a moral obligation to organize donations?
That has to be there. And second, very important thing that government of Gujarat has done is, they have made it mandatory to declare brain dead patients. Whether you donate or not is a different story, but whether you are declaring brain dead patient in your ICUs and then audit and checks of that has to be done.
Fantastic.
If you are doing that thing, then definitely more and more brain dead.
So a lot of regulations need to come in. Aditi, you were trying to say something earlier?
I think just to add on to what Dr. Dhiren is saying, one of the best way to expand this would be to improve trauma care. Just like if you're talking about improving heart transplant, the best way to increase rates of heart transplant is to provide better heart failure care. So if you improve trauma care in general, there will be more DBD declarations and more donations.
Absolutely. In fact, the biggest donation in West Bengal happens from a trauma center in a government hospital. So Dr. Das, you earlier on gave a very nice talk on managing marginal donors which could increase the donor pool. Very briefly, do you want to kindly summarize it for the audience who may or may not have been here?
So basically, a large chunk of donors are excluded because they are called suboptimal. But if we look into very carefully into that,
then we will see that quite a large amount can be used for transplantations. So one of the major thing is that expansion in the age group. What is that? That higher age group donations can be used. Second important thing is that poor LV function, as we a snapshot echo, if we do as soon as the patient is declared brain dead, there is a severe catecholamine storm, and there is depression of the LV function. And if we go and examine that particular patient with echocardiography, there will be a reduction of the left ventricular ejection fraction. And there is sub-optimized management of those patients. So the team should go few hours early, probably manage the patient, and then finally do another repeat echo. Most of the left ventricular function, unless there is some structural abnormality, they recover. And Dr. Bala has already shown that how marginal donors with his echocardiography recover and could give a good results.
Yeah.
So another thing is DCD you talked about. DCD needs a lot of resources.
Yeah,
because most of the DCD has to go into
at the moment.
organ perfusion system, which we cannot afford.
In fact, so my next question is to Julius. Julius, what do you think is a bigger problem? Actually, that is to everybody. What is a bigger problem? Lack of donation or wastage of organs?
See, to Dr. Das, I wanted to ask, we are not even utilizing all the good organs which are offered to us. Why would you be looking at marginal organs in that case? Why would you be? No, that is a different thing.
That's a fair point.
Yeah.
I asked you. So.
Where once before in ISCTS, I had a debate with Peter McDonald, who's written the editorial on utilizing marginal donors. So obviously, I don't have enough knowledge to argue with him. So I just took this point that we are not utilizing all the good hearts that are offered to us. A lot of them are still being wasted.
Yeah.
So if we had a good transport infrastructure, if these hearts are available in one place, we could transport it to another place.
Yeah, I mean, I'll tell you why marginal donor is still a good point, because sometimes you have to be at the right place at the right time. You may have a recipient who is in hospital ready to undergo a transplant. You may have a donor who is just marginal. Now, do you want to forego that, or do you want to wait for another 6 months before a heart becomes available?
It depends on the urgency of the situation.
Correct. So what I'm saying is, sometimes marginal donors can be considered if there is a dire need.
Yeah, I have accepted a heart which had 3 cardiac arrests during a day, because my patient was on ECMO and he was already on the way down. So I took that, and he's still alive. I'm not saying never use a marginal donor.
See, the problem in India is not the geographical location, it's the state-wise location. For example, we have a donor in Kolhapur or a recipient in Kolhapur, and in Belgaum there is a heart. Okay? If you have a donor in Kolhapur and the Maharashtra donor rate is much, much higher, reaching from Bangalore to Belgaum is much longer than reaching from Kolhapur to Belgaum.
Absolutely.
That doesn't happen in India because of ZTCC, SOTOs and all these differentiation. It should be geographical donation. Yeah. That means the closer you are, there you get the organ.
Yeah, I mean, we try that in West Bengal. Now I'll give you a local flavor of West Bengal. What happens here?
The donation, the donor organs get wasted because of this kind of barrier.
Yeah. So I think from Roto, after rotating all the hospitals, then it goes to Noto, and then Noto informs different states.
Correct.
That there is an organ available. So, no, but Roto has to inform Noto, and through Noto we get the call. So there is a lot of time information.
Yeah, I'll give you a chance, but first I will speak.
Organ allocation.
Okay.
Recently I had a meeting in Delhi with the Health Secretary Punya Srivastav and with Dr. Anil Kumar also. And they have promised that in short period of time, they are going to create a WhatsApp group of all the heart and lung transplant centers together. So at the same time, the cadaver will be informed to everybody. So similarly, right now what is happening is first it goes to Soto, then Roto, and then last to Noto. By that time, almost 7-8 hours are gone.
So what I'm understanding from all of you is organ wastage is a very important issue. I mean, organ donation is definitely something that we need, but we should not be wasting the organs. And it happens in West Bengal, we have seen, there are sometimes, there is a donation and there is no recipient. And people from Bala's team or, even from Bangalore, they have come and taken the heart. And you just think, so we say that we don't have enough donation. And here there are hearts which we are not using. So, yes,
another point.
I think Dr. Kaur has not spoken, so I think we'll have to give her a chance.
So, when we talk about this WhatsApp group where everybody will get informed, but it's only worth sending an organ out to a particular center if you know that would match. And that's where we need to have good practices in place where we have a virtual cross-match ready to say, okay, out of these 5 places which have a recipient waiting, this one scores more because his virtual cross-match is the best, which is the basis of organ allocation world over. So we need to...
Julius, you want to say something about that? Because I know your practice is slightly different.
Yeah, see, as of now, to do a virtual cross-match in our system is quite impossible. And our population is so varied in their genetic makeup, you cannot sort of generalize it. So I wouldn't take that as the criteria for allocation. Maybe it's important in kidneys, but maybe not so much in terms of...
So I think we should keep it simple right now, but try and build a recipient list rather than just harp upon a lack of a donor list, not having a donors.
What I want to ask is, why are cardiologists in general not convinced about the transplant being a useful tool?
Yeah,
we still, in our own hospital where there is a large footfall of patients, the number of patients who are referred to the heart failure cardiologist is pretty small.
Yeah, so right now, he's not on the panel, but we have got a very dynamic cardiologist sitting here. Oyan, do you want to come up and answer that question? Aditi is here, but I'll spare Aditi.
I'm on the same side.
Yeah, I know.
That happens to be the Pandora's box, and that's because we've typically been heart failure. Most cardiologists feel that, it can be treated medically. And by the time patients are really very sick, that is when they get referred across to us. And I think we've all seen. So patients in Intermax 1 and 2, they don't do very well. We typically would want patients in 3, 4, probably in 5, and once they get there. So it of course has been an issue. We've been short on referrals as far as heart failure cardiology is concerned.
Okay, thank you. Now my screen tells me that we have got
just
only 7
1
minutes
second.
left.
What happens? No, not to you, Pradeep. See, what happens is when we propose them for heart transplant listing, they go back to the same cardiologist, say, I don't want, do something for me. And they again go back into those 4 pillars.
Yeah.
So until they become Intermax 1 or 2.
Sure. So we'll move on to something slightly different, which is funding. Now today, we heard from Dr. Satyajit Bose, and I spoke to Dr. Bala, and he has published a paper. And there is a figure in that paper as to what is an average cost of a transplant in India today. But before I disclose that figure, I want to hear from all of you, what do you think that figure should be?
The cost of the hospital.
Cost, just the price of a basic price for a transplant?
Uncomplicated.
The cost to the hospital.
Cost
Uncomplicated.
10 to 15
Let's take an
lakhs.
average, a ballpark figure. No, it's difficult to give a proper answer. I just want to get some rough idea. What do you think is a reasonable amount? A patient, if I need a transplant, what would you tell me that this is the expected cost?
15 lakhs.
I'll look at it from 1 year point of view, because we have to include medications
Just
also.
the hospital cost. Just the
hospital cost, I would say 12 to 15 lakhs.
Okay, anybody?
But, yeah, in the government hospital, I calculated on the transplant that we did. The government had to spend 7 lakhs for each of the transplants.
Now,
can I?
Yes.
Well, the actual cost of a straightforward transplant falls less than 10 lakhs. Actual cost. Then that depends upon the professional fees of the surgeon and the professional fees of the manpower.
Yeah. So that can vary. That depends.
Can vary. Depends upon the type of the hospital.
Absolutely.
Mission hospital, corporate hospital, 5-star hospital. But average cost is 10 lakhs.
Yeah. So that paper.
You're talking about with the stay charges.
With the stay, with the immunosuppressants, with 1 biopsy, with angiogram at discharge, and the procedure. How much?
Inclusive complications. Inclusive complications.
I'm not talking about complications.
No, sir, obviously you cannot predict all complications and all the costs, but on an average, I think 10 lakhs is a reasonable figure. The only paper that has been published on Indian patients, the largest series was by Dr. Bala, and the cost there was 14.5 lakhs. And it matches the amount that is paid in the south. In some of the states, the government pays about 15 lakhs. So I think it's a very, very reasonable figure. Now, I don't know, I'm sure in 7 lakhs in government hospitals is possible, but corporate hospitals work in a different way. And they have to account for other expenses, but let's not get into that. Now, question is, how can we reduce this funding? Do you think there are some points, and you can choose whichever point you want to talk on? Now, yes.
See, when the Karnataka government started funding transplants for BPL card holders, I rang every transplant center in the state and said, please take this. Because if you don't utilize it, next year the government won't pay money. So it is in my interest also that you accept it. But there aren't many takers.
So CGHS pays about 15 lakhs. I mean, the PMJ pays less, and but the CGHS and some of the states in the south pay about 14 to 15 lakhs. Now, there is an interesting idea I came across, crowdfunding. Now, we did one case, Devashish, we did crowdfunding for a particular patient. Now, can we have a single portal for crowdfunding for all transplant patients?
Most of the crowdfunding we've got is through Keto. They are the ones, even for liver transplant, they've done, in one hospital, they've raised 4.5 crores over a period of time. This one.
Any other ideas of the panelists? Feel free to voice.
For the funding? Funding. I think so the best model that I feel is the Gujarat model right now. It is a typical PPP model wherein government gives 7.5 lakh rupees for the heart transplantation. Rest, whatever amount is there, the patient and the hospital has to manage. So they don't restrict the amount to 15 lakh rupees. What happens is in Tamil Nadu, if it is giving 15 lakh rupees, you have to wrap up everything in 15 lakh rupees, even if there is a complication or anything. I think so instead of that, if 1/3 of the cost government is giving, rest let the patient in the hospital
So what
manage.
you are saying is whatever be the cost,
Yeah.
the government should pay a certain
Fixed
part
amount,
of it.
yeah, fixed amount. So
I think
7.5 lakh rupees.
Maybe
is
you
what
can float that idea to the government, sir. Aditi, you wanted to say something? Yeah.
One of the big costs in transplant patients is medications. Because even if the government pays for the surgery itself, they often have challenges afterwards with the medicines, or if they have a complication. Particularly, we'll see more infections in BPL patients because of our socioeconomic conditions. So having those medications available at government pharmacies or at a subsidized cost can be a big help.
So yeah, that's, as if on cue, I have put this slide which you can't see.
That's what I was trying to tell you, that for 1 year at least, we should also include the cost of the medication, because that is the key. And many of the patients have mortality because they can't afford the medicine.
Sure. So Manoj, is there anything we can do for that? Like, can we tie up with some pharmaceutical companies, and as part of their CSR, they could sponsor those medications to the patients?
We have MCure in Pune, we have Biocon in Bangalore. They are having generic kind of molecules for the immunosuppression. I don't think it's difficult for us to reach out to those people and tell them that we are going to subsidize, or you can subsidize, and we can have some kind of CSR activity from their end. Have a pool from one source throughout the country where we can sort of, send the medications to such people, and poor people have to be subsidized. There's no doubt.
Julius?
I think more of a problem is with antifungals and more expensive medication. Immunosuppression, a lot of times is covered by the government itself. At least in Karnataka, they cover the first year. But if you get a complication, suppose you get AMR, every treatment modality for AMR is very expensive. So these are not covered by anybody.
Okay. I think, Dhiren, that's a last comment that's going to be, because we have got 20 seconds to finish this.
Yeah, only comment. We have tied up with the Zydus company and Intas company in Ahmedabad, wherein we tell them, if this patient will take your medicine lifelong, you bundle up the cost. So whatever the amount of tacrolimus they are taking, or whatever the amount of MMF they are taking, the amount will be fixed. So that is how their cost comes down.
So
but they are getting lifelong one patient.
I have a comment on the fundraising part. I want to try it out. So what we do in our center, of course, for pre-transplant counseling, we do a lot of psychosocial and economic assessment, right? The need for transplant need is far more than the patients who are capable. So we screen the patients, not that we cannot leave out the poor patients, but the spirit to live would be the key to do the fundraising. Not they have to read the medications, English or Hindi, right? Because that's how it is. So that would be the primary criteria. And then we try to get some help from the oncology team.
they are very good in, like the social worker, the psychologist, they are very good in fundraising. So the whole mindset of how do we raise funds, we take a lot of help from the oncology team. And that just has to be culture of the team, where we identify the patients initially on that they are a potential transplant candidate later on, so that we sensitize them and get the fundraising. So, inability to raise funds is generally not a barrier, at least, for the most part, for our patients in our center.
Okay.
Dr. Pradeep, before that you had one slide, adopt a patient. I think that's a very crucial thing which you had. A slide before, adopt a patient. You just see that before for funding? Adopt a patient program. I think that is the key to what you're trying to do.
Yeah, I know, see, but unfortunately we have run out of time, and it's my sort of religious belief not to go beyond my allocated time, so I'll stop here. Thank you very much all for being here, and please give them a round of applause. I wish it lasted longer, but like all good things, it has to end, because there is another panel discussion after this. So, but thank you very much. I'm sorry, Manoj, you couldn't cover all the points. And so for this panel discussion, I'll have to first of all tell you the topic is we'll be discussing some ethical dilemmas, and I'll be inviting on the stage once again Dr. Monimoy Bandopadhyay if he's here, and if he's not, then I'll invite Dr. Tanmoy Banerjee, Dr. Sudeshna Lahiri, Mr. Komal Dasora, Mr. Milan Mukherjee. Okay. Please come and take a seat. I'll repeat the names: Dr. Tanmoy Banerjee, Dr. Sudeshna Lahiri, Mr. Komal Dasora, and Mr. Milan Mukherjee. Now, we'll try and do it a bit differently because I'm tired. So we'll get Dr. Kaushik Biswas to come and give his talk first, and then maybe taking cues from his talk, which is again on a very similar topic, we'll continue with the panel discussion. So it's over to you, Dr. Biswas. Can you put his slides?
Good evening, my respected colleagues, seniors and juniors. At the outset, I would like to thank the organizers of this conference to allow me to talk here on a very important topic, that is ethical challenges in organ allocations for heart transplant patients. Now, as I understand that this is perhaps not the only thing which most of the doctors would like to know it from me, being my experiences of being into the West Bengal Medical Council as an elected member, I'm sure you would be liking to know something more about it, which I would come to it at the end of my talk. So let us first discuss what are the ethical challenges in organ allocations for heart transplants. As I am the only non-cardiologist available in this room, so let me just quickly and briefly introduce myself. I have done my MBBS from Kolkata Medical College, DO from Shankara Nethralaya, Chennai, DNB, and I am a Vitreoretina Fellow from Ludwig Maximilian University Eye Hospital in Munich, Germany. In the year 2022, I was elected into the Board of West Bengal Medical Council, and I am currently the chairman also of the Penal and Ethical Committee. I have around 22 international presentations so far in my career. Now, there are two important issues here about these organ allocations. Number one is declaration of the brain death, and number two is procurement of the organ. I am sure you all know about all these things very well, but I would just like to recapitulate and give you some inner points as to from where you can get entangled into a legal litigation. So number one, this is the proposal for organ allocation following second brain death declaration and the consent of the relatives. So what should be the flow of the organ guidelines? It's very simple as far as the state of West Bengal is concerned, and I'm very sure about it. It is nearly the same in every state. Brain death in a government hospital which has got a transplant license, the organ would go to that hospital first. If that hospital refuses, then another government hospital with a transplant license will get it. Even if that is refused, then it will go to the private hospitals with their serial numbers. And how these serial numbers are obtained? Serial numbers are obtained based on two criteria. Number one is the date of issue of the transplant license, and the number two is last organ transplant that was done. So here, as we are dealing with an unpaired organ, so to sum up, in a government hospital, if they get it and if they want to do it, who has got a transplant license, so they would be getting it first. If they refuse to do it, it will go to another government hospital. If they also refuse to do it, then it will only go to the private hospitals with transplant license. And for the private hospitals, I'm sorry it is not in the slides, if a private hospital with a transplant license gets the organ, then first they should be able to actually utilize that organ. Here there is a catch point. If that private organization with a transplant license do not want to do that, then it would go to a government hospital with a transplant license, not to a private hospital. If the government hospitals with the transplant license also refuses, only then as the third option, it will go to another private hospital with a transplant license, again maintaining the seriality. Now the catch point here, from the medical legal point of view, it's a Form 10, it's in a very miniature form, but the thing is this is the Form 10 for the declaration of the brain death. The most important things, who should comprise is a team. That is number one, medical in charge of the hospital. Number two, another doctor who has been appointed by the medical in charge or the institution, and the name of those doctors has already been approved by the Department of Health, Government of West Bengal. Number three, transplant cardiac surgeons. And number four, the treating physician who was treating. In some situations, which is quite rare, if there is no transplant surgeon into that hospital, or if there is no neurosurgeon for brain death cases, then intensivist, anesthetist, or any other surgeon can be a part of the team to declare the brain death. The most important point, in between two examinations of the brain death, there should be at least a gap of 6 hours in cases of adults, and in cases of children, it will depend upon the committee. Now, medico-legally, the most important and the challenging issue is, you have to explain everything to the patient in the language that he understands. Now, going to that, let me come to this. This is the statistics of West Bengal in heart transplant. 2018, 6, 2019, 5, 2020, 6, 2021, 7, 2022, 8, 2023, 7, 2024, 3, and 2025, 5. Altogether, till August 2025, we are at 45. And the good news for all of you here is, to the best of my knowledge, and my knowledge is fairly accurate in this subject, not even in a single case of this there is any medical legal litigation. So that's really a good news. Now, coming on to the point. What all we should explain to the patient? The most important is the consent for surgery. We always are now recommending on behalf of the West Bengal Medical Council, not only for the transplant patients, in other cases also, when you are dealing with the complicated procedures, do a complete videography of the consent taking procedure. Please understand, a consent form written in English, and if you are getting it signed by an illiterate patient or a patient who does not know English, it will go straight to the waste paper basket, either in the courtroom or in the medical council room. So the consent form has to be in the language that the patient and the patient parties understand. Now, a video recording with the presence of a hospital authority in this case would be very much advisable. We always say in case of any organ transplant, be it kidney or heart or liver, do a complete videography of the consent-taking procedures. Now, this consent-taking procedures has got 4 major parts. Number 1, who is operating and what is the operating procedure. You have to disclose it to the patient and to the patient party, who is the principal surgeon, who all are the rest of the team members in the operation that is going to be contemplated. So that is number 1 criteria, and it is also as per the NMC guideline regulations, point number 8. That the entire procedure, the type of procedure and who is operating has to be told to the patient in no uncertain terms. Number 2, why? What is the aim and what are we hoping to achieve by this surgery? That also has to be explained to the patient in a very candid and lucid way, trying to avoid the medical nomenclatures as much possible so that it is understandable for the patient and the party. Number 3, what are the risks? Here, if there are 100 litigations country-wise, 70 litigations, believe me, arises out of our incomplete consent form. Here we have to divide it into 2 parts. One is complication, the another one is adverse outcome. As we all know that adverse outcome can happen even with a very successful surgery. And complication can happen with the best of the hands. There is a very clear-cut Supreme Court judgment that complication cannot be construed as a negligence, even though that can be a different topic. So we should explain it to the patient that what could be the possible intraoperative and postoperative complications, and what are the adverse outcomes in cardiac transplant patients, and for that matter, in rest all of the surgeries which you want to undertake. 4th, that I think is very much pertinent to cardiac transplant. What are the alternatives? You have to explain it to the patient that what are the alternative procedures or what are the alternative treatment options available. And if the patient chooses a treatment option which is not so modern, as per all of us, patient has got a right to do that. One example, I will not be naming the doctor or the institution, that is beyond legality, but you can say something like police file, say whatever I say is from a case originally. A patient got admitted in a big corporate hospital in Calcutta just for a lap chole surgery. Gallbladder stone, ERCP done, lap chole done, pancreatitis, patient died. 60 lakhs sue. Only because of the fact that the doctor could not prove that he explained to the patient party that there is an open abdomen procedure also. So this is where we are standing today. We all know that lap chole is the most scientific and the best standard procedure these days. I am not talking about the robotics. It was just before the robotics. But just as because the patient was from Tripura, they said, the patient's husband said, "Doctor, I just came for a gallbladder surgery. It's so simple. And I'm going with the dead body of my wife. Why? Why did they not tell me that there is an open abdomen procedure? I could have obtained that. That has got a lesser chances of pancreatitis." And they lost. So it is very, very important to explain to the patient what are the alternative options available and what could be the possible consequences of all those alternative options. And then finally let the patient choose. Do not interfere with the patient's decision of choosing. As a doctor, it is our work to explain him which route is the best for him. But finally, it is up to the patient and the patient's relatives to decide. Now, very quickly, what could be the possible complications and the medico-legal ethical issues in also transplant cases? Because these are very typical super specialty surgeries. But when we deal with medical negligences as such, overall, what is typically said is this in this Jacob Matthew versus State of Punjab case. But before that, there are two tests which we always undertake before declaring that there was a medical negligence. One is called a Bolam test. It was a Bolam versus Freenholz in UK. That was a litigation. And the another one is Bolitho test. Bolam test says, in a nutshell, that you are expected to give a reasonable standard of care that is expected from a person or a doctor from you. Like what a MD doctor is expected to give cardiological care, that care is not expected either from an MBBS or from a DM. So it is not expected that you give a much below standard of care or not expected to give the best standard of care. So you are expected to give a reasonable standard of care, and the interpretation of that reasonability is really an evolving phenomena. And in Bolitho test, it also says what is a ethical standard and a reasonable care in one hospital need not necessarily be the same in the another hospital. One classical example I am giving, two patients had amputations, two separate cases. One amputation was done because of a diabetic foot in a district hospital. At the same length of amputation was done in a diabetic foot in a big corporate hospital of Calcutta. In the second case, they lost. Why they lost the case? Because of the fact, in a district hospital, you don't have the facility of a vascular surgeon to decide the length of the amputation. But in that corporate hospital in Kolkata, the vascular surgeon was very much available there during the surgeries and in the hospitals, so he should have been called into the OT to decide the extent of the amputation. So even though this case passes in the Bolam test that yes, an amputation procedure has to be done, it fails in the Bolitho test because what is expected from a big tertiary setup, be it government, be it private, in Calcutta is not expected at a setup in a district place. So these are the quick points of litigations that may come into it, but I would really like to go back to the happy slide again, that so far, with 45 transplants in West Bengal from 2018 till date, there is no medico-legal litigations. Having said that, these three most important catch points, one is the declaration of the brain death. It has to be completely as per the laid down criteria and the protocols which we all must know. Documentation for the brain death has to be explained to the patient and the patient party every time. That's the mistake that we make. We keep it in file ourselves. And whenever you keep it in the file within yourselves and when you explain, most of the time we make another mistake. We do not get it signed by the patient party. Let us say you explain the patient party that these things are the vitals now and these are going to happen. Many a times the patient parties, with the provocations or with the suggestions from their lawyers, they simply ignore. They say, no, he didn't tell me anything. They simply ignore. And then our colleagues have absolutely nothing to prove that they have said. That is why we always say now, just get everything countersigned by the patient party and the patient if possible, whenever you give a noting in the file in cases like this. Thank you all. The time is up. Any question? Is there? I'd like to take questions.
You have a seat, sir. Okay. If there are any questions, I'll ask you some questions as well. Right. And the audience can ask you some questions as well. So first of all, thank you very much for that very, very insightful talk. I'm sure we have learned quite a lot about some of the relevant things. If we can have my slides up again, please. So now we are going to deliberate a little bit on the ethical aspects, as sir has already started. And let me tell you one thing, that ethics is a strange thing. There is not often a right or wrong. You usually travel in shades of gray. And it's often the deliberation and discussion around it that is more important than the decision you make. Because as I said, it's very hard to tell whether it's a right decision or wrong decision. It's completely based on your circumstances and perspective. So I'll start with Tanmoy, because he's my friend. So Tanmoy, see, I'll describe a situation to you. A patient is in a hospital and he's not doing very well. He's on mechanical circulatory support. The doctor wants to treat him, but the patient doesn't want any further treatment to be continued. Now, whose choice is it? Is it the patient's autonomy to decide whether or not he should be treated? Or is it the knowledge of the doctor that is more important here?
I think it depends on whether the patient is mentally capable of making the decision or not.
He is mentally capable.
If patient is mentally capable of making the decision, then it is patient's autonomy. So you have to respect that.
So
doctor can explain, it's responsibility of the doctor to explain the pros and cons, as we discussed, as Dr. Kaushik Mishra was telling us also, that we need to, before taking consent, or positive consent or negative consent, we need to explain properly to the patient every aspect of benefit of the therapy, as well as the pros and cons, both, like benefits and what adverse events can happen. And then it is patient's autonomy. But we have to understand that patient can understand the information we are giving, he can assimilate the information we are giving, he can actually come to a reasonable conclusion, an inference regarding what information we have given. So these are all important things.
That's a very, very valid point. I think patient autonomy is more important than anything else. But then it also may bring some issues. Now suppose, let's assume that this patient refused treatment and then he dies. So I'll ask Mr. Milan Mukherjee. Now, if that happens, how is the doctor liable here for not continuing with the treatment?
The question is, okay, can you hear me? You've asked me a very pertinent question. It's a question of the patient's refusal. And it's the word of the patient against the word of the doctor. Now, who are the persons who should be involved in this process? The patient's family or the member where a clinician has a team of doctors to come to the conclusion to talk to the patient.
So I'll make it a little more complicated for you, sir, because you are a legal expert. So the patient...
I'm not. I'm not an expert.
Okay.
I'm a lawyer.
So the patient does not want to continue with the treatment. The doctor says you should continue with the treatment. The family says, doctor, we leave it to you, whatever you think is best. The doctor, but because of what Tanmoy said, autonomy of the patient's decision, the treatment is withheld, patient dies.
Sir, the question here is, you have to understand two things. The patient who gets himself admitted comes for treatment.
Sir, yes.
So let's come one by one. When he comes for treatment, he expects the best treatment for him.
But he can change his mind.
When he sees that nothing is happening to him.
He's not getting better. Something is happening.
Better. That's what I'm saying. So then the question is whether the name of that doctor or the fame of that doctor gets spoiled by such allegations made by the patient. Because once
the patient is not making any
when
allegations,
he refuses treatment, you're using the word refuses treatment.
No, he's saying, I don't want to be treated anymore. I'm fed up with life.
Oh, that is it.
I don't want to continue.
So then the treatment is an exercise in futility.
So my question to you, sir, is as a doctor, there are a lot of people here who face that situation quite often.
Correct.
Are they legally liable for not continuing with the treatment because
No, they're not legally liable.
They are not liable.
Not legally liable. I'll tell you two things here.
Thank you. That is exactly what I wanted to hear.
That is what I'm saying. It's the doctor, patient, who would be in his proper frame of mind to understand what he's saying. That has to be first judged by the patient himself.
Absolutely, sir.
So then the patient's party come into play.
Sure. Now I'll get in Dr. Sudeshna Lahiri here. So you probably deal with administrative issues very often.
Yeah.
And quite often families turn to you to seeking advice. So what do you think as an administrator, as a hospital administrator, you can bring in to protect the patients, to protect the doctors in these situations?
So see, basically our role most of the time lands up to be as a patient's advocate. So our role is to ensure about the patient's autonomy, whether it is there or not. See, maybe the words might seem to be too utopian, but yes, number one, a medical admin's role would be to ensure patient's autonomy, number one. Second is, from the doctor's angle, we have to see all those legal jargons like, that maleficence, non-maleficence, beneficence, right? And also the equitable distribution of the resources. Those things are our prime importance. Because of some social stigma or prejudice, we should not allow any vital equipment to be diverted to any specific person.
Sure.
So that is one. And also from our angle, we have to ensure crystal clear communication, repeated communication like Dr. Bishwas mentioned, without any hide and seek about the real condition.
So my question was a bit more specific. Like, see, we face these situations quite often. Do you have a SOP to deal with these situations, or do you deal with it on a case-to-case basis?
Well, we deal it with a case-to-case basis, but basically the directives, the draft of the Supreme Court, which is quite idealistic, but on real grounds, quite a bit of difference is there between what has been penned down and what we do.
Okay, I'll ask one more question to you. So in a situation like this, where the patient does not want to continue the treatment, the doctor thinks it's in the patient's favor, would you consider having a multidisciplinary meeting, a board, something like that?
So the first point is, if it is a sick individual, he or she is not entitled to take a decision regarding his continuation of life.
I'll stop you there because Tanmoy said that patient autonomy is important. If the
Patient's autonomy is important, sir.
Mentally able to make a decision.
Yes.
He should be able to make a decision.
He should be in a fit condition to decide about his, that is the advanced medical directive. And that is taken not when the patient is sick. That should be taken at
When you say sick, do you mean physically ill or do you mean mentally ill?
Both.
So what you are saying is if I am physically unwell, I have no right to decide my treatment. Are you saying that?
Well, to a certain point,
if
yes.
I am mentally incapacitated, I can understand that. But if I have got,
that will be driven by emotions. If you are sick, if you are too...
We'll move on from there. And at this point, I would like to... Komal has not said anything, so Mr. Komal Dasora, I'll sort of bring you into the picture. Now, whose decision is it? When we say withdraw treatment, because the treatment appears to be futile, or the prognosis is extremely poor, whose decision should it be? Should it come from the doctor or should it come from the family?
It's a combination of both. I will not say that in isolation you can decide. You have to take them on board. You have to form a medical board. You have to inform them the pros and cons. And on a very collective note, they have to take a decision. In most of the scenario, what we have seen, such scenario happens when the patient is very, very critically ill, ventilated, in a severe condition. He is not being able to decide himself or herself. On the behalf of that family, usually family decides, but it is our moral responsibility, it's our collective this thing that we have to explain them all pros and cons in details, and the family makes a choice. So it's like...
Milan sir, I want to ask you again. Whose decision is it? Can the family decide for the patient who is mentally not, has the mental capacity to make a decision?
Who else will do it? Because he is not mentally or physically fit to say
No, I'm saying the patient has the mental capacity. What does the law say? Can the family make a decision for him?
If required, yes. So you see, there has to be a corroborative part of the...
But that goes against the autonomy that we are talking about, isn't it?
You see, patient autonomy is always there. But once a doctor finds, what do? You withdraw the life-saving device from him. You're not doing euthanasia. You are doing passive euthanasia.
So I'll read out a case under Supreme Court of India judgment Aruna Shanbog versus Union of India 2011, clarified in 2018 and 2023.
That is the common causes cases. I have the judgment with me.
So
that's the common causes case where guidelines were given by the Supreme Court. Tell me which law is followed when Supreme Court laid down a law.
I'm not telling you, sir. I'm asking you.
I'm telling you. You tell me now. If you are to follow the law, you cannot treat a patient. Let's be very clear. Because the job of a doctor who treats a patient who doesn't want to be treated.
So my dilemma is not there. I'll tell you where my dilemma is. I'm confused. I'm confused because Tanmoy told us, and I agree with him, that the patient who has the mental capacity should be able to decide for himself, not his family. What you're telling me is that the family can decide. I just want to understand the
You
legal...
See, let's understand one thing. What does the patient do when he comes to the hospital? He comes for being treated. He comes to being treated. When he comes for being treated, then the onus is always on the doctor to see that he is treated properly and in accordance with the medical principles.
True.
True. So now let's understand. The patient's autonomy, because thereafter what will happen, if something happens to the patient, if we listen to the patient always, then it becomes a case of a negligent act on the part of the doctor.
I think best is, at this point, I'll ask Kaushik sir to give his opinion. What do you think on this, sir?
See, there is no dilemma in this. It's very straight cut. Absolutely straight cut. If the patient is mentally capable of taking his decision, and what you want to know is that the patient says that I don't want to be treated. That's right. One line answer is simply discharge the patient. You have to simply discharge the patient. That is it. A consultant cannot keep a patient under admission if the patient is refusing to be treated by him or by that hospital. Now, I go a bit farther from my experience. It may so happen that the consultant is willing not to discharge. If consultant says, no, you will die if I discharge you. It happened. You will die, I cannot discharge you. Patient says, I don't want to stay with you because of any reason, whatever. Then what should be done? Get a discharge on risk bond signed, get a LAMA signed, and get the patient out of the hospital. You cannot keep the patient under you and not treat him. That is not possible. So, giving the patient's choice not to be treated or the family's choice not to be treated has to be respected, and the simple one-liner answer is just discharge the patient. Simple.
Milan sir wants to say something.
Yes, I'll give you an example. I'm fighting a case where the patient was admitted into a hospital. The parents of the patient was not satisfied with the treatment being done in that hospital. So what he does, he contacts another hospital. He didn't want his son to be treated there. So he contacts another person, another hospital. That hospital, when he heard that this is the case of that gentleman who was in hospital, they refused to admit him. What happens then? Give me an answer.
Sir, I'm the one asking the questions.
I'm asking you. I'm asking you to give me an answer.
So, I'm asking the question because you are the expert.
Dr. Vishwas has very rightly said, you give a Dama or a Lama.
The problem is...
No, I think...
a Dama or a Lama?
I'll tell you the problem.
I am telling a very interesting case, I can tell you. Very, very interesting. This is the final quiz, 1 crore ka. And it happened. The patient said, after a gallbladder surgery, the patient was discharged by the consultant 1 day before. The tomorrow 10 a.m. the patient will be discharged. Then, we don't know, maybe that same night, maybe the next day morning, patient's condition started deteriorating. Consultant told over phone, don't discharge the patient. This is a real scenario, all of you understand. Don't discharge the patient. Registrar takes that call, don't discharge the patient. By the time the hospital authorities have completed the billing formalities and everything, the patient was in wheelchair, patient was in the lift, in the ground floor, right? Technically, patient is discharged, but physically, patient is within the hospital, okay? Patient goes out. 5 hours later, patient dies. Now, this patient party can say, when you knew my condition was unstable, why did you discharge? Then the patient and the doctor say, Kaushik, believe me, they said we don't want to stay. I said, then why did you not get the LAMA signed?
So that's
it's all done.
Documentation is
it's
very
all,
important.
Not only documentation, on the part of the hospital administration, you have to stop the patient in the gate. You have to tell him, get a LAMA signed, get the DRB signed, only then we will allow you to go out, otherwise come in.
So that's a very important point for the audience, and at that point I would like to invite Dr. Sarkar to make a comment.
I think 2 things. Milanda, one observation is the Aruna Shamba case is not really relevant Because Aruna Schönberg for a period of 36 years was in a period of vegetative state, right? So vegetative state and passive euthanasia is a different kettle of fish altogether. Now, just clarify one thing, in some of these confusing scenarios, which are genuine confusions, as doctors, are we right in understanding, supposing a situation come, patient is not in a corpus mentis condition to make a decision, doctor thinks a treatment can go on, the relatives seems reluctant. In that situation, was there, I'm not clear on this, is there a ground for the hospital or the treating doctor to approach a court for directions that what do I do in this matter? Do I treat or do not treat? Is there a ground? Because you see, today we do get patients, say somebody, an octogenarian getting admitted, who makes a clear cut say, I am not to be ventilated. End of story. Those are pre-made decisions. Do not go beyond this line. But that in our society is not very common so far.
Except in cases relating to abortions.
Yeah,
Okay, in respect of abortions, they have to take the permission of the court.
That's a different matter.
No, permission of the court. You said the permission of the court.
Yeah,
That's in abortions, you have to take the permission of the court.
So I think I'm going to stop both of you right now because I think we are moving from transplant to basically abortion. So we'll refocus
Sir,
it.
don't take me otherwise. I'm giving an example. You won't understand that because Dr. Sarkar's specific case was that there was a issue with the court.
Basically, when I started, I said that there is no right or wrong in these discussions. It's often the discussion that is more important than the decision. I want to request Mr. SP to come and give a comment as to what it is the practice in the UK. If the patient refuses treatment, can the family ask to continue the treatment?
No, I don't think they can. I mean, if the patient's got autonomy, this is it. So the patient refuses, that's it. I think in our situation, when this happens, then we have a team of doctors and clergy and so on and so forth, which we go and see the patient, see the family, and discuss that and discuss the end of life. So it's not a situation where you would say, right, okay, you don't want the treatment, you can go home. So there's end of life treatment, and that's the process that we take. And that starts, and that may take many days or weeks. So I think this is the way, and it is done with the consultation. I mean, you have patients saying no, you don't say, right, okay, that's it, we're out. So you still have a chat with the family, you still have a chat with the patient and see if you can come in any arrangement.
Okay. Thank you. So I'll just move on from this. We can bring him in, but I'll bring him in a second point because we are only focusing on this. So I want to move on from here. So Tanmay, once again, I'll come back to you. There is this utilitarian view, which is greatest good for the greatest number of people. Now, having a patient on a prolonged mechanical ventilatory support when you think that there is not going to be much benefit, the prognosis is very poor. Do you think in a country like ours, is a good option to continue with the treatment because the family or the patient wants, or should you use that bed for people who have simpler things which they can get better and go home?
Exactly. I think most important thing to decide in this sort of situation is futility of care. Now, whether it is futile to continue treatment in the patient, that particular patient, is the patient going to survive? Is the patient going to get better, get out of ICU, go home? These are kind of things you have to consider. Now, how do you decide? Now, ISCCM and Indian Society of Palliative Care Medicine, they had made a joint statement and sort of a pledge to the government, position statement, where they had mentioned that in these sort of situations, you can go for a medical board, which is first is a primary medical board to be followed by secondary medical board. So primary medical board will consist of 3 clinicians with at least 5 years of experience who are part of the treating team. But a secondary medical board will not be part of the treating team, that will be a different team. And one of them has to be ratified by the government or the legal authorities to be a member of that committee or that board. Now the question is that if after the primary medical board, the relatives agree with the decision of the doctors that it is futile to continue care, then only you go to secondary medical board. Otherwise, there is no point. Okay. If the relatives don't agree, they say, we have got money, you just keep on the ventilator, we'll pray to God, we are going to temple, and we are sort of,
Fine.
So, but there's one thing, two things I would like to mention, is that now some states have issued guidelines, like Kerala, Gujarat, and all that. Now, health is a state subject. In West Bengal, still we are waiting for some guidelines, number one. Number two is that there is no need to take permission from court. You just inform the judicial magistrate. That is what the rule in other states, like Kerala and Gujarat, to name one or two states who have made these rules. And last thing I just like to mention is that all the discussion that we're having, I was raising my hand, I was just trying to say that when patient is alive, obviously he has his compos mentis, he's making a decision. But if the patient dies, and when you are in court or you are in counsel, the patient is not there to defend you and to say that I had refused. So document it very clearly, because then you are actually dealing with the relatives who would have said that no, if the patient might have whatever had said, the decision should have been taken by us, or the doctors would have listened to us. Yeah. So that is a very important point to consider.
I take your point, Tanmay. You are trying to protect the doctor here, but I'm not talking about protecting the doctor. I'm talking about the ethics of it. When the patient does not want to continue with the treatment, ethically, are you right to continue with the treatment? That was the question.
No, I understand, but what I'm saying is that
explaining my point.
Documenting that, because otherwise you have to keep yourself medico-legally safe for a litigation later on, when the patient is not alive.
I get your point. I'll just move on to something else. Dr. Sudeshna has been very quiet for a long time. So now, if we are in a situation that the doctor thinks treatment is okay, there is a small chance the patient may get better. Patient has got no view on it. They are intubated. The family says we can't pay. How do you handle this situation?
Well, the easiest thing is to brief them up in great detail that what exactly the patient is going through, provide them with a case summary, and the cost of treatment.
That has been explained.
No, the cost of treatment is not uniform in every healthcare organization.
No, let's say it's a corporate hospital.
Yes.
The patient party knows that there is a small chance the patient can get better. We want the treatment, we don't have money. How do you handle that?
So there are benevolent organizations who do provide funds for the same.
What should the hospital do?
Well, at our organization, there are situations like this where fundraising happens. But the care should continue. There should not be any stoppage of care.
So what you are saying is the hospital should take the loss and continue with the treatment.
And also suggest de-escalating to a different healthcare sector where they can afford the cost.
Mr. Komal.
It is a very, very thin line kind of decision in such kind of scenario. We open up to the patient family, but in case they opt out, in case of the financial distress and all, and then they say that we do not want to take the patient elsewhere and you have to continue. So a facility which has got a standard of care available with them, they cannot go level down. So they have to continue the same level of treatment, irrespective of, even there is a provision in the Act also, in the Clinical Establishment Act also, that irrespective of the capabilities of payment by the patient family, you have to continue the treatment. And even if they don't pay, you have to continue. This is a dilemma, this is a question which we deal with day in, day out. For all right or wrong reasons, private hospitals are always been under question that they are very expensive and the cost is something which you cannot control. But continuity of care is paramount over all these things. So you have to continue. We do have such patients who are not paying, who are staying, their prolonged stay, and we have to continue treatment until unless they decide to go for DAMA, like the way in case they opt out for taking treatment with you or they decide to move out elsewhere.
So, Milan sir, what is your view on the legality of this situation? Because how much loss can a corporate hospital take before it stops?
There are cases, I will not name the hospital, there are cases who are staying in the hospital for last 1.5 years. There are cases who are staying in the hospital for last 5 years and 6 years in the hospital, and they are in vegetative state, and the hospital has to continue treatment, There is no bar.
Okay, from the
And
legal
there are
perspective-
cases available in Calcutta about whatever I spoke just now.
So basically, Kaushik sir, you raised the
See,
microphone.
this is purely a non-medical issue, so we don't have much to comment. But what I would say, 2 points. This is one area where from the maximum cases arises, right? Maximum cases arises. So what we, the doctors, I am talking only about the doctor's point of view, not the management. What we doctors should do is, we must explain the patient and the patient party in this case, everyday situation, citing them some examples on the literature, meaning we want a evidence-based medicine, not a eminence-based medicine. What we have to do, your patient's condition is this, international literature says he has got a survival chance of 1%. I'm just quoting an example. That has to be video recorded every day in a room when you are explaining it to the patient. That is number one. Number two is, another option would be to refer it to a tertiary government care hospital if they can, take the patients on that way. There are several government hospitals which has got a good standard of care for these matters, and they have a form also. Number three, finally what Mr. Kamal had said, this kind of a litigations, normally they come to medical council. That the most unfortunate part for the doctors, let me be very candid, we doctors do not get the complete share of the bill, but the patient thinks it is we who are increasing the bill, and it is we who are keeping the patients on ventilation, knowing it fully well the patient will not come out. Then they come to the medical council for a case. And then we refer the case to Health Regulatory Commission because it's a financial issues. To save the doctors, I would always suggest keep everything under video recording and in pen and paper writing, and refer the patient to a government hospital if possible, at least in writing.
Okay, thank you, sir.
At least in
I
writing.
think we have got 2 minutes left, so I promised I'll get Dr. Sivathasan to make some comments. What would you do if it was Singapore? Do you face these situations where people just say we don't have any more money to pay?
Well, Singapore has some sort of social welfare system.
Very much like UK.
Yes, but every patient has to pay. They are mean tested, but if they don't have funds, they can appeal to the medical social workers. The medical social worker would explore and then give a recommendation. Whether they can, there are special funds like Medi funds and Medi Shield, yeah, they can get funds from.
Okay, thank you very much, sir. If there are any burning questions in the audience, I mean, you are welcome to ask. We have got just under 1 minute left. So if not, I think this may be a good point to thank all the expert panelists that we have. Thank you very much, ladies and gentlemen, for being here and trying to help us out with our ethical dilemmas. And most of all, thank you to the grand audience who has been here. I don't know, it's 8:15 or something, and they're still here. You know, the hall is full. So thank you very much for being here.
I request all the members of the association to stay. We will be having the general body meeting right away. Dr. Rajan?
Kindly members, please be seated. Those who are not members, kindly This is the general body meeting of the association. Those who are not members, kindly step out of the room. All the members kindly be seated.